Hello, hello. Can I invite Dr. Suvendu Acharya, Dr. Balram Panigrai, and Dr. J. Kishore to chair this session? Dr. Suvendu Acharya, Dr. Balram Panigrai, and Dr. J. Kishore. Then Dr. Anuj, would you like, Dr. Anuj, Dr. Narsingh Verma, please chair the session. We have three speakers, Dr. Rucha Mehta, Dr. Suranga Manilgama, and Dr. Devjit Tripathi. Please start the session.
Hello. I extend a very warm welcome to all of you in the session, Meet the Global Experts, Tackling the Stigma of Obesity by Dr. Rucha Mehta.
So, Dr. Rucha Mehta is not a new personality and not a new speaker to be introduced. Most of the people in India know her very well. But the new thing what I could know about her, that she has been the ex-governor of LA chapter of ACP when she was in the United States. So now we are going to listen the ex-governor. So Rucha Mehta, over to you. Without much ado of introduction, except that she is very renowned physician of Ahmedabad.
PowerPoint I'm waiting on. Yeah. I'm just starting the PowerPoint, so can I start it? I mean, I don't know. It says enable editing and all that. Get Office. Yeah, this tool आपको ना वो तो देखा ही सब नहीं. हमारे काम ले लो ना. एक मुझे ये माइक दे दो.
कॉलर माइक दे दो.
This slider. Good morning, everybody, and it gives me great pleasure to be here. And this takes me back to my MD medicine days where we were very active trying to get into all the programs for ACP. And I really think when Dr. Maheshwari first called me with this topic, I said, oh my God, I feel like a socialist or an activist. And I'll tell you, I feel like I have a new perspective on how I look at obesity. So a lot of you might know that we have done a lot of work with obesity. We have a huge clinical practice looking at what I would now like to say weight management and not weight loss. And let's see what's going to happen by the end of this talk. Hopefully this will change the way you think, just like our leader in charge over here. So what am I going to discuss in the next 15 minutes? We'll talk about what is stigma or what is weight stigma. Why do we need to be discussing this and how will we go about tackling? So very simply put, my agenda always, as you know, I always have the what, why, how. Because if the why is clear, the how becomes very, very easy. So I really looked this up online as to where did this word stigma come from. So if you will understand, stigma was borrowed from Latin and Greek, as a lot of our things have come from there, and actually means a mark or a brand. And when back in the day when you used to torture people and leave a brand with a hot iron, that was known as a stigma. So it is really stigmatizing somebody with something. So what are some of the stigma that come to mind? So it's early in the morning, so I just want to keep it open. So what do you think? If somebody can say, what was most recent times, Dr. Maheshwari, I can't pick on the audience, what was the one stigma we all suffered from where you had to be isolated? Recently, in recent times? 2 years we were sitting at home. COVID-19, yeah. So, I mean, that was also a stigma. So there was a huge thing, it's a global perspective and ways to combat stigma at the time. And you can see how in this beautiful picture, the artist depicts, oh, he's infected, the story ends, there lived a man with a virus. So this is where, you can simply think that even now we have not got away from stigma. And in India, stigma goes back a long way right down to race, religion. And look at this beautiful slide over here that says stigma is more contagious than leprosy, than the bacteria itself. So leprosy was back in the day a stigma also. Leprosy does not spread by human touch. There was a huge movement back then. But today what I'll talk to you about is something totally different. So I'm trying to see if this video will play. Can I increase the volume? 1 second. Can you increase the volume for this? Let's see. Okay, I don't know if, let's see if this will play. So this is a scene from an, so here in, it's a scene from a popular, can I play now? Yeah? Okay.
कुछ ठीक नहीं होगा जब तक तुम्हारा वेट रिड्यूस नहीं होता कोई लड़का वड़का नहीं मिलने वाला तुम्हें मैं कोशिश कर रही हूँ ना नैना वो दिख ही रहा है वाओ इट्स सो क्यूट नैना
If you could hear it, the girl is, this is one of our popular movie stars, and her friend who is fat is telling her, she's being told, nothing is going to be okay, you will never get married till you lose weight. And she sees a boy and says, I really like this boy. So what we are talking about is several stigma like this. Nowadays, we also see these signs on the bathroom toilets. So weight stigma, isolation has become a big thing we are talking about. And imagine it starts right from our movies. It's somewhere where we don't even notice. Called fat by schoolmates, 12-year-old girl kills herself. 1 in 5 in India is obese or overweight. So if we don't address this issue today, how are we going to tackle this huge burgeoning problem? We know that the global prevalence And this included physical therapists, dietitians, nurses, and again, the rate of weight bias was almost 60 to 70%, that they did not try hard enough for these patients. Now, what about weight bias? If we are coming to a conference like the one Dr. Maheshwari has organized, so this was the World Obesity Federation that was done in 2012. 390 healthcare professionals underwent a survey, and this included nearly all the subjects were either physicians or they were doing healthcare professionals. 90% had a graduate degree, professional degree. And what did we find? They did an implicit association test, IAT, which is very interesting to understand because the IAT scores gives them different surveys and it can predict prejudice behavior towards a target group. So very interesting survey to be done. And what was found, again, as you can see, for obese individuals, this is in gray is the positive attitude and negative attitude. Even specialists who take care of patients with obesity had a negative attitude that these patients are not motivated, they are lazy, they are stupid, they are worthless. So this is the kind of responses that were received from healthcare professionals. So something really important to keep in mind, obesity stigma, as you can see, it's a busy slide, but happens across the spectrum, contributes to a lot of negativism and poor healthcare outcomes. Why do we need to know about this? Because this obesity or weight-based stigma causes stress to the patient, leads to increased eating, increased cortisol, further weight gain, thereby perpetuating this stereotype. And here is something from the endocrine practice guidelines as to once the obese patient starts to think he's obese, he then has this what is known as an internalized weight bias. So as clinicians, we need to screen for this and refer them early on to cognitive therapy, psychotherapy, in addition just to weight loss measures. And these are the patients who will then have a better response to medical or surgical managements of obesity. It starts very early in life from parents, community, society, social media, all of them trying to glamorize or put forward thin people versus the overweight stereotype. Also, all the factors we need to keep in mind when we are targeting weight loss. As you can see, I have not put in just the biological factors such as age, sex, genetics, epigenetics, or adiposity-based complications. But we also need to look at psychological and social factors. Just to stop for a second here, there was a huge push. When did obesity become classified as a disease in the US, Dr. Tripathi? I think 2000, very recently, right? Not more than 20 years ago, not even that much. So till then, it was not called as a disease. So obesity was something which was simply a state of being. There are obese people, there are thin people. We thought it's a good idea to have it as a disease so we could give treatment because everything in US is insurance driven. But now there's again a huge movement that obesity is not a disease and we need to move away from that and call it ABCD, adiposity-based chronic disease. Okay, so still has the word disease in it. So this is going to be more of a social talk is what I feel. So weight stigma or bias works in two ways. At the individual level causes stress, worsens eating and physical activity behaviors. And at the public health level, at the national level, it impairs healthcare quality and causes a lot of impact on our burden. Association between weight stigma and mental health. In this particular meta-analysis, what they show is we are all aware of obesity causing a myriad of complications, right from heart disease, diabetes, fatty liver, cancers, Alzheimer's dementia, PCOS, infertility. This particular study says that mental health stigma due to obesity is responsible for almost 60% of the mortality, which is just as high as having diabetes due to obesity. So the mental health stigma associated with this, the stigma causes much more death. So I behoove you to read this article which talks about obesity stigma, causes, consequences, and potential solutions, which says the physiological, psychological, and social leads to an increased morbidity, mortality, and in fact perpetuates obesity. Therefore, we really need to be thinking about this. And how can we do this? This is an example from Doncaster in UK, wherein they really tried hard to work on all of these factors. And if you just read the center, it says to the individual, the patient, you are already good enough and are valuable. So a lot of psychological work needs to be done. You need to be compassionate and empowering support for families and individuals and continuously start protecting and challenging them to achieve their own goals and focus on health more than simply weight as a number. This needs to begin at the grassroots level. As I showed you, most of these patients who became obese in adulthood, this started all the way in pediatric age group. Therefore, pediatric obesity weight-related bullying, this is where we need to start working and take away and make sure they have a good self-esteem going into adulthood. Lastly, addressing the knowledge gaps of doctors. So what we have understood is doctors think emotional or comfort eating, food addiction, gluttony, food environment, these are the causes for their patients gaining weight, that it's simply choices and that they need to be controlling their own foods. But maybe there is something more beyond this that we need to help our patients with. So with that in mind, there is a joint international consensus statement for ending stigma of obesity with all the thought leaders in obesity, Dr. Rubino, Dr. Mechanic, David Cummings, Phil Shower. So all of these group of people have come together to put together a very nice guideline. Also, the ACE has this consensus statement. We might need our own India-specific consensus statement that we should think about from our obesity society. And what this tells you is you need to develop a chronic care model. We need to end this bias in weight. We need to empower the activated patient. Now, society needs to come together to help these patients, and you need to develop the healthcare statements for optimal outcomes for our patient with obesity. Obesity stigma is thus an important consideration for public health, both at the individual level and also at the public health level. So public domain legislation, body positivity needs to be promoted, health needs to be promoted. So you can see that the sumo wrestlers have done this the best. They are supposed to be very healthy in spite of their large body weight. We see a lot of this in modeling nowadays, the large size, plus size models being done. So there is a huge movement out there. I urge you to be a part of this movement, and for your patients, spend a few minutes and focus on health more than simply body weight. And some of you who missed the first part of this, I showed that, the two, Preeti Zinta was telling Sweetu from this particular movie that teri to shadi hone nahi wali hai till you lose weight. She was trying to tell her. So what is the solution to this?
देखो जी, जो लड़का तुम्हारी फिगर को देख के तुमसे प्यार करेगा,
वो अंधा होगा।
वो गलत करेगा, इग्नोर करो। उसे तो डीपली तुम्हारे दिल के अंदर झांक के देखना चाहिए।
You're right, you're right.
I'm always right. एक बात बताओ, यहाँ पे कोई लड़का है जो तुम्हें अच्छा लगता?
So what he's telling her that you don't need to worry about your size, you need to connect at the heart level. So we need to be doing this in our daily practice. So I urge you all to join this movement, end the weight stigma, and health at every size is what we should be standing for. I believe I'm in my time length, so thank you so much for your attention.
I think one question can be allowed from the audience. Yeah.
Stigma is going on, and I think this obesity term should be replaced by some term that could be acceptable to our patients. Right.
So I think that's fantastic. In fact, I couldn't show the entire timeline history of what's been going on in the background. As I mentioned, that obesity was never a disease till 2012. And this started from the US. As you know, everything starts in the US, all the bad things now that I'm in India. So obesity became classified as an ICD code, so we could bill for it because we were treating it. And then medications came on the market for obesity. So that's why it's become an even more popular topic. Then there was a huge move to convert it from obesity, as I mentioned, to ABCD, adiposopathy-based chronic disease. Still has the word disease in it. Now there is a huge move that why do obese patients or people need to be classified for their size? We have done it for race, we have done it for COVID, we have done it for leprosy, HIV, syphilis, gonorrhea, name it. You know, so many things were classified when patients were chastised. And now we are just all people and we are going to classify. And as you can see, the obese people might be really not getting, when they come to your office, for example, they may not fit into your chair. So many things happen. We need to be cognizant. So your point is well taken. And like I said, there are powers higher than me in the room. I mentioned before you entered, Dr. Sabu, that we need India-specific guidelines. I showed the ACE guideline, the international consensus statement for obesity stigma. How do we move away from this? Maybe we need to be the trailblazers and come up with a name. So your point is well taken. Yes.
Thank you, Dr. Rucha. There are a lot of questions coming in the mind, very stimulating talk.
Yes,
but
yes,
because of the time constraint, I can't take all those questions right now. So initially, when we designed this session, we thought that probably this will be a endocrine session. But suddenly, we had to place Dr. Alisa Choi. She is the infectious disease specialist, and we thought that probably it's not going to be an endocrine session. And we kept the name of that session, Meet the Global Leader. While I was discussing with Dr. Varmani, our scientific chairman. And when I could know today that Dr. Rucha Mehta has been the ex-governor of ACP in Los Angeles, then I could really know that this global leader session is going to be. So another global leader in waiting is Suranga Manilgama, and probably you can also see him next year or next to next year as a governor Sri Lanka chapter. Maybe. So Dr. Suranga is endocrinologist. He is endocrinologist in Colombo North Hospital. He is first Sri Lanka to who have been awarded with the ACP Global Physician Award, and I have been witness of that award. I was there in San Diego. In San Diego, this has been awarded to you. Yeah, that. So I was really there. So Dr. Suranga Manilgama shall be telling us about the discordant thyroid functions. Over to Suranga.
Good morning, everyone. Thank you, Chairperson, sir, for your kind words of introduction, and thank you for inviting me to talk. So I'm going to talk about discordant thyroid functions. So I don't have anything to disclose. And this would be the structure of my talk. And yes, you all know abnormality of thyroid function tests are common. And the thyroid disorders in the most florid forms are easily recognized. But the often patient presents with non-specific symptoms, and therefore the high index of clinical suspicion as well as accurate measurement and the interpretation of thyroid functions are required in most of the cases. So let's look at the thyroid pituitary, the hypothalamic pituitary thyroid axis. So as you all know, thyroid hormone production is tightly regulated by hypothalamic TRH as well as pituitary TSH secretion. And T4 and T3 concentrations remain relatively constant throughout the life. That reflects the set point of the HPT axis. Yeah. Then thyroid gland secretes 85 to 90% of T4 and 10 to 15% of T3. And T3 is the biologically active hormone. And the TH are, both of them are heavily bound to protein and circulate in the blood. And the cellular entry of thyroid hormone in many tissues are dependent on specific membrane proteins like MCT8. And the action is further regulated intracellularly by deiodinases. Type 1 would do peripheral conversion of T4 to T3, and type 2 will convert it at the central level, hypothalamus and pituitary, and D4 that would inactivate the hormone to reverse T3 and T2. And the major actions are mediated through the binding of the thyroid hormone, the receptors in the nucleus. Yes, in general, thyroid cells are typically associated with unbordered changes. As an example, the T4, T3 will be raised. So these are the disorders would cause thyroiditis and hypothyroidism. We all know this. And so what would happen? In most of the cases, the thyroid functions would follow the rules where there will be physiological pattern. But in small but significant subgroup of patients, the thyroid function test would be confusing. So we call them discordant or anomalous thyroid functions. Yeah. So I will concentrate on these 4 cases, and these 4 cases won't follow the rules, where some cases would show all T4, T3 as well as TSH is low. Some it's not the usual pattern. Yes. And in those type of cases, how do you proceed? So first you evaluate the clinical history, taking the history of age and whether they are pregnant or not, whether they have any other illnesses other than thyroid, and what are the medications they are taking, and then the most importantly, reassess the thyroid status. Yeah, so we all know the thyroid status, the full-blown hypothyroidism and hyperthyroidism has clinical signs and symptoms to diagnose easily. And so we'll move on to the case 1, where a 75-year-old man was presented to the medical clinic for recent onset recurrent headaches, lethargy and malaise. His general examination and the systemic examination was normal, and the thyroid functions are like this, where you can see TSH level is marginally low, T3 is again low normal, T4 is again low normal. Yes. So what do you think? What is the most likely diagnosis? So out of these four, what do you think? What is the most likely explanation? Sorry? Central hypothyroidism. Why? Patient has recent onset headaches with symptoms of hypothyroidism. So we'll take the answer central hypothyroidism. So when you see a patient with these thyroid functions, T4, T3 low and TSH low or normal, so you have to think of central hypothyroidism, and other than that, isolated TSH deficiency, non-thyroid illnesses and assay interferences. So moving to the second case, where a 45-year-old man presented to the clinic with symptoms of malaise, weight gain and cold intolerance. So that would suggest you of hypothyroidism. And he had a history of primary autoimmune thyroiditis and was taking thyroxine 100 for last 5 years. So his thyroid functions are T4 normal, T3 normal, TSH is elevated. So what is the most likely explanation out of 4? Yes. The most likely reason is poor compliance. Yes. So when you see such thyroid functions where T4, T3 is normal with elevated TSH, so these are the other differential diagnoses you would like to think of. The subclinical hypothyroidism, and in a patient who is taking thyroxine could be due to poor compliance, malabsorption, and any other drugs causing interactions and assay interference. Yes. So in a patient who is on thyroxine, so these are the causes for deranged thyroid functions. When there is high TSH and low T4, could be due to malabsorption, poor compliance, or other causes of changing thyroid hormone metabolism. And again, if there is normal TSH with mildly elevated free T4, that could be due to normal physiological variant, so you need to give more thyroxine to suppress the TSH level. Yes. Moving to the case number 3, 65-year-old woman is referred from psychiatric clinic for abnormality of thyroid function test. She has been treated for major depressive episode 3 months ago with ECT and oral medications. She complains of lethargy and tiredness, denies weight gain, cold intolerance, or changes in bowel habits. These are her thyroid function tests. T4 is normal but lower range, T3 low normal, TSH low. Yeah. What is the most likely diagnosis? Drug interference could be subclinical hyper. Okay. What is the most likely? Possible? But this is non-thyroidal illness. Yes. When you see such thyroid functions, these are the probabilities. Could be due to anything, but in the case of this patient, she has had major psychiatric illness 3 months back, and she is on other medications also. It's a non-cause of non-thyroidal illness, major psychiatric illness, recent past. Yes. So what do you mean by non-thyroid illnesses? We call it 6A thyroid syndrome also. There you can see abnormal thyroid function test in both acute and chronic illnesses as an adaptive response in the absence of intrinsic abnormality of thyroid gland. The could be due to anything, what I have mentioned there, and the most of the cases there will be low free T4, low T3 with normal low TSH level. But during the recovery period, thyroid hormone and TSH levels return to normal. But in some patients, TSH will be overly elevated for a short period of time, which is required to restoration of the thyroid status. So moving to the case number 4, a 20-year-old woman complains of tiredness and she denies any weight gain, menstrual irregularity, cold intolerance or constipation. On examinations, she has mild tremors in her hands and pulse rate 76 beats per minute, and rest of the general physical examination was unremarkable. Her thyroid functions are as follows, and T4, free T4 slightly elevated, free T3 slightly elevated, and TSH again elevated. Yes. So when you look into the further history, she has a strong family history of thyroid dysfunction with her elder brothers and maternal uncles suffering from abnormal thyroid functions, although none of them are taking any medications. So what is the most likely diagnosis here? Is she pregnant? Is this due to thyroid secreting tumor or as an interference or thyroid hormone resistance? What do you all think? It's resistance. Why? She has slightly elevated, all with family history of strong thyroid illness. Yes. So when you see such presentation with high T4, T3 and TSH, so these are the other differential diagnosis. Could be due to assay interference and TSH secreting tumors. In TIs again, we have already discussed that, and thyroid resistance. So what is thyroid resistance? It's an inherited condition characterized by a reduced responsiveness of target tissue to thyroid hormone due to mutations of the thyroid receptors, usually thyroid hormone beta. The presence with features of hyperthyroidism or hypothyroidism, even they may be asymptomatic. Usually they would have elevated T4, T3 with normal or elevated TSH level. So what is TSH-oma? Where that is TSH secreting pituitary adenoma are considered to be the rarest of the classical pituitary tumors, and clinical phenotype of both disorders, thyroid secreting tumor and TSH resistance, would be more or less similar. They would present with asymptomatic state, or some of them would present with cytotoxicosis with goiter. Okay. So they also having elevated T4, T3 with elevated TSH level. Yes. So we'll move on to the medications. Medications is a common reason to have abnormal thyroid function test. So the sum of the medications will influence on the hypothalamus pituitary thyroid axis, where some of the drugs will increase the thyroid hormone secretion. Those are amiodarone, lithium, so on. And some of the drugs will change the TSH secretion and will give rise to low TSH and low T4 level. So like dopamine agonist, glucocorticoids, and some of the other drugs. So I will explain a few on amiodarone, because the amiodarone would inhibit T4, T3 conversion by deiodinases type 1, and that would give rise to transient increase in TSH level and persistent increase free T4 level with normal T3 level. And again, amiodarone can cause thyrotoxicosis as well as hypothyroidism with some other mechanisms. Yeah, these are the other drugs, and I'm not going to touch upon these. You just this for the completeness. Yes. So some of the drugs would increase the TBC, thyroxine binding globulin synthesis, and will give rise to increase in total thyroid hormone concentrations. Those are like oral estrogen, would cause increase in TBG secretion, giving rise to increased total thyroxine hormone. And some of the drugs would inhibit TBG synthesis and will give rise to reduced total thyroxine level. So some drugs would displace T4, T3 from the binding sites and will give rise to increased free T4 level, like importantly heparin, large dose of intravenous furosemide, aspirin, NSAIDs, and phenytoin are known to cause this phenomenon. Yeah. So we'll move on to the pregnancy. Pregnancy, the physiological alterations in pregnancy lead to changes in thyroid hormone and TSH level, and therefore trimester specific reference ranges of thyroid hormone as well as TSH are important whenever possible. So these are the changes, and these are the changes of the thyroid function test. So look at this graph where it shows the increase in total thyroxine T4 and T3 level due to increased production of TBG from 10th week onwards till the parturition. Then due to the stimulatory effect of the high circulating HCG, that would give rise to increase the suppression of TSH with increased free T4 level during the first trimester. Yes. So what do you mean by assay interferences? The most commercially available TSH assays are based on immunometric two-site format. they use two antibodies, capture antibodies and label antibodies as shown in the diagram, and the TSH would be considered as analyte is trapped between two and thus increasing the sensitivity of TSH detection. So what would happen when there is human anti-animal antibodies? So that will cross-link with the capture or detection antibodies and may give rise to positive interference leading to falsely high TSH level. But when those antibodies block the either side of those antibodies, that would affect negatively and causing falsely low TSH level. This is same as for T4 as well as T3 assays also. So what do you mean by the subclinical hyper and hypothyroidism, where the subgroup of population have altered TSH level? In hypothyroidism, subclinical hypothyroidism, they would have high TSH level, and in subclinical hyperthyroidism, they would have low TSH level with normal T4 and T3 levels. Yes, so this is a summary of discordant thyroid functions, what we can see. So I have discussed all 4 cases where there are discordant thyroid functions. And when you see a patient with discordant thyroid functions, how do you approach? So you first evaluate the clinical history of the patient, and then you reassess the thyroid status and think of what is the hormone which has been affected, whether it is TSH or whether it is T4, whether it is T3, whether it is in full form, the total TSH T4, or whether it is free T3, T4. And then you exclude any assay interference, and if everything is looked into, then you can think of rare disorders like thyroid hormone resistance and other causes of discordant thyroid functions. Yes, so these are the key considerations. The result of thyroid function test must always be interpreted in the light of clinical status of the patient and awareness of the conditions and all the diagnoses that can be associated with different patterns of thyroid functions, guide the further investigations and management. Confounding factors that might influence thyroid status, like intercurrent illnesses and the medications, should be excluded before investigating them further. And interference in TSH as well as thyroid hormone assays, laboratory assays, should be considered in any kind of patients when they present with abnormal thyroid test. Thank you.
Thank you, Dr. Suringa, for a very exciting and stimulating session. A lot of new things we could know, and we could also brainstorming also was there. And I wanted that to allow a few questions, but already running behind the schedule. If there is one question, I can, only one question. Please, very promptly, you should give the mic.
So the patients would take the thyroid hormones, like fasting or non-fasting, would give the result anomalous. Patient has not taken the medicines, or patient has taken the medicine and take the test of thyroid functions, right? So
you mean, so when you're checking for TSH, right. So ideally the TSH and free T4, T3 level, we ask them to check it at the first thing in the day, before taking the treatment.
Yeah, the patient takes the treatment and then do the test. So could give the anomalous reading.
Yes, correct.
Thank you. Thank you. Would be discussing more on the lunch time.
Thank you very much.
Great
Thank you.
session.
Thank you. So for the next global expert, I call upon Dr. Devijit Tripathi. Dr. Tripathi is Professor of Medicine at University of Texas, San Antonio, USA. And his research interest is regarding the mechanism of action of newer anti-diabetic drugs. And he will be talking about updates on management of type 2 diabetes with the newer incretin mimetics and SGLT2 inhibitors. So Dr. Devijit Tripathi.
Okay, I would like to thank the organizers, particularly Dr. Sahu and Dr. Panda, for the invitation. Actually, I am from here, from Bhubaneswar. I was visiting my parents, and then they said, hey, we have a meeting. So why not? So I'll share my whatever recent advances in diabetes that we have been following at the US. So I believe this is a seminar mostly focused on obesity. And I heard Dr. Rucha Mehta, actually she was one of our first fellow when I started in Texas. And so what I'll do today, I have too many slides. I'll try to skip most of them, the GLP-1 agonists, but only focus on two new drugs, which in future, which is not yet approved, but most likely in future will be the cornerstone of management of obesity, as per medical management of obesity. So I usually start with a patient. This is a real patient in my clinic. So this is a middle-aged man with a long-standing history of type 2 diabetes. He's already on insulin. He's about 100 units of insulin, metformin, and also on empagliflozin. And he has a history of coronary artery disease, has a coronary CKD, and he wants to have his glycemic control is poor, and he wants to achieve better control. His A1C is 8.5, and GFR is 50, so he has chronic kidney disease. So what are the choices? What do you want to do? So you can add insulin, of course, yeah, but he'll gain more weight. Can you give a DPP-4 inhibitors? Yes, you can, but the A1C lowering effect is very mild, so it will decrease from 8.5 to maybe 8. And how about pioglitazone? It can be used, but he doesn't want to gain weight. So the obvious choice will be GLP-1 agonist. So he was started, actually, I offered him to participate in a clinical trial, but there was no placebo. There was a GLP-1 agonist and a dual GLP and GIP agonist. After 8 months, he lost A1C was 5.9. He was on 100 units of insulin. He was no longer on insulin, and he's lost weight by 50 pounds. So can you guess what drug he was on? Obviously, there's no GLP-1 agonist which can lead to this degree of weight loss at such a short period. So most likely he was on a dual GLP and GIP agonist. So this is the guideline. I don't want to go over that. If patients have diabetes with heart disease, you start with either a GLP-1 agonist or a SGLT2 inhibitor. And as we all know that in type 2 diabetes, the majority of the mortality in type 2 diabetes because of macrovascular disease, more than 80% of mortality is accounted for the macrovascular disease. So just to show that, yes, diabetes is indeed a coronary disease risk equivalent. The top panel is for men and the bottom is for women. For each age category, the patient with diabetes has a much higher incidence of MI and coronary and death from any cause. So clearly it shows diabetes is a higher risk of MI and coronary disease. However, there is the relationship between glycemic control and micro and macrovascular disease is different. In microvascular disease, there is a linear correlation between glycemic control and macrovascular complication. However, instead, in case of macrovascular disease, this is not linear. For each 1% decrease in A1C, you can decrease the macrovascular complication by 35%. This is from Wikipedia. However, from macrovascular disease, about 14% decrease. It was not statistical significant. And several other trials have shown that intensive glycemic control does not reduce the risk of macrovascular disease. Although these trials were done when we did not have the SGLT2 inhibitor and GLP-1 agonist. So this is the list of major anti-hyperglycemic agents currently available. I'll just focus on GLP-1 agonists for the sake of time. And just for the clinicians, we know what is called number needed to treat. So for high intensity statin, these are standards of care for patients with diabetes, coronary artery disease. So you need to treat about 80 patients for about 3 years to prevent one event. However, and same with ACE or ARB, but you see the SGLT2 and GLP-1 receptor agonists, you need only 62 patients to prevent one event. So basically, this is one of the most effective agents to prevent any cardiovascular mortality. And even in a country like US, only about 25% of patients with diabetes, type 2 diabetes were on 2 or 3 more of this guideline recommended agents. So coming to incretin-based therapy, so these are currently the list of GLP-1 agonists that is approved. Most recently, the one approved was tirzepatide, which is a GLP and GIP dual agonist. I think in India, we have most of them, except I think Monjaro is not yet available here. This is the structure of GLP-1 agonist. This is the normal native GLP-1, which is at this position acted upon by DPP-4, which leads to inactivates. So the DPP-4 inhibitors prevent the degradation here. But then this is the exenatide, which is the first GLP-1 agonist. Then the liraglutide, semaglutide, the others, which is a slight modification of the native GLP-1. So I'll skip this. Mostly this is we all know that GLP-1s reduce cardiovascular outcome, particularly 3-point MACE. This is the left side is the liraglutide. The semaglutide, the XL or the exenatide did not show statistical significant difference because although this trial was the highest number of patients, 17,000, almost 17,000 patients, but patients on exenatide arm, most of them, a lot of them switched over to also started on as empagliflozin, and there was a high dropout, a 40% dropout. But collectively, this GLP-1 agonists have shown to about 14% decrease in cardiovascular events. And this is the kind of meta-analysis showing comparison DPP4, this is GLP-1 agonists and SGLT2 inhibitors. Top one is for GLP-1, then the SGLT green one is for SGLT2, and the blue one is for DPP4 inhibitor. As you can see, GLP-1 and SGLT2 inhibitors do decrease the cardiovascular outcome, whereas DPP4 inhibitors have been neutral. And for heart failure, of course, we have the SGLT2 also more potent. So I'll skip this. So let's start with, because we have I think in India, we have the oral semaglutide is currently available. It is the only oral GLP agonist currently available, approved for treatment. However, the problem with oral GLP-1 agonist is that the bioavailability is only 0.4 to 1%, because this is a peptide, so it is degraded by the gastric acid. And so you have to take a very high dose of GLP-1, oral GLP-1 agonist for sufficient amount to be available for systemic absorption. And the problem with it is this oral ribelsis is that it has to be taken in empty stomach with 120 ml of water. So there's search for other oral GLP-1 agonists. So currently, there's one which shown exciting data. I'm going to talk about the orforglipron, which is from Lilly, and there's another called danuglipron is from Pfizer, and Amgen is also working on another compound. So this is data from the oral semaglutide compared with the empagliflozins, which is showing this more potent than empagliflozin in terms of lowering A1C. And in terms of weight loss, it leads to about 5% weight loss, which was not significantly different from that of empagliflozin. So this drug is effectively in terms of management of glycemic control. The weight loss, it leads to about 5% weight loss, which is actually the cutoff requirement for approval for any weight loss drug in the US. So if you can lose 5% of body weight, that you can get approval for weight loss treatment. So there is a search for other compounds which can act like which a GLP-1 agonist can be given orally. As you know, in India, very poor acceptance of injectable agents. So this is the new drug called orforglipron. It's a non-peptide GLP-1 agonist. So that's because a non-peptide GLP agonist, it's not degraded by the gastric acid. And this is the structure. And it's a partial agonist. And what it does, it activates the cyclic AMP, by which the second messenger by which the GLP-1 receptor agonist act. And it also activates something called, it does not lead to activation of beta-arrestin, so which actually leads to degradation or internalization of the GLP-1 receptor. So the activity of GLP-1 agonist is prolonged. And half-life is about 30 hours. And the other thing is that the bioavailability is 30 to 40% compared to semaglutide, it's about 1%. So it's much more bioavailability. And this drug can be taken without restriction of food, water, or any other medications. So last time, I think last year when I came, I just showed the phase 1 data. And now it was just recently published in the New England Journal of Medicine, the phase 2 data of this particular compound. So the primary objective of this compound, the study, was to see whether this drug is effective in terms of weight loss. The first study, I'm going to show you the effect of this drug in patients with obese. This is a non-diabetic obese. And then I'll show you data on patients with type 2 diabetes. So this is the study design. There's placebo arm and there's multiple doses of this compound. To get into the study, we have to be obese, more than BMI more than 30, or more than 27 with another comorbidity. So here is show the effect on weight loss. So with the higher doses of this drug, one can see the weight loss about 12 to 15%, which is comparable to like injectable semaglutide. There's no other oral drug in which you can see this degree of magnitude of weight loss. And almost like with the higher dose of this drug, 15% body weight loss, which is remarkable given that it's oral agent. And this drug is taken like once a day in the morning, any time of the day it can be taken. And the percentage of patients who are achieving weight loss more than 5%, almost 90% achieve more than 5%. Compared to semaglutide, only about 30 to 40% achieve more than 5% weight loss. And about 15%, about 40% have lost more than 15%. In a bariatric surgery, they lost about 20 to 30%. This is as good as it can be with an oral agent with more than 40% of patients lose more than 15% body weight. And also it lowers the blood pressure, particularly the systolic blood pressure, about 2 to 3 millimeter of mercury. And the change in diastolic blood pressure was not significant. And has a beneficial effect also on lipids. It slightly lowers LDL and the triglycerides. And the side effects, now everybody will ask if this is so effective, the side effects must be very high. But the side effect is comparable to other GLP-1 agonists. About initially when you start, you have to go slow. And the nausea, you can see about 20 or 30% will have nausea, and some patients will have diarrhea. And the GI side effects are the most common, particularly the nausea. So in non-diabetic obese patient, this drug leads to about 15% of weight loss. And this is a short study, only 6-month study. If you extend it to maybe for a year, you may see much greater weight loss. They have not yet reached the plateau. That means they continue to lose weight. And about 70% patients who are IGT actually reverted back to NGT, which is remarkable. Again, you see very few drugs which can revert back to NGT. So, and the efficacy is comparable to other injectable GLP-1 agonists, and the side effects comparable to other. And the other thing is that you do not have to take an empty stomach, can be taken with or without food, and no other restriction. So this drug has a potential, this is not yet approved for treatment for obesity in the future. And then the next study is actually same drug in patients with type 2 diabetes. And this was in several centers, a total of 300 patients, again, multiple doses. And here they had a control arm with dulaglutide, which is injectable GLP-1 agonist. Again, you can see there is a remarkable degree of improvement in A1C, about 2% drop in hemoglobin A1C with this drug. Again, no other oral agent will lead to a 2% drop in A1C. Most of the oral agents lead to a drop of maybe 0.5 to 1%. And the fasting glucose, and there's the change from the base on the weight is 10% weight loss. It's always known that patient with type 2 diabetes on any weight loss medication will lose less weight than that of non-diabetic obesity. So about 10% weight loss and 2% drop in A1C. So again, about this is A1C less than 5.7. So diabetic coming back to normal glucose tolerance test is about 30% turn to complete normal glucose tolerance, and about less than 6.5%, because that means non-diabetic range, about 40%. And similarly with body weight loss, 15% weight loss is seen about 20%, and more than 10% weight loss, about 40% lose more than 10%. So this does remarkably effective in lowering body weight as well as A1C glycemic control. So patient with type 2 diabetes, it shows superior glycemic control weight loss compared to placebo and dulaglutide, which is an injectable GLP-1, and efficacy is compared to other like semaglutide, injectable semaglutide, particularly the 1 milligram dose, not the 2.4 milligram. The GI side effects mild to moderate, and the safety profile is similar to other injectable GLP-1 agonists. So again, so this drug has a potential for future treatment for diabetes and obesity. Now talk about some newer molecules. You can, because for metabolic disease, you need to have multi-pronged approach. And you can either give multiple hormones, separate hormones, or you can give unimolecular. That's one molecule will bind to several other receptors. So it's called hybrid molecules. So, and the benefits of hybrid molecules is that you can retain the beneficial effect of each individual component, whereas minimizing the adverse events. So you can have a complementary or synergistic effect of one particular compound on one particular receptor. So, and the other benefit, they all have a single pharmacokinetic profile because they have only one compound. And they all have potential multiple effect at a single target. And so this is just exam schematics of a different dual or triple agonist. And tirzepatide, I think you must have heard a lot about this drug. It's a GLP and GIP. For the general internists who do not know what a GIP is, a glucose-dependent insulinotropic polypeptide. This is another incretin. It's actually the major endogenous incretin, contributes about 40% of endogenous incretin effect. And tirzepatide is a 39 amino acid peptide, which is recently approved by the US for treatment of diabetes, not yet approved for treatment of obesity, just to show that this is the GLP-1. This is a combination of GLP and GIP. And the structure just retains amino acid both common to GLP and GIP, and the one in red actually similar to other amino acids coming from exendin. So how does it act? It acts both GLP-1, GIP act on the pancreatic beta cells, causing increased insulin secretion. and they have complementary effect on weight reduction, and GIP in particular acts in lipid partitioning and adipose tissue function, adipose tissue insulin sensitive. Cardiorenal effect, there's no study yet to come for cardiovascular trials results, but they have improved cardiovascular risk profile. There are multiple studies on with tirzepatide already been published. And just a summary of phase 2 and phase 3 data, effect on A1C. On an average, you can see there's a 2 to 2.5% weight loss with different strengths of tirzepatide. The weight loss, again, varies from 15 to 25% weight loss with this compound. It's a once a week dose. And there was a concern that if you lose weight, are you losing more lean mass or fat adipose tissue mass? Here, compared to semaglutide, they lose much more fat mass, and the lean mass is proportionate. There's no increased loss of lean body mass. That means muscle mass is in similar proportion to that of fat mass loss. And here again, comparison with semaglutide, you lose more fat mass in tirzepatide versus semaglutide. And this effect on pulse, all GLP-1 agonists, they increase the pulse rate by 2 to 3 milliliters. Despite this, they have improved cardiovascular outcomes, and they all lower the blood pressure also. And this incidence of nausea and vomiting, I already talked about it. So it's about 20 to 30% will have nausea. The key is to go slow, start slow and go slow for this kind of drugs. To summarize, this drug is very efficacious in terms of glycemic control. Cardiovascular outcome, we do not have the data yet, but there's a big trial going on called for the Surpass CVOT trial. That results come in 2024, and we'll find out if this is effective in lowering cardiovascular outcomes or not. Okay, so now I can skip this. So now let's talk about the newest drug in this class. It's called triple agonist. It's a combination of GLP, GIP, and glucagon. Why glucagon? Because everybody will think that glucagon increases the glucose. Why do you need to combine glucagon for treatment of diabetes? And because the glucagon also causes increased energy expenditure, decreases appetite, and it has an effect on gastric emptying. So it will be synergistic to GLP and GIP. So that's the normal role of glucagon in healthy individuals is to maintain the glucose during the overnight fasting period. However, it's other effects of glucagon which is beneficial can lead to complementary effect with GLP and GIP. So, okay, so now I'm going to show you this, the triple agonist, which can bind to GLP and GIP and glucagon. One molecule binds all three receptors. And this is the first data. This is the phase 1 data, let me skip that. But this is this compound called retatrutide, which is a triple agonist, GLP, GIP, and glucagon. And this is the GIP receptor active, mainly binds to GIP and less to that of GLP and glucagon. And this study design, there's a placebo and different strains of retatrutide. This is injectable once a week compound. And you can see that with this drug, you can lead to weight loss of 25%, which is like comparable to that of bariatric surgery. And from baseline to this is about 6 months. So you lose the highest dose, you lose more than 20% body weight. And the target body weight, about more than 20% body weight loss is around 30% of patients. So this is of all the available drugs so far, this is the most potent in terms of weight loss. And again, this drug also leads to significant decrease in systolic and diastolic blood pressure, and heart rate goes up, which is common to all GLP-1 agonists. So in summary, this is the triple agonist, GLP, GIP, and glucagon, which shows a very large drop in hemoglobin A1C and weight loss of more than 20%, and which is actually superior to other incretin-based therapies. And so far, and again, we have not reached the plateau by the age of 36 weeks, and also had improved cardiovascular markers like systolic and diastolic blood pressure, and the adverse effects were comparable to. So I'll just show you again the other potential other GLP-1 agonists in the horizon. There's the monoagonist, and then there's oral agents. I talked about this compound, the Lilly compound. Another compound, this is by the Pfizer called danuglipron, is undergoing trials. And these are the other dual agonists and triple agonists. Dual reduce appetite, and with the triple agonists now they're being developed. So again, so we start with monoagonist, dual agonist. Now we have the triple agonist for treatment of type 2 diabetes and also for obesity. This will be. So these compounds have I think, has a promising future for treatment of obesity and diabetes. And I think I should stop here. This is just the incretin-based drugs. I think will be a huge success. Will play a great role in future treatment of obesity and diabetes. Thank you.
Thank you, Dr. Tripathi, for throwing light on very exciting trends of monoagonist, triagonist, and twin ketones. So many new things we have learned. Thank you very much for giving newer mechanisms to manage type 2 diabetes. I think we are running late, but still one question can be, if one question, yeah, you can ask. Please give mic. Quick.
Oh, I think maybe in a year or two.
So then what will be the future of DPP-4? Do you think there will be a future for DPP-4
I don't
once
think
the
so.
oral non-peptide GLP-1 will be available?
Because this, in terms of efficacy, this is much more. DPP-4 will decrease the A1C by 0.4 to 0.5%, whereas this will decrease by 1.5. And DPP-4s are weight neutral. They do not lead to any weight loss. Whereas these drugs will lead to much more weight loss.
Except the tolerability may be an issue of
Yes.
the GLP-1.
So, yeah, so DPP-4 are very well tolerated, but this
the future of DPP. Yes, definitely for any new drug come with the cost is always, but the future means down the line 10 years. We are not talking about.
No, not 5 years. So you still have to market for them,
Yes.
particularly those. Oh, there's a very high dropout rate, 20% dropout.
Oh, yes.
Because of they could not tolerate the drug. So there will be.
And they started with 3 milligram and continued up to 36.
Right. Yeah.
40. Oh.
For 40 years. So the tolerability is an issue, yes.
Sir, in the recent ESC conference, they told that because this MREF and HFPEF, still SGLT2 is better. And sir, now that canagliflozin 300 was not in those things, they only talked about DAPA and EMPA. But canagliflozin 300 mg, when we are using clinical practice, significant weight loss as well as significant HbA1c control. However, mostly people use 100 mg, but I personally have seen 300 mg cost-wise also less, and it is as good as oral semaglutide.
Yeah, so oral semaglutide is not very efficacious in terms of weight loss, but if the patient has heart failure, definitely will prefer a SGLT2 inhibitor. But if you have, and oral semaglutide again has not been shown to have improved cardiovascular outcomes. So this drug also is not shown it, we don't know it. But canagliflozin you can use, particularly patient if there's any history of heart failure, I think that would be a preferred drug, yes.
Thank you, Dr. Devijit. And really, I am
one more question I would like. You have been giving a lot of stress on the pharmacological management, but you have forgotten entirely about the non-pharmacological interventions. In fact, the latest guidelines say very clearly, non-pharmacological intervention has a very strong role, especially the intermittent fasting, time interval eating, and vigorous physical activity. In fact, the three important role of this is they are seriously thinking to mention it as the reversal of diabetes, reversal of obesity, and even the conversion or sometimes remission of the diabetic. So I think while talking about the pharmacological thing, you must mention the non-pharmacological.
Thank you. Thank you. This was out of the scope of the topic. That's why it has not been mentioned. So,
I'll just have one minute because I agree totally. We do not say that start any drug for treatment of diabetes or obesity. Lifestyle modification is the first.
I think we are running late, so we can finish the session, and this discussion can be outside the hall. So now, yes, sure. Preeti, you take over. So for the next session, invite.
Mementos. Facility.
That I will do that. You invite the next chairperson here. We'll do the memento here. There.
I am delighted to invite our chairpersons for the next session, Dr. Pankaj Chaudhary, Dr. Subhranshu Patro, and Dr. Shri Prashant Mahanti for the session on master stroke. Over to chairpersons.
So very good morning to all of you. And, I think it would be a very exciting session. For now, there would be three talks lined up. So I think the organizers have not provided the CVs of the speakers. May I have the first speakers, please? Dr. L. Srinivas Murthy is here? Yes, sir. So we'll be speaking on a very interesting topic, diabetes in lung. Actually, this topic has not been, discussed in any other meeting. As a physician, I would say that if the patient having, tuberculosis, pulmonary tuberculosis, it's empirical to have the blood sugar also with HIV, right? But how the diabetes affect the lung, I think it's a very exciting talk. So can we have the first introductory slide of you, sir? May I have the first slide, please?
The lung functions are impaired.
Yeah. Talking about epilepsy and psychiatric disorders. Over to you, sir.
Yeah. So good morning to all. Thanks, chairpersons. And thank you, Dr. Virmani, Dr. Jayant Panda, Dr. Anuj Maheshwari, and all the senior members of organizing committee and the scientific committee for giving me this opportunity. Topic, whosoever dealing with the epilepsy, 60-70% in the refractory seizures, they have got a psychiatric comorbidity, which we used to forget about asking, and so that's why the result is not good. Now, in our presentation, scope, introduction, psychiatric comorbidities, etiology, and management strategy, and take-home message. Now, what the Hippocrates says, melancholics ordinarily become epileptics, and epileptics, melancholics. What determines the preference is the direction the malady takes. If it bears upon the body, it's epilepsy. If upon the intelligence, then melancholy. Now, as already told, 70% of the patients with intractable complex partial seizures had one or more diagnoses. There is a huge amount. 58% had a depressive episodes, 32% had a agoraphobia without anxiety or panic attacks, and 13% had a psychosis. Risk of psychosis in epilepsy is 6 to 12 times as high in the general population, with a prevalence of the 7 to 8%. So psychosis is also high, depression is also high, anxiety disorder is also high. In a population-based study in the Great Britain in children, that 37% among children with epilepsy, that they have got a psychiatric disorder in epilepsy. And compared to that, 11% among children with diabetes and the 9% among controls. So in children, the new onset epilepsy, they have got diagnosed of 37% the psychiatric disorder, while they have diagnosed that in diabetes, it was only the 11%. So why so much emphasis? Because that every physician is treating, neurologist is treating the epilepsy, but the outcome is not so good because it's a psychiatric comorbidity can affect the course and the management of the seizure disorder at various levels. And there are a history of mood disorder preceding the onset of epilepsy appears to be associated with an increased risk of treatment-resistant epilepsy. Treatment-resistant epilepsy. A history of mood disorder preceding to that. A personal or a family history of the psychiatric illness have been associated with an increased risk of non-psychiatric or psychiatric adverse events to the anti-epileptic drugs. The current and or past history of mood and anxiety disorder may facilitate the development of seizures associated with the stressful situation. Anything, anxious thing, they may develop the epilepsy because of they have got a history of the mood and the anxiety disorders. A lifetime psychiatric history preceding the onset of epilepsy can impact the life of patient with epilepsy in the following areas. The current mood and anxiety disorder is a strong predictor of poor quality of life. A poor quality of life. Current mood disorder is associated with an increased use of medical services. That's why the cost is high, leading to higher economic burden. Comorbid psychiatric disorders and in particular mood disorders and substance abuse are associated with an increased use of premature death by external causes like accidents and the suicides. So what are the psychiatric comorbidity? Almost all the psychiatry is there in the epileptics. The mood disorders, suicide, anxiety disorders, psychosis, PNES, personality disorder, other comorbidities like ADHD, aggression and hyposexuality. Mood disorder, most prevalent neuropsychiatric disorder in epilepsy. Depression among patients with epilepsy ranges from 20 to 55% in patients with recurrent seizures and 3 to 9% in patients with controlled epilepsy. So in recurrent seizures, 20 to 55% and the 3 to 9% in controlled epilepsy. Studies focusing on depression in children with epilepsy found depression rates of almost 23% in 8 to 18 years of age group with new onset of epilepsy. Depression can manifest in several forms like major depressive disorders, dysthymic disorders, adjustment disorder, and depressive episode of bipolar disorder. The major mood disorder in epilepsy have got a dysthymia, that's a low-grade depression, at least for the 2 years duration, is called as a dysthymia. So that is more common. Now, suicide. One is a completed suicide and here is a attempted suicide. So I am talking about a completed suicide. Risk of completed suicide in epilepsy patient is 4 to 5 times greater than that among the non-epileptic population. Patients with complex partial seizures of temporal lobe origin have a particularly high risk as much as 25 times. So if a temporal lobe is a sheet for developing the epilepsy, then the 25 times more chances of getting that tendency to suicide. Depression and cognitive impairment seems to be the risk factors for suicidality in epilepsy. Contributors to successful suicide includes paranoid hallucinations, occasional ictal command hallucinations to commit suicide. A word about anxiety. Prevalence of anxiety is 19 to 60% in epileptic patients, and the type of the disorders of anxiety is a panic disorder, generalized anxiety disorders, phobias, and obsessive compulsive disorder. The word about why the anxiety develops. Having epilepsy in association with a large number of threats, including the unpredictability of the seizures, the feeling of loss of control, the risk of ictal injury or even death due to the epileptic phenomena at that time, and negative social effects with the further increases anxiety in patients. Psychosis, 6 to 12 times more common in people with epilepsy than in the general population. However, in general population, 2 to 6% is the incidence. Among the most systematic description of psychosis is the categorization based on the temporal relationship of the psychosis to the ictus, that we can divide the ictal psychosis, post-ictal psychosis, and interictal psychosis. To the lack of the time, I am passing out all these three phases. A common word for the next comorbidity. Psychogenic non-epileptic seizures, PNES, are involuntary, psychogenically induced spells that mimic many epileptic patient behaviors. Up to 30% of patients with epilepsy are affected with non-epileptic seizures, like we used to say the functional overlay in the epileptic patient. So this is the categories of 30%. Differentiating epileptic seizures from non-epileptic seizure can be difficult based on history alone. However, video EEG monitoring is the gold standard and can diagnose non-epileptic seizure with near certainty. However, diagnosis of non-epileptic seizure does not rule out epileptic seizures. The most helpful differentiating feature, ictal duration, usually of the 2 minutes. Non-epileptic seizures usually occur in the presence of a witness, can often be associated, induced with injection, hypnosis, or suggestions in non-epileptic seizure. Poorly responsive to anti-epileptic medication, untimely, ultimately the differentiation may require video EEG. Now, personality disorders. 18%, which include borderline, histrionic, and dependent disorders, like they have got a histrionic type of the disorder, personality. They want to show whenever they are in the society. The most common personality disorder in epilepsy is a borderline personality. Personality profiles of patients with epilepsy can be explained by a complex combination of the effects of dealing with a chronic illness because of that being epileptic, anti-epileptic drugs, and temporal lobe pathology. Commonly, we used to see in the patient the aggression phenomena that can occur in relation to an ictus, as exemplified by the patient's subacute post-ictal aggression. Most aggression among epilepsy patients is not related to epileptiform activity. However, but aggression in epilepsy is usually associated with psychosis or with intermittent explosive disorder and correlates with subnormal intelligence, childhood behavior problem, prior head injuries. Now, about hyposexuality, which is the next comorbidity, which we used to see commonly by the attendants or by the patient himself. Patients with epilepsy tend to be hyposexual. Men and women experience disturbances of the sexual arousal and a lower sexual drive. Men have increased risk of erectile dysfunction, suggesting a neurophysiological component, and studies of sex hormones suggest the possibility of a subclinical hypogonadism. There can be undesirable effect on the sexual performance of the anti-epileptic medication, including erectile dysfunction, decreased sexual desire, retrograde ejaculation, and altered semen quality. Now, what about the etiology about all these two phenomena? It's a bidirectional relationship, and one of the two studies were there, Swedish hospital discharge registry. They have noticed about a patient who has been admitted for the psychiatric things in the hospital 2 years prior to that or 2 years later than that. They have got a chances of developing the epilepsy. They are being admitted. A psychiatric patient admitted for some illness, and 2 years later they may develop the epilepsy. A retrospective study done in England reported a significantly increased risk of epilepsy in patients previously admitted for schizophrenia and vice versa. The rate ratio for the risk of epilepsy in patients with schizophrenia were 2.1 and 3.0. These data suggest either a possible bidirectional relationship between these two disorders in the presence of common pathogenic mechanisms that facilitate the occurrence of one in the presence of the other. Now, where is a sheet in that in the brain? Main molecular mechanism involved is the hippocampus, which is being damaged in response to chronic stress and associated with epileptogenesis, epilepsy, and development of comorbid depressive disorder. So, hippocampus is the sheet. Now, affective disorder more common in temporal lobe epilepsy. The limbic structure located in the temporal lobe on one side is regulating the mood, pleasure in the mood. On the other side, that is generation of the seizures. So, due to this dual function of the limbic system, numerous studies have addressed the relationship between temporal lobe epilepsy and affective disorders. Now, about the treatment part. In the treatment of psychiatrically disturbed epileptic patients, we need to address certain issues. Which AED anti-epileptic drug is to be chosen, which psychotropic to be chosen, and what else can be done. Now, few facts are there about the anti-epileptic drugs. Carbamazepine and valproate have significant anti-manic and modest antidepressant property. So, with both these two drugs, they have an efficacy in the long-term prophylaxis of manic episodes. Carbamazepine and valproate may also ameliorate some discontrolled aggressive behavior in brain-injured patients. Lamotrigine is the only anti-epileptic drug that has a very well-established efficacy in preventing recurrence of depressive episode in bipolar disorder. Clonazepam, in addition to its anxiolytic property, can serve as a supplement to other anti-manic therapies. Even at therapeutic levels, barbiturates may need discontinuation because of drug-induced depression, suicidal idea, sedation, psychomotor slowing, and paradoxical hyperactivity in the very young and very old person. Levetiracetam may cause irritability and aggression. Vigabatrin may precipitate depression. Gabapentin and pregabalin also decreases anxiety and improve general well-being in some epilepsy patients. Now, as a whole, in short, anti-epileptic and their behavior effects, barbiturate already told, carbamazepine, irritability, impaired attention. Gabapentin, more better, behavioral problem in children only being noticed. Levetiracetam, irritability, emotionally labile. Phenytoin, encephalopathy, depression, impaired attention. Pregabalin has got a less likely to cause the behavioral problem. Topiramate, depression, psychomotor slowing, psychosis, impaired cognition. Valproate, encephalopathy and depression. Zonisamide, agitation, depression, psychosis. Now, which psychotropic to be chosen for the patients who has got epilepsy already? The principle of choosing antidepressant will be based on adverse effects and the tolerability of the patients. Antidepressant can elevate both anxiety and mood symptoms at the same time. Most concerned issue for antidepressant in epilepsy is the seizure threshold lowering property. So, to be chosen like that, which antidepressant is having a lower threshold, seizure threshold property. A small number, up to 15% of the interictal psychosis resolves without any treatment, but a majority of the patient requires antipsychotics. Now, that's a list of the psychotropic and their seizure threshold lowering property. The high one is the chlorpromazine, nowadays not available officially. Clozapine, olanzapine, quetiapine, they have got a high tendency to high threshold, seizure threshold. And the low one is a haloperidol, risperidone, and aripiprazole. Antidepressant, imipramine, meptrotyline, amitriptyline, like all these triptyline is a high tendency to develop the seizure, and less amount is a serotonin reuptake inhibitor. According to their better tolerability profile, SSRI and SNRI can be given as first-line antidepressant in patients with epilepsy. SSRI may be more suitable in patients with depressive disorder associated with comorbid anxiety disorder. SNRI may be more beneficial in patients with depressive disorder with psychomotor retardation, fatigue, and cognitive slowing. Now, first line SSRI has a fluoxetine, sertraline, escitalopram. SNRI has a venlafaxine and duloxetine. Second line is amitriptyline, nortriptyline, imipramine, clomipramine. So our treatment strategy should be screen for the presence of mood and anxiety disorders at every visit. So every patient who is epileptic in your next visit, always screen about the mood and the anxiety. A question should be asked in that patient because he will not tell. Emergence of depressive and anxiety features should not be ignored. Possibility of weight gain and impaired glycemic control must be kept in mind while selecting the antidepressant and the antipsychotic drugs. Almost I came to know that the 70 to 80% these drugs are poor glycemic control and they increase the weight. It is preferable to use drugs in combination with psychotherapeutic intervention. Milder form of the depression and anxiety, especially in children, adolescent, and pregnant females, can be managed by psychotherapeutic intervention such as cognitive behavioral therapy, motivational therapy, problem solving therapy. Now, what else can be done? We should also implement behavior changes with mind gym, which involves training the mind to maintain the balance. Now, that's a mind gym is a meditational technique, deep breathing technique, yoga technique, relaxation therapies like yoga nidra, progressive muscular relaxation can help in reshaping the mind balance, learning new skills or developing a new hobby to keep your mind active. Make efforts to go out, socialize with family and friends at least once in a week. Make efforts to go out with socialize with family and friends at least once in a week. Now, last, I'd like to say that epilepsy is more than seizures. Epilepsy is a complex neurological condition that extends beyond seizures, often involving psychiatric comorbidities. High prevalence of psychiatric morbidity. Psychiatric disorders are highly prevalent among epilepsy patients, impacting their overall well-being. Bidirectional relationship. There is a bidirectional relationship between epilepsy and psychiatric disorder, meaning one can influence the other. Diagnostic challenges. Diagnosing psychiatric disorders in epilepsy patients can be challenging due to overlapping symptoms and medication side effects. Quality of life impact. Psychiatric morbidity significantly affects the quality of life for epilepsy patients, affecting their social and occupational aspects. Integrated treatment should be integrated, addressing both epilepsy and psychiatric disorders with tailored medication, psychotherapy, and lifestyle adjustment. Systems matter. Support system, including family, friends, and support group, play a crucial role in the well-being of the epilepsy patient. Future research, ongoing research in this field holds promise for better understanding and management of the mind-epilepsy connection. Thank you for your attention.
Thank you, sir, for highlighting a very important issue that it's very easy to diagnose an epilepsy and just write the medications. And we should not, as you discuss about the mood and anxiety disorders of the patient.
Just ask mind, the mood, man kaisa.
Right.
And also one question is that just behind that, how's your appetite? How's your sleep? If the sleep is not good, that means you'll have to explore the psychiatric aspect. And mood from our language is man, ठीक है, दुखी है, प्रसन्न. In in that language. You'll have to, because not able to understand what the doctor is asking about a mood. Mood they think so the taste. Mood they think so any other thing. But ask about a mood, because you see that dysthymia is a very common because of the lot of the social issues, lot of the anxiety disorders are there. They have got a, when you say, doctor, when I'll be having a next season, so I don't know. Whether you are controlled, you say as a doctor, I don't know, because you'll have to take the regular medication. That time will say. So again, by listening that answer, they develop the phobia, they develop the anxiety, they develop the social issues. Still, social issues are so much.
It's very also important that some of the drugs that we give, actually, they also causes the mood disorder. So we have to be, knowledgeable to understand the effects of that particular drugs also. So that with time to time we can, ask the patient that any other changes that you are developing after this starting the drugs is also important, sir.
Yes. Because now I remember that thing that Dr. Mani and all team, if you remember that, they have taken out that from the Hindu Marriage Act, that epilepsy is one of the divorce condition if you diagnose the epilepsy. Now, when returned back, because epilepsy is having a lot of the psychiatric comorbidities, and that's why they have put down originally. Now, subsequently for the epileptic patient, they have withdrawn. But initially, at that time, epilepsy was also having a psychiatric comorbidity. The 100 years back or the 150 years back, and today also when the recurrent seizures are there, temporal focus is there, then the more chances are that to have that psychiatric comorbidity.
Thank you, sir, for a nice talk. So we'll move to the next topic.
Thank you, sir.
We'll move. I think the first slides are ready, I think, Dr. Murthy. So can we have the slides, please, Dr. Murthy? Yeah, because I think you have to take the flight, right? Right, that's great. So very long CV, I think, to cut short, he's Professor D.L. Srinivas Murthy is Life Care Hospital Research Center at Bengaluru, right? So I think without wasting time, we can have the
Thank you, sir. And I think lung functions are back to normal now. So we'll look at. I think this is a topic which is least covered, and Birmani sir is one of the persons who always looks at off-the-track topics, and this is what he gave me, the diabetes and lung disease, and I nicknamed it as an underestimated relationship. There is a relationship, but it's definitely underestimated in our routine clinical practice. It was Schuller et al. In 1976 who first identified in type 1 diabetics that the reduction in lung elastic recoil is impaired in type 1 diabetics, and that was the first evidence to show. And these are in general the factors in an individual where it can lower the immune responses. And you can see the diabetes apart from HIV, immunosuppressant drugs, and all these foods also reflects. So diabetes is the key factor where it is definitely there as one of the immunosuppressant immune lowering response. So why are we concerned about diabetes in general? Remember, every day in 24 hours, 3,600 new cases are diagnosed. 580 people die of diabetes related complications. 225 people have diabetes related amputations. 120 people with diabetes progress to end-stage kidney disease, and about 55 people become blind literally every day because of diabetes. That is why it has been their biggest burden on our economics. So let us look at the background for pulmonary lung functions and lung and diabetes. The infections in diabetes are definitely characterized by the host defense, the entire body and the lung locally, as well as the function of respiratory epithelium and ciliary dysmotility. They are characterized by serious clinical features, longer duration, more frequent repeated complications, and of course increased mortality, and that's how indirectly the burden on the society. The pulmonary infection mortality among diabetic patients with ESRD is 10-fold when you compare with the general population. And of course, hyperglycemia can cause an alteration in the host defense and consequently increase susceptibility to infections. Now, hyperglycemia in immune system, of course, the hyperglycemia impairs a wide range of functions related to the neutrophils and monocytes, particularly thus limiting the invasion by the pathogenic and other bacteria. Of course, the adherence and phagocytosis depend on the recognition of specific molecules on the bacterial surface, which includes the glycoproteins as well as the attached complement and the IgG produced as a result of the immune response to the infection. And the movement of these phagocytic cells to the sites of infection is impaired, and that is the reason why you have repeated infections. So the respiratory tract infections and diabetes At the population level, if you can see, the patients with diabetes may be more susceptible because of their age, unhealthy lifestyle, decreased immune function, increased risk of aspiration, because one of the factors is the diabetic gastroparesis, pulmonary microangiopathy, frequent comorbidities associated with diabetes, which includes renal failure, stroke, etc. And this slide summarizes the respiratory tract abnormalities in a diabetic patient. You can see the reduced lung functions, reduced forced vital capacity, the dynamic compliance, the lung autonomic neuropathy. On the right hand side, you can see that's another big time problem in diabetics, and which can result in impaired ventilatory response to hypoxia, reduced mucociliary clearance, reduced respiratory muscle strength and muscle dysfunction. These are the factors which can push and make lung, typical diabetic lung, which will result in a lot of complications. So let us look at the pathophysiology of lung functions in the diabetic background, which includes the hyperglycemia, hyperinsulinemia, autonomic neuropathy, oxidative stress. All these are, of course, it's a complex and multifactorial, completely not understood, but various factors have been implicated in this. Now, these are the various aspects of lung involvement in the background of diabetes, which can be infective, vascular, airway diseases, and of course, autonomic neuropathy. On the right hand side, you can see the complications because of these. So let us look at individually few of them. Of course, we cannot cover the topic, but this can be a bird's eye view presentation of all these. So the staph infections, which is the etiology of both the community acquired and the nosocomial pneumonia and diabetics. On the basis of this high nasal carrier rate, the diabetics are thought to be an increased risk of this staph pneumonias. 30% of diabetics are nasal carriers, and it's something which we do before a CABG. I'm sure all of you know how we desensitize the nasal carriers. 11% in the healthy individuals versus 30% in the diabetics are nasal carriers, and the rate of nasal carriage of staph aureus is directly related to the HbA1c levels. So the more the HbA1c, the higher the chances are becoming the nasal asymptomatic carriers in the diabetic population. So the diabetics, of course, are at increased risk of developing complications because the bacteremia and the staph aureus pneumonia with an increased risk in the mortality eventually. The gram-negative organisms, the predisposition in diabetics to the development of gram-negative aerobic pneumonia is attributed to the increased rate of upper respiratory colonization with these organisms, and diabetics have an increased susceptibility to laryngeal trauma whenever there is something like intubation, etc. And the ability of gram-negative aerobes to adhere to the upper respiratory epithelium is increased in diabetic patients, and upon adherence, the bacteria are aspirated in the lungs. The host defense may be further impaired by factors such as coexisting pulmonary edema and impaired phagocytosis, which is the basic defect, and subsequent risk of aspiration, which is increased also superadded by your diabetic gastroparesis. Anaerobic bacteria, of course, the diabetes is not specifically identified as a risk factor for developing anaerobic infections, but because of altered cough clearance mechanism, esophageal disorders, depressed mental status like hypoglycemic seizures, what Maheshwari sir was alluding earlier talk, which are identified as risk factors for developing the aspiration pneumonia, which is again a problem in the elderly diabetics. Atypical pathogens, I think Legionella is something which is underestimated again, which is one of the important causes of community acquired pneumonia, which is associated with the excessive morbidity in diabetics, possibly on the basis of impaired cell mediated immunity. Large series of community acquired Legionellas were reviewed, and diabetics were seen at an increased risk of acquiring these infections, and the mortality in one of the series is as high as 19% with these infections. And the presence of diabetes alone, the relative risk of acquiring this Legionella infection is about 3-fold more compared to non-diabetics. And of course, the most common complications of pneumonia in the background of diabetes would be the effusion, empyema, bacteremia, especially the Klebsiella. Now, the fungal infections, which can be caused by mucormycosis, aspergillosis, coccidiosis, or cryptococcus, the poorly controlled diabetes are definitely more prone for these infections, and the bronchoalveolar macrophages have a decreased ability to inhibit the spore generation, resulting in rapidly progressive pulmonary infections and the hematogenous dissemination and eventually death. And these fungal infections, aspergillosis can cause fungal pneumonia in diabetics. Typically, you see in a tuberculosis cavity as a complication. Although rare, coccidioidomycosis and cryptococcal pneumonia may be more common in diabetics than in non-diabetics. And of course, viruses, the viral infection may be one of the causes per se of type 1 diabetes, and viral infections can be dangerous in diabetics, not just from the problems of eating, insulin management and hyperglycemia, but there is an increased risk of complications like in influenza with associated risk of hospitalization and ICU admissions, which is again a burden on the society. The influenza immunization reduces the risk of admission, and this is something which most of us do not initiate in our routine practice to our patients, which is not very costly business, but we do not have the enough knowledge updation about the immunization, and we do not initiate to our OPD patients, and that's something important, and the onus is clearly on us to initiate and advise our patients for the effective immunizations schedules yearly or once in lifetime accordingly. The HBV, HCV are common among people with diabetes than those without, and HCV increases the insulin resistance and diabetes risk apart from other complications of the HCV. Now, influenza is a substantial cause of mortality and morbidity in diabetics, and during episodes of influenza and pneumonia, the rate of ketoacidosis mortality sharply increases in diabetics, and this can be due to reduced ciliary clearance of inhaled or aspirated bacteria and predisposes the infected host to bacterial superinfection as well, and that's another problem. Combined with the increased rate of nasal carriage of staph in diabetic patients, the reduced clearance leads to high risk of developing post-influenza staphylococcus pneumonia, which is a mortality of as high as 30%. So that's something which we should always keep in mind when we treat this, treat it completely and follow the patients properly. This is just to show an X-ray and a CT. We'll just skip that for want of time. Now, the common challenges is about the antibiotic usage in diabetics, especially the aminoglycosides. Most of us are expensive, we think, monitoring, but definitely the drug levels need not be, and the renal or ototoxicity can be managed. And remember, it's a reversible nephrotoxicity which happens. You need not avoid this, but unnecessary use of aminoglycosides is definitely not encouraged. Based on the culture, you can definitely start. And patients placed on aminoglycosides require consistent monitoring of therapy, and subsequent serum creatinine is something which, if you think it's worsened by 0.4 milligrams, is an indicator of renal damage, and you need to adjust the dosage or withdraw depending on the patients. And other nephrotoxic, ototoxic drugs, when you are using this, you need to be careful, keep in mind. Fluoroconolins, of course, are generally regarded as safe antimicrobials. I know during COVID, all of us have used it right and left, and they enjoy widespread use. And although uncommon, hypoglycemia has been reported with these fluoroconolins and appears to occur most frequently in the elderly subjects and type 2 diabetics who are receiving the therapy with OHs. And the exact mechanism, though it's unknown, but it is contemplated that the result of blockage of the adenosine triphosphate sensitive potassium channels in the pancreatic beta cell membranes are blocked, and thus it results in prolonged hypoglycemia. Sometimes it can be troublesome. So we need to be aware about the potential adverse event of these fluoroconolins whenever you use it. Now, let us look at the other problems. These are the 4 segments which we are discussing, and let us look at the tuberculosis part. TB is the shadow of diabetes, and that is what it's clearly said, and long recognized but underappreciated. And I'll show you this next slide. You'll be surprised who are the VIPs, stalwarts who had TB and diabetes. So I was always wondering, Gandhiji, how did he maintain his BMI? I thought it's all because of his salt walking. Again, he's fighting in the Britishers, but it was in the background. You see, these people had tuberculosis and diabetes, and that's what I searched whenever I was looking for this topic. So the remarkable historic fact is that autopsy of diabetics way back in 1883, the presence of tuberculosis granuloma was seen in 50% of the cases. That's about history about diabetes and TB. Prior to insulin era, it was said that diagnosis of diabetes was a death sentence, and that was a leading cause of death was tuberculosis. And during early 20th century, it was said that diabetics who does not die of coma would die eventually of TB, especially if they are on the lower socioeconomic background. So 14% of TB patients have diabetes, 5 to 30% of diabetics get TB with a relative risk of 3-fold. With diabetes, the spread of all these drug-resistant strains are becoming more, and eventually, again, the cost is increased. And there are various mechanisms postulated in diabetics which potentiates tuberculosis, starting from relative immunocompromise, cellular insulinopenia, local tissue acidosis and electrolyte upset, disturbed protein metabolism, fat metabolism, associated fatty liver, and increased stress hormones like cortisol, flaring up of tuberculosis, and pulmonary arteriosclerosis is one of the mechanisms proven by biopsy. These are all the various contemplated mechanisms. And of course, the Mycobacterium tuberculosis infects the alveolar macrophages, accumulates, and they replicates in macrophages, resulting in cellular death and shedding, and that's how the granuloma sets in. Of course, further studies needed to explore from immunological and biological aspects of these. We need to investigate the response of macrophage and lymphocyte phagocytic, chemotactic, and antigen presentation responses to the Mycobacterium tuberculosis. IgT and TB. Tuberculosis causes acute severe stress, and fever, inactivity, malnutrition stimulates stress hormones like the hormones and increases the sugar levels. And these plasma levels of interleukin-1, TNF-alpha are increased, which stimulates the stress hormones, and derangements of lipid metabolism have been described in the patients with diabetes. The pulmonary physiological dysfunction in diabetics would involve diminished bronchial reactivity, reduced diffusion capacity, occult mucus plugging, and of course reduced ventilatory response to hypoxemia. Now, how do you prevent these respiratory infections in diabetic patients? The sugars levels have to be maintained. As I said, the A1C levels are proportionate to the complications, especially with the influenza. Vaccinate against the flu and pneumonia. Raise patient awareness on increased risk of respiratory infections in poorly controlled diabetics. Practice hand hygiene and cough etiquette that we need to teach them. Avoid overcrowded places and wear face masks, which has become a rarity now. And of course, quitting smoking definitely matters. Prophylaxis, all diabetics require biannual, annual, depending on the patients. The X-rays, if indicated, need not be stress, of course. And let's quickly look at the other problems with diabetes and lungs, that is lung cancer, reduced life expectancy of individuals with diabetes whenever somebody has got, and lower chances to develop lung cancer, anti-neoplastic effects of some antidiabetics, including metformin, has been studied, and these are conflicting results. Cystic fibrosis and diabetes. There is cystic fibrosis related diabetes, CFRD, I'm sure all of you are aware, where it has an increased survival, increased mortality, and reduced lung function over several years prior to the diagnosis of CFRD itself. And the severity of pulmonary dysfunction is positively correlated with the degree of insulin deficiency. Insulin treatment improves the lung function and increases the FEV1 also. But they need further basic and clinical studies to investigate the relationship of hyperglycemia, insulin deficiency, and long-term insulin therapy in this CFRD. Diabetes and asthma, few words. Asthma and diabetes have common immunopathogenetic mechanisms. Remember this. And previously diagnosed asthma were at high risk of subsequent development of type 1 diabetes, but the children with previously diagnosed type 1 diabetes presented a decreased risk of subsequent development asthma. That means vice versa is not true. A1C level showed a positive correlation with the asthma occurrence in type 1s, and role of type 2 diabetes and asthma prevalence are inconsistent. Type 2 diabetes, obesity may increase the risk of asthma by 2 to 3 fold. Obesity reduces the effectiveness of asthma therapy, all of us know, and it pushes to increased rate of hospitalizations. GDM and obesity are associated with the increased risk of childhood asthma. That's something all of us should remember, that the GDM and obesity, when they're associated with the increased risk of childhood asthma. Diabetes and asthma are multiply linked through various pathophysiological mechanisms. And of course, COPD is something where higher incidence of COPD is seen in diabetic patients with higher BMI and higher A1C. So remember, the more the weight, the more the merrier for the complications, especially with the COPD. And diabetes can increase the risk of COPD exacerbations and mortality, and hyperglycemia associated with the poor outcomes whenever the COPD related morbidity and mortality, especially in the ICU background, which again we saw in the COVID, where the higher the BMI, the mortality were more, especially in the background of diabetes. And these are all the pathogenetic mechanisms, the systemic inflammation and the metabolic syndrome components with the structural alterations of the lungs, diminished pulmonary functions adds on to bacterial susceptibility, and chronic inflammation and systemic oxidative stress associated with the increased levels of these inflammatory markers are shared features of both in COPD and diabetes. Now we know diabetes also, we're looking at the inflammatory markers reduction. In fact, we have started a trial with interleukin-6 inhibitor to look at the mortality and the CV safety of this new drug. Diabetes and COPD again has been recently shown that the pulmonary function in diabetic patients with more than 10 pack years of smoking is reduced compared to that in the non-diabetics, and malfunction is associated with a significant reduction in the activity related quality of life and exercise capacity. So again, indirectly it affects the daily routine of exercises. And remember, inhaled corticosteroids in patients with COPD do not increase the risk of new onset diabetes, hyperglycemia, or significant change in the A1C level. Very important. Many of the doctors advise, when you're having a steroid inhaler, they would wrongly enlighten the patient that it would increase their A1C or sugars. Metformin treated over a 2-year follow-up period in patients with coexisting diabetes and COPD reduced the emergency room visits and hospitalization, especially in the low complexity COPD. So remember, metformin is one of the wonderful drugs for especially Indian context, and it has got a anti-neoplastic properties with the phase 3 studies are going on now. Metformin treatment reduced the risk of all-cause mortality in patients with coexisting diabetes and either stable or exaggerated COPD. And of course, the novel drugs, which all of us keep tending to talk about, the novel anti-hyperglycemic drugs, prevention of COPD, exacerbation among type 2 diabetes. This was a study which clearly showed, except the DPP4s, the GLP-1s and the SGLT2s have clearly showed in this part that there is improvement in this. ARDS does not affect the lung pathophysiology in patients with ARDS, and compared to other pulmonary disorders, diabetes seems to be protective against this ALI or ARDS development with unclear mechanism. That's the evidence so far as of now. And of course, pulmonary hypertension, the pulmonary vasculature is still not clear, the impact of diabetes on pulmonary vasculature. And insulin resistance and undiagnosed diabetes are common in patients with the PH. GDM may be a risk factor for pulmonary hypertension in the newborns. So remember that to treat GDM in a tight manner, and please follow the guidelines. Of course, the pulmonary fibrosis and diabetes, aging is an important contributor. Diabetes increases the risk of developing pulmonary fibrosis apart from the age, and the association between the IPF and diabetes, the strongest association is being with the use of insulin, and diabetes is the most important independent risk factor associated with the pulmonary fibrosis. These are all the various mechanisms involved in diabetes and pulmonary fibrosis. And how do you build the immunity? Obviously, don't smoke, eat a diet high rich in the fruits and vegetables, exercise regularly to improve the lung capacity, maintain a healthy weight, drink alcohol, drink only in moderation, and that's a big question mark. What is moderation by definition? None of us follow that. And get adequate sleep, minimize stress, keep current with all recommended vaccines. That's most important. And these are the various evidences which have shown that the various micronutrient deficiencies can improve when you supplement these vitamin A, B6, C and E, selenium, iron, copper and folic acid. The immune responses are improved, and these micronutrients enhance insulin action through activating the insulin receptor site, serves as a cofactors. And of course, the common micronutrient deficiencies in diabetic patients per se also, you can see the vitamin C up to 30% lower in diabetics. Zinc, people with uncontrolled diabetics have increased zinc loss in the urine, and high blood sugars may lead to decrease in the reabsorption of zinc in the kidneys. So it's a problem with diabetics, most of us are aware. Magnesium, 14 to 48% of patients with diabetes are hypomagnesemia. Thiamine deficiency, B12 and folic acid, again very common. The OHS like metformin inhibits the B12, all of us are aware. So treating with them definitely improves. And this is another evidence to show the lung and chest wall mechanical properties in metformin treated and untreated diabetics. The outcome is definitely better with metformin usage. To summarize, diabetic patients are immunosuppressed owing to the dysregulation of the immune system due to the chronic hyperglycemia. They are more prone to infections, including respiratory. Common pathogens we have discussed. Diabetic patients may have deficiencies of these micronutrients. A diet rich in above micronutrients, taking supplements, will definitely help prevent and treat deficiencies. And there is an increased population with undiagnosed diabetes, which is we have seen recently in the INDIAB study results. Despite emerging clinical reports on the diabetic lung, the mechanisms involved in diabetes-induced pulmonary disorders has been poorly studied. Therefore, intense efforts are required to better identify, quantify the pulmonary risk in diabetic patients, and targeting multiple risk factors associated with diabetes is essential to curb the growing prevalence and progression of pulmonary functions in diabetic patients. I'll take this is my last slide. Optimization of glycemic control plays an important role in improving the pulmonary complications. And from a public health perspective, the early treatment of lung comorbidities in diabetic patients, both diagnosed and undiagnosed, may have a strong potential to improve the quality of life and survival in these patients. Thank you very much for the patient hearing, sir.
Right. Thank you, Dr. Murthy, and for an excellent talk. And this talk has never been discussed in most of the conferences. The relationship with lung and diabetes. The recent trials have shown that the pollution actually causing both the lung and diabetes, the new onset diabetes. So it's a very untouched topic, and thank you for bringing out this topic. And with the positive time, can I have one question?
I am having one question, sir.
Yes.
Nowadays, it has been seen that the gram-negative infection, what you have told. What is your opinion regarding diabetes and association with mellidosis? Because now, previously, in recent era, what we have seen in this part of the world, the people who were treated as pulmonary tuberculosis, bronchopneumonia picture, they didn't respond, but later on when thoroughly evaluated came out to be Burkholderia sepsis. So what is your opinion regarding diabetes and mellidosis?
Diabetes and?
Mellidosis.
Burkholderia. Okay. To be frank, sir, I do not know the answer for that. What is the opinion about diabetes and this? Obviously, diabetes will worsen any condition in general. Okay, the perfect relationship between the two, I am not aware.
incidents you are getting in your setup. That's time because in this part of world.
No, I do not have the data. I don't know if anybody else has got the data. I personally do not know.
Not been worked up actually. There may be association, but the data
Exactly, the
may not
exact
be-
incidents,
may
the
not be
numbers,
there.
I'm not aware.
May not be there, right? So thank you, Dr. Murthy, for a wonderful talk, and thank you. And I think he needs a good applause, round of applause for the excellent lecture. Thank you, Dr. Murthy. So can we have the third speaker, Dr. Mugundan? Can we have the first slide, please? Dr. K. Mundan is TM Neuro and is Professor of Neurology and Head Stanley Medical College, Chennai. So he'll be talking about the viral encephalitis often missed. Over to you, sir.
Respected chairpersons, first of all, I thank Dr. Anuj Mageshwari, Dr. Narsingh Verma, Dr. Virmani, and Dr. Panda, and all my.
Just a second, sir. I think the poster session has been started. If anyone want to have the poster, they can proceed to the poster hall.
Senior colleagues.
Yes, thank you.
The topic given to me is viral encephalitis often missed. I'm going to discuss this topic under the following headings. All of us know encephalitis is defined as an inflammation of the brain caused either by infection, usually a virus, or from primary autoimmune response. The meningoencephalitis, it's a meningitis and encephalitis. If the cord is involved, it is encephalomyelitis, and the roots is also involved, it is called encephalomyeloradiculitis. Viral encephalitis is the most common infection. It enters the CNS either via blood or from the nerve endings. To differentiate it from encephalopathy, the encephalitis will have fever, headache, seizures, and focal deficit, where leukocytosis and CSF pleocytosis is common, and EEG will show a diffuse slowing and focal abnormalities, and also MRI changes. Then how will you differentiate from acute disseminated encephalomyelitis from infectious encephalitis, where the age in children, the JDM is common, any age in case of infectious encephalitis. The ADM is common following vaccination and infection, whereas infectious encephalitis, there won't be any prodrome or recent vaccination, there won't be there. In ADM, the spinal cord and brain changes are there. So the MRI will show the typical features of T2 hyperinternalization in bilateral symmetrical involving basal ganglia, cerebellum, and the spinal cord, whereas in infectious encephalitis, it will show in gray matter and in underlying white matter. So these are the viruses which causes encephalitis. HSV1 is the most common cause of adult sporadic encephalitis, whereas varicella zoster is the most common cause of pediatric encephalitis. From the history, how will you clinch the diagnosis? If there is a prodrome and recent vaccination, think of ADEM. If there is biphasic onset with systemic illness, then think of encephalitis. If there is recent travel to endemic areas, think of JE, dengue, and history of animal bite, think of rabies and tick-borne encephalitis. If he is an immunocompromised individual, think of HSV, CME, varicella zoster. Then abrupt onset and rapid progression, we have to think of HSV encephalitis. Clinical clues, if there is skin rash and vesicles, think of varicella zoster. If there is bite, rabies and limes. If there is also involvement of peripheral nervous system, think of ADM, CME, and varicella zoster and EB virus infection. GIT symptoms, enterovirus and rotavirus. Respiratory symptoms, as the previous speaker told, influenza and paramyxovirus. So lymphadenopathy, splenomegaly, think of EB virus. If there is basal ganglia and extrapyramidal symptoms, think of arbovirus, especially Japanese B encephalitis. If there is psychiatric features and memory deficit, always think of herpes simplex virus encephalitis. Microcephaly, we have to rule out Zika virus infection. Myelitis, polio, or arbo or enterovirus infection. Then in brain, there are specific sites for viral the predilection. In case of temporal and inferior frontal lobe, it is herpes simplex virus. Periventricular areas, it is CME virus. Limbic system, RSV. If there is cerebellum is involved, we have to think of zoster. Basal ganglia, think of Japanese B encephalitis. The clinical clues, always it starts with fever, headache, vomiting and prodrome, drowsiness, altered sensorium, hallucination, memory disturbances, behavioral disturbances, seizures, of hearing or visual disturbances, and weakness of limbs. The neurological features associated with the encephalitis are altered level of consciousness, impaired cognition, seizures, dysphasia, sometimes cranial neuropathies, focal deficits, movement disorders like chorea or dystonia, and meningism. Patient will have the headache, photophobia, and neck stiffness. How do you investigate? The CSF PCR or CSF specific IgM is needed in case of CME, dengue, or chikungunya or Zika, whereas enterovirus, stool or throat PCR are preferred over CSF PCR, whereas in case of herpes simplex, CSF PCR can be repeated within 2 to 7 days of disease onset if negative with high clinical suspicion, or CSF for the HSV IgG after 10 to 14 days of disease onset. Varicella zoster, it is CSF specific IgG. Then imaging of the brain and lumbar puncture are needed in specific cases. Then in temporal lobe actually is involved, we have to think of HSV. In EEG sometimes gives a clue. In case of JE, there is diffuse delta activity with spike. The major criteria to diagnose encephalitis, it is a must. There should be a subacute onset of impairment of consciousness, memory, mental status, or new onset psychiatric changes without alternative cause. Minor criteria, it is 2 out of 4. Fever more than 38 degrees centigrade within 72 hours before or after presentation. Seizure not attributable to previous seizure disorder. CSF pleocytosis and evidence of acute or subacute neuroparenchymal inflammation on neuroimaging. So the diagnostic approach is the CSF studies, as I told, blood test, imaging, and adjunctive test like EEG. So how do you manage this viral encephalitis? Mainly supportive. Seizures, then we have to give anticonvulsants. The raised ICT can be managed by anti-edema measures, rarely surgical decompression. If there is fluid electrolyte imbalance, it has to be corrected. IV antibiotics for secondary bacterial infection and aspiration, pneumonia, mechanical ventilation in case of respiratory failure. Most presentation of encephalitis are non-specific. An initial treatment approach should broadly cover treatable infections with subsequent narrowing of suspected diagnosis. So all patients presenting with a syndrome suggestive of acute encephalitis should be treated empirically with acyclovir. If there is any suspicion of bacterial meningoencephalitis, vancomycin and third generation cephalosporin as well. So in case of HSV1, we have to give intravenous acyclovir for 14 to 21 days, and also varicella zoster. In HSV, IV acyclovir 10 mg per kg TDS for 14 days. In case of CME, we have to give ganciclovir and foscarnet. In case of California virus, we have to give IV ribavirin. For other viruses, there are no specific treatments available. We have to give supportive management, which include management of cerebral edema, treatment of seizures, and prevention of complications such as hospital-acquired infections. Many patients require physical and cognitive rehabilitation after encephalitis. Where autoimmune encephalitis is suspected or confirmed after diagnostic evaluation, the treatment approaches, which includes immunotherapy. Then what is this post-infectious autoimmunity? As I told you, after viral infection or vaccination, the acute disseminated encephalomyelitis develops. The herpes simplex virus encephalitis sometimes trigger autoimmune encephalitis in the form of NMDA receptor encephalitis in a minority of patients within weeks to months following the illness. So in a patient experiencing relapsing symptoms following treatment with HSV encephalitis, CSF study should be repeated for HSV polymerase chain reaction. Other viruses may also act as triggers for post-infectious NMDA encephalitis. So detectable HSV suggests there is ongoing infection. These patients should be retreated with acyclovir. If there is undetectable HSV with a CS of pleocytosis supports an autoimmune mechanism in these patients, autoimmune antibodies should be tested in serum and CSF. Regardless of whether antibodies are actually detected at this stage, patients who have cleared HSV and autoimmune mechanism should be suspected and immunotherapy should be strongly considered. So patients should be treated according to the guidelines for NMDR encephalitis. First line including high dose steroids in the form of injection methylprednisolone 1 gram IV OD for 5 days, then plasma exchange or intravenous immunoglobulin, then maintenance therapy with rituximab or mycophenolate mofetil or cyclophosphamide. I will go to individual encephalitis, HSV encephalitis. One is common in children and adults, two in newborn and immunocompromised. After the initial infection, it establishes latent lifelong infection remains dormant until reactivated. So HSV encephalitis usually begins unilaterally. It has got a predilection for selective brain areas in the form of anterior and medial temporal lobe, inferior frontal lobe, thalamus and insular cortex. Mostly they will present with non-specific symptoms include fever, headache, confusion and altered behavior. Less frequent neurological features include dysphasia, seizures, cranial neuropathies and other focal deficit. Brainstem encephalitis is possible, but it is uncommon in HSV. So this picture shows the temporal lobe involvement in case of HSV encephalitis. Diagnosis, as I told you, by PCR, the MRI brain, inframedial temporal lobe involvement. Treatment, as I told you, acyclovir 10 mg per kg TDS for adults and say 60 milligram per kg TDS for children because of increased renal excretion for 14 days for immunocompetent and 14 to 21 days in case of immunocompromised. Varicella zoster encephalitis is the second leading cause of viral encephalitis. After HSV in children, it typically occurs 1 week after primary chickenpox rash. Most commonly, it produces cerebellar ataxia, also causes more diffuse encephalitis. In adults, it causes in elderly patients or the immunocompromised as a manifestation of viral reactivation. Typical symptoms are, as I told you, altered mental status, focal neurological signs, cranial neuropathies and seizures. The mortality rates up to 20% in case of varicella zoster encephalitis and a favorable outcome in approximately half of patients. EB virus encephalitis typically occurs during primary EB infection in children and young adults. The features are seizures, confusion, and Alice in Wonderland symptom, opercular syndrome, and hemorrhagic meningoencephalitis. The clinical outcome is usually benign, although some physicians treat with acyclovir, but there is no clear evidence. This Alice in Wonderland syndrome is a rare condition that disrupts your brain ability to process sensory input. This disruption affects how you perceive the size of things you see around you and the feel and look of your own body or both. It can also distort your sense of reality. So disturbance in self-perception, disturbance in visual processing, and also combined symptoms can occur. These phenomenon can occur in migraine and in other infection. As in the migraine, it appears as fortification figures. Japanese bee encephalitis incubation period is 5 to 15 days, frequent in children, mostly asymptomatic or mildly symptomatic. The mortality is 30%. Prodromal phase, encephalitic phase, and recovery phase. So the residual deficit is 40%. So JE encephalitis has a special predilection towards basal ganglia. It will produce extrapyramidal features. Prophylaxis, we have vaccine live attenuated, safe up to the 15 years. Enterovirus encephalitis, it's RNA virus. Clinical manifestations are aseptic meningitis, encephalitis, encephalomyelitis, rarely rhomboencephalon encephalitis. Definitive diagnosis, as I told you, by CSF, PCR culture, but throat and rectal swab are necessary, or serology. All three tests should be positive. Possible CSF negative for intro and other virus, either throat or rectal swab positive. In neuroimaging, there will be involvement of medulla, pons, midbrain, and cerebellum and spinal cord. So in case of rhombencephalon, pons and medulla can be involved. So this picture shows the rhombencephalon and other areas of involvement. Mumps occurs in less than 10% infection. The encephalitis around 0.1. So these are all mild encephalitis. Measles, less than 0.3% of measles infection. The measles encephalitis is usually severe. They can have, as other encephalitis, seizures, coma, and deficit. Mortality is 15 to 25%. As I told you, they will have disability following recovery. Influenza, it is very rare. Most commonly with influenza A, there is a prodrome, seizures, altered consciousness, vomiting, followed by ataxia and deficits. West Nile encephalitis, the vector is Culex, common in elderly and immunocompromised. Neurological illness occurs only in less than 1% encephalitis, characteristic of acute flaccid quadriparesis, and the basal ganglia symptoms can occur. Treatment is supportive. Nipah virus encephalitis, it's a paramyxovirus. Recently outbreak at May 2018. Last week also, or 1 month back in Kerala. It's a human-to-human transmission. Nosocomial infections are common. Mainly ARDS and multi-organ dysfunction are the major reason for higher mortality. The characteristic features are segmental myoclonus areflexia, hypotonia, and abnormal Dulce reflex. So imaging will show multifocal discrete lesions in the subcortical and deep white matter in T2 FLAIR images. Lab diagnosis is by antibody detection in CSF and serum. Antiviral like ribavirin can be given. West Nile virus, Zika virus, it belongs to arbovirus, flaviviral family. Spread of bite by infected Aedes mosquito. Most common symptoms are fever, rash, arthralgia, conjunctivitis, and headache. The complications are congenital microcephaly, GBS, myelitis, and ADM. Diagnosis by nucleic acid detection by PCR or viral isolation. I conclude my talk with the following points. Viruses are a frequent cause of encephalitis. While evaluating the patient with possible encephalitis, other etiologies must also be considered, such as bacterial, viral, fungal, and parasitic, or autoimmune encephalitis. So careful clinical evaluation may provide clue to the underlying cause of encephalitis, which will guide for further workup. However, empiric treatment with acyclovir should still be considered in all cases until HSV or varicella zoster are excluded. Finally, recognition of CNS inflammation in the post-infectious period has important implication in respect to treatment. Thank you. Thank you for the opportunity.
Extensive talk, sir. Good effort. Sir, I want to ask one question.
Yes.
Suppose you do CSF analysis. In how many percentage cases you can detect either virus, antibody, or by PCR technique?
So almost 40 to 50% we can get.
I think somewhat less than 15% probably. And that's why we are compelled to accept the definition of the encephalite there. Presence of fever with ultrasound serum plus presence of antibody either in the CSF or in the blood also. And number two, this is a comment, not a better to divide encephalitis, viral encephalitis in two, in epidemic setting and in sporadic setting. Herpes virus. In absence of antibody or virus. So where is acyclovir? Because there is no other alternative, or herpes simplex is also prevalent in India.
Sir, if you have listened to my talk, because both are treatable, HSV virus, and if the patient develops memory disturbances, psychiatric disturbances, and after recovery, the residual sequelae is more. So that's why we have to exclude all these things. So we should not miss. So if the careful history and examination and follow-up of patients with this investigation, I think we will not miss.
Any other paper regarding incidence of herpes simplex virus? I do not know. That's why I'm asking.
Herpes simplex?
Incidence in India.
Sir, I think, Justin, 20 to 30% what we see.
I think most of things have been covered. I think it's empirical that the careful history, careful examination, and the CSF analysis, along with neuroimaging, all would combine to give a proper diagnosis. Like this simply saying that how the patient present. It's the combination of everything that would lead to the diagnosis and the further treatment.
Thank you.
So I think we can close this session. One question is there, right? You can do this, Mike. Just like in sepsis, right? We start the antibiotics and we just wait for it. No, like in sepsis. Yeah, like in sepsis, right? We don't wait for the cultures. Yeah. Thanks for the comments.
Thank you.
Sir,
Thank you, Dr. Mugram.
Can I
for a
ask one
wonderful
query,
talk.
sir? Excuse me, sir. Can I ask one
Yeah,
query, sir?
yeah.
Sir, I am from AIMS Rishikesh, and we do get a lot of patients of viral encephalitis or basically albuminocytological dissociation with few cells in CSF. And it's very difficult to come to the diagnosis of whether it is viral or autoimmune with a subacute history of presentation. And we have scrub encephalitis also in in Uttarakhand. So after we give a cocktail of treatment, as sir was discussing, we do start artesunate and doxycycline and acyclovir. And after we tide over the acute condition, suppose the patient's altered sensation or the raised ICT symptoms they have reduced. So what is your take on the psychiatric disorder persisting, post-viral psychiatric disorder, when the patient remains altered or agitated? So what is the role of atypical antipsychotics, and how is catatonia associated with these patients? Like we do read case reports of catatonia associated with Japanese encephalitis and the West Nile virus. So what is it true that it is associated? They are often labeled by the peripheral doctors as having psychiatric disorders, but as opposed to virus.
See, the Japanese and arbovirus, it can itself present as akinetic mutism and other features. So it presents with akinetic mutism and extrapyramidal symptoms. So it can present as catatonia, especially JE and arbovirus.
Which antipsychotic do you prefer, sir? Quetiapine or risperidone?
Yeah, definitely we have to. So in addition to anti-extrapyramidal, then we have to give an antipsychotic. We'll give quetiapine or something.
We can discuss in detail because we have a lot of time. I think we can close the session as of now. Thank you very much.
Thank you.
Thank you for all the interesting talks. I thank Dr. Srinivasa, Dr. P.K. Maheshwari, sir, Dr. Mugatnathan for their intriguing talks on diabetes and lung, epilepsy and psychiatric disorders, and viral encephalitis. May I now request Dr. Subhranshu Patro, sir, to felicitate our speakers. Sir, please. And Dr. Sir. Dr. Anuj Maheshwari, sir, also, sir, so please felicitate our speakers, sir. Sir Patro, sir, please. Sir. Dr. Srinivasa. Dr. P.K. Maheshwari, sir. Thank you so much, sir. Dr. Mugunathan, sir.
Mugundan.
Mugundan. Sorry.
Mugunathan is there.
Sir, actually, two of the
I was in that and you were invited. You first see that next question so that it may not be delayed.
Yes. We have not received Dr. R.R. Singh's PPT. Next session is Dr. R.R. Singh. So may I now call upon Dr. Kamlakar Tripathi. Dr. Mitali. Dr. Yeah, Mitali. Dr. Meenal. She will be speaking on hypogonadism.
We don't have any chairperson for this session.
I request Dr. Prasad, Dr. Akshay Pradhan, Dr. Debandhu Sahu as chairpersons, please.
Please start.
Thank you so much. A very good morning to everyone present here. Since there is no introductory slide, I'll just say a word about myself. I'm Dr. Meenal. I come from Jaipur. I'm working as consultant, Department of Endocrinology, Manipal Hospital, Jaipur, right? So that's about myself. The topic that has been assigned to me by the governing body and my governor, Anand sir, is here, present here, is discussing male hypogonadism, the diagnosis, investigations, evaluations, and treatment. So first of all, before I begin, I must thank the governor present here, sir is here. Thank you so much for inviting me here and adjusting my talks because of so much of logistic issues. This talk was scheduled yesterday, but he is very kind that he is accommodating me today. So thank you, sir. And of course, the entire ACP team, my previous governor, my present governor, and the ACP body itself. Thank you so much. So hypogonadism. Before I begin, let me tell you that nomenclature has been redefined by the ISSM body, that is the International Society for Sexual Medicine. They have redefined the term hypogonadism to testosterone deficiency, right? The reason being, they say hypogonadism is quite confusing. It is primary, secondary, mixed, LOH, so much of confusion. So they say, just let us label it as testicular deficiency. Though we are still continuing with hypogonadism as per the urologists and the endo department. So to define testicular deficiency, it goes very simple, that either the testosterone itself is deficient or the action of testosterone is deficient, right? So we define hypogonadism as deficiency of androgens, which is just the same, and resulting into either a decreased sperm production or decreased hormone production, or it can be both. So just before we begin on hypogonadism, a little about the hormone itself. This pointer is actually not supporting me. So the testosterone, which comes from testes, undergoes aromatization and converts into estradiol. So there is some amount of estradiol in all males. And that estradiol is responsible primarily for the bone fusions and the final height. So it is important in children. The testosterone per se is responsible for sexual differentiations, muscle building, bone mass, erythropoiesis, which is very important, and of course your mood well-being, that is psychotropic actions, and the libido. Then it also gets reduced. 5-alpha reductase plays an important role, and it is responsible, dihydrotestosterone is responsible for your secondary sexual characters. Now this entire testosterone is not available to work. It is mainly bound to sex hormone binding globulin, that is 60%, and the bioavailable testosterone is one which is loosely bound to albumin and the free testosterone. So this is the 30% of your free bioavailable testosterone which is actually active. Now what are the conditions where you need to look for total testosterone or the bioavailable testosterone? So anything interfering with SHBG, that is sex hormone binding globulin, anything that interferes with SHBG rising or lowering needs to be differentiated from a true status of the testosterone, right? So we here as physicians are interested in two most important things. One is obesity or the lifestyle disorders, and another is aging. So obesity causes a drop in SHBG. So there is a falsely low testosterone. Free testosterone might still be normal. Another is aging. In aging, there is a rise in SHBG. So there is a falsely high testosterone, whereas the free testosterone or the bioavailable testosterone might be low. Now, why is testosterone important? It is not only about libido, it is not about fertility, it is not only about sex, it is about a lot of many things. Testosterone is responsible for your bone health, for your muscle health, for your emotional health, and for your overall well-being. So this is testosterone is important right from the day the male child is born till term, like till your last day of your life. So now this testosterone deficiency can happen at any point of time. A child can be born with it. So if the child is born with testosterone deficiency, the baby will be born with ambiguity. There will be ambiguous genitalia. If this deficiency develops after birth and before puberty, you will find that the male child does not develop secondary sexual characters and does not progress to puberty. If this problem or testicular deficiency happens after the attainment of puberty, then there will be infertilities and there will be sexual dysfunctioning. So this problem can occur at any stage of life. Now, what are the types of hypogonadism and how a child visualizes himself? Primarily, there can be some problem with the testes or the end organ itself. So if there's a problem at the end organ level, we label it as primary hypogonadism. If the problem is at the central level, at the pituitary level, or at the hypothalamic level, we label it as secondary hypogonadism. So primary hypogonadism, the most common causes, there will be a huge list. It can be congenital, it can be acquired, it can be anything to do with testes. So any damage at the testicular level will cause primary hypogonadism. Similarly, secondary hypogonadism. So any problem happening at hypothalamic level, again it can be congenital, it can be acquired, it can be chronic metabolic conditions that can cause damage at the hypothalamic level or pituitary level, leading to problem with the gonadotropins or the gonadotropin releasing hormones will cause secondary hypogonadism. Then there is another interesting part which we are more concerned with is late onset hypogonadism. Now, what is late onset hypogonadism? Late onset hypogonadism is something which is nomenclature is varied and it is labeled differently. We may call it as male menopause, we may call it as climacteric, we may call it as andropause, we may call it by Adam, partial Adam, or anything. But the crux is that this is a progressive condition, and every year there is a progressive decrease in the semen volume, there's progressive decrease in the sperm production, the sperm morphology gets deteriorated, and there is total motility of the sperms goes on decreasing every year. So by definition, either the testosterone level is less than 2.5th centile of the normal testosterone level, adult level, or clinically you should be having symptoms which are correlating with testicular deficiency. Now, this late onset hypogonadism has a mixed pathology. There is decreased testosterone from the testes, as well as there is problem at the hypothalamic level because there is decreased pulsatile secretion of the gonadotrophins, as well as there is decreased LHFSH, that is the gonadotropin release from the pituitary. They are also reduced. So late onset hypogonadism actually has a mixed defect, the mixed pathology. So why are we so much concerned? Why are we discussing it? Because hypogonadism is directly related, as I told you, to your increased metabolic diseases, increased risk of CV diseases. It is related to increased incidences of diabetes, obesity, and cardiac failures. So how do we diagnose this now? So diagnosis, as we all understand, is very simple. Send one sample of serum testosterone. So that is not all. First of all, we should have a clear history. Like, is the patient symptomatic? And if there is a symptom, what is the previous history? Is there any history of testicular injury or a brain injury or a brain infections, as Sir was rightly discussing, some NCAFs? Besides that, we need some drug history, which is very important, and the physical examination. Now, these are the various drugs which work at various levels and are responsible for testicular deficiency. Then what is the clinical picture? Clinically, you will find that either there is a baby-like face, there is failure of the beard and mustache to grow if the child is not able to grow into puberty, there is a small penile length, there is loss of pubic hair, there can be gynecomastia, there will be a small testicular size, scrotal pigmentation will be lost. Clinically, there will be loss of libido, there will be depression and infertility. So with this clinical picture, how do you begin to investigate? To investigate, first of all, you should know when to send a sample. So your serum testosterone level sample has to be sent early morning hours, somewhere between 7 to 11. So after 11, the testosterone levels start dipping, so do not send an evening sample. So after finding out your serum testosterone level, you will have two clear margins. Either it is less than 8 or it is more than 12. If it is more than 12, your patient is having a normal serum testosterone level. So think of something else. It can be depression or it can be some other issue, but not a testicular deficiency. If it is less than 8, then of course you have a very clear picture of hypogonadism. The problem is if the value is somewhere between 8 and 12. So if the value is somewhere between 8 and 12, either go for a repeat sampling or go for another test like LH, FSH, or even prolactin. So we are trying to figure out where is the problem. Is the problem at the pituitary level or at the hypothalamic level? Once you have the tests with you, you can always go for SHBG, that is sex hormone binding globulin levels. Then there is a free testosterone calculator available online. You can go for that. So what you need to know is a total testosterone and the free testosterone and the bioavailable testosterone. After that, you think of the late onset hypogonadism, as we also discussed. Again, you will go for serum testosterone, but clinically, if there is a triad of decreased libido, decreased morning erections, and erectile dysfunctioning with a testosterone level which is less than 8, of course, you are dealing with hypogonadism. Now, you have all the reports with you, the patient is in front of you, and you need to evaluate this case. So, to evaluate this case, you have to have a lot many things. History, physical examination. If there is one feature which I have missed and intentionally missed, there is also associated infertility. So if there is infertility associated, you have to go for some seminal analysis for the very first time, because you need to know the status of the sperms as well if we are dealing not only with hypogonadism but also with infertility. So now what are the goals? Now we have decided, we have evaluated the patient, we now need to treat the patient. So why do we need to treat the patient? What are the goals? So the first important goal is to restore the normal physiology. To restore the normal physiology, you have to consider fertility and hypogonadism. If it is a fertility issue, we will come to it later. If you are only dealing with hypogonadism, then of course you have established it is a testicular deficiency, so we'll have to replace the testosterone. If it is less than 8, we are definitely replacing it. So this is important when to replace. If it is less than 8, you have to replace. If it is more than 12, no replacements. Between 8 and 12, you have to consider. Now it is less than 8. So you have to know who should be treated and who should not be treated. So any patient with significant BPH, please don't treat. Patient with a history of CA prostate, please don't treat. CA breast, please don't treat. Erythropoiesis, there is already a high hematocrit, please don't treat. So who should not be treated is also important. Then what is the role of sildenafil versus testosterone? So a patient who's actually hypogonad with testicular deficiency will do better with both. So if you are replacing sildenafil or you're giving a sildenafil, please also give testosterone. And if you're only giving testosterone in that patient also, please also give a sildenafil. So sildenafil does better in combination with testosterone in cases of hypogonadism. So now how to treat? What are the options? Now treatment of testosterone is not something that we are doing it today. It's having a history. So it began initially from 1940 when they began with testosterone implants. And now we have in 2004 something very, very good, which is a long-acting injectable testosterone. That is 1 gram of testosterone can be given every quarter. So once in 3 months. That is what we are practicing. Oral testosterone, yes, you can do that, but you can't miss the liver bypass, the hepatic bypass. The most of the molecule will not be bioavailable, and you will also be facing the challenge of hepatotoxicity. So let's avoid the oral testosterone. The buccal testosterone, like yes, you have the small tablets which you can place just below the above the gums, but again the local area redness and their bioavailability is again uncertain. So we don't go for buccal replacements also. The pellets or the intradermal implants, again, the bioavailability is not certain and it is very cumbersome. So we don't do it. Gels, patches, everything is available, but everything is very uncertain. Bioavailability is uncertain. It needs a lot of compliance issue. Every day it has to be done. And then, of course, 1 hour you have to leave the skin so that it does not get rubbed by your clothes. So the best is we are treating by IM injections, that is intramuscular injections. We have available 250, 100 and 1. So we have 100 milligram, 250 milligrams and 1 gram. So we are prescribing preferably 1 gram every 3 months. Now how do they work? So the bioavailability is at the peak when the patient is injected. And eventually over a period of time it decreases. So if you are giving a 250 milligrams, you will find that the day of injection, the bioavailability is very high and it eventually comes down. So the day the patient is injected, you will find aggressive behavior, aggression, irritability. There can be a lot of mood changes and which eventually settles down. So these fluctuations need to be explained. My time is running. So we are giving this 3 monthly, which is giving a better and a stable bioavailability. Now this is the data which is showing how the pharmacokinetics works. In the first and the 13th injection, it becomes a little stable after 3 injections. Now once you have started the treatment, how do you monitor these patients? To monitor these patients, you have to evaluate the prostate, you have to evaluate the CBC, that is hematocrit has to be looked into, lipids and liver. What are the society recommendations? Society recommendations at baseline send 1 PSA. Do 1 digital rectal examination, hematocrit, testosterone and BMD. BMD has to be evaluated annually. You will find a bone DEXA scan will show you the bone improvement. There is an improvement in the bone density. PSA is very important. If you find a rise in PSA at the rate of 0.4 nanogram every year, or you find a PSA which is above 4 at the beginning, or the PSA is rising more than 1.4 in the very first year, please don't continue with testosterone. Then comes the most important question. A young male with hypogonadism also willing to have a baby, also wants to have a child, also wants to father a child. So what will you do? Go for a semen analysis. And after a semen analysis, the remaining protocol remains the same. So you have to establish whether it is a eugonadotropic infertility, hypogonadotropic hypogonadism with infertility, or a hypergonadotropic hypogonadism with infertility, right? So you have to establish that because the treatment differs. If it is a hypogonadotropic hypogonadism with infertility, please don't treat with testosterone. That will lead to testicular atrophy and probably the person will never be able to have sperms. Instead, treat with gonadotropins. So what is the protocol for gonadotropin administration? we are giving HCG 2000 IU subcute twice a week or thrice a week, along with HMG, which is given 75 IU, again subcute at least twice a week. So HCG plus HMG combination has to be given subcute, and the results will only be evident only after 6 months. So 3 to 6 months of subcute injections every week. Then of course, there are chances that sperm production might start. Besides that, what are the benefits of testicular treatment? Of course, there will be improvement in the muscle mass, bone mass. There will be increased bone density and decreased fracture rates. Sexual function will improve. Your metabolic syndrome will improve. You will lose your visceral fat and you will build your muscle mass. Cognitive functions will improve. Your mood will improve. Depression will be improved. Your quality of life will be improved. Now, how much to continue? The treatment for fertility has to be continued till the person is able to have sperm production and is able to, we can procure the sperms and we can make them available biologically. And otherwise, for a hypogonadism without fertility issues, the treatment has to be continued lifelong, or for annual evaluation, if there's no complication, you continue for lifelong. Otherwise, you'll have to withdraw the treatment. So this is, I have finished well in time. Okay. This is about hypogonadism and how do we approach it, how do we diagnose, investigate, evaluate and treat, and infertility as well. If there are any questions, I'll be happy to take. Yes, sir. So this is about this slide I have intentionally put. See, the old sperms and the fat sperms, they will lose the battle. If you need to finish the race line, you have to be healthy.
Thank you, ma'am, for the nice lecture.
Yes, sir, that is what we are discussing. The hypogonadism will have either the decreased testosterone production is either related to decreased libido, decreased sexual performance, and associated with infertility also. Yeah, of course. Of course, we can do that, sir. But being an endocrinologist, I can talk of medical management.
So, Minal, I'm sure many of us are here for listening male hypogonadism, or either to you or because of male hypogonadism we are here. One interesting fact which we know that it is actually very common in obese type 2 diabetic patients, the data. I have also done one of the data along with Dr. Rajiv Chawla and we published to it that 30% of our patients, their testosterone level is relatively low. But still the replacement is not done by the clinician or physician. How you recommend? I mean, for primary hypogonadism or the children or adolescents where you have to give for HSP and for other things, I'm talking of adult male, not for the purpose of giving them for erectile dysfunction. Overall, for how many times, I mean, how many patients of you, your patients or other clinic, they are actually giving. Because when we had talked with the Abbott company and those who are producing the testosterone, even injectable and tablet form, this is the only hormone replacement which is done actually very, very minimal in compared to the number of patients which we have. You just talk about the insulin, you talk of thyroxine, everything available, but it's not the replacement of testosterone, and it's very, very less. Why it is so?
So number one is, in obese patients, we have to establish that there is actually a testosterone deficiency, because replacement of testosterone will only be helpful if there is actual deficiency. If there is no deficiency documented, below 8 is the cutoff, sir, 8 nanogram per gram. Yeah, the labs will be different. Of course, the labs will be different. So, yeah, you have to replace it. The workup is done and we have established it is a testicular deficiency. Even when the patient is, yes. It is not a challenge, sir. This is very interesting fact. Many more things can be challenging, but talking of testosterone replacement in a male is never a challenge. It is very happily accepted by most male patients once you tell them that how it works and what it works. Not only talking about improving your sexual function, but also when you talk about bone health, about muscle mass, your visceral fat, your metabolic syndrome. So they are very readily accepting the molecule, and the injections are not very frequent. It is only 1 in 3 months. That is the The 1 gram one, yeah. Otherwise, if you're working with 250, it has to be given every 3 weekly, or rather, you can work up that also. If you just work up the testosterone 1 or 2 days prior to the next injection, you can find out whether you can delay the injection for another week. So you may be requiring it only once in a month. So this is what we are doing. And you are very right. If you establish that there is a deficiency, testicular deficiency, and patient may or may not be symptomatic, you should replace it. It should be replaced irrespective of the clinical symptoms, or the patient may not even come up with the clinical symptoms at times, because we are also looking for the bone health and muscle health and the general quality of life. And as sir is very right, the visceral fat, obesity, type 2 diabetes, the CV risk factors. So testosterone is one hormone which is not only targeting your libido, but it is also targeting your metabolic health. But you have to take care of few things. As I told you, annual evaluation of your PSA is very important. Annual evaluation of your DRE, that prostate size, is the digital rectal examination. Your DRE is important because we need to know the prostate size and the PSA and the hematocrit. Your CBC levels, hematocrit has to be evaluated. You can't overshoot that, of course. And one more important thing not to miss is your testicular dystrophy. So just take care that you are not ending up with though testicular dystrophy is not very important once you have overcome your, once your family is complete. If you're not looking for further family or children for that, then it does not really matter. But if the young male is coming a case of, sir, I'll just discuss a case of BMT, the bone marrow transplant, who was irradiated, came to me, a young male of 17. Now for that, I have to look that after 10 years, this boy will plan a marriage and a child. So for that child, if you go and start giving testosterone without looking for testicular dystrophy, then probably you are doing more harm rather than doing good. Yeah.
While those patients who have only erectile dysfunction, the desire is still there, create the possibility that testosterone is normal, but they have to go to muscular or maybe
yes. So that is exactly what I was trying to say. In obesity patients or in patients with CV factors, the cardiovascular factors or the metabolic factors or the diabetic neuropathy, for example, there can be loss of erection. There is erectile dysfunction, but the serum testosterone levels will be normal. In such patients, testosterone replacement alone might not help. So in such patients, you need to give a sildenafil, or you need to treat the underlying metabolic condition like a good glycemic control, good lipid control, good blood pressure control. Along with that, of course, you need to have your sildenafil replacement. But patients who have a documented testosterone deficiency and a decreased erectile functioning will be more benefited by testosterone as well as sildenafil combination. Or if you're planning a child, then of course it has to be HCG and HMG.
Thank you, ma'am. We are running out. Sir, we are already running out of time. We have entire session left. Please.
Thank you so much.
You can
Thank you,
continue
sir.
the discussion over there. Thank you, ma'am. So I think changing gears, we'll move to now heart failure. I think heart failure is an important disease whose mortality exceeds even cancers, which people probably do not recognize. So to talk on decompensated heart failure with preserved ejection fraction from hospital admission to discharge, can I invite Dr. R.R. Singh? Dr. R.R. Singh. Decompensated heart failure with preserved ejection fraction. Okay. I think Dr. R.R. Singh is not there. Maybe can we move on to the next lecture?
Yes. The next lecture is on time is late. That is renoprotection in hypertension. The esteemed speaker is Dr. Kamalakar Tripathi. May I invite Dr. Tripathi to present? Welcome, sir.
Thanks, Dr. Maheshwari and his team, Dr. Verma and the ACP members for getting this opportunity to talk to you about how early we should intervene for hypertension. And it's one of the social problems. People have blood pressure machine available everywhere. They need not go to doctor. They buy it, and one fine morning or running from the work, they get the blood pressure and it's high. So the first reaction would be, why to take medicine? Why to go to doctor? You reduce the salt. And this keeps on happening time and again. And often we have to, when they encounter to the primary care physician, then they ask, how should we start the treatment? So why to start early? Because the treatment may be associated with long-term clinical benefit. Treatment is associated with more effective blood pressure control. And the control are enhanced by rapidly achieving normal levels. And the fixed combination therapies as initial therapy are often needed. Those with chronic kidney disease, this is an important issue, people may not be aware of. And my very sane teacher, respectable teacher used to say that if you get hypertension with anemia, look for the serum creatinine. Those times albumin, and that would be one of the initial presentation of that chronic kidney disease. So achieving blood pressure control in CKD may be difficult, often require a lot of drugs, and one side doesn't fit to everyone. Kidney regulates blood pressure, it alters blood pressure, it sustains blood pressure. And the development of clinical hypertension, physiology was there. Even William Harvey did not write a single word in his Cardis Motto about the hypertension. He wrote only on the pressure, he wrote on the cardiac output and the peripheral resistance. It was Richard Bright who brought this information to the audience, that doing autopsy on a contracted kidney left ventricular hypertrophy and increased arterial size, then they found the patient has albuminuria also. So there is a strong association with poor renal outcome, microalbuminuria progression, and morphological changes in the kidney. And then initial days it was very popular, benign nephrosclerosis. It disappeared for 20-30 years. Now it has come again. And you look at the grade 1 hypertension, which often people try to ignore. You need not treat it. This would be all right, set, taken care of. But if you look at the total cardiovascular event, it's about 12%. Coronary event about the 7%. Stroke 28%, and that's very bad. Stroke is incapacitation for all your life. And therefore it needs to be treated. Heart failure 18%. Cardiovascular death 23%, total death about 21%. So that's the reason why grade 1 hypertension should never be ignored. It should be promptly treated. Apart from the cardiac remodeling, we have also vascular remodeling. And that's important in the sustainability of the hypertension and to modulate the response of a drug in response to the selection of antihypertensive treatment. So what are the potential factors? The endothelial damage continues over the time. Podocyte entry, to which we nephrologists are quite concerned. There could be local inflammatory factors. There could be tubular tissue protein reabsorption, genetic factors, and increased matrix formation. This is ICMR India. I have a study which have said that 35.5%, this is a huge upsurge in the prevalence of hypertension all over the country. There could be 9.8% patient in adult population and also 20% in urban area. In diabetic kidney disease, I said this could be one of the initial presentation, but 84.1% is late stage of the renal failure. And that's why nephrologists use 3, 4, 5 drugs sometimes, and they still do not get control of blood pressure because total destruction of the architecture. However, this is about 1/3 patient of CKD at the beginning, 35.8% stage 1. So if you get hypertension, patient is not treated, note it in your notebook, this patient is stage 1 and would develop progressive deterioration of renal function over the years to come. When you make what is the goal, we all know, proteinuric 130/80, non-proteinuric little liberal 140/90. So proteinuria is the hallmark when you plan the treatment. We have a lot of younger people who gradually like diabetes also. 50% has a sedentary lifestyle, diagnosed with hypertension 29.1%. So you need to answer this. There are a lot of comorbidities with the lifestyle modification. Diabetes mellitus can coexist with 42.4%. So we are dealing with the insulin resistance syndrome, metabolic syndrome, and it is related with bad lifestyle. Cardiovascular disorder, a lot of cardiovascular disorder is associated. We have a lot of guidelines. Just after 2 hours, will be issuing one of our International Society of Hypertension guideline also. So what should be the target? Look at the distribution from 2012 to 2017. All studies with CKD have said it should be 140 by 90, all through. But for conditions like American Diabetic Association become little liberal, 140 by 90, Canadian Association 130 by 80, then 120 by 80 in some of the area where it has shown the benefit and patient has been diabetic. Otherwise, maximum all adults with CKD, the target should be 140 by 80. If diabetes, 130 by 70 or 130 by 80. What are the reasons? And the reasons are both the physician inertia as well as the patient inertia to start. Once labeled, then it could be detrimental. As I said, salt sensitive, extremely, 87% of Indians are salt sensitive, so they run risk of developing hypertension. These are the 10 ways to cut the salt, and these are the social, it's a part of the slide. But what is the important aspect of Indian hypertensive studies, and this have shown second most important cause of CKD after diabetes. In 35 to 50% of hypertension, they develop CKD over the time. And it adds to the progression. If you don't halt it, stage 2 can go to 3, 4, 5, and ultimately patient will land up in a very difficult situation because renal replacement therapy, maintenance, hemodialysis is a costly affair. There is a direct relationship between the blood pressure control and rate of decline. You do it better in stage 1 to 2, it stays, but if you don't do it, there's faster deterioration. 50 to 75% of patients with CKD have higher blood pressure, 140 by 90. And that's one of the reasons why you should try to aim to reduce, and the target level has been kept between 130 by 70 in diabetics, 130 by 80 in non-diabetics. So retard the CKD progression and reduce overall cardiovascular risk. The patient is primarily proteinuric. It's a tubulointerstitial disease, and patient is getting proteinuria more than 3 grams. I said it should be little more stringent, 25 by 75. If it is more than 3 grams, less than 3 grams, that should be 130 by 80. Diuretic is an essential part. It would be good if you can reduce up to 120 by 80. Well, once CKD progresses, it's very difficult, but that's the ideal, what you should aim for. Why CKD is a major problem in India, I said before, because one of the reasons that the metabolic syndrome, 40 to 80% of diabetic patients have hypertension, and 2 times diabetic are likely to develop hypertension. So this area is the area where both of us are concerned, the internist, the endocrinologist, and the cardiologist. So overall prevalence of the proteinuric hypertensive in diabetic patient about 10 to 54%. And this could also be associated with secondary hypertension. You should better screen for it. And there are a lot of endocrine conditions are associated. We can use the risk calculator, and this is available, CVD from the Hypertension Society as well as Cardiovascular Society. Now, last question is the last part of my presentation would go on the renoprotective therapies in hypertension. And that's the one point which we all should know it, because indiscriminate use of antihypertensive may not be helpful, rather it could be harmful. I said the benign nephrosclerosis came back again. It started with Richard Wright. It stayed up to Guyton. After Guyton, it started losing its value, because then people thought, no, it is John Pickering, one of the very towering personality in the hypertension from the New York University. He said that you need not cut short the size of a person if the door is short and the person is tall. So he thought probably the good blood pressure perfuses your kidney very well, as well as your cerebral circulation. and this idea was dropped down. It's only after 1960s and 70s, after the famous publication of Black from the Royal Infirmary, then it started reconsidering benign nephrosclerosis. So if the blood pressure becomes more than 220 systolic, there would be enhanced malignant nephrosclerosis. And one of the reasons you should suspect if the patient has a persistent systolic blood pressure, that probably he's losing his kidney function very fast. Or it could be a chronic kidney disease, where it would be slow, progressive deterioration. This is the lifestyle modification would reduce 5 to 11 millimeter of blood pressure, and one should try before drugs. If the patient has a diabetes, then he should aim for 130 by 80. Some studies have said 130 by 70. Patient chronic kidney disease, 130 by 80. The RAS is important drug to be chosen depending on the urinary albumin creatinine ratio. Should we continue ACE or ARB? How long? Wait for hyperkalemia to come, or should we continue because that? This is an important slide. And all of you must have experienced in elderly patient otherwise, when you give RAS treatment, initially there could be some drop in the GFR. And this GFR is a good predictor that your patient would be doing much better in the terms of renal protection. But look at the contrast part. This slide, I kept it purposefully because this study was conducted, though it is 2010-18 publication, but then it shows that when you use RAS inhibitors, 25% people may become worsened, means serum creatinine would deteriorate. If it is stage 1, it will go 2, 3. And if you withdraw it, about 50% would improve. So not necessarily all ACE inhibitor is going to protect your kidney. And about 25% would have a stable eGFR. So when you start ACE inhibitor or ARB in a patient who has a great stage 2 chronic kidney disease, look at the GFR within the 3 weeks. If it drops initially, be watchful. There would be patients who improve subsequently. But if they do not improve, hold on it. About 50% people, your GFR will improve. So initiation, accept 25% fall in GFR, ensure it is not progressive, keep the goal 130 by 80, review the medication, look at the diuretics as well as the protein. Should we use mono or combination therapy? And as I said, most of the nephrologists would be using 4 to 5 drugs because we insist upon the reduction of the systolic blood pressure, which is difficult. This is the level A recommendation. And C, when you initiate antihypertensive drug therapy with the first 2 lines, and then initiates antihypertensive drug therapy with a single antihypertensive drug reasonably to make the goal 130 by 80. There could be use of fixed dose combination versus the single molecule, and fixed dose combination always improved. As I said, RAS, CCB, and diuretic could be one of the choice. The first generation, nifedipine, nicardipine, then you have second generation, third and fourth based on the different blockage of the site, and could be the drug looking at LNT. So you have an extended release nifedipine, very popular, very commonly used in the villages. The quacks use it because it drops blood pressure instantaneously. The amlodipine, but duration of action of amlodipine is 30 hours. So even if your patient tends to forget subsequent dose, it maintains a good, and this is very safe drug. But for pedal edema, maximum these results of the landmark trials have come because of the amlodipine. Cilodipine is another drug which is lyophilic. Good. Edema is 2.5% compared to 25%, and it does not produce tachycardia. Heart rate would be almost within the physiological range. And we understand all the 3 terminals, the L-type channel, and it blocks the output of the ephedrine. And none of the reason why these patients develop a sustained tachycardia is these patients are the hyperadrenergic type. So they have a increase epinephrine secretion, which adds to, and the persistent tachycardia, resting tachycardia, sleeping tachycardia adds and makes worse for the possibility of congestive heart failure in the future. So they work on the blood vessel, work on the heart, work on the kidney, and they block the norepinephrine release. Reduces blood pressure compared to older CCB. It's an N-channel blocking novel molecule. It's a sympatholytic agent. So it would not let your patient have a resting tachycardia, which is bad. And N-channel blocking benefits help in multiple ways, protecting the crucial organ as well as establish the renal protection action. So as I said, increased sympathetic overdrive in young children as well as adults worsens the hypertension and the CKD outcome also. 64.2% patients in Indian setup have a high sympathetic overactivity, and 6 of 10 newly diagnosed patients have a sympathetic overtone, and that's why you need to take care of. This reduces the heart rate better when it is in the higher blood pressure than 85 millimeter mercury. We have only beta blockers. Beta blockers are a problem. It reduces the heart rate, but on-demand tachycardia is not met with. So if you are trying to catch the train, if you are rushing at the airport, probably it will be very difficult with 100 milligram Celocaine XL or metoprolol or carvedilol, then you feel exhausted. Has a multiple approaches for the renal protection, restores the podosine and nephrin expression, which is one of the earliest lesion in the deterioration of renal function. It acts on afferent and efferent arteriole, inhibits oxidative stress, and ameliorates urinary albumin excretion, and blocks the RAS system. So this is the summary of recommendation, which is going to start with ARB. You can stay with ACE inhibitor, but never do the both. Then you can have a benefit of choosing CCB or the diuretic. And based on that, you can choose either cilnidipine, amlodipine, or the sartans. Cilnidipine has got a better availability and doesn't have a pre-delivery, 25%, 2% compared to amlodipine. Can stay with lifestyle modification. The other protective strategies are lowering the cholesterol, looking at the MRAs, looking at some of the drugs which are uricosuric. Some people would like to add in chronic kidney disease in advanced therapy because of the heart failure also, especially diabetics. So you can use ARNI, you can use SGLT2 inhibitor, you can use MRA, and all three would have potential to decrease the blood pressure. So therefore, to summary, in protecting this chronic kidney disease, you can start with ACE inhibitor, restrict the salt, use the diuretic. You can start with non-dihydropyridine and keep the goal 130/80, especially in the type 2 diabetic patient. In non-proteinuric CKD, you stay with salt reduction. ACE inhibitor may not be mandatory. Diuretic is good for the protection. Non-dihydropyridine like CCBs can be used, and the goal should be 130/80. This is the summary slide in CKD workup patient. Patient is hypertensive, look at the proteinuria, non-proteinuria. Depending on that, you can add the molecule of your choice. So early is on time, and if you try to wait longer, it's too late before you can do anything good to you. Thank you very much.
Thank you. Thank you, sir, for your enlightening, informative talk. It is packed with practically useful tips. Now the session is open to the house. Any questions from the house? One or two questions.
Dr. Someone, any comment? I wanted to keep the time so that I was looking at the watch.
In the past, people were hesitating to use chlorthalidone or thiazide like diuretic in people with CKD. Now the entire scenario is changing, and now people who have a diminished eGFR less than 30, there is a definite indication for chlorthalidone or thiazide like diuretic instead of hydrochlorothiazide. What's your comment on that?
If you have a loop diuretic which is working round the clock 24 hours, the older thiazide like diuretics the one which we have been using, initially they take out lot of fluid from the body and the sodium. Rest of the 10 to 12 hours, again, gradually there is a restitution. So the net result is not very good. And therefore, what you said, the hydrochlorothalidone, these are the patient who takes longer time, slowly, gradually loss of the water. It's the physical property actually. If you drag the water too quickly, like Lasix, very potent diuretic, it takes water, no doubt. But the same amount of water in subsequent 8 to 10 hours, either you have immense thirst, you drink the water, or the fluid comes back again. And the interstitium of the collecting tubule, if you remember, which there is a multiplication of the osmolarity. This osmolarity, which was initially hyperosmolar to hypoosmolar movement, becomes isoosmolar. So that loses its importance. So therefore, the diuretics which are slow acting and acting on the proximal tubule, where the thiazide has been acting, is a better diuretic for the purpose of lowering blood pressure. The loop diuretics are good to take the water leg out, but subsequently there's a rebound hypertension. So that's one of the reasons why people have come back to the older one.
Thank you, sir. An excellent deliberation. So, humble questions. So, the MRI, spironolactone improves the heart failure, no doubt. But spironolactone may also deteriorate the renal failure.
Potassium.
Yes.
Sure. Agreed. Therefore, if the stage patient has gone to stage CKD 3 and 4, then should not be used. But stage 2, 1, you can use MRAs safely.
With caution.
Because the proteinuria, that I said, you could be a non-proteinuric, it could be a proteinuric. So if the patient has potential proteinuria and CCBs is not taken care of, ACE-ARBs have a limitation, then you can add on MRA, you can add on SGLT2 inhibitor. They would take care of both.
Thank you.
Yes. Yes, after renal transplant, good. Some of these patients initially, see, all during transplant procedure, there is a transient acute kidney damage. When you harvest the kidney and you do the anastomosis, you open the clip, there was be initially profuse diuresis. So it's a transient phase. Patient has started from serum creatinine 8 or 7 on maintenance dialysis program. We did an anastomosis. Initially, patient would drop. There would be a lot of diuresis. Creatinine would come to 1.8, 1.2, but it may rise again next to 1 week. That takes time, so about 2 to 3 weeks. And then it stabilizes. Same fluid. But second to third week, when you use a lot of steroid as immunosuppressive, high dose steroid, then there could be enhancement of the pre-existing hypertension, or a normotensive patient can become hypertensive. All calcineurin inhibitors, even cyclosporine, have a potential to increase the blood pressure. Otherwise, over the period, after 3 to 4 weeks, gradually these patients' requirement becomes less, transient acute kidney injury revert back, and the physiology is taken care of. And ultimately, your patient may revert back to normal. But if the patient of the 3 situation has gone into intermittent crisis, lot of steroids have been used to reduce the acute kidney damage, patient would be in the hypertension. We published an article about 25 years back in the Journal of Hypertension Transplantation, and there we proved that sudden deterioration of the increase in the blood pressure is one of the earliest signs of the graft failure. Thank you.
Very good afternoon, each one of you. And I would like to thank at the outset the organizers for having me here. And since we are just talking on about time before this also, so time is equally important for neurons as for the nephrons and other things, and maybe more important for neurons because you know a second of loss of oxygen, a second of loss of hypoglycemia in glucose or hyperglycemia, you lose your neurons. So the basic thing they wanted me to speak was about a stroke and a thrombolysis, which basically is for ischemic stroke. So the stroke statistics of our country is actually a very, very big problem, but is what we are addressing at tertiary care centers or at quaternary care centers is just a tip of iceberg, because we already know around 1.8 million people suffer from stroke in India each year. And it's a very, statistics is very profound. It came up in the Tribune that one Indian suffers from stroke in every 20 seconds. So the stroke risk in India is around 1:5 for the lifetime. So you already know this. So there are two types of stroke, ischemic and hemorrhagic. The topic, which is mainly about thrombolysis, is mostly applicable to the ischemic stroke. So as we go to the next slide, you know that ischemic stroke is mostly due to large vessel atherosclerotic disease, and it can also be due to cardioembolism. There are a lot of causes which are unidentified in stroke patients. In those cases, it becomes a cryptogenic thing. So a hemorrhagic stroke accounts for 15%, and ischemic stroke, being the larger chunk, is our point of discussion and is in the spotlight. So there are risk factors associated which are modifiable and non-modifiable. Obviously, you all know the non-modifiable are the risk factors which we cannot change. It depends on the age, gender, family history, and the race. And modifiable can be easily classified as the factors which doctors can modify and the patients can modify. So patients can always be motivated to stop smoking, stop alcohol, to have a better vegetarian diet, and obviously recreational drugs should be avoided and physical inactivity should be discouraged. Apart from that, which we can during our interaction in the clinics, we can modify is the hypertension, diabetes, and taking care of their lipid profile, and to identify early atrial fibrillation, because many times we have to ask a leading question for this regarding that: do you experience any kind of faster heartbeat suddenly and then it goes off? And during that session of having a faster heartbeat, do you face some giddiness? And AF may be missed out in most cases, and they become a very big important cryptogenic cause of stroke if not dealt with in a proper center. So for that, you may have to recommend them for a 24-hour Holter or a ELR extended loop recorder to identify the AF. And obviously important next is the identification of transient ischemic attacks. During our consultation time, which we spend with the patient, we have to ask them about: do you experience shorter duration of any weakness in the limbs, any numbness in the hands, or any kind of transient blurring of vision? Which stays for some time and goes off. This has to be a leading question, because many times they think that possibly it came and it went, it is not important. I have now come for some other diabetes checkup or some other BP checkup. Why should I tell this to the doctor? But for these things, if the patient is more than 40, we have to ask, so that we can actually identify TIA, and we can also forewarn them that TIAs are actually forerunners of stroke. By that I mean TIAs are the nature's way of giving us a warning symptom, a warning that possibly the person is in a high risk of landing into a proper stroke. So having said that, how do we identify early on the symptomatology of stroke? Very nicely, the World Stroke Association and the AHA has given us a very good short form B fast, in which we actually mean is balance. B is for balance. E is for any symptoms related to eye, like blurring of vision, sudden onset of blurring of vision. By F, we mean facial drooping, asymmetry of the face, which is happening suddenly. Or there is any A. By A, we mean arm, sudden onset of arm weakness, arm numbness, anything like loss of grip. Or by S is the slurring of speech or any change in the speech, such as sudden mutism. Aphasia is also important symptom of stroke, in which the patient suddenly becomes mute, is unable to talk, unable to understand. It can be Broca's or Wernicke's, whichever type. So B fast is an easy way of remembering the stroke symptoms. And if anybody over a call or during consultation says that we had such kind of symptom, then you can guide them to get a CT head or a MRI brain and identify the symptom. Why do we want to identify it early? Because you all know acting fast can actually save neurons by offering treatment, and it is all evidence based. As per the 2018 American Stroke Association guidelines, people treated with thrombolytic agents within the golden period of 4.5 hours are actually going to have a better quality of life, lesser residual weakness, and overall the prognosis in them is actually better than the people who land late to our places. So this is the thing I was talking. So it's very catchy, easily anybody can remember. B fast, that is balance, eyes. F is for the face, actually it's a typo error. A is for the arm, S is for the speech, T is time. Time means if you are identifying such symptoms, please immediately channelize the patient to a nearest center which has a neuroimaging at least. So we all know this thing, ABCD, we learnt in the school, medical school, otherwise airway, breathing and circulation whenever the patient reaches us. So that is the first thing we have to look. Apart from that, we'll quickly go to the D. D is the deficit quantification, whether it is a mild, moderate or severe. There are a lot of scoring systems available, the best one being the NIHSS scoring system for the stroke, and that is a readily available document in most of the equipped emergencies, where you can quickly quantify the type of stroke, whether it is mild, moderate or severe. And quickly then we have to counsel them that you immediately need neuroimaging, so that we can know whether it is an ischemic stroke or a bleed, and accordingly, if it's a ischemic stroke, we can actually offer them thrombolysis in 4.5 hours or mechanical thrombectomy up to 24 hours as per the recent trials. So, and quickly we also need to ask the patient that what was the last drugs he took in last 24 hours, because we may be dealing with somebody who was on anticoagulants or drugs which can be a potential contraindication for thrombolysis. So after this ABCD, we have to actually quickly, this is for the centers where you do not have neurological backup or facilities. After detection, you have to dispatch the patient, and the patient is to reach a place where the proper neuroimaging is there, and there is the facility for thrombolysis is available. So what we have to do after the arrival is quickly process the data which has come with the patient. Suppose the patient has already done a CT and arrived, we have to quickly process, take a decision, and then start the drug and dispose of the thing. So the current stroke management, the thrombolysis, as you all know, was approved since 1996 by the FDA. The first being the altiplase, which was approved. But do you think we are using the drug as as much as we can. Since 1996, it is approved, and still the awareness, the use is not as much as it should be. So thrombolysis is largely underused, and as per the data, up to 2 to 12% of eligible patients are only receiving the and TPA. Other patients they are not being offered, or they are not having the awareness, or they are not reaching the center where they can be given. So the important problems being delayed arrival to a stroke-ready hospital, TAPA not being available, and in-hospital delays also are important cause, because you need to have a stroke team where the stroke, everybody is ready. There is a stroke nurse, there is the radiologist available, the technician is aware, and a stroke code, which is the way in most NABH hospitals nowadays have code for violence, code red for fire, like that. Stroke code is a reality. The stroke code has to be announced, and immediately everybody is on their toes, so that door to needle time, which is as per the guideline 60 minutes, has to come down only if everybody works collectively and the time is reduced. Otherwise, it's very tough, because already the patient must have reached after 1 or 2 hours. And if we also keep in hospital lot of delays, then thrombolizing will be a big problem. So in a very experienced stroke ready center, the door to needle time can actually be less than 20 minutes, because it's very easy. If everybody, the stroke code is announced and everybody is on their toes, it doesn't take longer time to actually start the thrombolysis agent. As you all here, I would also like to say that since the time period is 4.5 hours, sometimes the drugs which are being used are currently only 2 drugs approved by the DGCI in India. That is, one is alteplase and another is tenectase. So in both these agents, there is a lot of difference, which I'll quickly be telling you. So this is about the stroke code prior notification, how it can be actually helpful in decreasing the time. So apart from that, if we have an organized team and a stroke unit, a stroke code, then the door to needle time as per the guideline can be less than 60 minutes. So what are the important things? Suppose we have got a patient who has arrived to us within the golden period. What is the minimum things we need to do? Is the priority is to know the drug history. The drug history, if the patient was on acetrom or warfarin or any oral anticoagulant, then the PT-INR has to be sent on the urgent basis. Those patients can also be thrombolized as per the guideline, and we have thrombolized such patients with a good recovery. If an INR processing in a good lab takes around 30 minutes max. So in 30 minutes, you will be getting your INR report. And apart from that, you also have to get a blood sugar level. If the blood sugar level is less than 50, or if it is very high, more than 180, then you cannot thrombolize. You have to first correct that, because there is a possibility that you are dealing with a stroke mimic rather than a true stroke. So blood sugar, and if the patient is on oral anticoagulant, INR, these two are the basic test which has to be done as per the guidelines. And after that, if these two things are done and it is all okay, then you can actually go for counseling the patient about the cost, about the possible complication of thrombolysis, and go ahead. If they are okay, you can obviously go ahead with the thrombolysis. So I would here request, just if you can run the video. No? We actually keep a video very handy in the emergency, so that because it's not easy for the layman to understand what we mean by IV thrombolysis, because so this kind of videos in the emergencies can be actually very helpful for them to comprehend and understand what you are planning, what you are saying. It's because it's a short time. The patient family has to also take a decision very quickly in 30 minutes or so, whether to thrombolize or not to thrombolize. So it's a layman you are talking to. So you have to be actually, so I'll be giving you that example video. So if they see it visually, it can be a ready tool. If they see that visually, and then they can be actually very easily, they get convinced that yes, this is something which is going to help me out, because it's for people, it's not a easy thing. When you tell them that possible complication is a bleed inside the brain, they are totally, they don't want to take the risk. We are not risk takers. In general, Indians are not risk takers, no? So we don't want to take the risk that a bleed ho jayega, but it's less than, it's really very safe if it is done within 4.5 hours, and people have actually got a lot of benefit. So we have to show them the video, and then we also tell them the risk is there, risk is real, but your patient can actually improve from the disability of staying one side paralyzed, unable to speak with a asymmetrical face, and then they understand, yes, possibly the quality of life will be actually much better if they are getting from it.
Rupture, promoting thrombus formation by activating the coagulation cascade. Platelets in red blood cells aggregate at the site of injury, causing further narrowing of the artery. This impedes blood flow even more and causes turbulence in the artery. It also increases the likelihood of thrombus formation. As the thrombus grows, it causes increased vessel narrowing, leading to partial or even complete occlusion. The occluded artery leads to ischemia and tissue necrosis. When a piece of thrombus breaks off, it's called an embolus as it travels up the artery. During a stroke, ischemia can progress to infarction. Beyond the infarction lies still viable tissue called the penumbra. Cells within the penumbra are potentially salvageable if blood flow and vital oxygen are restored promptly. The penumbra is the focus of fibrinolytic treatment. Now let's look at the thrombus itself. Inside the thrombus are strands of fibrin, the protein that forms a clot. Enmeshed within the fibrin is plasminogen, the inactive precursor of plasmin. This is administered by IV infusion within 3 hours of acute ischemic stroke symptom onset. Binds to the fibrin in a thrombus and converts plasminogen to plasmin. Plasmin then breaks the strands of fibrin and dissolves the clot. As the clot dissolves, blood flow is restored, and viable tissue may be reperfused. Although the original infarction remains, when surrounding cells in the penumbra are saved or reperfused, function may be restored. The 1 TPA for stroke is the only.
So there are 2 drugs currently approved by the DVCI. One is antiplase and another is tenecteplase. So both tenecteplase, I'll just quickly have a short of time, that it is 50 times more febrile. And the difference of the two is that one has to be given over infusion. The antiplase has to be given over infusion of 1 hour, whereas the tenecteplase can be given over bolus. So this is a major difference, and major also a positive point we must think, because if the patient is running at the end of window period, suppose 4.5 hours, so at that time when you want to give a drug which is going to go for another 1 hour can be actually risky to the fragile brain tissue, because it can be potentially leading to ICH. So in those cases, choosing a medication which can be given bolus like tenecteplase is actually going to be very helpful, because you just give bolus less than 30 seconds and it does it immediately resolves. Moreover, cost is definitely a difference in both of them. Apart from that, the fibrin specificity of tenecteplase is also better, and that helps in the large artery occlusions can also be dealt with it. So these are the points, and it depends on your institute where are you working and what kind of drugs are approved by your stroke committee. So as if the patient agrees, immediately checking for the blood glucose and then oxygen saturation, obviously these things are done in the emergency. So, and then it's not required to actually undergo all the testing at the same time. only important investigation is blood glucose level. Getting a INR if the patient is on oral anticoagulant should be the main things to be done. Because if INR is less than 1.7, we can actually normalize the patient. So I'll quickly, I'm running out of time, so I'll quickly go through a normal NCCT head, non-contrast CT scan of the head, or getting a MR diffusion screening, which both of them take almost similar time. It is basically to be very sure that you are not dealing with any bleed and to see the size of the infarct tissue. So that is important. That is class 1 evidence. And apart from that, I'll quickly go. So this is what the recommendation is if you are having a stroke in all across all NABH hospitals, that if you are having a suspected patient of stroke, within less than 10 minutes, all emergency evaluation history, lab, what has to be sent to the lab has to be done. And within 15 minutes, the stroke team has to be informed of the patient of arrival. And within 25 minutes to 30 minutes, CT scan or MRI, whatever you are deciding as per your hospital choice, you have to get it done. And within 60 minutes, if the patient is eligible, we have to, this is the standard guideline, but usually it gets delayed by double in most of the centers, including ours. So this is the basic flow chart. I'll quickly run through that. That once the patient comes, go for ABC, airway, breathing and circulation, give oxygen only if saturation is less than 94, and perform immediate pre-hospital stroke. Yeah. I'll just quickly go. And get a RBS, get a PT-INR only if oral anticoagulant patient is on oral anticoagulant. Otherwise, there is no need of PT-INR. You can quickly inform the stroke team and get the CT or MRI diffusion done. If it is eligible, we must, if there is no bleed, we must go ahead with thrombolysis. But before that, you have to check the blood pressure. If it is more than 185 by 110, then we have to bring it down so that it at a very high blood pressure, if you thrombolize, there is the chance of getting an intracranial bleed are very high. The drug of choice for that is usually labetalol. So after you have done everything, all these thrombolysis, be it alteplase or be it tenecteplase, we have to make sure that DTN, door to needle time, is 60 minutes, and that is what we should all be working towards. Apart from this, before ending, I would like to request each and one of you to think about thing of tele-stroke units and teleradiology, because it is approved thing by FDA, by the AHA also. So even if we think that we are at a smaller center where we can do correlating by having a license with people who are having a teleradiology facility or a telestroke, we can actually give the real benefit of thrombolysis to many more patients, because we are going to be treating patients free from disability. With that, I'd like to end the session. Thank you.
Thank you for your extensive talk on management of stroke. So far as the time is concerned, it is valuable for managing the cardiac cases as well as the stroke cases. So as the governor's address has already been started, there is less time, and we will close the session here. Thank you.
Thank you, sir.
I hereby thank all the speakers and respected chairpersons. May I now request Dr. Akshay Mahajan to present a token of appreciation to our speakers, Dr. Kamlakar Tripathi, sir. Dr. Akshay Mahajan, please, sir. Dr. Dinabandhu Sahu, sir, please present to Dr. Meenal Mohit, madam. Sir. Dr. Kamlakar Tripathi, sir. Sir, Dr. Meenal Mohit, sir. Dr. I request Dr. Sahu, sir, to present a bouquet to Dr. Mitali Karkar. Dr. Mitali Kar, please. I now request Dr. Narsingh, sir. Sir, please present the appreciation, token of appreciation to Dr. Akshay Mahajan and Dr. Sahu, sir, please. Our chairpersons. Thank you so much.
by case, by Dr. S.N. Narasinghan, who is a known lipidologist and cardiologist from, of national and international repute. And he would be discussing on case-based discussion in hypercholesterolemia. Over to you, Dr. Narasinghan.
It's not appearing here. Thank you very much, chairpersons. My dear friends, at the outset, I would like to thank Dr. Anuj and his other organizers, including Dr. Virmani, for giving me this opportunity to be here to talk on an important aspect in lipidology. I have chosen a case-based discussion on hypercholesterolemia. With one of my patients who had seen me in the year 2018, he was only 23 years old, came with the cholesterol levels of 279 and LDL cholesterol was 200. The moment he entered into my clinic with his father, I did not talk to the patient, but I talked to his father. Did you get submitted for any of the procedures in the heart? He told me yes, bypass. How do you know, sir? The cholesterol levels of this patient tempted me to ask this particular question. I'm sure you would have definitely undergone a procedure for your heart problem. In fact, his father had higher cholesterol 340, LDL cholesterol was 254. He was submitted for CABG. Post CABG, after a period of 1 year, 4 months, it was 115 LDL cholesterol. That means he has not reached the goal of LDL cholesterol, what is required, even if the patient had undergone a CABG. That's most important. He has not reached the goal of LDL cholesterol. What we recommend from Lipid Association of India is about 50 milligrams. Having seen this, I'd like to ask you some few questions before I talk about the subject. If a patient of 18 years of age consults you with a lipid profile where the LDL cholesterol is 164 milligrams, so what's your diagnosis? 164. Familial hypercholesterolemia. If a 9-year-old patient is brought to you with the LDL level of 520 milligrams, what's the diagnosis? Homozygous familial hypercholesterolemia. Thank you. 40-year-old gentleman who suffers from ACS, his LDL level is 190 milligrams. What's the diagnosis? Familial hypercholesterolemia, which has ended in a cardiovascular event. He developed acute coronary syndrome. Most important complication of familial hypercholesterolemia. In an unfortunate situation, the same patient is not reaching the LDL goal with available drugs. What will you do or how will you proceed? ACS, familial hypercholesterolemia, 40-year-old man, you have started a high-dose statin. What will you do next? All together or sequentially? Yeah, your answer is perfectly correct. Probably I will take you to that level of understanding about familial hypercholesterolemia. So that paves me the way for proceed, how to go about talking about this particular entity which is totally forgotten, it is underdiagnosed, underdiagnosed, untreated. Familial hypercholesterolemia, just look at the prevalence. In Iceland, it is about only 1 in 800 people suffer from this. Whereas generally, globally, it has been estimated that about 1 in 300 people suffer from familial hypercholesterolemia. Surprising to see that 1 in 80 people suffer from this problem, particularly they are from founder population, like French Canadians and Africans. You can just see what's the prevalence in our country. As per the data projected in Indian Heart Journal, in 2017, it is clearly seen that 1 in 125 or 1 in 40, 1 in 450 suffer from this problem. What is founder population? I must tell you. Look at the bigger circle. The original population has nearly equal numbers of blue dots and red individuals. The three smaller founder populations show that one or the other color may predominate. That is called founder effect due to random sampling of the original population. You can look at on the right side, the red dots are seen. Again on the right side, you can just lower down, blue dots are seen. In between you have a mixture. One is probably higher than the other. This is called founder effect. The founder effect is actually the loss of genetic variation that occurs when a new population is established by a very small number of individuals of a larger population. Smaller number of a larger population representing. So those people are found to have a higher number of or higher prevalence of the familial hypercholesterolemia. So familial hypercholesterolemia is a genetic condition that causes high cholesterol. Left untreated, heart attacks happen in 30% of women by the age of 60 years. 50% of men by the age of 50 years suffer from this and die. So finding and treating familial hypercholesterolemia reduces the coronary heart disease risk by about 80%. So it is an autosomal dominant inherited disease. The cause is most often a variant in the gene. The gene defects may be in the form of allele receptor gene or ApoB gene or PCSK9 hyperfunction. So the heterozygous familial hypercholesterolemia, the prevalence estimated is about 1 in 200 to 250. The three genes probably can be involved. The levels of LDL cholesterol can go up. Look at the homozygous, 1 in 160,000 or 1 in 320,000 people. The same genes are probably involved, but the LDL cholesterol is abnormally high. Next is the familial combined hyperlipidemia, and it is also common, 1 in 100 to 1 in 200. I am seeing it in my clinical practice, which I am not going to touch here. Let us not go into the depth of the details of the rare problems. Suffice to say that this simple diagram will tell you about the problem of LDL cholesterol. Taking into consideration 100 LDL cholesterol milligrams is normal. That means somebody is having 160 and above, 500 and above, or 400 above. You need to think only in terms of familial hypercholesterolemia. So there are two types. One is the heterozygous familial hypercholesterolemia. If you get an altered DNA from one parent, it is called heterozygous familial hypercholesterolemia. It is more common than the two types. Homozygous familial hypercholesterolemia, if you get it from both the parents, it is called homozygous familial hypercholesterolemia. It is a rare type. This is the important slide which probably tells you about how the child can get affected if parent A, parent B status. For example, heterozygous man 2, a person who is not having any familial hypercholesterolemia, 100% heterozygous. That is the way in which the children are likely to get affected depending on the genetics. Let me now try to take you to our understanding about the signs and symptoms of familial hypercholesterolemia. In homozygous, in children, the symptoms are consistent with IHD, peripheral arterial disease, cerebrovascular disease, or aortic stenosis. The articular symptoms such as tendinonitis or arthralgias can occur. Cutaneous xanthomas at birth or very early childhood, planar xanthomas, tuberous xanthomas, later tendon xanthomas. Corneal arcus, it can be circumferential corneal arcus. If it is seen in a child, it indicates that it is only familial hypercholesterolemia. Murmur of aortic stenosis can also be present. This is the patient. I actually covered the face. She had seen me when she was 8 years old. Two children were brought to my clinic. One is 8 years, the other one is 10 years old. The two children had the problems of xanthelasma everywhere, xanthelasma, tendon xanthoma, and the children were actually criticized in their school by telling them that you have got leprosy, don't come near. So she was very much upset when both the children were brought to me. That was a simple case of familial hypercholesterolemia homozygous. That was a diagnosis which I made, but told the parents that at any time the child would die, don't put the blame on me. Because this is a critical problem because the cholesterol levels were 720 milligrams of LDL cholesterol for both the children. So one child, after a treatment for 3 months or so, she died one fine evening. That's all. The other child is now 24 years old. She is still under my treatment. I have exhibited all sorts of drugs now, which I will tell you at the end. So very interesting case. She now is asking a question to me. Can I get married? That is why I started projecting. If a homozygous person gets married to a person who is not having a problem, you may get into the difficulties of getting the familial hypercholesterolemia. The signs and symptoms in heterozygous children, no symptoms at all of CAD. Most of them do not even develop xanthelasma or xanthaloma or corneal arcus. One parent probably will have a severe hypercholesterolemia, either a personal history or a family history of premature coronary artery disease. Heterozygous in adults, this is most important. This is what we normally encounter. The cardiologist enters into the ICU. There is no risk factor at all. The physician assistant or somebody tells there is no risk factor at all. Cardiologist must immediately ask for increased levels of LDL cholesterol if it is there, or LPA levels. Very important. I think the severe hypercholesterolemia in childhood, if that history is coming, probably that gives you satisfaction that you made a correct diagnosis. No previous ACS event, symptoms IHD in the presence of other risk factors, particularly smoking. Past or present symptoms of recurrent Achilles tendonitis or arthritic symptoms. Heterozygous familial hypercholesterolemia left untreated. Tendon xanthomas by the third decade of life in more than 60% of the patient, and xanthelasma. How to diagnose familial hypercholesterolemia? There are three important criteria. One is the Simon-Broom criteria. Two, the familial hypercholesterolemia Dutch lipid clinic criteria. The third one is the MedPred criteria. The Lipid Association of India recommends Simon-Broom criteria, which is very, very simple to follow. Please see that this is a Simon-Broom criteria which is recommended by Lipid Association of India. One, if the total cholesterol or the LDL cholesterol is more than 190, think about it. Or in a child, if it is more than 155 in persons in whom you have LDL cholesterol between 155, 190 and above, think about the Simon-Broom criteria, point 1. You had second point, where there is tendon xanthomas. Third point, DNA-based diagnosis. Fourth point, family history of the myocardial infarction before the age of 50 or before the age of 60 in a female or a second degree relative. The fifth point is the family history of elevated cholesterol levels of more than 290 total cholesterol or 260 total cholesterol in the second degree or 16 years of age. So add 1 positive plus 2 or 3 or 1 plus 2 or 4. If you get it, if you have 1 plus 2 or 3, there is a definite diagnosis of familial hypercholesterolemia. Whereas the second one, possible diagnosis. I am not going into the depth of the details of the other criteria. Other criteria tells you about the family history, the clinical examination, and then the physical examination of the patient, the cholesterol levels, all those things are highlighted here, which I don't want to dwell. The MedPred criteria, again, is very difficult because people who are above the age of 40 years, if somebody is seen with 290, 300, 310, 360 total cholesterol, think about familial hypercholesterolemia. Then it is screening, not routinely required. If you have the xanthelasma, if you have tendon xanthoma, the cholesterol levels are high, family history of premature coronary artery disease and death, as I had shown in the previous patient, so the first patient, and the father also gave a positive history. In fact, I went into the depth of the story. All the relatives of that particular individual were suffering from coronary artery disease, either they had undergone PTCA or CABG. That's the story. So you need to think about the clinical examination, the LDL cholesterol examination, and that is most important rather than genetic testing. I think all of you are aware about this portrait of Mona Lisa. Very attractive. But if you closely observe, she has a xanthelasma. Probably she would have had a familial hypercholesterolemia, and if at all she lived, she would have died only due to familial hypercholesterolemia leading to ACS or atherosclerotic cardiovascular disease. This is xanthelasma characteristic. You look at the cornea, circumferential accumulation of this white matter which is seen around the cornea. That is the most diagnostic of the problem of familial hypercholesterolemia. What about the lipid levels? There's an interesting detail. When there are more lipid levels in spite of treatment, you have increased cardiovascular events.
Number two, if you are able to reduce the LDL cholesterol by effective treatment, the percentage of reduction, for example, 50% reduction of LDL cholesterol, 70% reduction, with the PCSK9 85% reduction, and you get a good amount of reduction of cardiovascular events. That's the message, what is available in this projection. What are the drugs that are available to treat people with LDL cholesterol which are very high? One, all of us know the HMG coenzyme E reductase inhibitor, statin. One step above is the acetyl enzyme, cyclase, ATP, which is blocked by a drug called bempedoic acid, which is available in our country. The third one is the cholesterol absorption inhibitor, acetamide, which blocks the Niemann-Pick C1 like 1 particle. That is an enzyme which is blocked by this drug called acetamide. And the other one, all of us know about the PCSK9, is a proprotein convertase subtilisin kexin enzyme, which is secreted in the liver. This gets blocked by monoclonal antibodies like avelumab and alirocumab. They try to increase the production of LDL receptor, thereby the clearance of LDL cholesterol is enhanced. The other one is the PCSK9, again abolished by another one, that is the inclisiran, which is a small interfering RNA which blocks it. It is also in the pipeline yet to arrive Indian market. The other one is the AKCA is a drug. The other drug which is mentioned here, blocking the ANGPTL3, evenacumab. Again, the drug has been tried in homozygous familial hypercholesterolemia. So this one diagram, ladies and gentlemen, tells you what are the drugs that are available with us to tackle the patients with the highest levels of LDL cholesterol. The statins, you know about the moderate dose statin and high dose statin. I don't want to dwell. Suffice to say that if you start the patient on a 40 milligram to 80 milligram of Tarva or a 20 milligram to 40 milligram of rosuvastatin, it is considered as a high dose statin, when you can expect the LDL cholesterol levels to be brought down by 50%. If you give high dose statin, there is enough data to show when compared to smaller dose or moderate dose or no statin at all, there is a mortality benefit to the extent of 13%. Okay, what about the acetamide, the drug that was tried in a trial called IMPROVE trial? The absolute risk reduction is only 2%. In non-diabetic, it is 6%. Whereas in people with the diabetes, it is 6% reduction of relative risk reduction has been identified. In non-diabetic, in diabetic, it is about 14% risk reduction. Again, people with the diabetes of the polyvascular disease like heart attack, ischemic stroke, peripheral vascular disease, which is commonly seen in people with the diabetes, they have shown much more benefit with the acetamide combination than with the statin alone. So this trial has probably improved our approach in those patients in whom we are not able to tackle the LDL cholesterol. The PCSK9 inhibitor, the drug avelumab, was tried in 4-year trial. Of course, the stable patients, coronary artery disease stable patients were recruited for this study. It clearly indicated that LDL cholesterol can be brought down to the levels of 30 milligram within a matter of 4 weeks. Within 1 month therapy, the drug had produced a marked reduction to the levels of 30 milligram. It was maintained up to 48. After that, throughout the end of the study, 3.2 years, the levels were maintained. Even you're bringing down to the levels of 30 milligram, got reflected in the form of reduction of cardiovascular events to the extent of 15%, the primary endpoint. That's most important. Even in this trial, people have seen, people are reaching levels less than 15, 10 also. If you take 10, the subgroup analysis, people have seen that there is the benefit of reduction of cardiovascular events in those people in whom the levels are only 10 milligram. So ladies and gentlemen, I don't know at what level probably you can think about much more benefit. Is it good? Is it going to be less than 10? We don't know. And even alirocumab has shown people who reach the levels of 15 milligrams, they have shown much more benefits when compared to people who reach the levels of 30 to 40. Again, indicating the more the beneficial effects the drugs are appreciated in the form of reduction of LDL, the more event reduction have been appreciated. Recently approved drug is a bempedoic acid, which was approved in those patients with familial hypercholesterolemia, in those patients with the ACS who are not able to bring down the LDL cholesterol, give bempedoic acid. Or people who are statin intolerant patients, true intolerant. I'm not talking about people coming back with the myalgia, then you stop that and put the patient on imidoic acid. You are wrong. Should not be done at all. You need to convince the patient to go back and come after a period of 4 weeks or so, taking into consideration the CK values. The CK values are normal, don't get worried. The patient is not suffering. All my patients who come for my consultation, I always tell them that this drug is likely to produce muscle pain. Don't get worried. You need not come back to me. And if it is severe, and it is persistent, and if it is proximal, and if it is bilateral, please come back to me. Otherwise, don't consult me for that. If you talk to the patient, one-to-one interaction, that will give him the strength of continuously using this drug for the benefits what he is going to achieve in the form of reduction of cardiovascular events. So that is most important. And then the next one is the other medications, lomitapide, mipomycin, or the drugs which are used only for patients with the homozygous familial hypercholesterolemia. Inclisiran is a drug, small interfering RNA, which is available in the United States, but not available in our country. It is likely to reach within the next 6 months or so. The company is very keen on getting it to Indian market. This drug is better when compared to PCSK inhibitor like about 50% reduction in and outcome data is also high. Oral PCSK9 inhibitor is on the pipeline. It shows the various doses, like 30 milligram of oral drug is almost equal to the injectable form of PCSK9 inhibitor, where you can get about 60% reduction in LDL cholesterol. And then the last one is the evenacumab, which blocks the ANGPTL3. This drug has been tried in homozygous familial hypercholesterolemia, the case which I had encountered in clinical practice. Now she is 23 years old. She is an ideal candidate to receive this drug. Unfortunately, we don't have an access to this particular drug. Evenacumab, which blocks the ANGPTL3, is a drug of choice in those patients in whom you have a LDL levels high, homozygous type, patient had undergone all sorts of therapy, high dose, plus or minus ezetimibe, plus PCSK9 inhibitor, still the levels are not coming down. LDL apheresis had been started. In spite of that, you are not getting it. This drug has shown marked benefit in the form of reduction of LDL cholesterol. The lipoprotein apheresis reserved for homozygous can be used even for heterozygous familial hypercholesterolemia. Surgery, elio bypass surgery, which is not routinely practiced as a methodology to control the cholesterol, but the liver transplantation has shown marked benefit in increasing the LDL receptors in the hepatic cell surface. Ladies and gentlemen, never forget about another autosomal dominant problem, that is lipoprotein(a). See that you ask for extended lipid profile for every individual in our country, because I have seen number of patients getting this problem of LPA in association with high levels of LDL cholesterol. If it is combined with heterozygous familial hypercholesterolemia, the events are much more. I have seen people getting heart attack first, getting stroke. That made me to think in terms of an associated problem. LPA was 180 milligrams. So please remember to evaluate this particular entity. We don't have any specific recommendation. Suffice to say that PCSK9 inhibitor is a drug of choice, but is not recommended by FDA so far. The newer stricter guidelines, which I don't want to dwell, this is the Lipid Association of India recommendation. This is how to treat heterozygous and homozygous, because the time is out. I don't want to take much time because of I'll be interfering with your lunch time. Let me not dwell into this. For heterozygous, go through all this sequential way. For homozygous, start lipid apheresis as early as possible. That is the message. My patient who had homozygous familial hypercholesterolemia started high-dose statin Rosuva, plus ezetimibe, plus PCSK9 inhibitor, plus bempedoic acid. Look at the levels now, 231 milligram, which was initially 504. Now it is 231. I am happy that 50% reduction has taken place in this individual. Probably she has some LDL receptors to act. So that's the message. So if you are able to find one case, please remember, this is a message from my end. If you see one patient, you will detect more. Keep that in mind. You know why? Familial hypercholesterolemia is a family disease. Ladies and gentlemen, before I conclude my talk, I need to tell you, since I am occupying the Vice President post of the World Hypertension League, we are now going to have first time World Congress on Hypertension, which is going to be in 2025 February. 21st, 22nd, 23rd February at Chennai, and I am the organizing chair. It has been given an opportunity by the World Hypertension League. The registration details are available in IMCO halls, and of course, I have given 3,000 discount for those people who are attending this conference. From 15,000, you can only pay 12,000 rupees if you are really interested. Thank you very much, ladies and gentlemen, for patient listening.
Thank you, Dr. Narasinghan. Can we take up one or two questions? Okay. I would, like to ask you is, how early or young patient, heterozygous or homozygous familial hypercholesterolemia, you can start treatment? Any age?
No, if you have a strong family history of premature coronary artery disease death or premature coronary artery disease, either in the parents or in the first degree or the second degree relatives, and the LDL cholesterol is higher in one individual, it's always better to do cascade screening. If you are catching a child at the age of 2 years, 3 years because of the skin problems, the dermatological manifestations, you need to go for reverse scanning. Reverse screening is important. I think it is mandatory even at the age of 2 years. But normally, when you send the lipid profile at the age of 18 years, please include lipoprotein literally also, you will get the information.
Okay, that's very good. Yeah, any comment from, yeah.
Started statin from the age of 11. What's your recommendation?
In fact,
and what statin to start? And what statin would you choose?
No, when I had these two children, when they were all brought to me, one was only 8 years old, the other one was 11 years old. There was no data with respect to the starting of statin for this group of children. In fact, I had a discussion with the pediatrician. They were ignorant and they were not able to give me the details. In fact, I boldly started 20 milligram of rosuvastatin at that stage for both the children. And I was continuously giving it. One child had at the end of 3 months of treatment. The other child was behaving in a slow way. Not that aggressive reduction is happening. In fact, we had a discussion with Dr. Virgil Brown, who came to Chennai. He was the National Lipid Association of India's president. I was sharing the platform with him to discuss on various issues. That time the question came from the floor that how to treat familial hypercholesterolemia homozygous. Then he asked me, do you have an experience? Yes, I have an experience. I started treating a child. Treating a child at the age of 8 years, there is no data, but I started only with the 20 milligram. There is a poor response. What am I supposed to do? Virgil Brown told me, Dr. Narasinghan, don't get worried. I am starting 40 milligram of Rosuva for a 2-year-old child. For a 2-year-old child.
Dr. Narasinghan, as per the recommendation, I think it's 10 years as of today. The recommendations are 10 years onwards,
Yeah.
but yeah.
As per the recommendation, yeah.
Done.
Perfectly correct.
Age is no criteria. Simple.
Instead of concentrating on high dose statin, go for the other drugs and give it instead of high dose statin, high lipid lowering therapy. Yeah.
Okay, so I think we move to the next session, and I hand over the mic to my co-chairperson.
Thank you, sir, for excellent. Once again, thank you, sir. Moving on to the next topic, moving from the realm of cardiology to endocrinology, we have the next topic, that's cyclic Cushing syndrome, and it shall be delivered by Dr. Abhishek Pandey. Yes. He is a DM endocrinologist from BHU, well renowned. The floor is all yours, sir.
Cyclical Cushing's. Have you changed the name?
So good afternoon. So I am really grateful to Professor Anuj Maheshwari, Governor ACP India, for giving me an opportunity to talk on this platform. And special thanks to the scientific chairperson of the ACP India, Dr. Anil Virmani. And thank you, chairperson, for your kind introduction. So before this technical glitch solved out, I will be very straightforward with my presentation. How many of you want challenge in your clinical practice? Challenging case. You can raise your hands. Let me see how many of the physicians who are sitting in this room want a clinical challenging case, a difficult case, not an easy one. None of you? Oh, great. Great to know. There are some who want clinical challenging case. So the topic which I am going to talk about, that is cyclical Cushing syndrome. This is a very clinical challenging case in our practice. Many times missed, misdiagnosed, not able to diagnose it properly, and patient suffers a lot. So as you must be aware that Cushing syndrome, when we say, I have already given to you. Why you are so much blank? Bring that laptop. So when we say the Cushing syndrome, we know that there is, by Cushing syndrome, we understand there is an increased cortisol. This cortisol will be very high. So there are two things, whether it is exogenous or endogenous. So for any patients in which you are suspecting Cushing syndrome, you all must be aware of the clinical features of Cushing syndrome, round faces, the buffalo hump, various other things that I will talk in my subsequent slides also. So this Cushing syndrome, when we say, so first we have to rule out whether we are dealing with exogenous or endogenous. So exogenous, you get the history. There are some other ways also we can find it out, like we can measure the serum cortisol, urinary cortisol, steroid profile we can do. Sometimes patient unknowingly taking the steroids in some form of alternative medicines. When we talk about the endogenous Cushing's, we divide into two classes, whether it is ACTH dependent or whether it is ACTH independent. So as we know, there is an adrenocorticotropic hormone being released from the anterior pituitary gland, and it is going to stimulate the adrenal gland to produce the cortisol. So when we talk about the ACTH dependent, so that means there is some problem in the pituitary where the ACTH is being produced. So might be microadenoma of the pituitary, the corticotroph cells, they are secreting more ACTH, so it is ACTH dependent. There can be other sources of ACTH production. Yeah. So there can be other conditions in which ACTH can be produced, but it is not produced from the pituitary. So what we say, it is called ectopic ACTH producing syndrome. It can be various tumors like thymic carcinoids. Various carcinoid neuroendocrine tumors can be associated with that ectopic ACTH production. So this is a broadly divided the ACTH dependent group. ACTH independent means ACTH is not the thing which is leading to production of cortisol. So what can be the cause? It can be adrenal Cushing's. So various adrenal tumors which can lead to production of the cortisol in that group. So when we talk about the cyclical Cushing's, so what the message we want to give, that there is some cyclicity, whether it is regular or whether it is irregular, it varies. Means you have sometimes when you measure the serum cortisol, it will come higher side, and when sometimes you measure the serum cortisol, it will come normal or lower side of the normal. So this is the time the problem starts in diagnosing. Means you are thinking that it is a Cushing syndrome, and you measure you have done the ONDST, and that comes to be a normal. Then you think, no, it's not Cushing, but the patient has symptoms. And sometimes you measure, it comes to be not suppressed. So this the way the things start. Now my slides are there, so now it will be easy for me also and for you also to comprehend. So nothing to disclose. So the case from which I am going to start my presentation. This is the case published in BMJ case report in 2017. This is a 68-year male patient with 3 years history of type 2 diabetes and hypertension. And he was referred in the endocrinology clinic for the evaluation of the possible adrenal insufficiency. Means they were suspecting that there was some problem in the adrenal gland, maybe primary adrenal insufficiency, means cortisol is lesser, they were suspecting. Why? Because there were some episodes of muscle aches and pains, extreme tiredness. You know, adrenal insufficiency means low of cortisol is very low. So patient will feel very tired. Increased sweating is there and generalized skin pigmentation is there. Why skin pigmentation in adrenal insufficiency? Anyone who want to answer? Because of increased ACTH, right? So when this patient was evaluated, they found that the patient also has some symptoms of polydipsia, nocturia, difficulty in climbing the chairs, but there was no history of change in the weight. So I think by this second line, you can understand difficulty in climbing the chairs, means some form of myopathy is there. It's clear. Now coming to the change in the weight. Why it is being stressed here? Because when we suspect that the patient is having adrenal insufficiency, we suspect weight loss. When we suspect cortisol higher side, endogenous cortisol more, generally in a Cushing's disease patient, we suspect weight gain. So there was no change in the weight. So, but other important things they have noticed in their patient that it was intermittent and it occurred at least twice a month. So in endocrinology, when we talk about the hormones, we talk about the rhythms, how the hormones are related with the day and night, with the time, whether it is cyclical, how is the cyclical. So these things come in our mind. So this problem which the patient was suffering, it was intermittent and it occurs at least twice a month. And there was too much of myalgia and patient was unable to walk. Blood sugar was very also fluctuating. It was ranging from 54 to 360. Now coming to the medical history of that this patient is having hypertension, benign prostatic hyperplasia was there, and patient was regular in taking glimepiride, aspirin, amlodipine and tamsulosin. Now coming to the biochemical workup which they have done in this patient. So when we suspect any hormone deficiency, what we do stimulation test and measure that hormone. When we suspect any hormone excess, what we do suppression test and measure that hormone. That's the common basic principles of endocrinology, which I am telling you. So when they were suspecting adrenal insufficiency, they have done a short synectin test, or we do in our practice, that is syntropic we use, and we measure the serum cortisol. So they found that it's a normal short synectin test, normal pituitary function was there, and other hormones also, evaluation was also normal. But blood pressure was higher side, means hypertension was there, and even on the medication, the blood pressure was not well controlled. And there was a prominent, there is a pelvic girdle weakness is there, means proximal myopathy is there. And there are, but no other phenotypic features of Cushing's were present. So when we talk about the Cushing's, we know there are some discriminatory markers, discriminatory signs we say. Like most of you might be thinking that's obesity, round faces. These are not a discriminatory signs. So don't judge the diagnosis by that. So if you are getting easy bruisability, you are getting a stria, purple stria of length more than 1 centimeter. These are the discriminatory signs, not the round face. These are very non-specific things, and you can get it like obesity patient also, simple obesity, you can have the round faces. So in view of this proximal muscle weakness and increased pigmentation, this initial workup they have done, and they have found that 24-hour urinary free cortisol was high. So don't remember these values. I think this is not important point which I want to highlight here. This you understand that urinary free cortisol was measured and it was very high with the reference if we compare. Then they have done the overnight dexamethasone suppression test. A standard test we all do in our clinical practice. So we use 1 milligram of dexamethasone at 11 p.m. and measure the serum cortisol at 8 a.m. At some centers they are measuring serum cortisol at 9 a.m. also. So what they found that it was high, it was not suppressed. Means the value which I have put here as per the units which we use in our clinical practice. So less than 1.8, so that is a normal response. If it is not less than 1.8, so it is not suppressed. Then the further workup will start. The ACTH was also elevated. So this is also pointing that something is there, that means cortisol is not being suppressed, urinary free cortisol was there, means Cushing syndrome means we are getting endogenous Cushing syndrome picture is there. Now what they have done, that intermittent symptoms were there, so they started with the measurement of 24 urinary free cortisol repeatedly, multiple times they measured. But this type of things we don't do in clinical practice. Means this is like a institution where they have dedicated and resource is not a problem, but this is not in a clinical practice we start doing it. But they demonstrated that there were fluctuations of urinary free cortisol, sometimes high, sometimes normal. Then because there was a fluctuation in the cortisol value, then they started to think that let's see the salivary cortisol, the late night salivary cortisol. Let's measure the late night salivary cortisol and see how it is related with the symptoms. So they plotted a curve. So where you can see there are 3 peaks are there. I think in this slide, if you see here, this is the baseline normal value. So 3 peaks you are getting. And there are 2 down values you are getting. So this way they demonstrated that there is a cyclicity relation of the cortisol with the days, and there is a 3 peaks with 2 falls. So here the presentations we are going to learn about the cyclical Cushing's, the basics part, the definition, and different subheadings I will cover. So let's start with the basic thing first. So this is the HPA axis, how it is being regulated. So I think in a diurnal species, so in the paraventricular nucleus, they are releasing one hormone known as corticotropic releasing hormone, that is CRH. So what will happen? CRH will act on the pituitary gland. So what will happen? Pituitary will produce adrenocorticotropic hormone. This adrenocorticotropic hormones will will stimulate the adrenal gland to produce more cortisol. So when this cortisol is produced, so in our body we have a very beautiful mechanism of feedback. That is a very important concept. So this cortisol, which you can see in this slide, it is being inhibiting the adrenocorticotropic hormone at the pituitary level. It is inhibiting the periventricular nucleus at the hypothalamus level also. CRH is also being inhibited. So this feedback loop is being there in our body in a normal healthy person. One important point which I want to highlight, we all are diurnal species, means we awake in the daytime and sleep in the night time. In the morning time, if you see the cortisol value in a diurnal species, it's high. And as the time progresses, the cortisol value falls. That is also a normal physiology of cortisol production, and same for the ACTH also. This will be more prominent with this slide. In this slide, A is for, they have plotted the ACTH value and cortisol value on the y-axis, and x-axis is for the time. So if you see the time from 9 a.m. to next day 9 a.m. means 24 hours. So this dotted plots are for ACTH and the bold one is for cortisol. And the B slide is for the normal person and A is for a patient having Cushing's disease. So let's see the normal person first, the cortisol and ACTH. So you see there is a peak is there. At the 9 a.m., let me show you with this. At the 9 a.m., if you see here, ACTH is high. And same for the cortisol. And as the day progresses, if you see at 11 o'clock, means 24 is 0, means 12 in the night. So at 11 o'clock, cortisol is lowering. And same for the ACTH also. So this is a normal healthy condition, this way is going. But if you see a patient having Cushing's disease, see at 23, at 11 o'clock in the night, the dotted line is very high. And same for the cortisol also, means there is no, that diurnal cycle is not maintained of the cortisol. That variation is lost in Cushing's disease patients. So now coming to the definition of and criteria for cyclical Cushing syndrome. So this is a cyclical Cushing syndrome is known by different names. It may be known as intermittent Cushing syndrome or periodic Cushing syndrome. And as I told you, there are periods of hypercortisolemia, and then there will be periods of normal to hypocortisolemia. And we have to demonstrate 3 periods of hypercortisolemia and 2 periods of normocortisolemia. So this is an important thing. I think the important point which I want to highlight, just not on a single value we are labeling that this patient is having cyclical Cushing syndrome. So as already mentioned earlier with the case. Now coming to the prevalence. So if you talk about the Cushing's disease, so Cushing's disease is a very rare disease. It's not a common disease. If you talk about the prevalence, it's 1 case per million population. But if you are an endocrinologist, you face Cushing's disease patients multiple times, but might be possible as a physician, you might be missing, and then that case is being referred from somewhere else and getting to the specialist, and they are able to pick it up. So 1 per million to 0.1 case per million, the prevalence is there. And if you talk about the cyclical Cushing's, so this is very beautiful study done by done from the Greece, and they have published in European Journal of Endocrinology. So overall period of the cyclical Cushing's, they have found in their study was almost 14%. Now coming to the pathophysiology. So the pathophysiology, different proposed one there can be hypothalamic dysfunction, because from the hypothalamus that paraventricular nucleus is releasing CRH. Second problem may be because of some that tumor is there in the pituitary. Then the third can be that feedback is affected, the negative feedback. So what is the most common cause of Cushing syndrome? So most common cause of Cushing syndrome is endogenous Cushing syndrome is Cushing's disease. That's proved. And for what is the most common cause of cyclical Cushing syndrome? It is also Cushing's disease. So they have reviewed the cyclical Cushing syndrome, and I have presented this table from one of the paper. So they have found that Cushing's disease is the most common cause of cyclical Cushing. And ectopic, as I already mentioned you, it is associated with various carcinoids. Adrenal Cushing's contributed almost 11%. Now coming to the clinical features of the cyclical Cushing's. So one important point which I want to highlight here is the female sex. If you see, Cushing's disease is more common in the females, and cyclical Cushing's also is more common in female. So female preponderance is there. The other thing which I want to highlight is there that Cushing's features is present almost in 94%. Overall, if you see in the slide, almost 94% of the patients have the Cushing's features. So in our patient also, the patient have that features were present, which I probably presented from the BMJ case report. Now coming to the evaluation part, that's the interesting part. How you are going to evaluation, but it's very challenging also, because many of the tests which we read in a theory, we do not do in practical, because of the limitations of resources, because of limitations of some of the chemicals which are not available. So let's start with the first line test which we do. We can do overnight dexamethasone suppression test. The protocol is very clear, but there are other tests also which we do, like low dose dexamethasone suppression test, high dose dexamethasone suppression test. So these tests, depending upon the which test come positive, then subsequent test we are going to do. And there are cutoffs are there. There's a fixed protocol. There is the institutional protocols are also there, so which we follow. It's not a very straightforward and simple things that I want to sensitize that we have the fixed set protocol which we perform. So if that patient is coming where we have a high clinical suspicion of hypercortisolemia is there, so first and foremost thing is you have to exclude the exogenous Cushing's. So exogenous Cushing's you exclude from the history, and you can exclude from the serum cortisol. So what will happen, like if you measure the serum cortisol at the 8 a.m. in the morning, the fasting condition, in a normal person, in a patient having exogenous Cushing, what will happen to that person if we are measuring the serum cortisol? What will happen to the ACT test? That analogy you have to understand. So if we are performing the overnight dexamethasone suppression test in a person who is having endogenous Cushing, there will be non-suppressed serum cortisol. The serum cortisol will be higher side. The cutoff is more than 1.8 mcg per deciliter. So in a normal person, it will be suppressed. In a patient having Cushing syndrome, it will be unsuppressed. Then there are other tests also which we have to show to prove. So we can do urinary free cortisol or late salivary cortisol measurement also. So late salivary cortisol measurements, it's very technically difficult, but nowadays I think from All India Institute, from Department of Endocrinology, they have recently in March 2023 published a very beautiful article in Clinical Endocrinology where they have developed a normative data for the late night salivary cortisol also. Other tests like DEXA CRH test and other tests, this CRH is not available in India, so we are not performing it. Now, coming to the treatment part, how you are going to treat? First, you have to prove the diagnosis, then the treatment is, I will not say easy one, it's a complex one, but you are treating the cause in the same way we treat the Cushing syndrome patients. Means if a Cushing's disease is there, surgery is the mainstay of treatment, then there are some drugs which we also use for hypercortisolemia. So in conclusion, the cyclical Cushing's is a significant diagnostic problem, and we should consider this suspicion of this hypercortisolemia whenever we have suspicion and we are getting normal results, then you suspect that this patient can have this cyclical Cushing's. So then you reassess that patient whenever the symptoms are coming. So many times physicians are seeing patients who are having non-specific complaint, and you think that this patient is having functional, you are writing amitriptyline and everything, but you are not evaluating in accordance for like what can be the cause for that, and you are missing that case. And that case turn up. I'm not saying for all, but it can be missed it out. So the 24-hour urinary free cortisol, the late night salivary cortisol, and that can confirm the hypercortisolemia. Thank you.
Thank you for excellent deliberation. One or two questions, we are running short of time.
Yeah, I will ask you. Okay, this cyclical, as you mentioned, it may become normal or even hypo. So would you like to wait, or there would be certain cases here where you would like to treat? Yes. Are there any criteria to treat or not?
Yes, sir. Sir, the cycle length can vary, sir. Means it is not fixed, it varies from patient to patient. So what normal recommendation, as per the recommendations, when you are high suspicion of cyclical Cushing's and you are having normal cortisol or lower cortisol, then when the symptoms reappear, again measure the cortisol and then see the response. If it is coming, then we are going to make the diagnosis, and we have to prove that there are 3 peaks and 2 troughs. When we are able to prove that, then we will level at cyclical Cushing, then we are going to treat, not but just with one single value.
Thank you, sir. We go on to the next topic.
Thank you.
Shall be chaired by my coach.
Okay, so I would like to invite the next speaker, Dr. Samarjit Banik from West Bengal. So kindly deliver the talk, sir. The topic is cirrhosis and what is new. Welcome you, sir, to deliver the talk.
Good afternoon, respected chairpersons and seniors and friends. At the outset, I should express my sincere thanks and gratitude to the organizing committee, particularly Dr. Bhirmani and Dr. Anuji Maheshwari, and of course, Dr. Jayanta Panda for his kind invitation to get me this podium, and I also congratulate them for the excellent conference, this ACP Con. Now my topic is cirrhosis, what is new? There are lot of changes in recent years in the field of CLD and cirrhosis, and there are many different guidelines from different countries, and there are some joint consensus statements, which is popularly known as Baveno guidelines. And just I want to focus some highlights of the statements, because we all know that cirrhosis is a commonly practiced field of us, and we used to get cirrhosis patient day in and day out. Now my highlights of my presentations are diagnostic evaluation, changes regarding dietary sodium restriction, changes regarding portal hypertension and beta blocker controversy, spontaneous bacterial peritonitis, AKI, HRS, and there are some miscellaneous issues. So this was the one guideline which is called Baveno guideline, and there is another guideline, American guideline, and also there was one guideline recently published, Japanese guideline. These all guidelines have changed the scenario of management of cirrhosis. And we all know that hepatic decompensation starts with ascites, and what happens, actually development of ascites in otherwise stable CLD patient reduces the mortality to, actually reduces the 5-year survival up to 30%. And what happens that ascites brings up the hepatic encephalopathy and HRS, and which culminates into portal hypertension, GI bleed, and patient ultimately land up with repeated admissions with HRS and HRE, and the 6-month survival comes down to as low as 15 to 20%. So this is the first statement which says that hepatic venous portal gradient value more than 5 indicates sinusoidal portal hypertension, which remains unchanged as per the previous guideline. But they have mentioned that in patients with viral and alcohol-related cirrhosis, the HBPG measurement is a gold standard method, and clinically significant portal hypertension, that's the new term coined instead of portal hypertension, CSPH, which is defined as more than 10. This has been changed. That's at 5 to 10. This was the change. Now, what is the second change? Definition of CLD. The term compensated advanced chronic liver disease has been proposed to reflect the continuum of severe fibrosis and cirrhosis in patients with ongoing chronic liver disease. A paradigm definition of CLD based on liver stiffness measurement. And this is the change. The CLD has been defined as per the liver stiffness measurement, not as per the histologic criteria as was there. And irrespective of histological stage of ability to LSM to identify these stages. So these stages are irrespective of histology. We don't need to do biopsy again. And currently both terms CLD and compensated cirrhosis are acceptable but not interchangeable. So compensated cirrhosis is defined by the absence of presence of past complications of cirrhosis. Transition from compensated to decompensated cirrhosis leads to increased mortality risk. And events that define decompensation, we all know that, that is overt ascites or pleural effusion, overt hepatic encephalopathy and variceal bleed. And insufficient data are available regarding whether a minimal amount of hepatic encephalopathy, minimal amount of ascites or newly detected in imaging procedures, or very minimal hepatic encephalopathy or your subtle hepatic encephalopathy, and occult bleeding from portal hypertensive gastropathy, not from the variceal bleed, can be considered as decompensation. So minimal ascites is not decompensation. Bleeding from postal gastropathy or your say GAVE, gastric antral vascular ectasia, is not, can be defined as decompensation. This is the new change. So what is the criteria? They have defined as elastographic criteria, value of more than 10 as CLD. Values between 10 to 15 suggestive of CLD, more than 15 are highly suggestive of CLD. And less than 10 have negligible 3-year risk of decompensation. So a rule of 5 of LSM has been done, which is 10, 15, 20, 25. That 10 is mild CLD, 15 is moderate CLD, 20 is severe CLD, and 25 is end-stage liver disease. So this was the very simple clear-cut gradation done by the Baveno guideline in 2023. So how to diagnose? The concept of CSPH driven non-invasive tests that can also be employed. So we can diagnose by ultrasound, no need to catheterize every patient. So I am not going to detail this busy slide. This is their recommendation for initial evaluation, just to go around it. But ascitic fluid evaluation should be there in case of decompensated liver disease, and we should not forget to measure the amylase or lipase and other parameters, and your lactate dehydrogenase when a secondary bacterial peritonitis is suspected in case of CLD patient. There are some novel biomarkers as of now regarding the stage and the prognostication of CLD patients, and but the bottom of the story is, what is the bottom of the story? The most common and most easy to apply this is APRI, that is AS to platelet ratio, because we all do the CBC and your AST, LFT test, and only AST and platelet count. It was validated extensively in hepatitis C patients, particularly when the hepatitis C guidelines were formed long back in 2019. but it has recently evaluated also for NASH and it was found to be very effective, highly predictive for mortality in alcoholic cirrhosis. There are some other tests like King's score, combined King's score, which are all available online. Now there are some novel direct biomarkers, of which most commonly employed is serum hyaluronic acid. And I am not going to detail because my purpose is not to discuss on the biomarkers, but discuss on the changes of guidelines. So what are the recent changes on sodium restriction? Sodium intake should be less than 2 grams per day. We should not ask the patient to restrict the fluid. If the sodium level is less than 125, then only we can ask the patient to restrict fluid to the extent of 1 liter per day. Daily weight loss, yes, we all know that it should be 500 grams without edema. And there we can monitor whether patient is following the sodium restricted diet or not by simply doing a spot urine sodium potassium ratio. If the ratio is more than 1, patient should be losing weight. If less than 1, we should think of or we should consider dietary non-compliance on the part of the patient. So if the patient coming with first time ascites, we can start with aldosterone only as per the guideline. For long-standing cases or recurrent ascites, we can combine aldosterone plus loop diuretics. But the new statement is, after ascites is adequately controlled, attempts should be made to taper off diuretic to the lowest possible doses, and if possible, we can withdraw them. If the ascites is controlled, withdraw diuretic. They are not telling now that you continue with the diuretic. Now, there are some side effects of aldosterone therapy. You all know painful gynecomastia. We can switch to amiloride or eplerenone. The conversion rate is mentioned here. Muscle cramps were very commonly seen in patients with diuretic therapy, and we can use oral baclofen to start with 10 milligram per day. We can give IV albumin, or we can start with quinidine 400 milligram per day for 4 weeks for muscle cramps in CLD patients who are on high dose diuretic. But we should clearly contraindicated drugs are NSAID, ACE inhibitors, ARBs, aminoglycosides, and alpha adrenergic blockers in advanced CLD patients. This has been mentioned in guideline. Long-term albumin use, there was a hype regarding long-term albumin use that in 2018, 19, 20 during the COVID period, and the answer study was published, and it showed that 30% reduction of mortality was there. But afterwards, when in 2021, another study, match study was published, they have shown that there was, which is much bigger trial, no difference in death or complication, and now to date, for this present guideline, no recommendation for long-term albumin use. For refractory ascites, sodium restriction, fluid restriction, but no long-term albumin. And large volume paracentesis is the first line treatment for refractory ascites as of the present guideline. Albumin infusion should be there after the end of paracentesis, not with paracentesis. If the volume is more than 5 liter and the risk of post-paracentesis circulatory deficiency should be less with albumin infusion, and the rate of albumin is 6 to 8 gram per liter. That is, if you say take out 5 liter of acetic fluid, we should give 40 gram of albumin to that patient. Now, again, there was a controversy regarding the procedure of ascites if the platelet count or INR was high or low. So INR more than 1.5 and platelet less than 50,000 is not a contraindication for paracentesis now, and transfusion of clotting factor and platelets not recommended. This is clearly mentioned. And I am not going to detail the TIPS guidelines, but most patients with cirrhosis, ascites, hyponatremia are hypervolemic hyponatremia. Hypovolemic and euvolemic hyponatremia, although not rare, and mild hyponatremia, yes, sodium restriction, then fluid restriction, use of vasopressin analog or vasopressin receptor antagonist when they were coming to market. Initially, they are claimed to be highly hepatotoxic, but in recent publications, recent clinical experience, they can be used with caution only for a short period of days, less than 30 days. Use of hypertonic saline is reserved for short-term treatment for severe hyponatremia or those with immediate liver transplantation done. Why? Gliptins are effective in CLD, 3% NaCl in CLD except in very severe cases. Osmotic demyelination is more common in CLD due to underlying alcoholism, malnutrition, other metabolic rearrangements, low cholesterol level and prior history of encephalopathy. In these 5 situations, osmotic demyelination is more common and we should use 3% NaCl with caution. Now, hepatic hydrothorax occurs with CHPH, typically unilateral. Mortality risk exceeds that of male score. So, if a patient develops hepatic hydrothorax, mortality risk is very high. Now, coming to the SBP, more than 36% infections are spontaneous bacterial peritonitis, and more than 55% of them are community acquired. And patients with ascites due to cirrhosis admitted to hospital should undergo diagnostic abdominal paracentesis to rule out SBP, and the ascitic fluid should be cultured, and if the PMN count more than 250, SBP can be stamped. So what is the IV antibiotic should be immediately started? First line antibiotic is IV ceftriaxone, nowadays not cefotaxime, although they have mentioned broadly third generation cephalosporin, but in their statement they have preferred ceftriaxone over cefotaxime, and should be treated with IV albumin. For day 1 it is 1.5 gram per kg, and for day 2 and day 3 1 gram per kg it is recommended. And if we should suspect multi-drug resistant organism in patients with SBP with shock or recent hospital admission with recent antibiotic therapy, and recommendation for these patients are pipzode plus piperacin tazobactam plus vancomycin, or meropenem plus teicoplanin or vancomycin, and duration of should not be less than 5 days, if possible up to 7 days. So this is the recent recommendation for suspect MDRO. We should not prove it, but we can suspect it. Now, for secondary prophylaxis, norfloxacin, ciprofloxacin is still recommended. For upper GI bleed, we have to give IV ceftriaxone 1 gram per day for 7 days. But we should think of primary prophylaxis as per the present American guideline. Cirrhosis with low protein ascites, where renal dysfunction is present, or sodium level is low, or liver failure is there with bilirubin more than 3. In these 3 situations, when the low protein ascites is there, we can give primary prophylaxis with ciprofloxacin. Now coming to the AKI and HRS, and we know that development of AKI in cirrhosis entails a poor prognosis with a 30-day mortality of 45%, can reach to 45%, and there are recent changing terms, and the HRS own term has been changed into HRS AKI, and there are some criteria of diagnosis that HRS AKI. I am not going to detail or read out this slide because it might bore you, but we should remember the one thing: increase in serum creatinine as low as 0.3 milligram per deciliter from baseline is the defining criteria. So a small change in creatinine, you can define the patient as HRS AKI. And terlipressin is the drug of choice in combination with albumin. We all know that, and without 10-day survival was much better without RRT, and albumin was 1 gram per kg. Terlipressin, the concept has changed. Initially terlipressin was asked to give in bolus dose, but in the present guideline they have mentioned that continuous IV infusion over 24 hours. Starting dose is 2 milligram per day to be dissolved in 500 ml of NS to continue over 24 hours. Then we can increase the dose every 48 hours until the creatinine decreases, and the maximum dose is 12 milligram per day. There are some side effects, but what is the recent change which is more important to us, physicians like us who practice in the government setup? Because in government setup, terlipressin is not well available and patient cannot buy. Very simply, they have said that, they have mentioned clearly that norepinephrine should be given. It neither can be administered. A trial of oral midodrine in combination with octreotide can be given. So response to terlipressin or norepinephrine is defined as creatinine decreases to less than 1.5. And if in those patients where creatinine remains at above pretreatment level over 4 days with a maximum tolerated dose of norepinephrine, the therapy might be discontinued. So norepinephrine is a alternative to terlipressin, which we can use if terlipressin is not available along with albumin. Albumin should be given in both the cases. There are some non-etiological therapies are there. Use of statin should be encouraged in patients with cirrhosis. Approved indication for statin since these agents may decrease portal pressure, improve overall survival. Level of evidence is A1. Patients with Child-Pugh B and cirrhosis, statin should be used at a lower dose, and patients should be followed closely for muscle and liver toxicity. Use of aspirin should not be discouraged in patients with cirrhosis. Approved indication for aspirin since it may reduce the risk of hepatocellular carcinoma, liver-related complication and death. This is a new guideline. And rifaximin should be considered for prophylaxis for overt encephalopathy and is not indicated beyond this indication, including primary or secondary prophylaxis of SBP. So we use rifampicin right and left for prophylaxis of SBP, but they are this is not recommended now. Regarding beta blocker controversy, there was a hype that beta blocker has a window period of action in cirrhosis, but nowadays, in contrast to traditional MSBP, it has been recommended that carbidopa has intrinsic anti-alpha adrenergic vasodilatory effect, and it has been preferred MSBP in compensatory cirrhosis instead of in place of propranolol, because it is more effective in reducing HBPG, has a tendency towards greater benefit, towards better tolerance, and demonstrated to improve survival. So we should avoid beta blocker in some situations. When there are some miscellaneous issues, I am skipping this slide. And the update regarding the complications, laxative can be used. Some nutritional measures are there, of which zinc repletion is a new point of discussion. And also avoid to treat hypokalemia and hyponatremia. And regarding my last slide, this is not a part of cirrhosis, but this is the management guideline of non-alcoholic fatty liver disease as of 2023. Semaglutide, pioglitazone and vitamin E are the only recommendations, and they have clearly mentioned metformin, rCDoxycholic acid, DPP-4 inhibitors, statins and silymarin are well studied in NASH, should not be used as treatment for NASH. They have clearly mentioned, just to mention this point regarding this in the context of CLD. So my take-home message is over ascites, overt hepatocellular and variceal bleed can be considered for decompensation. Liver stiffness values by fibroscan more than 10 cutoff for CLD. Diuretics should be tapered of lowest possible doses as soon as possible. Long-term albumin use is not recommended. We should curtail our albumin use. Carbidopa is the preferred NSBP, not propranolol. We should try to switch over our patients from propranolol to carbidopa now onwards. FFP platelet transfusion is not indicated in case of acute variceal bleed. This has been clearly mentioned repeatedly in different guidelines. Neither monitoring of PT, APT, fibrinogen can have a predictive value, and NORAD can be used in place of terlipressin, but midodrine with octreotide have limited efficacy in HLS-AKI. Thank you, with greetings from Darjeeling.
Thank you, sir, for delivering the excellent talk. So it's time for any query from the house. Any one or two? Okay, so we conclude the session here. Thank you, sir. Thank you.
Thank you.
Yes, there is one.
Yes, ma'am. No, recent recommendation is for carbidopa, and there are 3 contraindications for beta blocker therapy. Patients with severe SBP, patients with shock with a systolic BP of less than 90, and there are another recommendation was patients who have previous beta blocker toxicity. It has side effects of beta blockers. So these three are clear-cut contraindications to beta blocker therapy. And once patient comes with acute GI bleed, a CLD patient, and probably patient might have some circulatory disturbances or shock, the beta blockers are for your prophylactic purpose. This is not curing that particular episode of variceal bleeding. We should remember, it is working to prevent the next episode of variceal bleeding. So we should be very cautious on starting beta blocker in those patients. One patient is stabilized, patient's EVL has been done, and then we can state beta blocker jolly if the BP permits. And the carbidiol is the recommended beta blocker since this guideline has been published.
Okay, thank you, sir. We conclude the session here.
I thank all the esteemed speakers, Dr. Samarjeet, Dr. S.N. Narsingham, Dr. Abhishek Pandey, and I request Dr. Srishendu to kindly felicitate our speakers, please. Sir, please. And Dr. Meghnath also, please, sir. Dr. Abhishek Pandey. May we have a round of applause, please?
Sir.
Dr. Samarjeet Banik. Thank you, sir, for your intriguing lecture. May I now request Dr. Niranjan Tripathi, sir, to felicitate our chairpersons, Dr. Srishendu and Dr. Meghnath. Sir, please. Next panel discussion, and it's titled Star Gap Study on Sleep Pattern in Diabetes. And may I request our panelists to join us on the panel for the panel discussion, Dr. Daria, Dr. Dhruvi Ansani, and Dr. Vipul Chawla. Please. We welcome all the panelists. And the chairpersons of the session would be Dr. Amitesh Chatterjee, Dr. Pranay Patro, and Dr. Rajiv Srivastava. We welcome you, sir.
So good afternoon, everyone. This is a panel discussion about sleep study in a diabetic population. And we had done a star cap study, and we will discuss about the star cap study and the impact of sleep and quality of sleep on the management of non-communicable disease, including diabetes. To give some introduction about the star cap study, it is a multicentric cross-sectional study to assess the awareness of risk factors and current behavior among type 2 diabetes patients in India. The PI is with us, Dr. S.S. Daria from Jaipur. The mentors were Dr. Anuj Maheshwari sir, Dr. Vijay Viswanathan sir, and Dr. A.K. Virmani sir. All the other investigators are also mentioned in the slide. So first of all, I would like to call upon Dr. Daria sir to give us some brief about the star cap study.
Thank you, Dr. Vipul. And at the outset, I would like to thank Dr. Anuj Maheshwari sir, Dr. Anil Virmani sir, and Dr. Jayant Pana sir for giving me the opportunity. This is first of kind study which we just completed in July, and this is the multicentric cross-sectional study to just see the awareness, risk factors, and current behavior among type 2 diabetic patients. So, acknowledgement, my scientific and knowledge partner is Medeva, and the funding supporter is the Netco Pharma. So the background of this study was that we all know that diabetes is a complex issue that involves multiple factors such as dietary habits and the physical activity, which can contribute to the development and management of the conditions. You see that there is a lot of extensive research has been done in the field of the prescription medicine type 2 diabetics and outcome about that, but the patient awareness and perception of risk factors, how they behave in relation to these factors, it was not done in India, and we did this first time. So why we choose this topic, as we all know that almost 101 million people are living with diabetes, and only 1/3 of them are being under treatment, which reaching the glycemic goals as per the ICMR INDIAB study. And despite of significant advance and availability of newer methods and line of therapy, we all know about the doctor side, but the real need to understand the patient side as well, as we did this study. So by finding this research, we can through the patient education program, we can improve the diabetic outcomes in terms of the treatment and in terms of the complications. So once again, thanks Netco for supporting this study to bring India-centric evidence. So the primary objective of our study was to assess the current awareness, perception of risk factors and behavior. And these awareness and behavior factors are related to either lifestyle, the diet, physical activity, the sleep habits, and compliance with the medication. And secondary outcome was to segment the patient population based on the awareness and practice, profile the patient group based on the demographic and other relevant criteria. We did through the ECRF, the electronic case report form, in the form questionnaire, and data was collected for assessing the awareness and attitude towards the type 2 diabetic management. And we started this from the April and finished on the 15th of July, this July only. And it was divided in two sections. Section 1 was the clinical information about the patient from the routine consultation from a doctor, and the section B, which was to be answered by the patient, related to the behavior, perception and attitude towards the various risk factors. We also take consent from each and every patient before enrolling them, and the inclusion criteria was to submit the information from the adult type 2 diabetic patients and who gave the consent. This was the CRF. You can see this the routine demographic profile, and here the risk factors. We achieved total 2752 samples, but after the data check, the 90% patient considered for the detailed analysis. This was a pan-India study including all three mentors, Dr. Anuj Maheshwari, Dr. Anil Virmani and Dr. Vijay Viswanathan. The other ones were Dr. Vipul Chavda, Dr. Dhurvi Asnani, Dr. Mohsin Aslam from Hyderabad, Dr. Arun Kedia from Raipur, Dr. Ashish Saxena from Punjab, Ludhiana, Dr. Murthy from Bangalore, Dr. Vijay Patni from Kolkata, Dr. Alok Modi from Mumbai, Dr. Ashutosh Chaturvedi from Jaipur, Dr. Arvinda Jagdisa from Bangalore, Dr. Ajay Tiwari from Lucknow, Dr. Anubha Srivastava from Lucknow, from Allahabad, Dr. Jayant Panda from Cuttack, Dr. N.K. Singh, Dr. Akash Singh, Dr. Anil Samaria, Dr. Dinesh Agarwal from the Guwahati, Dr. Rajni Saxena from Ajmer, Dr. Abhishek Kumar from the Jabalpur, Dr. Abhishek from Patna, Dr. Ashish Dengra, Dr. Bharat Sabu, Dr. G.D. Ramchandani, Dr. N. Kannan Natarajan from the Chennai. So you can say that this was the pan-India study. So we tried to include from each and every region. So now what we are going to be answered by this study and what will be the profile sample. So overall, what is the knowledge patient having regarding the diabetes, and how does this awareness differ by the age, gender, duration of diabetes with or without complications, or the HbA1c level. And the last answer was to the prevalence of device usage and app-based program. Is there any difference regarding the knowledge levels? So this is the profile patient will take by the Dr. Vipul Chawda.
So it was a study about knowledge, attitude and behavior. So patient profile we took was age, gender, BMI, blood pressure, type 2 diabetes in terms of duration and medications, complications of type 2 diabetes and associated comorbidities, as well as glycemic parameters of the patient. Talking about profile, the age and gender, the population less than 50 years of age were 35%, between 50 to 60 years were 34.1%, and more than 60 years was 30.9%. The average age was 54.1 year. About gender discrimination, 60% patients were male and 40% patients were female. Talking about BMI and blood pressure, the 2.2% patient were having BMI less than 18.5, while obese or whose BMI was more than 30 were 19.5%. Talking about blood pressure, again the patients were divided according to the blood pressure, whether they are having optimal blood pressure, high normal, grade 1 hypertension or grade 2 hypertension. The average BMI of the patient was 27 kilogram per meter square, and about 43.9% of the patient reported elevated blood pressure during the visit in the clinic. Talking about duration and current medication of the diabetes, we can say 38% of the patient had a duration more than 5 years, less than 5 years, 42% has a duration 5 to 10 years, and 20% of the patient has a diabetic duration more than 10 years. Talking about current medication, more than 79.6% patients were taking metformin, 44% patients were taking sulfonylurea, 40% of the patients taking DPP-4 inhibitor, 27.6% were taking SGLT2 inhibitor, and semaglutide were taken by 5.2%. 15.9% patients were on insulin and 3% patients were on other insulin. The patient's average duration of diabetes among this STAR-CAP study was 7.2 years, and the majority of the sample is on metformin therapy, that is around 79.6%. Talking about diabetic complication, the neuropathy was most prevalent, it was 38.6%. Diabetic foot were present in 21.3%, it's a big number. Retinopathy in 20%, nephropathy in 16%, coronary heart disease in 8.8%, that is a low as compared to what we think in normal diabetic population, and 40% of the patients do not have any diabetic related complication. Talking about known comorbidities, yes, hypertension is a companion of diabetes, so 59.2% of patients were having hypertension, 29.8 had dyslipidemia, 11.9 was having obesity. Again, this number is not matching what we are learned, that obesity is associated with more than 60% of the patient of type 2 diabetes. In this study, only 11.9% were patient had obesity. Talking about hypothyroidism, 11.2% of patients, CKD 9.3%, hyperthyroid in 2%, and other were 2.8%. 59% of the patients have reported any diabetic complication, and the most commonly reported was diabetic neuropathy, and the most commonly reported comorbidity is hypertension, that is 59.2%. The glycemic parameter, the HbA1c, the average HbA1c was 8.2%. The fasting glucose of all the population was 140 148 and postprandial blood sugar was 215. The average A1C was 8.2 and that was a fairly control as compared to the data that shows India have more than 8.5 HbA1c in general population. So what were the findings we found in this STAR CAP study? So again I would like to invite Dr. Daria sir to highlight the finding of this STAR CAP study.
Thank you again, Dr. Vipul. So, come to the finding part. What we find in this study. So, the knowledge level. All questions related about the diabetes symptoms and complications were aggregated and created composite score. As we know that in a routine examination also, if somebody takes a more than 80%, then he is a good score. And if it's between 40 to 80, then it's a below normal. And low score is less than 40. So the composite score of our study, that was a more than 20, was high, medium was 11 to 20, and the low composite score was 10. So this was the knowledge composite score creation, mainly about the 8 questions where the diabetes in major cause, these are the lifestyle modification, the blood pressure, the uncontrolled, all 26 parameters, each have a correct answer gets a 1 weightage to create the composite score. So this was the total 8 questions. So now come to the knowledge level composite score. So my question to the audience, so what do you think? How many of the normal population of Indian diabetic patients, then they know about the knowledge of diabetes? So what it should be? Anyone? So in our study, we find that the 27% of the patient possess a high knowledge regarding the diabetes risk factors, and while approximately 26% are having the very low knowledge. So it's almost that between 27% are having the good knowledge or the high knowledge, and 26% are don't know about the diabetes. So this is a significant difference in level of knowledge. So we can see if somebody can be given the education program to the diabetes, then we can create the awareness among them and the outcome of diabetes will be better. So in terms of the level of knowledge, there is no significant difference in the duration of the diabetes in our study. If duration, if it is less than 5, if it is a more than 5 to 10 or the more than 10 years, then there was no significant difference was found in our study regarding the duration of the diabetes. And if somebody is having the good knowledge of HbA1c or a poor knowledge of HbA1c, there was also no significant difference found in our study. Here you can see the all diabetic patient whom HbA1c is less than 7%, 7 to 8 or 8 to 9, the knowledge of diabetes was high, almost 30%, medium 44 to the almost same in all 7 to 8, 8 to 9 or more than 9%. Now what do you think? If higher knowledge patients with any complication comorbidity? Anybody? So the answer comes to again the higher knowledge among patient with any complications or comorbidity. Here you can see that more patient with complications, more complication have a higher knowledge. Likewise, patient with other non-comorbidities also possesses significantly higher knowledge compared to those without any other comorbidity. So the higher level is, it may not be the lead indicator, but rather outcome of development of complications. What do you think? The younger population or the older population know better than about the diabetes, or what is the answer in the in terms of age? So in our study we find that this significantly higher knowledge was among the younger age population, and it was more in the male patients also. You can see that the age, if it is less than 50%, then 33% patients having the higher knowledge about the diabetes, while the older patients having the only 20.6%. So a larger, and the same here in the male-female ratio, the females exhibit the low knowledge compared to the males, where the significantly higher proportion of males possess the high knowledge compared to the female 23.7. So the summary of this part of our study that the current quality of knowledge level relatively poor, which was only 27%, and more alarming that 26% have a very poor knowledge about the diabetes. In terms of duration of diabetes and the A1C level, seems there is no impact on the lower level of knowledge, and younger patients have higher knowledge with the age. Women have much higher percentage, 32% versus 22%, and men with a poor knowledge. So males are better in understanding the diabetes. So we can hypothesize that once a patient has complication, comorbidities, they would feel a higher desire to learn more and stay informed. So now come to the second part regarding the earlier was the knowledge and now this is the behavior. So let's see the findings. So what do you think that how many patients consult a doctor in a month or twice or thrice? Any guess from the audience? How many patients used to come frequent, the frequency of consulting to the doctor? So in our study, we find that 71% of the patient consult with the treating physician at least every 3 months. And here you can see that monthly patients go to the consulting physician only 11.5%. So every month only 11% patients are going to the physician. And once in 4 to 6 months, almost 17% patient, they don't used to go regularly to take opinion from their consulting physician. So next is the frequency of consultation is higher with higher levels of knowledge. Yes, of course. If patient knows more about the complication, more about the knowledge, then he will definitely used to go to see their treating physician. The non-compliance about the drugs. We know that we are treating each daily in and out, that how many patients comes to us that they are non-compliance of their drugs. So in our study we find that 25% they self-reported that they are non-compliant in regularity of taking their medication. And I think 25% is a big number. So when we ask, do you miss taking the dose of your diabetic medication, the overall says that 74.8%, and among them it was a high knowledge, it was more in patients who have the higher knowledge. And missing the dose of within last 7 days, the average number of patients taking the drug was 6.2. And in our the composite score regarding the knowledge, we can see that the patients are taking at least 5.6 days in a week. So this is the on an average patient in some form of activity. So if we ask each and every patient, so what you are doing regarding the exercise, and they answer that the walking is the most popular activity, and a patient in our study only 3.8 days he walks in a week. So the aerobic exercise was only 2.6 and resistance and weight training was 1.9%. Then the next question we ask about the meals per day. How many meals they are taking? So here you can say that in our study, average 3 meals per day with 87% having the breakfast regularly. So average meal was 2.8 meals per day and 87% are having their breakfast regularly. This is the appetite, how they classify their appetite, and here we can say that almost 80% patients are says that sir, our appetite is okay, it's good. And among the diet type, whether they are a vegetarian, non-vegetarian or mixed, so here you can see the majority patients are the pure vegetarian, and it was around 47.1%. So next is there any difference in diet by knowledge level? If somebody knows more of somebody having the more knowledge about the diabetes, so there is no significant difference was found in our study. The 81% had a diet counseling in last 1 year, and about 90% have they educated about the complication of uncontrolled diabetes. So in last year, whether this was from the doctor, this was from the dietitian or the other staff, 80% had the diet counseling in the last 1 year. And whom they received this diet counseling? The doctor was the 40%. And here you can see that 3% family members and friend, and dietitian was the 41%. So it was almost same with dietitian and the doctors, and they advise about the counseling. Here the educated about the complications. So here you can see the patient answered that almost 50% says that yes, sometimes back they have been educated about the uncontrolled diabetes complications. This is the diet counseling. Here you can see that 80% patient who was having the good knowledge and they have a positive association with the diet counseling. So somebody is having the knowledge, definitely will take a good diet, or he will take a advice from the dietitian or a doctor. So doctor was 40% and dietitian was the 41%. The education. 51% patient with the high knowledge have been educated recently about the complications, and only 2% whose knowledge was good and they did not educated by anyone in the recently. The last is the sleep. So for sleep, I would like to call Dr. Dhruvi Asnan.
Thank you so much, Darya sir. And we are all in a post-lunch session. We are quite a handful of people here. Before I go to the questions, and our panelists are here to answer those questions, how many of us sleep for, say, 6 to 8 hours with just a raise of hands? 1, 2, 3, 4, 5, nice. So, our scriptures, our evidence-based medicine, and a lot of research says that it's not just the quantity of sleep that matters, it's the quality of sleep also. And as physicians, as diabetos, as endos, as super specialists, we tend to ignore or let's say, tend to miss to ask our patients with diabetes about daytime sleepiness, about snoring, and most of the people come back to us and say, I don't think I snore, whereas in fact that's not true. There is something known as a stop questionnaire, wherein you just ask them about their sleepiness, their tiredness, their exhaustion, their snoring, and their sleeping patterns. Just a 4 questions questionnaire. And that was what was incorporated also. So I'll bring a couple of questions to our panelists and our chairperson sitting here. What is the normal sleep pattern? Just, to make it all interactive. Darya sir, would you like to take it up?
Yeah. The normal sleep pattern in a population, we can see that people are taking at least 7 to 8 hours daily sleep. And the sleep is, we know that it's divided into REM sleep and non-REM sleep.
Yes.
And they are, it depends on the both pattern of that.
Yes. But sir, with the advent of social media, a lot of us sleep with our phones together. A lot of us would scroll through social media before we sleep at night. There have been studies which are showing that teenagers are having a lack of sleep because they are most of the time on social media till the wee hours of the morning. They get up again because they have schools and because the parents push them to go to the schools. And that is also hampering their performance at the school time. So I am going to, with a couple of next few slides, I just wanted to wake you all up so that you listen to me. So I'll just go through the next couple of slides. Diabetes and sleep disorders have been proven to have a cognitive impairment when the sleep patterns have been disturbed. For somebody with uncontrolled diabetes, and it is a vicious cycle, for somebody with uncontrolled diabetes, that sleep disorders are going to lead to recurrent hypoxemia, sleep fragmentation, and sleep deprivation, again leading to the cognitive impairment. Reversibly, somebody with vasculopathy, somebody with neuropathy, somebody with even non-vascular CNS damage will also have all of these sleep fragmentation and sleep disorders. What should we do for all of these disorders that we are observing in our people with diabetes? So there are sleep interventions which we need to ask our patients about. So ask them about the sleep duration, Ask them about the efficiency or what sort of a satisfaction they have. Do they feel fresh after a good night's sleep in the morning? Do they feel exhausted after that? What is the time duration of their sleep? What is the alertness that they have in the morning after the sleep? Some people also get up with jerks in the middle of the night. Some people also get up with the sense that, I'm having a hypoglycemic panic attack. And people with diabetes, or say even parents with kids who have diabetes, have bad sleep quality. All of these in turn are going to lead to some or the other complications of diabetes. The number one being hypoglycemia. Behavioral factors and self-care again is impacted, and the knowledge, aptitude, and the behavior of all the people that we studied in the STAR-CAP study is based on all of these factors, specifically for sleep. There are a lot of psychological factors, again, which are going to be impacted because of a bad quality of sleep. Physiological factors, of course, the glycemic parameters, the metabolic parameters, and a lot of hormonal disbalance amongst males as well as females. We had an excellent hypogonadism, hypogonadotropic hypogonadism lecture by Dr. Meenal ma'am in the morning. And those hormonal disturbances are also impacted by a poor quality of sleep. If you read the statistics which are there on the screen right now, 72% of the people with type 2 diabetes have obstructive sleep apnea. Now this is such a big number. And a lot of them may not even know or may not even be aware that they have something known as an obstructive sleep apnea. Even physicians do not regularly tend to ask questions about sleep. A simple question, do you sleep well, or do you think you sleep well? Do you think you are exhausted throughout the day? 86% of the obese people with diabetes have obstructive sleep apnea. That's an even bigger number, which means that when obesity and diabetes are together in the same person, it has a lot more obstructive sleep apnea. So if you look at the third, last point, 30% of the people presenting to a sleep clinic have impaired glucose tolerance, irrespective of their age or diabetes, and out of which 40% are undiagnosed. This is what is more concernful. Coming back to sleep apnea and the glucose intolerance, we again talk about sleep fragmentation, and we again talk about the intermittent hypoxemia that is happening, and it is impacting or it is influencing the sympathetic activation, increase in the catecholamine levels. It is affecting the hypothalamus pituitary axis alteration, increasing the cortisol levels. It is also increasing the oxidative stress, increasing the inflammatory, activating the inflammatory pathways, and increasing all of the inflammatory processes of the body, increasing the leptin, increasing leptinemia. There is hyperleptinemia in the body, which leads to increase in the obesity, again, increase in the insulin resistance thereby, and leading ultimately to glucose intolerance and type 2 diabetes. So now there is a very exact sort of an association between diabetes comorbidities and sleep disorders. So I know it is there on the slides as well. Would any one of you with a raise of hand want to say which are the most often diabetic complications that you have seen along with sleep disorders? Anyone? Just a simple. It's there on the slides. So there is depression, there is anxiety. A shortened sleep span also will lead to the loss of cognitive processing. A lot of people go dull. They do not want to. They have reduced concentration, energies. Even during the meeting, when the boss is talking, a lot of people with type 2 diabetes and sleep disorders are not able to comprehend the information well. Again, it's a vicious cycle. So something that started with sleep disorders will also lead to glucose intolerance, and something that starts with the glucose intolerance is also going to lead to a lot of sleep disorders, because all of this is leading to hyperleptinemia, hyperinsulinemia in the body, leading to insulin resistance, obesity, and the vicious cycle continues if we do not break them up. So I go back for the statistics. Okay. So about 29% of the patients in our study were not satisfied with their sleep. If you ask me, even I'm not satisfied with my sleep, which I had last night, because again, change of place, all of us traveling, anxiety of the next day's panel discussion. So 29% of the people who we took in the STAR-CAP study were also not satisfied. 35% of them had trouble falling asleep. I think the term trouble falling asleep is also very relative for a lot of us. For somebody, it might be, one peg of alcohol and you sleep well. For somebody, it might be something else. For somebody, it might be, let me just scroll through a couple of Instagram reels and I'll be able to sleep. For somebody, it is, let me complete this chapter of the book and then I'll be asleep. But that never happens up to the time. And if you see the numbers over here, I usually go to sleep around the same time. It is less than 50% of the people, which is again something that we have to tell our people living with type 2 diabetes also, that you have to sleep on time for your body to understand and regulate your metabolism. So something known as chronomedicine also is linking our sleep and our biological parameters and our metabolic dysfunction in the body. If you are not sleeping at the correct time or synchronizing yourself with the chronobiology, your metabolic parameters are going to be hampered. Around 38% only said that I am satisfied with my sleep. So more than 33, then there was 22, and there was 6.5, which said I'm rarely satisfied with my sleep. So again, it's a big concern that we all need to address. I have difficulty falling asleep. So there are more than 17%. Then again, 17% who said, I often have difficulty falling asleep. I always have difficulty falling asleep. And there are 31 only who say, rarely I have trouble falling asleep. It's such a boon, when somebody comes and tells you, मैं सर लगाता हूँ तकिए पे and I sleep. You feel so jealous of that person coming to you and saying that, and you say, आपको तो आशीर्वाद है कि आप सो सकते हो. So sleeping is really something that is going to help your body rejuvenate and refresh in the morning. And only 42% say that I feel refreshed after sleep. Look at the last bar over here, and 42% only saying that I feel refreshed after the sleep means there are 60% of the population in our study saying that they do not feel refreshed even after a good sleep of say 6 to 8 hours. Another statistics, no significant differences in the sleep behavior by the knowledge level as well. Darya sir and Vipul sir and I, we were just talking the other day on how to take up the panel with the Midiva team, and we heard that सबसे ज़्यादा जिसको knowledge होता है, that person is troubled the most. So even your knowledge and your aptitude levels were not affecting your behavior, because a person with a lot of knowledge is going to be thinking a lot, and it is not having any significant impact on your sleep pattern. So even if you had a good knowledge about your diabetes, if you had a bad knowledge about your diabetes, your sleep patterns, irrespective of that, were hampered because of your glycemic status or because of other parameters, and not relating it to the knowledge of diabetes that you have. Yes, last few slides. Again, technology, the findings of our study were saying that overall 40% of our patients have behavior impact of self-monitoring of blood glucose. So that was the sleep part. They took the demographic part and so took the findings part. I'm just going to touch a little bit upon the technology part that our people with type 2 diabetes in the StarCap study did. So 40% of them had some SMBG knowledge. They undertook that knowledge and they were implementing and executing it. 22% amongst the patients did not have a good knowledge of the risk factors or did not have a good knowledge about how they could execute this technology into their day-to-day life. 3.7% of the type 2 patients in this study used app. All of us are using smartphones in this room. Is there anybody with those older phones? Nobody, right? But in spite of that, only 3.7% of the people in our study, it's very rare to find somebody using the older phones now. Even our auto driver or even our maid uses a smartphone. And in spite of that, only 3.7% of our type 2 patients were using an application for the diabetes management or logging into the application provided by other healthcare professionals. So again, a very small number. With that, I'm going to give it back to our panelists for further questions.
So India, we are having a high number of type 2 diabetic patient. We are known as a diabetic capital. We want to be known as a diabetic care capital. And we all know in any non-communicable or chronic disease, the main thing would be lifestyle changes. So in this study, we assess the knowledge, attitude, and what are the behaviors that are there in the patient. And we found that knowledge level is not more than 40% in any age group, whether the duration of diabetes is less than 5 years or more than 15 years, whether there is comorbidity or not, whether there is a associated complication or not, whether A1C is less than 8 or A1C is more than 10, the patients are not properly educated. So if we improve this education level, we can thereby, in a positive attitude can be reinforced in the patient, and thereby we can achieve a behavioral level that can be beneficial for the prevention of all the non-communicable disease, including diabetes.
Yeah, absolutely, Dr. Vipul. The main motive of the study was the same, that if we can induce the education program to the patient, then we can achieve the glycemic control through them. Because if patient improve their knowledge, behavior and attitude regarding the disease, it may be a diabetes, it may be a hypertension or any other disease. So reinforcing the education programs, we can improve the outcomes. And in terms of that outcomes, only the not the diabetes control, but we can stop the complications also by giving education to them.
All right. From this study, actually, we have seen that India is not sleeping well. And in fact, it has quantified with the statistical values. And it must be brought forward before every clinician that diabetes is not due to only other problems, but sleeping properly does have a major role. Sleep deprivation not only causes new onset diabetes, but at the same time, if a diabetes patient is not sleeping properly, then the control of the overall glycemic status will be very much difficult to attain. And also the diabetes-related complication, be it microvascular or macrovascular, it is thoroughly related with the sleep pattern, sleep deprivation and all that. So again, coming back to the main motto that awareness amongst the patient as well as the clinician is mandatory, and it should be done in every podium, in every sphere of our clinical gathering. Yes.
Yeah, at our center also we empower the triple S in all the patients, that stress, sleep and sexual dysfunction. If the quality of sleep is not well, and even in the India, when the more than 60% of the patients are obese and they are not actually accepting that they are obese, at that time sleep apnea and inappropriate sleep increases the arrhythmias, increases the glucose intolerance, increases the hypertension, including pulmonary hypertension, and they also can be a cause of a sudden cardiac death in the individual. So sleep pattern is very, very important. Stress management is very, very important, and sexual dysfunction, again, it is a very neglected in a non-communicable disease doctor's OPD, that we must talk about that and do some improvement about that. So with the respect to the time, I would request Dr. Dhruvi to conclude if there is no question from the audience.
So thank you, everyone. It was wonderful interacting with everybody present here. In the end, like our panelists said, the triple S, stress, sleep and sexual functioning, all of that is of utmost importance. Let us take that as a take-home message back home and, educate ourselves as well as our patients. With that, thank you so much for your patient hearing. And thank you to our organizers and the whole ACP Council for having this important topic as a panel discussion today. Thank you.
I think all the panelists have done justice to this particular topic, and we are pretty much enlightened with this. Thank you very much.
Thank you.
May I now request Dr. Amitesh Chatterjee to kindly felicitate our panelists. Dr. S.S. Daria. Dr. Dhruvi. Dr. Vipul. I now request Dr. Mohanty to kindly felicitate Dr. Amitesh Chatterjee. Thank you so much, sir. Now the next session is about the special invited lecture by Dr. Shishindu Pal. I now request, invite the chairperson, Dr. Sandeep Rai and Dr. Gohar to come on the stage for chairing the session, please. Dr. Sandeep Rai and Dr. Gohar. Dr. Chatterjee, could you please share the session for us? Sir, please. Because, sir, I invite you for chairing the session, please. Yes. Dr. Mohanty. And also, Dr. Jyoti would be chairing the session with us. Thank you.
So very good afternoon to all of you. After post-lunch, I think everybody feeling sleepy. But I met Dr. Shishindu Pal in the morning during the poster presentation session. He is a very gentle man and he did wonderful job during the session. So I'm happy here to see him presenting a talk on diagnosis, evaluation and management. So I request you, sir, please come on the dais and give your talk.
A very good afternoon to all of you. So starting after lunch, a very important topic, disseminated intravascular coagulation. At the outset, I would like to thank the organizers for selecting this topic, especially Professor Anuj Maheshwari, Professor Panda and Dr. Virmani sir, because I feel this topic should be given due importance as it has a very high mortality. DIC, depending on the word DIC, please remember DIC, if you had not seen, if you had missed it, even in a chronic DIC, you may not have the time to rectify your mistake. So, my presentation today, DIC, disseminated intravascular coagulation, diagnosis, evaluation, and management. We all know DIC is characterized by systemic activation of blood coagulation, which results in generation and deposition of fibrin, leading to microvascular thrombi in various organs and contributing to multi-organ dysfunction, very often leading to multi-organ failure and death. Consumption of clotting factors and platelets in DIC can result in life-threatening hemorrhages, and derangement of fibrinolytic system further contributes to intravascular clot formation. But in some cases, accelerated fibrinolysis may cause severe bleeding. Hence, a patient in DIC can present with simultaneously occurring thrombosis and bleeding diathesis, and that's why it is very difficult to treat. You have to see the both sides of the coin. You have to use your judgment. You have to examine the patient, balance the pros and cons, and go ahead. The subcommittee on DIC of the International Society on Thrombosis and Hemostasis has suggested the following definition for DIC. and acquired syndrome characterized by intravascular activation of coagulation with loss of localization arising from different causes. It can originate from and cause damage to the microvasculature, and which, if sufficiently severe, can produce organ dysfunction. So, coming to the epidemiology, it may be present in 1% of hospitalized patients, carries a very high mortality from 31 to 86%. That's a wide range. It is a complication or an effect of progression of other disease. Please remember, it always starts from an underlying disorder. DIC is always secondary to an underlying disorder associated with the number of clinical conditions generally involving activation of systemic inflammation. Now, differentiating between acute versus chronic DIC. In acute disseminated intravascular coagulation, there is sudden exposure of blood to procoagulants, mainly the tissue factor or tissue thromboplastin, generating intravascular thrombosis. In chronic DIC, which reflects a compensated state that develops when blood is continuously or intermittently exposed to small amounts of procoagulants, these features may not be present. The thrombosis you may not notice. In acute DIC, compensatory hemostatic mechanisms are quickly overwhelmed due to huge production of thrombin, and as a consequence, severe consumptive coagulopathy leading to hemorrhage develops. But in chronic DIC, compensatory mechanisms in liver and bone marrow are not overwhelmed, and there may be little obvious clinical or laboratory indications of presence of DIC. Abnormalities of blood coagulation parameters are readily identified in acute DIC because it's a fulminant process and organ failure ensues. In chronic DIC, frequently observed in patients with solid tumors and those with large aortic aneurysms, you may miss the diagnosis. Now, coming to the basic pathophysiology, it all starts with activation of the monocytes. And how are the monocytes activated? In an inflammation, say in severe sepsis, the cytokines are released. These activate the monocytes, which in turn activates the tissue factor. And this tissue factor in the coagulation cascade leads to huge thrombin generation. And that's the crux of the matter. This excess thrombin causes platelet activation, consumption of natural coagulation inhibitors, leading to a hypercoagulable state, forming thrombus. Inhibition of fibrolysis or fibrin formation goes on side by side. There is deposition of fibrin in the vasculature and lead to medullary organ dysfunction. Finally, the peculiarity of thrombin is that as it leads to increased formation of fibrin, it also leads simultaneously starts the fibrinolytic process as the coagulation factors have been consumed, and all these can lead to hemorrhage. So this is the abnormality, and this is the risk which you have to manage as a clinician. Coming back to normal hemostasis, we all know there is formation of blood clot at the site of vessel, followed by resolution of clot to allow tissue repair. And there are multiple feedbacks built into the system to prevent activation of this coagulation cascade. But in DIC, these processes of coagulation and fibrolysis are hampered, normal processes are hampered. There may be increased thrombosis, increased fibrinolysis, both going on side by side and leading to multiple thrombus formation or fibrinolysis. Now coming to the etiology, causes of acute DIC, most commonly we have sepsis that caused by infections, maybe bacterial, the gram-negative sepsis most common, may also be gram-positive infections or even rickettsy. The viral infections include the HIV, cytomegalovirus, the varicella zoster virus. Fungal infections includes the histoplasma or even malarial infections such as the cerebral malaria or the malignant malaria we used to say before. Hematologic conditions include the hematologic malignancies, the acute myelocytic leukemia, or metastatic ones such as the mucin secreting adenocarcinoma. Obstetric causes are very common. It includes amniotic fluid embolism, abruptio placentae, acute peripartum hemorrhage, preeclampsia, eclampsia, or even the HELP syndrome. Trauma may be in the form of burns or motor vehicle accidents or even snake envenomation. Transfusion reactions may be a cause for DIC, and others, of course, include the liver failure, use of prosthetic devices, or even shunts, the Denver or the Levin shunts, or the ventricular assist devices. Now, coming to the causes of chronic DIC, most common causes are the tumors, the solid tumors or leukemia. Obstetric causes include the dreaded retained dead fetus syndrome, retained products of conceptions. Hematologic conditions are the myeloproliferative syndromes. Myocardial infarction may cause a DIC, or even the inflammatory gut disorders as ulcerative colitis or Crohn's disease. Sarcoidosis in the lungs may also cause a DIC. Localized DIC causes include the aortic aneurysms, giant hemangiomas, or even we find it in acute renal graft rejections. Epidemiology, as I said, it occurs in 30 to 50% of patients with sepsis, and it develops in almost 1% of hospitalized patients. It occurs at all ages, all races, and with no sex predisposition. Prognosis of patients with DIC depends on the severity of the coagulopathy and on underlying condition. Please don't miss this. Underlying condition is very important, which is leading to the DIC. Don't miss it. Assigning numerical figures to DIC-specific morbidity and mortality is useless. The following are the examples of mortality. Idiopathic pulmonary fulminance associated DIC carries the mortality of 18%. Secondary abortion, especially from clostridial infection and shock associated with severe DIC, has a mortality up to 50%. And in setting of major trauma, presence of DIC doubles the mortality rate. Now coming to the physical examination, in acute DIC, physical findings are usually those of the underlying condition. Please remember, we all know this, but don't miss it. Particularly, we all very often miss if it's present in the legs, in the thighs, when the patient is wearing pants. It may be on the trunk, it may be on the extremities. Also, there may be ecchymosis. In chronic or subacute DIC, primary manifestation is thrombosis in different organs may present as a deep venous thrombosis. Secondary signs include signs of spontaneous and life-threatening hemorrhage, signs of subacute bleeding, signs of diffuse or localized thrombosis, and bleeding into serious cavities. CNS signs are non-specific altered consciousness of stupor, there may be transient focal neurologic deficits. Severe signs are the hypotension, very important for prognosis, tachycardia, circulatory collapse. Respiratory signs include the pleural friction rub. Signs of acute respiratory distress syndrome may be there. GI signs are hematemesis and hematochezia. On physical examination for genitourinary signs, there may be acidosis, hematuria, oliguria, metrorrhagia, uterine hemorrhage. Sometimes there may even be renal failure or azotemia. Now coming to the dermatologic signs, which are found in almost all patients. It includes, as I said, petechiae, jaundice, purpurea, hemorrhagic bullae, acral cyanosis, skin necrosis of lower limbs, localized infarction, and gangrene. Wound bleeding and deep subcutaneous hematoma may be there, or there may be thrombosis in different organs. Now coming to the lab results. The main markers are first the platelet count. It is reduced in 98% of the patient. Please remember, patients have high FDBs or elevated D-dimer levels, and the D-dimer is more specific for DIC, and the second comes the FDB. There also may be microangiopathic hemolytic anemia. Why this? Because the fibrin may cause breakdown of RBC. That's causing the microangiopathic hemolytic anemia. Most individual laboratory tests demonstrate high sensitivity for DIC, but very few are specific. Whereas the acute DIC typically overwhelms the compensatory anticoagulation mechanism, resulting in depletion of factors and laboratory derangements. Chronic DIC may be more subtle. Please remember this. The laboratory tests, even all may be normal in a case of chronic DIC, but please don't miss the diagnosis. You have to be strong clinically. It is essential to keep in mind that laboratory values may represent only a momentary glimpse into a very rapid changing systemic process, and that repeated tests may therefore be necessary in order to make a more clinically certain diagnosis. Because if you miss the diagnosis, probably you'll miss the patient. Other labs tests include, in clinical practice, we know diagnosis of DIC can often be made by a combination of these tests, as I just said before. Platelet count, the clotting times, mainly the prothrombin time, a reflection of the reduced coagulation factors, mainly 2, 5, or 8, or even 7. The APTT activated partial thromboplastin time, 1 or 2 clotting factors, usually not estimated, but you can do in sophisticated institution. Assay for D-dimers or FTBs are now available. Now coming to a comparison of the acute and chronic DIC, the coagulation parameters. Platelet count reduced in acute DIC, maybe normal in chronic DIC. Prothrombin time prolonged in acute DIC, but normal in chronic DIC. Activated partial thromboplastin time is prolonged in acute DIC, but may be normal in chronic DIC. Thrombin time prolonged in acute DIC, in chronic DIC, may be prolonged, may be normal. Plasma fibrinogen drops in acute DIC, but may be normal or elevated. Why elevated? Because maybe the underlying disease process, especially in inflammation, the fibrinogen level rises, and in the DIC process, it reduces. So it's a combination of the two, whether the disease process is more fulminant or the DIC is more fulminant, and depending on that, the plasma fibrinogen level will be there. Plasma factor 5 reduced along with plasma factor 8 in acute DIC and normal in both chronic DIC, both cases. The FTP and D-dimers are obviously elevated in both acute and chronic DIC, and don't forget these tests. Now coming to the scoring systems. Nowadays, to simplify our clinics, probably, and more scientific data has come out on the basis of which we have scoring systems. This is the International Society on Thrombosis and Hemostasis score, and it shows the 4 parameters. One is platelet count, the level of fibrin markers, prolonged prothrombin time, and the fibrinogen level. Platelet count less than 50,000 carries a score of 2. Fibrin markers are mainly the D-dimer. If strong increase carries a score of 3. Prothrombin time less than 3 seconds, no mark, but if it's prolonged more than 6 seconds compared to the control, it's 2. And fibrinogen level more than 1, the score is 0, but if it's less than 1, it's 1. And if the total score is more than or equal to 5, it indicates overt DIC. But a score less than 5 does not exclude DIC. That's the catch. The DIC may be there, but it may not be overt. You may have to do other tests. You may have to take the help of other scores. Because of these fallacy of the International Association, the Japanese Association has brought out a different score which actually differentiates between the fulminant acute DIC and the borderline cases of DIC. And this is the score table. You can see it's quite simple, but it's very effective. Search criteria more than 3 carries a score of 1. Platelet count between less than 80,000 or 50% decrease within the previous 24 hours carries a score of 3. And if the platelet count is more than 1,20,000, the score is 0. P time more than 1.2 carries a score of 1. Fibrin more than 25 carries a score of 3. you can see the importance given to fibrin degradation products. If it's between 10 and 25, it's 1. If it's less than 10, it's 0. And the total points, if 4 or more, confirms a case of DIC. Now coming to histologic findings, very common, all of you know, gross hemorrhage into tissues, different organs, brain, adrenal, lung, kidney. Histologic studies in patients with DIC shows presence of ischemia and necrosis due to fibrin deposition in small and medium-sized vessels of various organs. Presence of intravascular thrombi appears to be clearly and specifically related to clinical dysfunction of organ. Specific thrombotic complications that are sometimes seen in the framework of DIC, and that's why this clinic is so important. Don't miss acral cyanosis, don't miss hemorrhagic skin infarctions, don't miss limb ischemia. A limb ischemia patient may present just with pain of the limb. Touch the limb, it will feel cold. Do the limb elevation test, and you can easily diagnose limb ischemia. Please don't miss these. Coming to the management, obviously, always treat the underlying cause first. That's most important. If your diagnosis is established, you'll win the game. Next, coming to supportive treatment, please remember most of the cases present with a bleeding diathesis. So first, in most cases, you have to manage the bleeding rather than the thrombosis. If the platelet count is low in a case of bleeding manifestation, you give platelets, preferably if the platelet is less than 20,000 or even less than 10,000. You may give FFP or factor concentrate if the coagulation factors are low, or if the prothrombin time is increased, or the activated partial thromboplastic time is increased. Fibrinogen, very difficult to assess sometimes, but if the levels are low, suggestive consumptive coagulopathy, you have to go for the cryoprecipitate. If there is vitamin K deficiency, give vitamin K, but try to avoid tranexamic acid because it may lead to fibrin problems. Minor or no bleeding, you give low molecular weight as prophylaxis, but if the platelets are down, be cautious. You may have to give the platelet concentrate if the total platelet count is less than 20,000. But if a patient is totally asymptomatic, that is, you have you have laboratory parameters of DIC, but no such much clinical features, you just start a low molecular weight prophylaxis. If there is thromboembolism, you give LMWH prophylaxis for microthrombi. For overt venous thromboembolism, therapeutic low molecular heparin dose may be given, and you can choose the low molecular heparin depending on the age, because you know, for example, dalteparin works better in very elderly, say a patient 80 years old, it's perhaps better to give a dalteparin rather than enoxaparin. For overt arterial events, antiplatelet treatment if minor or no bleeding. Optional treatments include the antithrombic concentrate. So, to conclude, please remember diagnosis and management of DIC are complex and challenging. Key is to address the underlying disorder, and despite optimal treatment, DIC carries a very high mortality rate. And since DIC affects many organ systems, most survivors have a prolonged recovery period, and please brief this to the patient party and the relatives. Thank you all for patient listening.
Thank you, Dr. Sirsendo. So you talked the time, finish in exact time.
Thank you.
Now coming, any questions from the house? Before they start, you say the prognosis is very bad in DIC. This is the underlying cause and then DIC.
Yes, sir.
The underlying cause usually sepsis in the acute DIC. So how do you know it is due to the acute condition the prognosis is bad, or the DIC is added to that? This
Sir,
is one.
actually, when the DIC starts, the vitals rapidly deteriorate. That will give you the clue. in the ICU, even if the patient is a case of sepsis, when, as long as the DIC is not there, the vitals do not drop all simultaneously. But when DIC sets in, all the vitals may drop simultaneously. That will give the cutoff actually, whether it's due to the disease itself or it's due to the DIC.
Second thing, a lot of people keep on asking bleeding time, clotting time in several hospitals.
Yeah.
In your hospital, do you carry it on? BT, CT? Surgeons is special, as a routine.
So BT is not much required nowadays. Clotting time still you can do. It's actually easy to be done, that's why. But nowadays, it's actually being replaced by the prothrombin and the APTTs. Much more.
We don't do any BTCT as such.
Now
It is surgeons or anesthetists, but they
Yes.
keep on asking.
Yeah.
Ever it is abnormal. Another SIRS in sepsis, systemic inflammatory response
Yes.
syndrome. That term has been almost taken out in diagnosis of sepsis.
Yeah.
So what is your opinion?
Yeah. Yes, sir, very true. Actually, what is happening in systemic inflammatory response syndrome, that term had come from the sepsis guidelines actually. And as the guidelines are going on, the time is going shortened, Initially it was 2 days, then it came to 24 hours, then it came to 6 hours, then it came to 3 hours, now they are telling it's 1 hour. So if you go for a systemic inflammatory respiratory syndrome, that cannot stand actually. That's why it has been modified actually.
Any questions from the audience?
Very well presented, sir. Just one question from my side. As most of the residents working in the ICU, so they, most of the patients are on anticoagulants, so patients start bleeding. So after how many days suspect DIC, and what are the essential biomarkers to be done for the diagnosis in a one line?
In bleeding,
Yeah.
the most specific marker is D-dimer. The most specific marker is D-dimer. It will give you the clue whether it's a DIC or not. But of course, please remember, you have to assess clinically. That's very important. Because nowadays we try to avoid giving platelets. Actually, in future days, we may not be giving platelets at all. Because it's mainly a consumptive coagulopathy, but it's mainly because of the coagulation factors. Platelet reduction is actually secondary. It gradually picks up. You have to assess clinically, but the main marker, the chief marker, and the most specific marker is the D-dimer.
If there are no questions, will agree. Dr. Sissendu covered the acute DIC so well. Of course, the chronic DIC, depending upon the condition, those are mostly malignancies. So, thank you so much. And
Thanks.
the next speaker is Dr. A.K. Azad Khan. He's here. Please come. He is going to speak on prevention of diabetes and other non-communicable diseases through faith-based leaders. This topic is not a very usual topic. I think we'll do justice to this faith-based leaders.
Well,
you can start, sir.
By the time they set up the slide, please allow me to thank the organizers for the kind invitation, especially on his master. Right, press here. Well, let's say that please convey my gratitude to the owners for the kind invitation and also warm hospitality. The topic I am talking may not be appealing to the audience, but
welcome to India, sir.
Well, I'm glad that there's small numbers, so that means they are truly interested. You see, diabetes has been identified as world epidemic, first by IDEA, then subsequently by World Health, but then subsequently by United Nations. And I dare say the United Nations identification was started by a letter from me I requested Bangladesh government to raise this to the United Nations, and then in 2006 it was unanimously passed by this. But here I want to request you to go through the resolution. You see, resolution is not a simple piece of paper. It has requested all governments and all bodies linked to United Nations to take up national policy for prevention. But the pandemic is mainly due to type 2 diabetes, as you know, which is largely preventable. That's the point of talk. I will go quickly through it. It just shows that how prevention is also this, because I want to leave enough time for interaction. You see, for prevention, you have to know the reason for it. And diabetes is a combination of hereditary factors and environmental factors. And you see, hereditary factors, for practical purpose, we cannot change. Although in reality, if you think mathematically, it can be changed. But anyhow, the hereditary factors you can compare like growing a tree. Now you have the coconut. If you clean it, put on the shelf, it won't produce the tree. It has to be planted. So that is the environment, you see. And then you see why hereditary factors we can modify, but we will never be able to change. You see, I'm just showing an example. In the same jungle, the deer and the leopard lives. A leopard has the take-up speed of 90 miles and go up to 120 miles. But deer can take-up speed would not be more than 15 miles, can't go more than 40 miles. So theoretically, leopard should be able to catch all the deers, but it can't, because there is one factor is called endurance. The leopard can run like that only for 5 minutes, and deer can run like that for at least half an hour. So this diabetic gene in a minute dose may give an survival advantage. That's it. Gene will never be eliminated out. You see, when you are hunter-gatherer, it mattered how long we could continue. And then a little bit of diabetic gene without being diabetic might give an advantage. So anyhow, the normal people, you see, what people inherit? You see, it was shown in early 50s by Rolf Luft and his group that people really inherit insulin secreting capacity. So if people have got low insulin secreting capacity, they will normally overcome it by producing more insulin. But then if people cannot produce more insulin, then they will become diabetic. You see, that's the thing. So natural history is that it is gradually progress and it's virtually, you see, lifelong disease. Once you are diabetic for the rest of your life. Although in recent years, people are trying to modify this statement that if you can revert it completely, then you might become completely without medicine normal. You see, but whether you have really become normal is another matter. You see. Okay, we are still susceptible to diabetes than a normal person. Although all factors for prevention are not known, but it is now definitely known that lifestyle is the modification, is the important factor. And we have done many studies all over the world that this can be modified by different ways. I shall not go through it. You see, I shall just go quickly through it. And prevention is highly cost effective. See, lifestyle, metformin, chemo prevention, lifestyle for this, these are all this. And as I said, the national policy for prevention, you see, this site has been made for local population, so it's in Bengali, but you can see that that's the one that we have submitted to the government, that government should adopt this policy, so Bangladesh. I thought for Bangladesh, because we are the sponsor in the United Nations, so it's more duty that they must adopt it first. But I have not still been able to get it adopted. And you see, it's now still lying in the parliament. You see, because here you will have to understand one factor. You see, it's not easy to get it done by the government. With the government, let's say in Bangladesh, it's controlled by business people. Yes, for them, it's important to make money by selling fast foods. You see, by selling cigarettes. So it's not an easy task, you see, to get done. So anyhow, in Bangladesh Diabetic Association, we have taken many policies, you see, even to the extent we have produced a full-length movie released in the cinema hall with the message of diabetes prevention. I got the idea from a movie which some of you might have seen, One Flew Over the Cuckoo's Nest. I don't know whether any of you have seen it. One of the, well, anyhow, like absent-minded professor, you see, whenever the professor is anxious, that he lights up a cigarette. This connection, this cigarette company is established, you see, for the sale. So, but anyhow, this we did, and we used folk songs, we used dances in the places where we. So many programs, but I'll come to the one that I want to show particularly. See, we have done survey in workplaces and see, and then our idea was to identify people who are normal, identify people who are pre-diabetic, so they can be advised. You see, these are policies. See, yeah, I'll just go through it quickly. So, in fact, we are diabetic of Bangladesh, which is the largest diabetic in the world. And we provide care ourselves. It's not like other diabetics. We have got more than 300 hospitals. We own a university. We own 3 medical colleges. So it's a countrywide network, you see. So we thought community mobilization would be an important. In our place, we tried to do community mobilization for improving maternal and neonatal mortality. It's a multi-country study, including Mumbai, Jharkhand, Burkina Faso, Bangladesh, Nepal. And that showed community by participatory cycle, it can produce big effect. So we did that for diabetes, and this showed big reductions, very big reduction. And we tried mobile messaging. And that sort of mobile messaging, we found that it has created awareness and knowledge, but did not reflect on the outcome. So maybe that we have to give more messages, you see. So you can see this PLA reduced it by 60%. So highly cost effective, you see. So now the question, so you can conclude that to be able to choose the right language and the right medium is very important. So now I am coming to a different point. So who amongst you does not know that smoking is harmful? So not only it is harmful, but also I believe many of you must have taken a puff sometime in your life. I mean, I'm not a smoker, but must have tried once in a while. Why I'm saying that?
The second-hand smoke.
Yeah. Why I'm saying that? Because to start with, it's very unpleasant. But still, think of the cigarette companies. They're still able to recruit new smokers. So can you think how good they are? I mean, to me, all cigarette companies are enemy of the human race. This is simply they have sold their soul to money. But how efficient they are. See? So you can see that they have used so many means. Here, some of you, the people who are slightly older, they will recognize this character, Uttam Kumar, you see, the most popular hero ever produced in this part of the world, you see. And whenever in the cinema you find smoking, you see, smoking. This did not happen. See, the cigarette company suddenly introduced it. And here you can see vegan smoking, advertisement, you see. So that gave me an idea whether we can use religious leaders, you see, who have influence in the society to use this. So I'm showing two groups that we have done. Number one is, in Bangladesh, or also in India, all marriages must be registered. Cohabiting is not something accepted as a whole by the society. In Bangladesh, it's not at all accepted, will not be accepted at all. So all marriages have to be registered. So we thought at the time of marriage, if the message is given to the couple, that God has given enough knowledge to plan your pregnancy. So before you contemplate pregnancy, check the lady for 6 things. You see, and we open many preconception desks because we have got set up throughout the country. And we ask them that she's underweight, correct her weight, overweight, correct her weight, correct anything like that. You see. And we were able to persuade the government to, because these marriage registers are from the Ministry of Law. I think in West Bengal, at least in the Ministry of Bangladesh Ministry of Law. So, and the slogan was, all pregnancies should be planned, and this preconception project, see. And so these Qazis, we trained them, and in fact, this project that we did, we are now doing the impact study. But apparently, it showed it has made a very big effect, but we are able to persuade the government. These are the Qazis who are being trained. You see, I'll just go through it. And then we have made it completely self-sustained project, because they go to the preconception clinic and pay 600 taka. 600 taka would be like 500 rupees, you see. And for that, all the tests will be done, and they will be given all the advices. And here people, even poor people in this part of the world, they are prepared to spend money to get a healthy baby. In this part of the world, babies are all wanted. So we played that psychology. So these are the steps. As I said, I'll go quickly so that you can have enough time to question, you see. And these baseline surveys, I can go, some of it has been published. So I'll just go through it. So through this, you see, the data shows that we found that DDM was of 26.4% in our place, you see. And the one I want to show is, you see, we were able to persuade the government that all marriages, I mean Muslim marriages, I've said, Muslim marriage is not like Sanatan Hindu marriage or like Christian marriage. The Muslims don't take a vow that we make partner for the rest of our life. This vow is not taken. The Muslim marriage is like exactly like a business contract, if you know it, you see. Absolutely. So this is called Kabir. This contract is called Kabir. And government has passed a decree that this Kabir has to carry a seal. The preconception advice has been received. Yeah. So why I'm saying that? Because you can see that if you persuade, even government can be persuaded. This project was financed by World Diabetes Foundation. They attended attended one of the meetings. And in fact, it was selected as a UN high-level meeting for this. So that's the preconception guidebook. And the slogan is, all pregnancies should be planned. That's the slogan. I'll go through. The next thing that I'm coming is that through Imam, you see, the Muslims go to the prayer, and on Friday the Imam gives a sermon. So we are using that sermon for spreading the message. And then I'll go quickly. And so we have talked to the temples, the churches, and also Buddhists. They all have agreed to do it. I'll just go through it. So these are just showing the pictures. So that project has also become self-sustaining, this project. In fact, the government printed 1 crore those sermons. Quoting religious texts, we got it authenticated by the Grand Mufti of Kaaba and also Al-Azhar University Fatwa, and that has been distributed. We distributed this all YC countries. YC countries. So And the project is completely self-sustaining now. I will leave. So other temples you see that we are including, and some of these have been published. Somewhere I will not go through it. So now the impact study that we are doing is now being financed by the government now, because these pilot studies have been financed by WDF. So my conclusion is prevention of diabetes is feasible, but you have to know the right language and the right medium. And in fact, you see the people who are involved with prevention, we medical community, have not done any research. What will really motivate you is the tobacco companies have done. Thank you.
Thank you, sir. This is a very unusual talk, and he has been practicing in his own country and giving a strong message. Any comments or questions?
In fact, Bangladesh and India share many a common thing, and the total rural structure you have put out in your discussion. The basic intervention, how to convince the rural population and to some extent semi-urban region also, matches same with India. Now, you see, diabetes is a lifestyle disease, as we all know, and here the major player is the awareness, the knowledge, the education of our population as a whole, and diabetes patient in particular. So the effort you have done and initiated in Bangladesh, I think we also should imitate to incorporate this kind of intervention in our society. Thank you very much for putting this. Yeah. Okay. Right.
Devashit Basu, he helped me to make the contract. In fact, the West Bengal Assembly Speaker was there when I talked to them. They have agreed that they will try to do it. But what I am saying, that to be religious is also a good advantage, because religious leaders, through them, you can disseminate the message at a very, very low cost. Very, very low cost. So why not use it? Now, but the point I want to emphasize that physicians is we have not thought fundamentally that we need to do research work. What will affect it? What will be the language that we use? The tobacco companies not. Now, can you imagine? There's such a thing which is totally harmful. There's nothing good in it. And they're still able to recruit people for smoking.
They have the banking system, which is used for Nobel Prize. And your talk is very eye-opener for India, which can be prevented. So Bangladesh is the brain of India now.
Well, yeah. If you allow me just some more second. You see, Bangladesh, Bihar, Orissa was once a one. And we did not divide it. I don't think you also divided. But
politicians divided.
The division was first organized by a foreign.
Yes.
So, very excellent deliberation, sir. The greatest part of it, if you go through religious leaders, first, people are convinced very easily, one, and next, people come to a doctor when they're in trouble, but they go to the mosque or their place of worship maybe weekly. So, if you can talk to the imams, if you can talk to the qazis, there is reinforcement. They can tell it every week. Yes, yes, of course. So there is reinforcement. That's the best part of it. And next, conviction. A patient is very easy to convince if he has faith in you. And the religious leaders in your country, in our countries also, they are faith healers. And they control our minds. And people will be convinced far easily. In fact, I would say Bangladesh had one step before us. Even a few years back, they have abolished the caste system also. And it was also taken up like that only. You all are great innovators. Great, great. It's a great step forward. I feel we should have emulated. Huh? Yeah.
Sir, we'll come to the topic proper. We'll come to the topic proper. I have a question. What is the prevalence of diabetes before this practice and after this practice?
Yeah.
Prevalence of diabetes in Bangladesh before this and after.
Well, I have showed in the PLA, it was reduced by 60% by PLA, participated learning science. But in the religious leaders, apparently seems to be a big reduction. But we haven't done real scientific study, which is being done now. In fact, the government is financing our study.
Maybe because of the shortage of time, we didn't cover up the other non-communicable diseases. That must have been also.
Yes, yes. Hypertension is included in it. Just one, I'll just make one remark to his role. How many times did you read to remember ABCD? Remember in childhood? It must have been at least 100 times. So don't expect people to be influenced by saying it only once. It has to be said repeatedly. Thank you.
Thank you, chairpersons, and thank you, speakers. I would like to request Dr. Ambika Mansar to felicitate our speaker, Dr. A.K. Ajad Khan. Sir, could you estimate, sir? Sir, to get your memento, sir. Token of appreciation from Dr. Ambika Mansar, sir. I request Dr. Jyoti Baspe to felicitate our chairperson, Dr. Ambika Ma. So moving on to our next session for this topic is a state-of-the-art lecture. I would like to request Professor Dr. Namita Mahanti Madam, Dr. Bhagyasri Panna Madam, and Dr. Hare Krishna Naik sir to come to the dais to chair the sessions.
Now I request Dr. Abhishek Arun, speaker of this session, to come to the dais to give his lecture. He is a consultant physician and diabetologist. He will be speaking on in-flight emergencies. Let us listen from him.
Thank you, ACP, for inviting me to this conference. And of course, I would like to thank the organizers and Dr. Anuj for giving me this very unique topic. and yet very important one. Why? Because this is something which is not commonly discussed in the majority of the conferences. So I'll be talking about in a while about in-flight emergencies. So what are in-flight emergencies? We all know that they are unique events which while traveling, physician, nurses and other healthcare professionals might render medical assistance to. And what happens when a person is cruising at 35,000 feet with limited medical equipment, often hours away from the closest medical facility? It creates an unfamiliar care challenge for many healthcare professionals. Unfortunately, there's no internationally agreed upon recording and classification system for such emergencies. Whereas if you talk about the prevalence of it, it estimates between 24 to 130 emergency per 1 million passengers annually. So let us closely touch upon some of the important pathophysiologies which are really contributing some of the major in-flight emergencies once the commercial aircraft or the other aircrafts have been cruising at an altitude of around 30,000, 40,000 feet, and the passenger cabins are pressurized to very high level of pressures at around 12 psi to 11 psi, which is equivalent to being an altitude of around 5,000 to 8,000 feet. So what happens is this pressurization leads to expansion of the closed gas containing spaces in the body, which is there in the sinuses and the middle ear, and the non-physiological gas connection can happen in the form of pneumothorax, other GI problems, ocular problems, and even intracranial injuries. So at 8,000 feet of altitude or equivalent, the volume of gas in an enclosed space increases almost to a tune of 30%. And what happens, it causes discomfort to the patients, especially leading to upper respiratory problems, infections, sinusitis, and otitis media in certain cases. Now, the aircraft cabin has got a lower pressure, oxygen at altitude, which resulting in mild hypoxia in healthy passengers. And this effect can be more pronounced if the patient is already having a pre-existing pulmonary condition. Prolonged sitting and hypoxia may also trigger decreased venous flow and systemic inflammation and platelet activation, which explains the association between air travel and venous thromboembolism, but it usually happens short interval. Cabin air drawn from outside dry environmental at altitude and pressurized and dehumidified oxygen by cycling through an engine compartment, it leads to dehydration as well amongst the passengers. Recycling of the air may also expose these passengers to certain harmful allergens. And the enclosed and the limited environment of the aircraft raises also a concern of transmission of certain communicable disease, which are highly infected. So let us touch upon some of the basics of the in-flight emergency. So almost 65 to 75% of the in-flight medical emergencies are managed by the cabin crew itself without any assistance of healthcare professionals, and they are actually professionally trained for that. The crew members are trained to give individual airline operating protocols, including the CPRs and the use of emergency and life-saving equipment like automated external defibrillators, which are usually carried on board on basically all flights. However, physicians assist around 46 to 48% of in-flight medical emergency on request. Other skilled medical professional help can also be sought, which includes nurses and emergency medical services personnel as well. Now, what exactly happened in an emergency? In in-flight medical emergency, there is an approach for the voluntary medical professional. Now, it can happen with any of a doctor who's traveling in a flight and he or she happens to coincidentally have an in-flight emergency. So first of all, you have to identify yourself as a doctor, and of course, state your qualification to the airline personnel. And then if you have to address with the patient, you have to take a brief history in a very short while, and this may require an interpreter sometime because of language problem from the family members or any nearby passenger you can always take. You have to also identify the high-risk symptoms in such patients. Of course, if the time permits, you can also go on obtaining the vital signs and do a mini physical examination if it is possible. Inform the cable crew about your impression, what you have gone through in that particular patient and the recommendation what you are going to have.
then you have to do a basic first aid to the patient. So the airline may require consultation before the emergency medical kit is already there, and aircraft diversion can be done based on the severity of the medical condition. And you also need to administer supplemental oxygen or can use an external automated defibrillator in certain cases, depending on the severity of that medical condition, of course. So what onboard medical equipment do we have once you are traveling in flight? We usually don't have any knowledge about that. Usually why? Because we never used it. Now the Federal Aviation Administration is having a mandatory emergency medical equipment kit along with certain medications which needs to be carried on board along with major flights. These are having it as a plates, alcohol sponges, cardiopulmonary resuscitation masks, IV lines, needles, oropharyngeal airways, protective non-permeable gloves, sphygmomanometers, stethoscopes, syringes, tape scissors, and tourniquet, along with certain medications which are important like antihistaminic tablet, injections, aspirin, atropine, bronchodilator, dextrose, epinephrine, lidocaine, nitroglycerin, of course, and narcotin analgesic tablets, and of course saline solution in certain cases. This is an expanded emergency medical equipment list to tell you. There's a huge list, but not all the aircraft travels with a very extensive medical aids and the drugs which have been mentioned over here. So this is just a picture of the first aid kits. How do they look like? So there are various conditions that might cause a problem during the flight, including pregnancy, newborn babies, patient already having middle ear infection, psychiatric illness, recent myocardial infarction, recent history of any chest, intracranial, abdominal surgery, the recent history of pneumothorax, moderate to severe hypoxic pulmonary diseases, presence of any communicable disease, and previous record of certain disruption during any air travel as well. So how do you go on managing in-flight medical emergencies? We'll talk about some of the very important ones, the common ones over here, the syncope, GI respiratory cardiovascular stroke-like symptoms, and seizures. So the commonest one, like syncope, it accounts for almost 30% of the in-flight emergency. You need to really elicit the cause behind that. Is it a vasovagal attack, a cardiac cause, the pulmonary cause? Is it stroke, or is it because of hypoglycemia for which the patient has landed in this particular condition? Now, once you've evaluated the cause, you can go on treating the patient. If the patient is lying flat, if the patient is unconscious, lying flat, elevating the legs, applying oxygen. So usually address to some of those syncope attacks. If it's a transient support supine position, elevating the legs will usually helps the patients to return to the normal state within a while. If the patient is having hypoglycemia, of course, the oral glucose or the dextrose or intravenous supplemental dextrose needs to be given if needed. Other severe condition now. Any severe conditions which cannot be managed on board, you need to really get back to the crew, and you can also give instructions for diverting the flights for seeking ground-based medical support. The cardiovascular complications account for around 7%, and they can be very, very tough to handle, including myocardial infarction and other cardiovascular history patients. You can have a 12-lead ECG if those facilities are available on board. They can be there with some of the big flights, whereas with smaller domestic flights, they are not usually available. Suspected acute coronary syndrome, arrhythmias, dyspepsias needs to be ruled out, and then appropriate action needs to be taken based on the nature of the problem. GI illnesses, these are very common ones. Around 15% of the medical emergency, you again have to identify the cause of nausea, vomiting, diarrhea, bleeding, and abdominal pain, and based on that you have to treat them either with antacid, antiemetics, and so on, and antidiarrheal in certain cases. Or all those refractory cases not responding to these classical agents which you have limited on board, you can of course give the instruction to the ground staff and divert as the flight, as I've already told you. Stroke-like symptoms, again, for severe form of strokes, again you have to give a first aid. You have to stabilize the patient, administer oxygen unless the saturations are known. And then once the patient has been resuscitated, you again have to give recommendation for diversion. to the nearest health facilities. Respiratory distress. Now, this is a very important thing because you have to identify the history of respiratory disease, with the patient having extreme swelling, infectious symptoms, and based on that, you have to give the oxygen on board. If the patient is having bronchospasm, administering albuterol, allergic reaction, refer to the allergic card and give an antihistaminic. And if the patient is having seizures, those patients they can be given and treated with benzodiazepines initially. Sometimes hypoxia can also trigger seizures in certain cases. So addressing to the cause of hypoxia is very, very important. And in those refractory cases where the seizures are not resolving, you again have to get back to the ground staff for diversion. So other cases like trauma, allergic reactions can also be there, which can be dealt based on the nature of the injury. Of course, you have to give the first aid. With all those measures which you have, the allergic conditions, you have basic medications with you on board. You have to treat that. And then, of course, if the patient is having a severe form of anaphylaxis, you have to even give epinephrine in certain cases. And if the patient is still not normal, you have to divert the flight. Obstructive emergencies, psychiatric conditions are the other ones, wherein you have very problematic situations where you can only use benzodiazepines in certain psychiatric symptoms on board. For rest of those violent patients, you have to restrain the passenger or divert the aircraft based on that patient conditions. Obstructive emergencies, you again have to see the history of that lady who's traveling in pregnancy. You have to look for their vaginal bleeding, if there's a suspected labor, and then you have to also give the proper counseling and active management as per the condition of the patient, whatever sources limited are available on board. And substance abuse and cardiac arrest, they are emergency situations. Of course, those patients who are having history of alcohol intake and then they are traveling, they can also be treated in that way. They have a problem of altered sensorium, or weird kind of behavior. So we have to see exactly the cause behind that. If suspected alcohol dose is there, observing the patient, and certain antiemetic therapy can be given. And if there's a history of opioid injection, naloxone, which is usually available on board, can be given intravenously or intramuscularly, even intranasally can be given. So cardiac arrest. So of course you have to restrain, maintain the airway, and definitely do the CPR or use the AED, what is available on board. And you can always take the help of the crew for doing that. And once you have restrained the patient, if needed, you have to obtain an intravenous line and also start the fluid as well. And you can have all those emergency drugs in the form of atropine and adrenaline, which is there on board for doing a cardiac arrest and managing such kind of emergency. So apart from this management, what we have discussed, they are very confusing differential diagnosis of in-flight common medical conditions, which is there happening on board. So they look alike sometimes because they have overlapping symptoms, but there needs to be a differential diagnosis because the cause can be different. Syncope or near syncope can be because of vasovagal attack, dehydration, hypoglycemia, arrhythmia, pulmonary embolism, and hypoxia. Chest pain similarly can be because of acute coronary syndrome, pulmonary thrombosis, air embolism, pneumothorax, bronchospasm, aortic dissection, and GARD as well. Shortness of breath can be related to a pulmonary cause. And stroke-like symptoms can be because of transient ischemic attack, can be due to an electrolyte imbalance, can be due to even hypoglycemia. And seizures, you have to again manage the cause of the seizures, syncopal attack, hypoglycemia, eclampsia, cardiac arrest. There can be an obstetric emergency in the form of preterm labor, miscarriage, ectopic pregnancy. There can be allergic reactions, which can range from very mild ones to very severe form of anaphylactic reactions. And we have to also look for the psychiatric illnesses and history of the substance abuse. Now, the question which arises once you have managed these emergency, on-board emergency, how you proceed ahead with it. Now, prevention is the most important aspect once we talk about addressing to in-flight emergency. So the risk of syncope increases with the hydration, and in the setting of low humidity environment, pressure changes and exhaustion, especially during the long flights. So travelers should hydrate often and eat scheduled meals and snacks during travel, especially with the connecting of the extended flight. That is very, very important because a lot of us are also traveling on for very long duration, and we get tired, and we have a lot of other problems ranging from mild jet lags to severe form of respiratory or any other problems. The physician and nurses assist the flight travel plans for the patients with chronic medical condition, should consider and educate the patients on the effect of altitude, need of routine medication, and potential occurrence of the medical emergency which might happen because of any underlying medical condition. Passengers who are at the risk of symptomatic hypoxia need to have a portable oxygen concentrator once they are on board, because anything might happen with those kind of person who are at high risk of developing such kind of illnesses. And parents traveling with children should be also, the medication should be brought in pediatric formulation. Why? Because this is something which is very important, because these medications are not commonly available in medical emergency kits. So the pediatric formulations are not commonly available. So the message should be loud and clear that the parents, if they are having some kind of medical conditions, when they are carrying infants, when they're carrying small child, they should always travel with some basic medications. So to take home, there are certain very important points. Over the last few decades, we have witnessed increase in the ease and accessibility of air travel, with resultant rise in number of diversity of the aircraft passengers. Accordingly, the patients and the chronic medical conditions could be screened by primary care providers prior to the air travel to determine their ability to endure flight environment, and patients with significant pulmonary cardiovascular disease should be counseled to avoid any kind of untoward events during the air travel. With this, I would like to conclude, and I would love to welcome any questions from the audience.
Any questions from the audience? My one question is in preterm labor. So, what are the things to be done? Please tell vividly.
So we have to, again, we have limited facilities even in preterm labor. I've already shown in that particular slide. We have to maintain the blood pressure, the vital parameters, for all those things. And if it is unavoidable, the delivery is actually, because the aircraft also takes some time to be diverted to the nearest terminal. In that conditions, you need to deliver the baby as well. So the doctors, even the crew members are also trained for such conditions when they have to deliver. Although they are not very common, not very common.
But sometimes happen.
But sometimes they might happen, and certain cases they might have to go on doing an assisted delivery during certain conditions.
That has to be done.
Yes.
Thank you, Dr. Abhishek, for your detailed description about the emergencies. All emergencies in flight you have covered nicely. Thank you.
Thank you.
Now, the next session is on smoking cessation. I will be requesting Dr. Jyoti Bajpayee. Pardon, please. There is a slight change in the schedule. I will be requesting Dr. E.C. Sethi, sir, Professor Cardiology, for the topic being non-invasive testing for coronary artery disease.
Thank you so much. Why is it flickering? It's flickering. It's interfering.
ladies and gentlemen, and I hope my talk is worth it, or I will at least I'll try to make it worth it. So, eminent members of the panel, colleagues, ladies and gentlemen, the topic that has been given to me is how to assess coronary artery disease in a non-invasive manner. And in this context, I would like to highlight the importance of the use of TMTs and CTs and all the new technologies that are coming up every day is becoming a rampant use, and many a times patients end up being tested and who are subjected to TMT or CT angio, and we have some mild disease and asymptomatic individual. So I would really like to discuss with you all the nuances and the finer points of non-invasive testing of each test, philosophically when we should be using it and when we should avoid and refrain ourselves from an overzealous diagnostic approach. In that context, it is very important to understand that by the time angina appears on the horizon, it's already, a lot of metabolic changes have already taken place. So angina appears before this large cascades of things happen, starting from ischemia, producing metabolic abnormalities, reducing LV functions in terms of first abnormal relaxations, then abnormal systolic functions, wall motion abnormalities, then ECG changes, and then angina precipitates. And each and every non-invasive test is supposed to test one or the other facets of this entire cascades. For example, TMT is testing ECG changes during angina or during ischemia. Stress echo is testing the systolic functions. And then you have metabolic alterations and wall functions being tested by the micromyocardial perfusion scans or PET technologies. So we have to remember that all non-invasive tests are not alike. They are testing different facets of ischemia as they are happening at a cellular, the electrophysiological, and at a gross molecular and the gross cellular level in the myocardium. So we have to be aware in order to make judicious choices of which test to use in which particular setting. So we have, as we discussed, number of tests: stress echo, TMT, MR, CT angio, PET, myocardial perfusion scan. And non-invasive testing has been clearly proven to diagnose ischemia in the setting of angina, to find out whether this chest pain is anginal or not, to detect critical flow limiting stenosis, and for prognosticating and deciding the management plans when angina or when ischemic heart disease is present. Furthermore, non-invasive testing can also tell us which patients post-myocardial infarction should be intervened upon based upon which of the territories of the myocardium which are viable, still viable after MI, and if there is ischemia present in those viable territories. So all these are very judicious use of non-invasive testing for coronary artery disease, but at the same point of time, testing a patient for asymptomatic patients to detect subclinical atherosclerosis so as to find out which patient would be higher risk for myocardial infarctions in future is something that is very controversial, and we would deal with this controversy in a scientific and both a philosophical manner. So the problem starts to arise, the conundrum starts to arise when there is non-adherence to guidelines and we start doing non-invasive testing as part of our executive health checkup, as part of our pre-operative evaluation. For oversensitive patients, we want to advise something for the other, and sometimes the overzealous physician who want to have all the tests done in an asymptomatic individual only to land himself or herself and their patients into trouble. So this is the frequent question I ask my fellows or residents, that give me 3 reasons why we should treat any disease from common cold to malignancies, including coronary artery disease. And it's a trick question because there are only 2 reasons. There are only 2 reasons where we should be intervening upon any disease, and that is only if we can offer a symptomatic improvement for the patient, or if we can promise that our treatment, be it medical or be it interventional treatment, can prevent further mortality or morbidity. So in an asymptomatic individual, the fun component of this thing is gone. So if we are testing non-invasively an asymptomatic individual, we really have to be sure that the treatment plan we offer to this patient based upon that non-invasive testing should be strong enough to prevent future mortality and morbidity. If it's not presenting that, there is no point treating an asymptomatic individual. We also have to remember that in this context, when we are trying to use non-invasive testing for prediction of future myocardial infarction, we have to realize that most acute coronary syndromes will happen because of plaque ruptures that are generally are innocent plaque less than 50% in diameter. There are hundreds of such plaques present in all our coronary arteries, cerebral circulations, peripheral circulations. Which of those plaques are going to rupture and produce an acute coronary syndrome is something that cannot be predicted by any non-invasive testing. And since these lesions are less than 50% in most of the cases, you can't do any level of criticality testing in terms of stress testing, because none of the stress testing is going to pick up the criticality of less than 50%. Other thing we also have to remember in terms of the foundational principles of non-invasive testing in CAD is that when the likelihood of CAD is low by clinical risk scoring system, we have to go for tests like CT angiogram. If the likelihood is very high, we have to go for an invasive angiogram. But if the likelihood is intermediate, we have to go for some sort of stress testing. It can be ECG stress testing in form of TMT, but more preferentially, it should be an image-based stress testing. For example, stress echo or stress thallium or even stress MR in good centers. Coming to individual tests, and let's see how they rate one against each other. CT angiogram provides us excellent anatomical detail. It is readily available in many centers. It is very good to rule out sometimes an acute coronary syndrome, to rule out the triple test, because an acute coronary syndrome, acute chest pain situations with breathlessness, it can rule out acute coronary syndromes, it can rule out pulmonary embolism, and it can rule out aortic dissections. So a triple negative test can be used in acute coronary syndrome settings in emergency department to completely, rule out three tests, three important life-threatening emergencies: pulmonary embolisms, acute coronary syndromes, and aortic dissections. Disadvantages are radiation exposure. It does not give you any idea about ventricular function. It doesn't really tell us anything about ischemia, and it should be used in caution with renal impairment because of the contrast being used, which is actually radiation and contrast being used in CT angio is multiple times higher than that is used in conventional angiograms. CT angio, however, can be used for risk prediction models in future if in high-risk individuals we add the coronary CT calcium. It's not a complete CT scan, but a simply scanning for calcium, and then based upon the calcium scores and based upon the baseline risk of age, diabetes, renal functions, and many such parameters, we can clinically risk score our systems that this is the patient who is more likelihood of having 10 years or 5 years risk of acute coronary syndromes, and they probably should be treated intensively by medical therapy in terms of risk factor reduction. But when such scoring systems are used as a surrogate to treat those diseases in an asymptomatic individual, that is something that we should be cautious about. CT coronary angiogram has class 1 recommendations along with other forms of non-invasive testing according to the ESC guidelines. Treadmill test is a test that we commonly do every day in our clinical practice. It is cheap, easy to perform, extensive long-term data is available. However, it's very poor in diagnostic capabilities with sensitivity of around 60% and specificity of around 76%. So, but we use it every day. Stress echo, although used limitedly because of, the expertise required and the interpretation skills required here, but it is an excellent tool in forms of, it is non-ionizing, it is relatively easy and fast to perform for those people who are doing routine echocardiography. It's got a long-term data. And actually speaking, if we treat patients based upon a positivity of the stress test, it actually has much more higher likelihood of providing benefit to the patient if we are talking about interventional treatment or if we are talking about CABG, because stress echo will pick up large chunks of myocardium that are moving in sync. And if they go into hypokinesia or something like a biphasic response, you are relatively sure that if you treat that artery, that entire region of myocardium will improve. So the importance of proving that which patients are going to benefit by interventional treatment is best predicted by stress echogram, while as other tests, for example, PET and all will pick up, or MR will pick up islands, patchy islands of ischemia or of scarring, and therefore they really not, they're a very sensitive test, but they are not predicting the response to the treatment. However, stress echo is a little challenging because many physicians, it's a little time consuming as far as setting up the things are concerned, and sometimes interpretations by physicians may be challenged. Of course, adding the dobutamine test and adding atropine adds to the diagnostic ability. If the patient has normokinesia at baseline, it becomes hypokinesia on dobutamine. It predicts ischemia. If it's akinesia or very severe hypokinesia, and the kinesia improves, it shows a scarred, not a partially infarctive territory, but still a viable territory. But if the akinetic territory remains akinetic, it shows scarring or necrosis. The best test, the best use is actually a biphasic response, where on baseline, on improvement, if there is improvement in functions on low dose of dobutamine, but on increasing the dobutamine, the functions deteriorate. That is very, very high prediction of ischemia and viability. Myocardial perfusion scans, we all do stress thalliums. Again, a very long-term prognostic data. It can be It's performed easily in many of at least the large cities, but it's disadvantageous because it is again radiation causing, and sometimes in presence of bundle branch blocks or in presence of multivessel territory, there's something called as a balance ischemia, and the images are difficult to interpret. But yes, it is easy for people to pick it up because the diagrams that are giving, the images that are giving are relatively same as your echo images of short axis and long axis. And here you can see on rest, there is perfusion in the entire segment, but on stress, you see there is a septal and apical region which is devoid of uptake, and you can show that there is ischemia in the apico-septal territory. Again here, if you combine the myocardial perfusion imaging with the CT scan, you can have a more diagnostic image. As you see here on rest, the images are fine, but in severe stress, the inferior wall appears to be ischemic, and you can correlate with the CT finding of a right coronary artery, which is also critically narrowed at the crux of the heart, and you can predict the CT, and you can very accurately predict where is the lesion and what is that lesion causing to the myocardium in terms of ischemia. PET, you can have, again, available in larger centers. You can have rubidium to see for flow, and you can see for FDG, F18 to show the metabolic functions. What you see here is that the flow in the coronary arteries is not there, in the myocardium is not there in terms that the myocardium is devoid of blood supply, but you see the FDG PET uptake is a little bit higher. So there is some viability in the tissue left, but the perfusion is not there. There's viability, but the perfusion is not there. This is a hibernating myocardium, and if you improve the perfusion, this myocardium is going to improve and the patient is going to benefit. You have cardiac MRs, again, very, very upcoming technologies. We also are still learning on it. It is relatively inexpensive to perform. It is non-ionizing radiations are used, and it can give us a variety of information that is given by variety of these other non-invasive tests. For example, you can put the patient to stress, and between the stress and the rest images, if you take a look on the image, you can see the darkness area developing on stress that shows myocardial ischemia. So it can predict ischemia like the stress thallium. At the same point of time, you can really look inside the coronary arteries and see for the blockages inside the coronary arteries. It can give you information like a CT angio, and you can also have the scarring that you've seen by the late gadolinium enhancements. If the scarring is more than 50% of the thickness of the myocardium, it shows that that particular territory of the myocardium is scarred, and there would be no benefit in treating that disease. So it can give us a variety of information like each of these individual non-invasive testing was giving us. So I really wanted to go a little fast because of the time that we consumed early. So I would like to end here by just sensitizing all of you that all these non-invasive tests are very important when they are used judiciously in a patient so as to benefit him because of the treatment that we provide. But many a times the use of non-invasive, the indiscriminate use of CT angiograms or sometimes even TMT leads to confusion in the patients, leads to unnecessary invasive angiograms, unnecessary procedures being performed on patients with no benefit to them, rather harm to them. Because if they are asymptomatic individuals, we really have to ask ourselves whether doing any intervention of these patients is really improving or enhancing his life in future. And if that answer is no, then we should not be treating these patients. And sometimes indiscriminate use of non-invasive testing leads to such indiscriminate procedures. Thank you for your attention.
Thank you very much, Dr. E.C. Sethi, for your, you have covered everything about the non-invasive testings. But what I think in our setups, in ECG, followed by biomarkers and echo, to the best we can do stress echo. That will be useful for our setup, not even dobutamine. We can't take the risk of dobutamine injection. And this CTM, angio and MRI, cardiac MRI is very useful, but you know the cost effective. So, but all these things should be tried. Suppose enzymes and ECG all are confusing in those settings, we can advocate all these tests. Any questions from the audience?
I'd like to clarify here that when we talk about non-invasive testing for CAD, we are talking about stable CAD. So that's for ECG and biomarkers would be important when we are diagnosing acute coronary syndrome. But for stable coronary artery disease, the issue is that many a times patients who just go to a physician, that I am a 45-year-old person, my father had a heart attack, should I get a TMT done, should I get a CT angio done? That's the question that we really have to ask, because doing them in asymptomatic individuals as part of executive health checkups when the entire bank employees undergo TMT or other tests, that in fact is something that, in fact, doing TMT in an asymptomatic individual is a class 3 recommendation. It should not be done. The only exception to this rule is if there is an asymptomatic individual with high CAD risk, for example, a diabetes, something, and that individual wants to undertake a rigorous exercise program. Somebody wants to go for Amarnath Yatra, and he has a history of diabetes and a family history of CAD. Those are the patients that we want to test for subclinical stenosis in coronary arteries that can be picked up. But otherwise, doing a TMT in an asymptomatic individual is a class 3 indication, should not be done. Sir.
Thank you, Dr. Rishi, for your excellent discussion regarding this confusion, because many of the physicians and colleagues, they do recommend CT angios for routine screening. As you have very rightly answered that, the level of contrast which is given and the level of radiation which is exposed to the patients are pretty high compared to the invasive angiogram. And you have very rightly discussed regarding the stress testing, that it is better to have a stress imaging technologies and the best for the cities like smaller cities where we don't have facilities for CMR and all those. Stress echoes are the best.
Stress echoes, best.
The one thing which I just want to discuss in this audience that, as you have said that coronary calcium scoring is an important tool and that we can do as a screening test and recommended by different societies for high risk individuals. So the people, those who are having coronary calcium score between 0 to 100, what should be the usual protocol for high risk people, those who are not having a very high calcium score, but they are having a high risk? Because many times we prefer to have risk stratification, 10 years or 20 years risk stratification for those individuals, those who are high risk, as we have discussed, that family is fail and others. So what should we follow for those who are having calcium score less than 100?
So, as I said, that non-invasive testing per se, except the coronary CT, is not a prognostic importance if it's there. So, this question has baffled the physician for years. How do you lower your chances of having a coronary or a cerebrovascular event in future? And in that context, if you want to lower it, how do you predict the chances? Of course, the classical risk factors, the most basic thing is you control all your classical risk factors in terms of diabetes, hypertension, blah, blah, blah. You can control all these risk factors, but the most scientific way is to pick up any of the multiple risk scoring systems that are available internationally, the Framingham risk scoring system, the Q risk scoring system, the WHO risk scoring system. There are modern in artificial intelligence-based algorithm systems that we have also been working upon, which are better than these conventional scoring systems. But two things that we have to remember, and coming to the CT. So CT calcium score is an add-on on these conventional scoring systems. If the CT score is less than 100, but still we have a very high risk by, let's say, a Framingham risk scoring system, we will have to treat this patient according to a high risk criteria because he is already fitting in that high risk criteria. CT was adding on to it. But if in the absence of CT calcium score being positive, we still have a high chance because the plaques itself, why do you want to predict a high risk score? Because effectively we want to go more aggressively on the risk factor control. We want to keep the sugar levels to very strict controls levels. We want to keep the cholesterols to, if a patient of high risk, very high risk is there, we are not happy with the LDLs being at 100. We would like to keep the LDLs to 70 or 55 because the overall risk is very high. So the high risk scoring systems can be predicted by numerous clinical risk scoring systems based upon age, risk factors, genders, and other comorbidities that the patient is having. The calcium scoring system is an over and above those systems. So even in the answer to your question is that even if the calcium score is less than 100, if the patient is conventionally a high-risk patient by other risk scoring system, it is wise to treat them as a high-risk individuals because this is an add-on. Framingham risk scoring system has been there for like since 1960s and 70s. With this caveat here again is that all the risk scoring systems have been developed in the Western world, and you have to put the correction factor for Asian populations, which is anywhere in the range of 1.3 to 1.5. Because the Indians and South Asians are at a higher risk for CAD as it is.
Thank you, sir. Thank you for your vivid presentation, sir. Now, we will request Dr. Jyoti Bajpayee, ma'am, for the topic being smoking cessation.
For being late, and I promise in 8 minutes time I'll finish up, sir. It's granted, Dr. Kulkarni. Yeah. So with permission of the chairpersons, actually the topic is very simple. You have heard many times earlier also. The glycemic metrics and the patient-centered considerations to assess generation 2 basal insulin options. So the purpose is how to give the comfort to our patients. And we know that the 75% people of diabetes are lost at each step of the diabetes care cascade. In a lifetime disease, it's very difficult to take control of such a disease. The awareness is 47%, treatment is 12%, and failure is 16%. And in that scenario, in the landmark study, the Indian Reality Diabetes Control, 4 out of 5 diabetic are uncontrolled, and uncontrolled patients have reported higher incidence of complications that we'll know. And the transition of glycemic triad to Hexad, which includes hypoglycemia, A1C, fasting, postprandial, and the nocturnal hypoglycemia and glycemic variability that you can see. This are the new terminologies for us, which we utilize for the monitoring. So this hexad, you see, triad to tetrad to pentad to hexad has expanded the horizon of glycemic monitoring. And the beyond A1C, glycemic variability, and the time in range, the key metrics to support effective diabetes management that we all of know. So what are the most important problem with the treatment of the insulin in diabetes is fear of hypoglycemia. And hypoglycemia is a major barrier to insulin initiation and optimal insulin titration that we know from our patients. And evolution of the basal insulin development, you will see from first to second generation basal insulin analog overcoming the limitations. This is in preparing a peakless insulin. Previously, we were giving a long-acting insulin, which was causing hypoglycemia. So we preferred a peakless insulin, which had a steady level throughout. So the second generation basal insulin analogs can minimize the risk of hypoglycemia. That was the sole aim. There should not be a peak, there should not be a drop. So I'm taking a case, 52-year-old male, 32 BMI, 6 years diabetes, businessman with a eGFR of 90, shows almost preserved renal function and poorly controlled diabetes at 8.2%. So current medications, the metformin and sulfonylurea, and the A1C is 8.2, and we want to intervene. So with this background, I'm telling you the research evidences. We'll take control, the addition 3 and the addition, the bright trials and the RCTs and the deliver naive programs. They tell that the clinical considerations of the patient considering aiding a basal insulin and reducing the sulfonylurea dose with intent to eventually discontinue the sulfonylurea, because no meaning in giving secretagogues for a long time. And advice on lifestyle and the diet modification has to be reinforced with guidance on training and performance of blood glucose measurement, family history. In case 2 comes a old man, 80 years, with 27 BMI and a duration of 16 years, long-standing diabetes with estimated GFR 64, which tells a diabetic kidney disease and poorly controlled diabetes. Patient on metformin, a patient on SGLT2 inhibitor, DPP4 inhibitor. So again, the research evidence to quote, the senior RCT, the addition of 1 to 3 RCTs and the bright RCTs, and the clinical consideration for the patient B, it can be raised blood glucose level detrimental to his neuropathy and the retinopathy, and then addition of a basal insulin with a simple titration algorithm, because by giving a single dose, it never affects the patient's compliance of multiple dose, number one, and it also may give the comfort of a peakless insulin where the blood glucose is well controlled. And then the GL300 provides a relatively simple regimen where we help to improve the glycemic control and risk of hypoglycemia that could be lower than the first generation basal insulin. Let us come to the third case, 68-year person with 30 BMI, 20 years diabetes and estimated GFR still less. It's 40 ml, 8.8% A1C on a host of drugs, the metformin, SGLT2 inhibitor, DPP4, ARB, atorvastatin, calcium channel blockers. And here, again, the evidences are addition 1 to 3, deliver high risk, and the bright RCTs. But the clinical consideration for the patient C includes the glycemic control, recommendation for the medication use, should receive the education as well as the pragmatic A1C reduction. And case 4 is a 50-year male who has BMI of 32, 6 years diabetic, relatively recent detection, 75 ml eGFR, 9.2% A1C, fasting 220 and postprandial 256. So very poor control on host of drugs, the metformin, sitagliptin, empagliflozin, premix insulin, etc. And if you'll see the change of A1C was 0.13, final insulin dose, it was 1.31, and the weight gain there was a similar glycemic improvement in the body weight versus the premixed insulin. And low risk of the any time in the 24 hours confirmed hypoglycemia with this long-acting insulin, pickless insulin, and generation 2 insulin was very significant as you see the data. So the strong evidence for the glycine 300 is PKPD, the RCTs, the real-world studies. All the studies you see have supported this preparation better than that of the glycine 100 and the IDEG or the other pickless insulins. To summarize, people with type 2 diabetes will eventually require a basal insulin to achieve and maintain the glycemic control. And here I want to tell you, we in India are not very in favor of basal insulin. So most of the initiations are with premix insulins, most of the initiations are with basal bolus. But basal only is a very good initiation, and remember, even in patients critically ill, in hospital patients, ICU patients, a single dose of basal insulin works without dose modification. And the second generation BI analog, like glargine 300, represent a suitable basal insulin option for people needing intensification of their anti-hyperglycemic regimens, where a higher dose can be given in a lower volume with almost zero chance of hypoglycemia. Improved communication between the healthcare personnel and the patients, along with the appropriate educational tool and the support, may increase the patient confidence in the administration and the titration of the basal insulin dose. So with this, I thank all of you for your time, and I tell this is an option which you can think in your clinical scenario. We had the molecule since long. I think it's almost for 5-6 years we have the molecule less utilized for our patients, and those who take it up, they are conformed in their approach and utilizing this molecule for their patients. So with this, I thank chairpersons, thank all of you, and will be happy to take up questions if any.
Thank you, Professor Jayant, for all your talks regarding this insulin.
I saved your time.
Yes, thank you. Any questions from the audience for Professor Jayant?
Any question you can discuss with me downstairs. I don't want to make Dr. Kulkarni wait anymore. He is our guest here. I had to make it. Dr. Patni, want to say something? No.
Thanks a lot.
Yeah. Thank you. Thank you, everyone.
Come on the stage, and I'll ask chairpersons to please felicitate them. So, Dr. Jayant Panda sir, Dr. Abhishek, and Dr. Seth. Yes, please. Next speaker, Dr. Rishi Seth. Dr. Rishi Seth, okay, he's not here. And then Dr. Jayant Panda sir. So I'll request Panda sir to please felicitate our chairpersons. Thank you so much, Dr. Jain Panda sir. So now for the next session, I would like to call Dr. Vijay Patni sir, who is going to speak on post-COVID pulmonary fibrosis. So Dr. Jain, Vijay Patni sir. Chairperson.
Professor Dr. Sri Prasad Mahanti sir and Dr. Vishwaranjan Panda sir to the dais, please.
Okay, sir, without wasting time, let us go to the topic straight. Thank you, Chairperson. That was quick, and that's the way to go, actually. At the outset, I would like to thank ACP India chapter for inviting me for this particular talk, and Dr. Jain Panda, sir, Dr. Anil Virmani, sir, and Dr. Anuj Mesuri, sir, for giving this particular talk. The COVID situation has improved a lot. Probably we are not at all having incidences of COVID. Forget about cases, but what we probably are still having is the sequelae, which is still persisting post-COVID. So that is what one of my talk is post-COVID interstitial pulmonary fibrosis and what's new about it. So COVID-19 pandemic has been a curse basically for the mankind and has increased mortality and morbidity. And definitely it was a situation where probably we have to deal with multi-organ system consultancy, and because SARS-CoV was practically affecting each and every organ, but definitely lungs were the mainstay. Long-term respiratory complications secondary to COVID-19 has been described, ranging from persistent symptoms and radiological observational changes to impaired respiratory physiology, vascular complications, and pulmonary fibrosis. And the commonest symptom, if you see, was along with dyspnea, the commonest symptom was fatigue. And that is what we need to understand. And that was the major issue which was disturbing majority of the population who ended up with post-COVID syndrome. Now, long-term complication of COVID-19 has been described and practically affecting each and every organs. But today our focus area happens to be pulmonary, that is the lung tissue, and the major issues is with the symptomatology along with the oxygen dependence and the pulmonary function test abnormalities. So if we try to look into the definitions of the various stages of COVID, we would describe them as the acute COVID-19, acute COVID-19, obviously those with signs and symptoms up to 4 weeks. And then we had the ongoing symptomatic COVID-19, which extended from 4 weeks to 12 weeks, and post-COVID syndrome, signs and symptoms during or when the infection was consistent with COVID-19, which are persisted for more than 12 weeks and could not be explained by any other alternative diagnosis. Why this particular definition has come is important, because even during that post-COVID situation, when probably the patient has come out of the acute situation, the patient still had symptoms. So we should not forget the other pathologies which could have affected those patients. So it has to be ruled out in order to describe this post-COVID syndrome. And the long COVID, obviously, which describes the signs and symptoms that continues or develop after acute COVID-19. And it includes both the ongoing symptom COVID-19 as well as the post-COVID-19 symptoms. So basically, this is the sequelae, or this is the definition of these are the various stages of COVID which we have witnessed during these infections. Now, as I said, what are the symptoms which you see as far as respiratory system is concerned post-COVID? Symptomatology, the majority of the patient presented along with dyspnea was fatigue. And at times, rather, the fatigue was more common than the dyspnea. So that is why some of the investigation like 6 minutes walk test was actually the one which we could basically define, or that was the methodology which was used in order to understand that this patient is suffering from respiratory symptoms. Along with that, if you look into radiology, then it is the ground glass opacity, consolidation, interstitial thickening, crazy paving, occasionally traction bronchiectasis and mosaic attenuation. But if the physiology and the PFT is concerned, the majority had low FVC, FVV1 along with the ratio and obviously the diffusing capacity. Now, as I said, 6-minute walk test was one of the way to find out, and it was decreased, and that was extremely important to identify these candidates and to further investigate so as to plan out some kind of management tool for that. Now, if you look at the basic mechanism of fibrosis, obviously this particular diagram, what it shows is that SARS-CoV-2 can enter the lung infection, but if they enter directly the blood vessel, which is again can lead to systemic disorders leading to multi-organ acute and chronic failure. But most of them led to virus-mediated immune response and inflammation-mediated fibrosis. All had a cascading impact or effect leading to cytokine storm, because there was accelerated cytokines being liberated in the system, and that is why it led to cytokine storm, and that will ultimately lead to modification which led to fibrosis. So if you just look into the way it went about, that increased immune response along with the inflammation resulted in the induced transcription of the fibrotic genes causing the induced fibrosis. So this is how it worked in particular in SARS-CoV-2. So if you now let's go into the etiology of post-COVID. You can say a very busy one, but what is more important, if you say, though there could be a shared risk factor for both the idiopathic pulmonary fibrosis and severe COVID-19 induced idiopathic pulmonary fibrosis, but there was again an injury which was not only due to the virus, but along with that the resultant ARDS which happened, or the ventilatory induced lung injury which happened, that led to aberrant repair of the tissue or the epithelium, and that ultimately led to increased activity which led to fibrosis. So there was a deposition of collagen-rich extracellular matrix in the interstitial space, leading to respiratory insufficiency and destruction of the lung microstructure, leading to fibrosis. So again, this has been very well described, because if you see in what happens in IPF, idiopathic pulmonary fibrosis, the resident cell populations are altered with the loss of the alveolar cell 1, and new subpopulation apparent transitional cells were seen. But in both IPF as well as SARS-CoV, both the type 2 cells were actually undergone apoptosis. So they were no more viable there. So in post-COVID ILD, the SARS-CoV can directly infect AAE2, that is the alveolar cells 2, via the ACE inhibitor receptor, and along with that, as I said, ARDS in the villi may also contribute to the injury. There was a macrophage activation and recruitment of immune cells, results in substantial production of the pro-inflammatory cytokines, and that led to the cytokine storm. The alveolar epithelial cells and endothelial cells damage triggers the activation of fibroblast with the deposition of the collagen, and endothelitis with expanded population of activated T cells and hypercoagulability also increase the risk of thrombosis, which we saw in all cases or almost in all cases who had the sequelae of the long COVID. So where you have to probably put them on the NOACs. That was a very common methodology or treatment which we employed in these group of populations. So, as we suggested, there has to be risk factors, though the risk factors are both for the idiopathic pulmonary fibrosis as well as ILD, but the advanced age and severe comorbidity were the major issues which actually defined, and the stay in the hospital, the use of ventilation, all these actually led to increased incidence or increased chances of them in going into pulmonary fibrosis. And so basically increased age, comorbid conditions, stay in the hospital, on ventilation, all these were the increased risk factors for pulmonary fibrosis. Now, if you look at the diagnostic criteria for this SARS-CoV pulmonary fibrosis, that after 3 months of infection, the CT thorax was the one which could determine that yes, this patient probably was suffering from fibrosis, because why it was so different? I mean, what we see with idiopathic pulmonary fibrosis is that most of those patients are irreversible. But what we see in maximum patient of pulmonary fibrosis, though the word fibrosis is being used, which is actually irreversible, but here maximum patients were able to normalize, right, within the 6 months. But still there was a certain group of population, even after 3 years of the COVID infection, has not been able to come back to the normal self. So still they are having that baseline issues. And what can identify that CT thorax and sequential CT thorax could be one determinant factor which can give you an idea of prognostic issues for that particular gentleman who has been suffering from increased oxygen demand, right? So these are the various CT scan finding, and that can be seen in this particular CT scan. Those are the fibrous bands you can see out there on the basal aspect, and even most of the patients have recovered to that extent. So most of the patients of fibrosis in COVID has recovered substantially within 3 months to 6 months. But there was a small group of patients who could not recover and still suffering from the post-COVID idiopathic pulmonary fibrosis, probably where other modalities of management has to be used. And similarly, you can see in this particular scan. And this again is a plain X-ray. Probably we have already shown this HRCT. Here also you can see at the time of COVID infection, you had the discrete area of air space consolidation in both lower zones of the lungs. But on the second one, they have practically recovered. So this was the usual history. But in certain group of population, that was not the case. So what's the way forward? This is important. Now the prevalence, severity, and impact of healthcare system are currently still unknown. The influence of viral load, new variants, vaccination, ventilatory strategies, and the severe hyperinflammation and immunomodulation which underwent while managing the patient and during the acute phase led to this particular state is even still controversial. The role of immunomodulatory or antifibrotic therapy are still unresolved. It is tempting to speculate that immunomodulation may have a role in accelerating the reversal of inflammatory changes, and antifibrotic may attenuate fibrotic-like changes, and that is why we have been using this in this certain group of population. However, this post-COVID ILD appears to be non-progressive, and clinical trial outcome data are eagerly awaited. Even after 3 years, we are still awaiting the full-fledged data, and this was a paper in early 2023. So most of them are non-progressive, but whatever sequelae they are left with, probably that is the reason why they are still having the symptomatology. It is well described that a subgroup of patients with all-cause ARDS can develop persistent and non-progressive pulmonary fibrosis with enduring physiological and radiological abnormalities, and which can considerably impact quality of life. So this is the, I would say this is the way actually this progressed, this post-COVID ILD. So what could be the treatment? Now treatment, we all know at an acute phase we gave steroids, and it was continued as well post-discharge. Only when the CT scan prior to discharge showed significant ground blood opacity and the patient remained hypoxic. Even the duration of steroid was not defined. It continued, it had a huge lot of variability. Antifibrotic agents was well tried, but it was only successful in certain percentage of population. But these two, and these are the two recommended antifibrotic which have been used and has been recommended. What is pirfenidone and nintedanib. And the choice will obviously again remains not very clear which one to be used and which not to be used. Most severe ARDS that are most likely to end up with fibrosis is the group where we have to consider these antifibrotics. CT scan evidence of fibrosis with traction bronchiectasis or honeycombing are the usual way to identify whether to use antifibrotics or the immunomodulatory therapy thereafter, which has been advocated for the use in post-COVID ILD. Now, those all of you are aware of it. Those who have used this, they are, as far as nintedanib is concerned, it was 150 milligram twice daily. But yes, initially who could not tolerate it was 100 milligram twice daily. And pirfenidone went into an escalating dose, starting from low and then almost doubling it, but thrice a day it was given. Again, the duration of the therapy was not clearly defined, and the major side effect of these particular molecules were GI side effects. Otherwise, they were well tolerated. And the combination therapy with antifibrotic combination with steroids was very frequently used, but with kind of variable response. Patient who required prolonged ventilation with high oxygen was the most common way of actually managing these patients. So oxygen support became very important in these patients. And pulmonary rehabilitation with a proper chest physiotherapy was also advocated. Anticoagulation, that is what was was very much needed in most of the COVID patients who had to undergo, who were hospitalized and had come out with some kind of sequelae. And in these cases, up to 6 months anticoagulation was used, but thereafter, there's not much of data to support the further use of anticoagulant. Then you have the novel agents. You have those mTOR pathway modulators like ranamycin and sirolimus and all. And obviously the vaccination and ultimately the lung transplantation. So presently, whatever we might say, it looks very theoretical, but there are certain group of population who are still suffering, though they are very small population. Sorry. And in those cases, I think the mainstay happens to be the supplemental oxygen through the concentration, because oxygen requirement is usually 1 to 2 liters for them. So thank you. I think I've been able to cover up, and these are the references for my talk. Thank you.
Now the topic is open for discussion. Any question is? Any question? Okay. If there is no question, we'll go to the second topic.
Thank you.
Thank you.
Okay, we'll go to the next topic. Next topic is role of yoga and neurotechnology medicine. To talk on this, I invite Dr. S.P. Kulkarni to the stage. Now, sorry,
Thank you. Thank you everybody for being in the hall and with a lot of interest and enthusiasm. This is really a future of clinical medicine. What we are going to practice in the next 5 to 10 years, that is what we are going to discuss. Friends, greetings. I bring you greetings from my medical college, Miraj Medical College, also as well as MGM Medical College from Navi Mumbai. And I appreciate the enthusiasm and vision of organizers of ICP and Indian chapter 2023 for taking this subject. When we talk about anything like artificial intelligence or technology, we have got two questions in our mind. And I'm going to simplify this with very simple 6 topics. That is, the first is introduction, what is AI or why AI? The answer is on the left side. What is artificial intelligence? What are the principles used in AI-based technologies? And I'm going to give you certain examples of daily use with a peep to the future, a take home and further reading, which is going to really keep you engrossed if you take interest. We are using technology everywhere. The AI is in and around you. AI only knows that you are in Bhubaneswar. Your digital footprints, your electronic footprints are very difficult to erase. But for a medical professional, it saves time, money, as well as efforts. You have got a patient with 10 different comorbidities and you are writing 25 drugs. Every time you cannot write, you can just do a copy paste if you are using a electronic health record, which is AI powered. It reduces the travel of the person, the trouble and torture of waiting in the busy consulting room. And what is most important is the amount of data which is handled. AI can handle any huge amount of data, which cannot imagine, and with lot of accuracy. And at the same time, for all of us, it is said that physicians are under a lot of stress, but definitely using technology and AI will increase your serum level of confidence, concentration, competence, enthusiasm, acceptability and adaptability. I am very happy that there are a lot of young people who are in this audience, but a senior physician needs to get adopted to the technology as much as possible, and you must take the help of all your junior colleagues or your children, grandchildren. There are 5 important things as far as AI is concerned. It is an umbrella term covering a variety of distinct but interrelated processes. AI is classified into narrow, general, generative and super AI. And the principles which are used are machine learning. It involves pattern recognition or computer vision, deep learning called as the DL, natural language processing called as the NLP, large language processing called as the LLP, and robotic process automation called as the RPA. We know that there are a lot of robotic surgeons who are operating. They are using this technology. And it's a very wide spectrum of utility in healthcare system, right from training to early detection, to diagnosis, to decision making, treatment, end of life care, research. AI in healthcare encompasses practically every aspect of the activities which we do. So these are the 3 types of AI which are existent. We are in this second stage, that is artificial general intelligence or regenerative AI. The next step which is going to come is the artificial super intelligence. It can have some deleterious effects on the technology as well as the scientific things. What are the components? The components of AI can be descriptive, diagnostic, predictive, presumptive, and cognitive. Practically every spatial sense what you have got, that can be duplicated with the help of AI related activities. But unfortunately in India, the research is very, very poor. And not only poor, we are working very heavily. We have got lot of patients, but unfortunately we are not keeping any data. There is something called as the H index. It is a metric that measures the country's scientific productivity and impact produced. India ranks 19th amongst it. India produces significant amount of research, but its utility is very low. The onus is on the clinicians, institutions and policy makers that will definitely take us from this position to somewhere at least 2nd or 3rd position. So you have to not only see the patients, you have to maintain the data and take use of AI to analyze it. Now the biggest question asked is evidence based. So these are 3 references You can copy this presentation from the podium, that is not a problem. But these three presentations tell you that how in India utilizing AI can transform the healthcare systems. And this is as updated as June 30. Even the lay press like a Hindu has taken the cognizance of it and they are given an attack. Now imagine something like this. There are 1,000 cats and only one tiger in this hall. How they recognize it? That is exactly what is used as a pattern recognition. And for a medical professional, daily activities, whether you do a morning punching in your medical college or institute, or whether when you are reading a MRI, pattern recognition helps you to understand the situation. Now, what are the different kind of technologies which are there on the threshold of our day-to-day life? That is called as a augmented reality and virtual reality. You can wear a goggle-like thing, and then if you are seeing a match, you feel that as if you are on the ground. And it can create immersive experience for patients as well as for the doctors both. And there is one more concept called as extended reality. This is useful for patients who are in the rehabilitation. They can perform exercises in the virtual world to can make them more engaging. Doctors can practice surgical activities before doing the real thing. You can get a feel of the tissue, whether it is soft, firm, hard or very hard. If you are drilling with the help of an AI equipped drill, you can make the feel that you have cut the bone and you have entered into the medulla. Patients with phobic conditions can take an exposure therapy in a safe, controlled and virtual reality environment. But very two simple conditions called as agoraphobia and claustrophobia. They are very well managed with virtual reality. Patients have got phantom limb syndromes. And there are a lot of people who receive new transplants. So hand transplant is not a new thing now. You can get even a bilateral hand transplantation. But how to get adjusted to that? That is possible with the help of this virtual reality and other types of programs. These are the immersive realities. Then take the example of COPD. You have got a smart spirometer which can even predict when the patient is likely to have a next attack of COPD, acute exacerbation. And they are not rocket sciences. These are the equipments which have been certified by Niti Aayog and they are available. The reference is given below. You are using Google every day, but at least go and get registered with Health Google, and there is an app called as the Checkup. You will have lot of information, and not only it will increase and improve your practice also in a very significant way. Everybody has got a smartwatch in his hand. How many of us see that whether I have done my 10,000 steps or not? That is the way in which you can insist your patients or the caregivers to have its correlation with the activity and its medication. This is MD Palm 2. It is an expert level large language machine learning program from Google, and it has even passed the USMLE examination, and it has even performed an expert doctor level with score of 85%. So 18% improvement was also possibility. The question asked by everybody is how is going to make our practice different. So from the theory of artificial intelligence, let us go to our consulting groups. Everybody knows this kind of thermometers which you have been using. But suppose you have got a thermometer which is at the entry of your clinic. By the time the patient passes, if he is febrile, you get a red signal on your computer. So that is something very simple. We use pulse oximeters, but you concentrate only on oxygen and pulse. But there are smart pulse oximeters which can be attached to a mobile phone. You can monitor from your own home, and there are two indices called as a perfusion index and respiratory rate. That is possible. Our staff, all our staff nurses are very short. So we make a lot of errors in adjusting the height. There are AI assisted equipments. If you have got an iPhone, there is an app called as a measure. So if it hits my feet and my head, they will get a height of 175 centimeters. And this instrument is a very simple instrument. You don't require something like a very modern type, but this gives you a very good analysis of the body composition of your patients. the smart stethoscope is definitely there available in the market, and this is a make in India stethoscope, cost around 15 to 20,000, but it is one of the best stethoscope I have ever handled. It gives you 16 times more intensification of your cardiac sounds. And you feel that as if you are sitting in the heart and listening to the heartbeats and to the heart sounds. Please do take this stethoscope not only for yourself, but for training also. This part can go anywhere, and anywhere in the world when you are connected with Wi-Fi, you can hear the patient's heart sounds and the lung sounds. Gone is the bulb, gone is the tube, gone is the batteries. These are the good BP apparatuses which can work on your arm, even like a exercise BP apparatus. For a pediatrician, otoscope is very simple. You can see the ear on a mobile phone. This is alive core or a cardia mobile. Anybody who is interested after the presentation, I can show you these two instruments. Suppose if somebody crashes down here or in this hotel, can you take a ECG without jelly, without leads, without machine? I got a small instrument which will take this. There are glucometers which talk to the patient. There are people who have got visual problems. So the glucose value is clearly set. It is not necessary that you should have all the very costly equipments. This B2 glucometer, it fits onto your mobile phone. And not necessarily that technology should be only digital or electronic. Here, the biggest problem for a diabetic patient is not taking insulin, but the pain which is associated with finger prick. And this prick can be reduced with vacuum. And this is generally the equipment which uses vacuum to reduce the pain. And everybody knows about CGMS, non-invasive glucose monitors. Please don't take any screenshots. I am sharing this presentation to all of you. And Noga is a company from Israel. Actually, our organization, ACP, RSSDI, should call people like this. It is a non-invasive glucometer. They have got technology. We have got patients. We can measure it and we can certify it. Dr. Narsingh Verma, this is a challenge for you that you contact Noga people and get these two instruments. This is it is a hybrid non-invasive glucometer, and this is a 15 para glucometer. Right now my instrument is stuck in the customs, but when it comes, it is going to be an amazing thing. Now, diabetes is disease of what? It is a disease of muscle. So if you can see the muscle strength of the patient improving, the patient is also happy. There are many things which are available in the market. It is a video laryngoscope in emergency when you want to intubate, video proctoscope. 10th compartment diseases are very common in diabetics. This is called as a DentaCam. All the aphthous ulcers, all the CA of mouth can be visualized, and you can see it on a big screen of 52 inches. This is a video otoscope for examination of ear, and these are the dermascopes. They can pick up malignant melanoma at a precision of 300 times of its magnification. And skin is a mirror of health. It is the biggest organ of body. If you have got a doubt of a skin lesion and if you are suspecting a malignancy, this kind of app will definitely help you. Whatever you are wearing on your wrist, it is going faster. These are called as the wearables. You can wear it around the neck, you can wear it around your wrist, and there are going to be rings like this. This is called as an ultra-human ring. It is a AR based monitors pulse, SpO2, most important is sleep. A similar Indian version, 16,000 rupees, but it will be sleep, stress and activity tracker. And this is a multi-para monitor which tracks 6 different kind of things. That is includes your blood glucose. That has got a even built-in glucometer also. Forget the word plagia. No monoplagia, no quadriplegia, no paraplegia. These are exoskeletons. These are the people who are going to use light and digitally controlled exoskeletons. These exoskeletons, the patient thinks that I want to go to that corner and have a cup of coffee. It is brain activated. There is a chip which is activated with the helmet of the person, and there is a very ambitious project of Elon Musk. You should go on the net and check about Neuralink. That is something really fantastic. Don't forget windows of our eye. That is called as the oculomics. There are lot of informations which you can get, and even there is a study which has predicted the coronary vasculature according to the fundoscopic findings. You can pick up lot of systemic disorders with the help of fundoscopy. We have heard this word, generative AI. Generative AI, many of you must have used ChatGPT. It is a potential is fantastic. It reduces the cost of drug discovery and also improves the efficacy of drugs post-clinical trials. Generative AI has transformed potential in the healthcare, enhances patient care, personalizes treatment plans, and accelerates medical research. None of your malignancy patient will lose even a single hair if you practice personalized medicine. They are medical chatbots, treatment plans, and simulations for conditions like sepsis, stroke, AMI, status asthmaticus, epilepsy. Suppose for the relatives of the patient, if you explain them that what can be the simulation of epilepsy, they will be in a position to pick up even at the stage of aura, such a big advantage. There are ethical AI issues about data privacy, transparency, biases, and potential to influence decision making. And worst part is it should not make the doctors dumb. Generative AI is poised to revolutionize our healthcare. Can ChatGPT help in the awareness of diabetes or multiple sclerosis or bronchial asthma? Yes. Go to these three references. They have given all the methodologies with their projected plans and a simple single-page Excel sheet. Now the question is always asked, is AI a threat to the medical professionals? Or whether the AI is going to replace the doctors? The sound answer is no. From the 5 sector leaders in the panel, but it is about machines making people more effective, more, I will not call it as artificial intelligence. It is assisted intelligence. This is a BMG reference. This is the BMG reference of yesterday. That there are threats which arise from deliberate, accidental, or careless misuse. But that threats can be used in a balanced way. And there are certain people which consider AI as a threat to the humanity. It is not true. Definitely it will replace the physicians who are not using technology or artificial intelligence in the future. These are few further readings as journal, blogs, and links which you can copy. Dedicated journals, there are 15 dedicated journals of only artificial intelligence and medical technology. If you are interested in this ICP monograph, I can share a link with you. Me and my colleague Sagar Sinha, we have written this book. Friends, before I thank you, I am inviting for 2 exciting events in future. There is one conference in Goa, 3rd, 4th, 5th of November 2023. It is an international event on telemedicine. Whatever you can see in the scientific films, sci-fi films, you are going to experience there. So, and the another is, don't forget, 18 to 20 April 2024 for Boston ACP. This will be my 6th American College of Physicians meeting. I am the highest person attender in this country. And I attended from 7 o'clock in the morning to 10 p.m. in the evening. It is absolutely fantastic. So be fit, go digital, learn and use, and most important, teach the technology. Friends, this is the competitive edge. If you don't use, you lag behind. So be optimistic, informed, empowered, futuristic, build a bridge of knowledge, clinical acumen, experience, artificial intelligence and technology. It will make your life very easy. By the way, this bridge, which has been developed in front of my house in Ulve, is the longest bridge in the country, connecting the two parts of Navi Mumbai and Mumbai. Please do visit our place if you are interested in seeing at least 20 type of equipments which I use in my day-to-day practice. Be in touch. Thank you very much.
Thank you, sir, for a wonderful topic on artificial intelligence. Now, topic is open for discussion. Any question from the floor?
Mic, please. Mic, please.
This deals with assisted intelligence, but what about the human being developing inwardly the psychic, spiritual, intuitive qualities? Does it not dwarf those aspects of human development? Because man is not the last species. Man will evolve. And this evolution is a thing decreed. So, what about that aspect?
You are absolutely taking me from the other side of the human emotions. See, unfortunately, people are getting more and more dependent upon technology. But at the same time, what you suggested about stress reduction, yoga, and psychological well-being, burnout prevention, that combined with technology will give you good results. But unfortunately, in this competitive world, because I stay in a 18-floor building, I don't know who is my next door neighbor. That is unfortunately the way in which we are, we are declining in our social connect. We can say that I have got 5,000 friends on Facebook, but I don't know my next door neighbor. So that humanity is most important. And Madam, you pointed out it right way. Technology is not going to give the feel, the touch of the patient doctor. It is not going to give an expression of how the caring doctor is for the patient. So you have to combine the human abilities with the help of technology. Then you will be a fantastic doctor. Thank you very much.
Thank you, sir. The next topic is andropause, myth or reality. To deliver this, I invite Dr. Abhishek Srivastava.
So good evening, everyone. And first of all, I would like to thank Anuj Maheshwari sir, Narsingh Verma sir, Jayant Panda sir, Vinmani sir for giving the opportunity to get involved in this very prestigious ACP. And today I'll be more or less would talk on male andropause. Is it a myth or a reality? So to start with, andropause basically by few subsets of physicians is actually termed as male menopause or male menopause, and by few subsets of physicians it is termed as an andropause. So what is right? Basically, see, male menopause is not the appropriate term to use because men don't have that. To be talking about physiologically, men do not have those menstrual periods, and therefore we cannot say or we cannot term it as a pause or a stop, unlike those in women. And men's reproductive system also do not cease abruptly as we see in the female menopausal symptoms as phase completely. So that is the reason some men actually would experience the andropause symptoms and some men would not feel those symptoms. Almost 90-95% would feel the symptoms of andropause, but the phases are quite different. Some might feel at an age of 45, some might feel at an age of 55, and some might feel at an age of 60-65. So that is the reason calling the term male menopause is not appropriate. The best word we could actually say is andropause, male andropause. And what is andropause? How we can actually define andropause? As the male ages, some male patients do actually feel the symptoms like lethargy, irritability, insomnia, hot flushes, erectile dysfunction or loss of the libido, and more or less depression, anxiety. And most of the studies in the recent times have enough data, accumulated data to show that symptomatic men with low levels of testosterone will find relief or total amelioration of their symptoms when given the testosterone supplementation. And in that opinion, or my opinion, this could actually rightly be termed as an andropause. So what is andropause? The low testosterone levels causing symptoms, and which is relievable in part or completely by testosterone administration. However, in clinics, andropause is diagnosed if tests show that testosterone levels have decreased compared to previous years. But mind it, some men would actually feel the symptoms of andropause even if they have their testosterone level to a normal values. And some men might actually not feel any symptoms even their testosterone levels are low. So the symptoms are variable, the phases are variable, and the ages are variable. So it is very difficult. So all these things do actually contribute to a collective diagnostic procedures and treatment if a physician wants to treat the phases of andropause. They can be termed into various synonyms like PADAM, partial androgen deficiency in aging male, or androgen deficiency in aging male. Male climacteric also they have defined, biropause or hypoandrogenemia or menopause or late onset hypoglycemia. These are all synonyms which actually we can give term to an andropause. Now, few myths also which actually lies among patients and among physicians also. One of the most common which I actually see in the clinical subsets is low testosterone levels are normal as the male, low testosterone levels are normal as the male gets older. So there is no reason to see the medical practitioner if he has symptoms. So this is actually the total myth, which not most of the physicians, few subsets of the physicians or the primary care physicians would actually have their have these things in their mindset. But the fact is, aging is not only the reason why men's testosterone levels drops. That person, that male could also be suffering from obesity or diabetes or metabolic syndrome or some medical conditions where he or that patient can suffer from lower levels of testosterone. So treating all these conditions becomes at much more importance, and it becomes the viable importance why we should actually treat those males who actually have symptoms of andropause. Then one is we should not use. And other myth is all older men should be on hormonal replacement therapy or take natural supplements that help them enhance testosterone level. This is also one of the myths. One myth is no one should take. One myth is all the older men should actually take supplements that help them enhance testosterone level. This is also a myth. And fact is, hormonal replacement therapies for older men with low testosterone levels is actually controversial. It may alleviate symptoms for some men, but may not benefit many others. Therefore, it must be properly diagnosed, it must be properly screened before initiating the hormonal replacement therapy. And moreover, the androgen supplementation could have an adverse effect on different organs, most importantly, the prostate, the liver enzymes, and the cardiovascular diseases. So that is the reason why, as a physician, we should moreover target on diagnosis and screening of a patient rather than directly supplementing that patient with the hormonal replacement therapy. Now, some history about andropause. Yes, way back in 16th century, Chinese texts of medicine provided a series of symptoms believed to be male equivalent of menopause. In late 1800, at age of 72, the distinguished French neurologist and psychologist Charles C. Brown reported in Lancet the rejuvenating effects of self-administered extracts of dog and guinea pig testes. So what he did, actually he injected 5 subcutaneous doses of extract prepared from dog testicles over a 3-day period, and this was followed by 5 more injections of extract from guinea pig testes over the following. And what he reported, this was his words which was published in Lancet, the day after the first subcutaneous injection and still more after the 2 succeeding ones, a radical change took place in me. I had regained almost all the strength I possessed a good many years ago. My limbs worked very properly. My mood swings were almost gone. So all these things, these feelings, this was his feelings, and he actually reported this in the Lancet. So that is the reason why supplementation with hormones or testosterone level actually could be benefited in most subsets of the male patients who are suffering from andropause. In 1935 also, Butinet and Ruzicka received the Nobel Prize in Chemistry after synthesizing testosterone in the laboratory. All these are the old data which actually favors the prevalence of andropause. So mainly andropause is not a myth, it is a reality, but in few subsets of the men, they might suffer from the symptoms, few subsets they might do not suffer from the symptoms. But yes, andropause is there. And andropause is low levels of testosterone. In the general term, we can call that phase as an hypogonadic phase. So the prevalence of hypogonadism when measuring the total testosterone levels. You can see in the slides, less than 5% of the men actually who are in their 20s or 30s have low levels of testosterone. And look at the last one, 49% of men more than 80 and 28% of men more than 70 years of age do have low levels of testosterone. And among these 28%, if I can signify more, the prevalence of andropause symptoms are as much as 60%. So male patients at an age of 55, 60, 65, 70, most of the male patients do suffer from one or the other symptoms of andropause. Pathophysiology is very simple. The decline in testosterone is as men age results as apart from the reduction in Leydig cell numbers. The most simplest thing. The decline in the Leydig cell numbers would actually ultimately lead to a decline in the testosterone levels. That's it. No complex pathophysiology which is associated with andropause. Yes, total testosterone is there, but most importantly, the bioavailable testosterone, which actually works or is the free testosterone. But yes, most of the testosterone, 2% of the free testosterone is only available to us. Rest is almost bound to either sex hormone binding globulin or albumin. Albumin is weakly bound. So if free testosterone level goes down, the albumin, the loosely bound albumin would actually release free testosterone and works. It works in the function of the male functions. Epidemiology, testosterone levels decline by 1% per year after the age of 50. Some studies show that 20% of men over age of 60 have abnormally low level of testosterone and 50% have abnormally low level of bioavailable testosterone. So if we count that by the age of 45, 50, a 1% decline in testosterone level every year, we can clearly predict that by age of 65, 70, almost 30%, 25, 30% of the testosterone would automatically go down. And the symptoms of andropause or low levels of testosterone would be evident in most numbers of the males. Now symptoms, yes, the sudden surge of adrenaline that rushes through the body at various points of time when we are young. The growth of hair in the body, the deepness of the voice, and the larger reserves of stamina compared to women, etc., actually differentiate a men from a women. And the most common the lack of these hormones lowers all these characteristics in male. And the most common of all is actually the loss of sex drive in men, a decreased libido or the erectile dysfunction. अब हम लोग बहुत कॉमन भाषा में we always say that a male, aged male, when he suffers from the symptoms of andropause or low levels of testosterone, हम बहुत ही simple बोल देते हैं, either you have a girlfriend or your testosterone levels are low. So इसी में हम we can predict almost that if a male patient who is suffering from all these symptoms, clearly you should go for the levels of testosterone to be detected. And overall reduction in energy levels and strength levels after a certain age can also be a possible sign of these conditions. Now, how to diagnose? Yes, diagnosis of late onset hypogonadism, screening beginning at age of 50. 45, 50, you should start screening with certain subsets of questionnaires are there, Adams or MMAS questionnaires are there. Simple questions, we can ask those patients, you have a staff, you can ask the staff to before sending that patient to you, you can ask the staff to go ahead with all these questions and we can do the simple screening. Now, positive screening should be followed by check of the total testosterone levels. And if total testosterone levels is less than 200, certainly hypogonadism is present in that patient regardless of the age. But still, the younger males who has low level of testosterone appropriately, the reason could be primary or secondary, but in older age of males, primarily the reason for low levels of testosterone is actually the secondary causes. And we should actually rule out all these secondary causes in those subsets of the patients. And once testosterone deficiency is established, obtain the values of LH and prolactin levels. Certain medications are also there which actually lowers the testosterone levels. Corticosteroids are there, ethanol, ketoconazole, spironolactone, flutamide, all these drugs are there which actually lowers the testosterone levels. Why I'm showing this slide? Because these subsets of drugs lower the testosterone levels as fast as 5% of the total testosterone. So that is the reason why if subsets of patients who are taking these kinds of medications, clearly we should go for the levels of testosterone level. And how to Dr. Meenal has already described or very well said how to go ahead with the treatment of hypogonadism. Diagnosis of the right patient for the testosterone replacement therapy. Yes, if a patient has symptoms, clearly we should go for a testosterone evaluation. And if testosterone levels is low, go ahead with the supplementation of testosterone injectables or tablets or even patches. Now, some contraindications to testosterone replacement therapy. Yes, most importantly, history of prostate cancer. Yes, history of breast cancer or sensitivity to ingredients in the tea formulation or untreated sleep apnea. Yes, obstructive sleep apnea is one of the major causes of testosterone deficiency, but beware that do not start testosterone replacement therapy if a patient has an untreated sleep apnea conditions. Then severe obstructive section of benign prostatic hypertrophy. So testosterone supplementation is there, yes, but few things which I would like to say is natural is better. Natural is better because here are some ways you can naturally boost up your testosterone levels. Exercise is one of the most important things. Decrease stress, sleep more, shake up your diet. But most importantly, it is what I would like to see is, I would like to point out is eating a balanced diet as well as aphrodisiac foods. These are the foods which actually we actually get normally in the generally we get in the markets, and these natural aphrodisiac foods are the major sources of the testosterone levels, or rather than they increase the testosterone levels. So let's face it, gorging is delicious. Aphrodisiac foods with your romantic interest pushes the passion in the bedroom to soaring new heights. What are the aphrodisiac foods? Yes, one of the most commonly got is pomegranate. Pomegranate is a fruit that helps promote testosterone levels in the body. And this fruit, why? This fruit is rich in substance called punicalgin, and which is an antioxidant that helps slow down the conversion of testosterone to dihydrotestosterone. So that is the reason why pomegranate could be one of the most natural things which could actually increase the levels of testosterone. Pistachios, yes. Pistachios are known to come with certain health benefits. Yes, decreasing weight is there, reducing heart disease, lowering blood pressure, but one of the most important effects of pistachios are they actually increase the levels of testosterone. Sweet potatoes. Sweet potatoes is another excellent food to eat. The starchy food is rich in antioxidants and minerals that help boost fertility and sexual desire in men. Then ginseng. Ginseng is a popular herbal medicine widespread across China and other Asian countries. And ginseng is easily available, and these few aphrodisiac fruits or supplements could actually improve in increasing the testosterone levels. Dark chocolate, most evident. Dark chocolate is one of the most important things which actually increases the testosterone levels drastically or improve medically. That's it. Thank you. Thanks a lot.
Thank you, sir. Now it's open for discussion. Any question from the floor? If there is no question, we can.
Dr. Abhishek.
Sir.
Excellent talk.
Thank you, sir.
I just wanted to know, in a patient, you had gone for testosterone checkup test. Thank you. And if the level is low, and I am sure before starting the replacement, we would also like to review it with the next test. So when would be that? Got my point? When should you go? Should we go for the second test before starting HRT?
Second test in meaning what? Pre-testosterone levels, LH, and all those things. Yes, if a patient is capable of doing those tests, certainly you should go with the next level of total testosterone is widely available and it is cheap, cost effective. So total testosterone is the test which actually we should go with. If total testosterone level is low, certainly if patient is affordable, you can go. But easily said, if total testosterone is low, then you can go ahead with the testosterone supplementation.
This is what I wanted to know. Total testosterone test, when should we repeat?
If you are giving the testosterone supplementation, then or not?
No.
See,
because the supplement can we give if it is low at the first reading?
If it is low at the first reading, then you should actually assess the metabolic condition of that patient. If a patient is a diabetic or say hyperthyroid patient, male, or say even a hypothyroid male, then we should actually assess the metabolic condition of that patient. Because see, if a patient has associated metabolic condition, then there is no use of repeating the test, because ultimately the testosterone level would go down gradually in 6 months or 1 year. So there's no point in repeating the test. Once you get the reading as less than 150 of total testosterone, then go ahead with the treatment if you want to go ahead. See, testosterone supplementation is not only could not be confined only for increasing the sexual drive. They actually give some pleiotropic benefits also. They improve resistance, they decrease the oxidative stress, which most of the metabolic patients do actually suffer. So that's the only thing. Yes, we can go ahead with the treatment also, but there's no point in repeating the testosterone test when a patient has the first reading is low.
Thank you.
Yes, go ahead with pre-testosterone, go ahead with LH, go ahead with prolactin levels. All these things are things. And one more thing, levosulpiride actually, which we usually use nowadays, has found to decrease the testosterone levels almost by 8 to 10%. So beware of be cautious in using levosulpiride.
Yeah, levosulpiride is used by right and left.
Yes, that is the thing. That is.
So that is very important. Thank you.
Thank you, sir. Thank you.
Does a house believe that the andropause is a temporary phenomenon?
So that is debatable. I think the first slide only I told you.
Changing the name, should we consider changing the name?
Sir, yes, we should actually. Male hypogonadism we can clearly use. Pause is actually not the appropriate term, what I also feel, because pause is not the word which we should use for males. But the researchers have coined these terms, so we are actually, but there's a reason to change the words and go ahead with some new entity. It is a misnomer, yes. It is a misnomer.
Age of 70 years, he has very good function.
Yes. That is true.
What are the types of patients who develop andropause quickly? I'm not talking about mechanically dysregulated patients, the hypothyroidism or hyperthyroidism. Can you tell me some characteristics that these patients are more likely to develop early andropause?
Sir, most importantly, what I feel is the normal patient with low testosterone levels, almost 80% of the patient would not ever feel the symptoms of low levels like hypogonadism. That is for sure. Yes, associated comorbid condition would actually alleviate the symptoms of hypogonadism, to be precise.
Patient once initiated with the testosterone replacement, is he likely to be required for a long-term repeated basis? Or like suppose the patient is in distress, we should give him some time to recover his own.
That is the point, very valid point, sir. We should immediately should not go for testosterone supplementation treatment, because patient might suffer from associated conditions also. And most importantly, in my clinic, what I actually have seen that diabetic patient or a thyroid patient do suffer from high level of anxiety also. What I have seen is silent anxiety is there. But so high levels of anxiety also suppresses the functions of testosterone to some extent. So basically, you should not go for a supplementation of testosterone directly. You should actually assess. That is why always I said assess that patient. Initially go for the diagnosis, go for the screening. Some Adams questionnaires are also there. These questionnaires actually are very simple and very easy to use. And if that patient could actually write down those questionnaires, and if you find that 5 factors of that Adams questionnaires are positive, then certainly we can find out the reasons for the symptoms of andropause or say hypogonadism. So that depends, because few physicians do prescribe 200 milligrams of IM injectables for around in 3 weeks or 1 month. So that is debatable. But yes, once started, around 4 to 5 doses of testosterone is actually required. After that, you go ahead with another screening of total testosterone levels, or rather say free testosterone also. but at least 4 injections is required for that patient to go. Thank you, sir.
Okay, sir, we end the session.
Thank you, Chairperson, and thank you to all our speakers. I would like to request our chairpersons to felicitate our speaker, Dr. Patni sir, Vijay Patni sir, and our next speaker, Dr. Kulkarni sir.
वो साइड एरिया में हुआ है
Dr. Vijay Patni sir. Okay, okay. Then Dr. Abhishek Srivastava. Request Dr. S.P. Mata to felicitate Vijay.
Dr. Vijay Patni?
No, he is not available.
Dr. S.P. Kulkarni?
No, he is not available.
Dr. S.P. Kulkarni?
To felicitate Dr. Vishwaranjan Pandit. So moving ahead to our next session for the day, I would like to request our chairperson for the session, Dr. Syama Kanungo, Dr. Seva Mahapatra, and Dr. Sanjay Jangit to come over the dais, please. Would request SP Mandi sir, please. I would request Dr. M.R. Behra sir, please, to felicitate our speaker.
Hello. May I call Dr. Purvi Chawla? Dr. Purvi Chawla, she will talk on vitamins, probiotics, GDA. Please.
Yes, thank you so much. At the outset, a big thank you to the entire team of IMACP, Dr. Anuj Maheshwari sir, Dr. Anil Virmani sir, and Dr. Jayant Panda sir, and the entire team. A very big thank you for having us here. I'm going to address the vitamins, probiotics, and myoinositol in GDM. And to begin with, let's just focus on the fact that the high prevalence of GDM is not only associated with increased morbidity and mortality in mothers as well as the fetus, but it's also a huge strain on our healthcare resources. And it remains a surrogate marker of future type 2 diabetes. And hence it provides us with an excellent opportunity to intervene in this window and reduce the long-term burden of diabetes itself. Needless to say that the nutritional status before and during pregnancy is very critical on the woman's health as well as the baby's growth and development. And it has been identified that there are macro and micronutrient deficiencies as well as gut dysbiosis that is very closely linked with insulin resistance and even pro-inflammatory states. So GDM stems from all this, and we need more research on what happens when you supplement the woman with all of these and how does she respond. So this particular review published last year from Qatar focused on nutrients and GDM, and they identified sort of four primary four of the important nutrients that are linked with gestational diabetes, some of which the deficiency may lead to an increased risk of GDM itself, and supplementation may offer alleviation of blood glycemic levels. So first, coming to vitamin D and GDM, we know vitamin D as an essential nutritional factor which is important in the bone metabolism and also maintains the plasma calcium homeostasis, but is also important for normal growth, puberty, reproduction, as well as the immune function, prevention of cancer, and also prevention of cardiometabolic diseases. This deficiency during pregnancy is a worldwide epidemic and a very significant one, with almost 18 to 84% of the pregnant women being deficient in these. In the United States alone, almost 50% of pregnant women are found to have vitamin D deficiency, with an increased prevalence in the Afro-American subpopulation. But the startling figures are from this one particular study in North India, which says almost 94% of pregnant women had vitamin D deficiency, and almost 34% had severe vitamin D deficiency, along with low levels of serum calcium, alkaline phosphatase, and also phosphorus. And a myriad of reasons, social as well as nutritional, have been found to be contributory. So why the low vitamin D levels? Well, it could be geological factors like high latitude, etc., dietary insufficiency or poor dietary intake, even socio-cultural practices like long clothes and no sun exposure or excessive use of sunscreen, etc. Even metabolic conditions like obesity, hepatorenal dysfunction, pregnancy itself, and aging. So all these can lead to vitamin D deficiency. And again, very well we know the adverse effects on the feto-maternal outcomes, especially the increased risk of preeclampsia, hypertension, calcium malabsorption, bone loss, poor weight gain, myopathy, higher PTH levels in the woman, and then in the fetus, small for gestational age is common, neonatal hypocalcemia or even related seizures, infantile heart failure, enamel defects, and so on and so forth. What happens in pregnancy? Again, we all know that the final activation step is at the level of the kidney, but in pregnancy, the placenta can also do that. But higher maternal levels are required or essential to increase the intestinal calcium absorption during pregnancy and to support calcium for maternal as well as fetal metabolism. The central role of vitamin D in glucose metabolism is also well documented. We know that it promotes insulin secretion as well as it improves insulin sensitivity and has a positive impact on food intake and body weight as well. Deficiency of vitamin D is related to GDM as well as type 2 diabetes. And again, that has been documented. But let's look at some of the evidence. So a systematic review and meta-analysis of 2018, which looked at the vitamin D deficiency and the incidence risk of gestational diabetes, found a very close correlation between the two. But there were some studies which did not prove that. But overall, they concluded that definitely vitamin D deficiency is related to an increased risk of gestational diabetes, odds ratio of 1.18, despite the heterogeneity seen. Interestingly, this had a geographical sort of subset analysis also. And you can see I've highlighted the part where Asian studies are represented, and you can see Asia is no behind. We are deficient as well as with an increased risk of GDM due to the deficiency. So they concluded that women with GDM had significantly less vitamin D levels than women who had normal glucose tolerance. And these low levels were definitely a risk factor during gestation. Next, the meta-analysis looking at serum vitamin D deficiency and risk of GDM again. This was published in 2020. Found that between women, when women with GDM were compared with those who were normal, they found that the vitamin D levels were significantly low in women with GDM, and also this correlated very well with the incidence of GDM in these women. Also interestingly, that vitamin D levels correlated negatively with HOMA-IR, and that has been seen across the studies. So they concluded that vitamin D in GDM subjects was much lower than that in healthy subjects, as we saw before. And this deficiency was associated with high risk of GDM and also negatively correlated with HOMA-IR. So lower the vitamin D, higher is the insulin resistance. Now look at what happens when we supplement. So this is a systematic review and meta-analysis of randomized controlled trials looking at the vitamin D supplementation during pregnancy on the maternal and neonatal outcomes. And they looked at least 13 randomized controlled trials where they found that the circulating vitamin D levels were significantly higher at term when supplemented during pregnancy, and the birth weight and birth length was significantly greater for neonates in the group that was supplemented with vitamin D as compared to the group that did not get vitamin D as a supplement. Incidence of preeclampsia, GDM, small for gestational age, low birth weight, preterm birth, and cesarean section were unaffected. So it clearly looks like vitamin D supplementation during pregnancy is associated with not only increased levels, but birth weight and birth length are also positively affected. Another systematic review and meta-analysis looking at this supplementation during pregnancy, published in 2020, found that again the evidence was very strong that maternal vitamin D supplementation significantly increased maternal as well as fetal or infant levels of vitamin D concentrations. But there was a fair enough evidence to say that these levels were, in fact, these increased levels were better for insulin resistance because it improved insulin sensitivity. However, again, despite all the heterogeneity seen, however, the maternal outcomes did not get affected by any of this supplementation. A meta-analysis and systematic review on the vitamin D supplementation for the outcomes of patients in GDM and their neonates found that there were significantly higher levels of circulating vitamin D, also of HDL, but improved levels in total cholesterol as well as LDL, even triglycerides and other parameters like gestational hypertension, also hyperbilirubinemia, and preterm birth. All were positively impacted. So vitamin D supplementation can effectively improve the prognosis of pregnant women with GDM and reduce the incidence of adverse pregnancy outcomes. Next, we look at B12 and folate. Many studies have shown this association between maternal folate and B12 status and the presence of GDM. However, we need more longitudinal cohort studies looking at the status of supplementation as well. Other than that, there are markers like holotranscobalamin, homocysteine, or even red cell folate that have been confirmed as that confirm the association thus far between B12 status as well as during each trimester of pregnancy and the development of GDM. So this systematic review and meta-analysis looking at vitamin B12 and GDM, again, they found that there was no association between maternal B12 concentration during the first trimester with GDM. However, low B12 concentrations in the second and third trimester of pregnancy were related to an increased risk of GDM. So compared with the non-GDM group, the vitamin B12 concentrations in GDM was remarkably decreased, and B12 deficiency increased the risk for GDM as we discussed. And this effect was more prominent in Asians than other ethnicities. Why is folic acid important? Well, again, folic acid gives us, is converted into folate in the body, and it's vitamin B9 and sourced from green leafy vegetables and also from fortified foods. However, folate is not something that can be given from outside. It needs to be, it's not something that is created in the body and hence needs to be supplemented. We know again that early trimester folate deficiency is related or associated with neural tube defects and also conditions like spina bifida, and the growth of the brain and spinal cord both are affected. So we need to supplement the women with folic acid. And again, not only that, but folate forms a building block for DNA, and large quantities of nucleic acids also require folate for their replication. So this longitudinal study looking at the association of folic acid supplementation in early pregnancy with the risk of GDM. This was a Chinese study, and they looked at almost 25,000 women, where they just looked at folic acid supplementation and then the presence of GDM. They did look at a subset of women, almost 1,300 women, where they looked at the dose as well as the brand or frequency of folic acid supplementation and the development of GDM. And they found this kind of, this is an example of the results from this particular study. And overall, they concluded that the association of folic acid supplementation with GDM was ambiguous, because too many doses, too many different regimens were also used in the same. But they did conclude that overall it could be a protective factor against the risk of GDM caused by a high level of postprandial blood glucose, especially in women with normal pre-pregnancy BMI. So again, this is very confusing, but they did feel that, overall all the studies have shown some benefit of folic acid supplementation against GDM. A new concept coming up is not just the vitamin B12 status, but actually the ratio of folic acid to vitamin B12 and the related risk of GDM. And this systematic review and meta-analysis again looked at almost 10 studies involving more than 10,500 pregnant women. And they found that women with B12 deficiency were at a higher risk for developing GDM as compared to those who were sufficient with the levels. And again, this might differ based on the geographical distribution, etc. But elevated vitamin B12 levels may decrease the risk of GDM by almost 23%. The role of excess folic acid and low vitamin B12s seems to be controversial, but needs to be studied further. So the normal folic acid levels in pregnancy are given here. The WHO does recommend that we should have at least 400 nanograms per ml of red blood cell folate level before conception, or at least in the first trimester. Again, various levels of supplementation have been given depending on the risk, and that sort of completes folate for us. Looking at now probiotics in GDM. So all vitamins are important and essential, but there is definitely increased focus on vitamin D and folate given their role in GDM. The rationale for probiotics in GDM is also it's well documented yet somewhat controversial. So gut microbiome composition, which may be altered by an imbalance between symbionts and the pathobionts, and I think it's all self-explanatory. This is called as gut dysbiosis. The link with non-communicable diseases has long been established, especially with allergic conditions, inflammatory bowel disease, and allergic conditions, and metabolic syndrome, and more so now with insulin resistance, adiposity, as well as type 2 diabetes and GDM. Based on scientific evidence, gut dysbiosis in GDM patients includes three of the main things. One is changes in alpha as well as beta diversity, which is changes in microbiome within the individual and then across the species. An increase in the Firmicutes, which is F, and Bacteroides B, F and B, F by B ratio, and increase in the gram-negative bacteria, and reduced counts of bacteria with probiotics properties, as well as decreased short-chain fatty acids producing bacteria. This is especially seen in mid and late gestation as compared to early gestation. All of this is associated with elevated blood glucose levels. Increase in the F by B ratio in late pregnancy is also indicative of obesity and aggravation of low-grade inflammation. So don't want to complicate this, but this sort of summarizes the link between gut dysbiosis and GDM. If you just look at this, gut biosis is associated with reduction in bacteria with probiotics properties, or the short chain fatty acid producing bacteria, or the aromatic amino acids degrading bacteria. All this plus increase in that ratio and increase in gram-negative bacteria, all this can lead to a decrease in the incretin hormones, GLP-1, GIP, as well as reduction in PYY levels. And this further translates to increase in insulin resistance. And here the end organ effects are so well displayed here at the pancreatic level or at the adipose tissue, skeletal muscle, liver, everything is outlined here. So probiotics are important. In fact, when gut dysbiosis in the mother is associated with increased maternal glucose and increased maternal BMI and a distorted dietary intake, it also leads to increase in the pro-inflammatory microbiome in the fetus, also reduction in the alpha diversity, and decrease in the bacteria with probiotics properties in the fetus. So, and this can be impacted also by the type of delivery and the feeding pattern or the breastfeeding pattern in the mother and child. So when I was looking up the definition of probiotics and prebiotics, I came across this International Scientific Association for Probiotics and Prebiotics consensus statement. And this definition probiotics are essentially live microorganisms that when administered in adequate amounts confer a health benefit to the host, has been widely accepted by many, many societies and professional organizations across the world. Of course, the Bifidobacterium and Lactobacillus are two prominent genus that constitute probiotics. And prebiotics is nothing but a selectively fermented ingredient that results in specific changes in the composition or activity of the gastrointestinal microbiota, thus conferring again health benefits upon the host. And the fructooligosaccharides or galactooligosaccharides and trans-galactooligosaccharides are the most common prebiotics. And there are a lot of conditions or criteria for calling something a prebiotic. These are the food sources of prebiotics and probiotics. This is probably easier to remember. And this is a list of studies, and obviously you can't read all the details, but let me just summarize this for you. These are some of the studies which have looked at probiotics and then again symbiotics, which is nothing but pro as well as prebiotics given together in GDM. And most of them have found beneficial effects in lowering fasting plasma glucose as well as post-lunch glycemia, and also improvement in HOMA-IR and quick-eye indices. So again, looking at a meta-analysis of randomized controlled trials, looking at the effect of probiotics and symbiotics on glucose and lipid metabolism in women with GDM, they found that there were distinctly, they concluded that there was benefit in fasting plasma glucose, fasting serum insulin, indicative of insulin resistance, HOMA-IR, the quick-eye index, total cholesterol, and also HDL. LDL and triglycerides. So overall, they concluded that probiotics and symbiotics could control the glucose as well as lipid metabolism in pregnant women with GDM, with a significant improvement in fasting plasma sugar, fasting serum insulin, HOMA-IR, and total cholesterol. And this offers a promising strategy for therapeutic intervention in GDM, but we need to study this more. This is a 2023 publication which summarizes evidence for precision medicine, as in it looks at several interventions for preventing GDM. And as far as probiotics are concerned, they concluded that there is no reduction in the risk of GDM, as there was significant heterogeneity across the studies that were included. There was one study which had dietary intervention along with probiotics, and that had shown reduction in GDM. So definitely we need more data to substantiate our understanding of the same. With that, I just want to show you that this is widely available, the recommended dietary allowances for a pregnant woman of all these. And then coming to the last part, myo-inositol. Myo-inositol is considered as a pseudo-vitamin and is one of the many isomers of inositol, which is produced by the human liver, kidneys, and brain, and naturally occurring in foods like fresh fruits, vegetables, cereals, etc. It's like a second messenger for insulin, enhances not only the glucose transport across the cells, but also improves insulin sensitivity. And again, in GDM, there is conflicting evidence. This particular Cochrane analysis looking at antenatal dietary supplementation with myo-inositol in women during pregnancy for preventing GDM found that there was evidence of a potential benefit for reducing the incidence of GDM, but no primary neonatal outcomes or secondary outcomes were reported in this. So it looks like it's a dietary supplement during pregnancy. It can prevent the development of GDM. Further, this particular systematic review and meta-analysis concluded that myo-inositol is related to lower incidence of GDM for sure, as well as fasting, 1 hour postprandial and 2 hour postprandial levels as well, and in pregnant women with high risk for this condition. Myo-inositol might not be related to a lower birth weight, which needs further confirmation. And this systematic review and meta-analysis further included some more trials, and this was published only last year. So they found that there were several benefits, not only in the incidence of GDM, but in fasting levels, in 1 hour post-OGTT levels, 2 hour post-OGTT levels, and several other outcomes as well, which I have shown you here. And they concluded that based on this, the incidence of GDM was significantly lower. The related glycemic levels were also lower. Regarding the pregnancy outcomes, the incidence of gestational hypertension and preterm delivery was significantly lower in the myo-inositol group as compared to the control. And finally, a meta-analysis of randomized controlled trials again. It has also concluded that the supplementation is recommended to prevent GDM with caution due to some heterogeneity. Systematic review and meta-analysis, which I quoted earlier, the 2023 paper, as far as myo-inositol goes, they concluded that there was a significant reduction in the risk of GDM, even though there was significant heterogeneity also seen. A lot of combinations of myo-inositol are found on the market. And just to summarize this, preconception optimization of both macro as well as micronutrients is very, very important. Vitamin B3, we know deficiency is associated with increased risk of GDM, and supplementation is associated with improved levels and also better glycemic control. Folic acid and B12 supplementation, again, is a must. Optimization of weight before pregnancy and promotion of foods rich in pre as well as probiotics is also a good practice. Adequate sun exposure and physical activity will ensure improved vitamin B metabolism, and myo-inositol supplementation is probably a novel way to prevent GDM and to manage glycemia and lipids better during pregnancy. We thus need to encourage more research in this field because we really need some more concluding evidence from each of these micronutrient and vitamin supplementation. With that, I thank you very much for patience.
Thank you, Dr. Chawla. Now for a very comprehensive presentation. The topic is open for questions. Any questions from the floor? Yes. Please.
Compliments and a wonderful talk. I just wanted to ask you, is there any magic formula or medical nutritional therapy or nutritional diabetes specific nutrition that is there, which sort of matches or is close to providing all the micronutrients and macronutrients, any commercial products which matches the requirements?
So I would not encourage commercial products, but I think encouraging a movement to the preconception period to actually include all the foods in the right quantity and the right total calorie calories.
Chawla, please use the mic.
So the total calories as well as the macronutrient composition, including a lot of fresh vegetables, fruits, as well as all the food groups, and a good amount of protein as well, because we know India is really a protein deficient country. With the right supplementation, I think it's the way to go. So there's no magic bullet, but definitely optimization of dietary patterns and feeding habits would be ideal before conception.
Thank you. I have a question. In addition to all these that you mentioned, and that preconception values are much more important, and if you miss that, at least before the second trophoblastic invasion at 16 weeks, you have to have all these levels at their optimal values. I want to add another thing. What about serum calcium? It's extremely important. Calcium levels, if they are low, you have those intricate changes in the endothelial damage that occurs. You have platelet aggregation also is prevented by high dose of calcium, and our women our community is calcium deficient. So in order to prevent not just GDM but also preeclampsia and eclampsia, it's one of the leading causes of maternal mortality, perinatal mortality, growth restrictions, preterm labor, all those accidental hemorrhages, unexplained stillbirths. So all this to prevent calcium must be an important factor in
calcium as well as iron. We know that yes, women are more than 95% women are deficient in
that should be achieved at least before 16 weeks of
absolutely.
There's something low dose aspirin, 150 milligrams.
Yes,
that also affect the incidence of
that is part of our recommendation of the Ministry of Health and Family Welfare. That's more for preventing preeclampsia rather than preventing GDM, and that's given right from the first trimester.
Thank you very much. Yes.
Thank you, ma'am, for the wonderful talk. We will move on to the next topic. Next topic is smoking cessation. And the speaker is Dr. Dipti Bal. What do you have?
Very good evening to all of you. At the outset, I would like to thank organizing committee to give this opportunity to me to present my talk on smoking cessation at this prestigious platform. So as we know, smoking cessation it looks like a very simple thing, but I really tell you it is a very difficult thing to do in our practice. I will discuss my talk in these headings: why do people smoke or chew tobacco, burden of smoking globally and India, benefits of quitting, why it is difficult to quit, and smoking cessation, what are the options we have, pharmacological and non-pharmacological options, and what are the newer advancements. So a little bit about history. As we know that tobacco and tobacco-related products have a long history that stretches back to 6,000 before Christ. And the plant today known as tobacco, Nicotiana tabacum, is a member of the Nicotiana genus, a close relative to the poisonous nightshade, and could previously only be found in the America. So this plant was mainly found in America. How it came into India? Tobacco entry in India happens in 1556 by Portuguese sailor during the Akbar reign. And these are the different forms of tobacco: smokeless tobacco and smoked tobacco. As we know, pan with tobacco, gutka, mawa, and canny, these are the things which are smokeless tobacco. What is smoked tobacco? It is bidi, cigarette, chillum, dhutti, hookah. These are the smoked tobacco. Coming to the definition of smoker, when you say this person is smoker, a smoker is an individual who currently smokes tobacco every day and who has smoked at least 100 cigarettes in his entire life. So these are known as smoker. What is the difference between addiction and dependence? Because these are the two important factors which are responsible for not to quit tobacco. Patient, because of these two things, a person not able to quit tobacco. Addiction is defined as the individual perception of a constraint of smoking with struggle to stop or reducing smoking for a long interval of time. The term dependence referring to a physical dependence on a substance. Dependence is characterized by the symptoms of tolerance and withdrawal. What are the rewards of smoking? So average smoker takes 10 puffs per cigarette. If you smoke a pack of cigarettes a day, this is about 200 puffs. Each puff of nicotine reaches the smoker's brain within 7 seconds, twice as fast as a syringe full of heroin injected into your brain. Once nicotine enters the brain, it begins to mimic the brain's most powerful chemical messenger. So nicotine is a most powerful chemical messenger. It results in enhanced pleasure, decreased anxiety, and a state of alert relaxation. Because of this positive reinforcement many times a day, each time a cigarette is smoked, smoking becomes a part of every aspect of a smoker's life. So these are the reasons why we are not able to quit the smoking. So as we know, smoke has about 4,000 chemicals identified in tobacco smoke. And nicotine is the highly toxic and potentially lethal alkaloid responsible for a number of pathophysiological changes in the body. On the right side, there is a diagram of cigarette. It contains lot of toxic agents like acetic acid, methane, arsenic, cadmium, methanol. These are the very toxic things which are found in a cigarette smoking. So these are the reasons why cigarette smoking is too dangerous. Why do you smoke? Nicotine is the only known psychoactive ingredient in tobacco smoke. Addicted smokers smoke for one principal reason: to get their accustomed dose of nicotine. When you stop smoking, you will likely experience unpleasant side effects. Research shows that nicotine provides a variety of desirable psychological effects. So what are the excuses? Why the people are not able to quit smoking? Most smokers say that smoking helps with concentration, help reduce tension, help them relax, decreases feeling of distress, help keep their weight down, increase energy level. With all these rewards, no wonder it is too hard to quit smoking. So these are the chemicals released when somebody smoke. Dopamine, norepinephrine, acetylcholine, glutamine, serotonin, and endorphin and GABA. These are the substances which, on the basis of these substances, the chemical dependence makes quitting difficult. And dopamine is one of the important factors. Dopamine release is critical to reinforces effect of nicotine as a pleasurable experience. So smoking is not just a habit, it is an addiction. Nicotine in cigarette is a powerful addictive drug that makes smokers feel good. Each time you smoke, the positive biological reinforcement effect happens, and nicotine adds to all the other positive rewards of smoking. Nicotine affects almost every organ system in the body when you puff. Smoking kills? Yes, it kills. Smoking kills more people each year than AIDS, fires, car accident, murder, suicide, alcohol, other drugs, and combined effects. So these are the various celebrities. Raj Kapoor, greatest showman from Bollywood. He was a heavy smoker and died of emphysema COPD. Walt Disney, famous cartoonist, created Mickey Mouse, Donald Duck, and he died of lung cancer. John Wayne, Oscar-winning actor known not for his many starring roles but also a heavy smoker, consumed more than 6 packs per day and died of stomach cancer. So, there are some consequences of smoking have transformed the lives of several celebrities who have subsequently taken up the cause of anti-tobacco activism. So, she's Amanda Blanc, she's an actor in the film Miss Kitty on Well Smoke. She had developed lung cancer at the age of 40 years. After this surgery, she involved in anti-tobacco activism. Sad story. Most of the celebrities, we are too much follower of these celebrities, but they are a strong promoter of these smoking. So now coming to the burden of tobacco, what is the global scenario said? About in the 21st century, about tobacco kills up to half of its users, and tobacco kills more than 8 million. It means 80 lakh people each year. In India, its number is about 1 million. It is 10 lakh per year. So total, it is a global scenario burden. Total smoker, it's about 1.12 billion. It means 110 crore. 110 crore people suffering smoking globally. Total death due to smoking globally is about 6.48 billion. As I told, 80 lakhs per year. Total death due to second-hand smoke is about less than 85,000 per year. Death toll in India due to tobacco, nearly 1 million. 10 lakh people in India are dying from smoking every day. 2,740 people every day, 114 people every hour, about 1.9 Indians every minute dying due to tobacco smoking. Tobacco use current scenario in India. In any form of tobacco, 34.6% men and women are using tobacco in any form, but in the smoking form, about 14%. Tobacco use as a risk factor for leading cause of death in the world. Ischemic heart disease, cardiovascular diseases, chronic obstructive, LRTI, and other diseases. Regarding cardiovascular risk, 10 to 30% of all cardiovascular deaths worldwide are related to cigarette burn. This is the only non-pharmacological management which has shown mortality benefit in the CO benefit. When patient stops smoking at any stage of time, he gets benefited in mortality. So in this slide, 100% increase in risk when patient is smoking, stroke, coronary heart disease, and hepatitis. 300% increase in risk death from undiagnosed coronary heart disease. More than 300 increase risk due to smoking is peripheral arterial disease, and 400 increase in risk due to aortic aneurysm. This is the data adopted from WHO India Fact 2018. The most common way tobacco kills is from cardiovascular disease. Its prevalence proportion is 48%. 48% cardiovascular disease patients are dying due to tobacco. And chronic respiratory disease prevalence proportion is 23%. Cardiovascular diseases in younger people are more common, likely to be caused by tobacco use. As shown in this graph, 26% population in between 30 to 34 years of dying due to smoking. Cardiovascular are the number one cause of death, causing about 27 lakh each year, as well as of premature death. Top 5 causes of overall death like ischemic heart disease, chronic obstructive pulmonary disease, diarrhea, cardiovascular. And top 5 causes of premature death as well as the same ischemic heart disease, and number 5 is cardiovascular disease. So 266 million current tobacco users and substantial number of people exposed to second-hand smoke are the increased risk for cardiovascular diseases. What is the first, second, and third hand smoke? First hand smoke, harmful fumes inhaled by the smokers. Second hand smoke, a toxic cloud released from the burning cigarettes, cigar pipes, or vacuum devices. What is the third hand smoke? When somebody like someone from your house and the positive poisonous residues of this smoking deposits on your sofas, curtains, and your clothes and mats. Then somebody comes into the contact of these things. Then she had to face this problem of third hand smoke. So these are the first hand, second hand, third hand smoking. How much nicotine kills a human? Currently, safety database state that lethal dose of ingested nicotine in adults is 60 milligram, which is equivalent to the amount found in approximately 5 cigarettes. The average cigarette deliver between 1 milligram to 3 milligram of nicotine. A person who smokes 1 pack a day absorbs 20 milligram to 40 mg of nicotine daily. So it is a high risk of mortality in these kind of patients. Why to quit smoking? What are the benefits? Because we know smoking can damage every part of body. Correct? The alphabets and the words which are written in red shows the cancer. So it can involve head or neck cancer, lung cancer, leukemia, stomach, kidney, pancreas, colon, bladder, and cervical cancer. What are the chronic diseases caused by smoking are stroke, blindness, gum infection, aortic rupture, heart diseases, pneumonia, hardening of the arteries, chronic lung disease, asthma, reduced fertility, and hip fractures. So these are the events which happen to a person who is smoking at any point of time. What are the health benefits of smoking? Immediately quitting, the benefits reflect immediately after the quitting the smoking. When you quit to smoke, when you stop smoking, after 20 minutes of stop smoking, you find enough change in your blood pressure. Your blood pressure drops to normal. After 12 hours of smoking stop, you get carbon monoxide level in your body drops to normal. 2 weeks to 3 months, your circulation improves and lung function increases. 1 to 9 months, your coughing and shortness of breath increases. 1 year, you get excess risk of coronary heart disease is half that of a smoker. So when you stop smoking before 1 year, then the risk of heart disease are half that of comparison to smoker patients. 5 year stroke risk is reduced to that of non-smoker, and 15 years risk of coronary heart disease is same as non-smoker, and 10 year lung cancer death rate is half the rate of a smoker. So this is a chart, a timeline when you stop smoking and you are getting benefit from the stopping the smoking. Why it is difficult to quit smoking? Nicotine dependence, withdrawal symptoms, as I told you, addiction and dependence. These are the important factors to quit smoking. Difficult to quit smoking. So quitting is difficult, yes. Approximately 70% of the people who smoke cigarette want to quit smoking. This is good, but last time I quit, but the smoking I failed. However, individuals who attempt to quit smoking makes an average of approximately 6 quit attempts before achieving long-term abstinence. Relapse, yes, it can happen in a smoking situation. More than 70% of the people who try to quit smoking by themselves relapse within the first week, making this time period critical. And patients who are free from smoking for at least 12 months have a likelihood of relapse of 35% during their lifetime. So it is important to quit smoking, or it is very important to maintain it. So how nicotine works. Nicotine predominantly binds to the nicotine acetylcholine receptors, alpha-4 beta-2 subtype is the central nervous system located in the mesolimbic dopamine system of the brain. Nicotine specifically activates nicotine receptor in the tegmental area, causing an immediate dopamine release, and it feels pleasure. So nicotine binds to nicotine acetylcholine receptor. It leads to opening of the sodium ion channel, influx of sodium, depolarization of the cell, activation of the voltage-gated calcium channel. Calcium triggers the release of epinephrine from the intercellular vessels into the bloodstream, and it leads to vasoconstriction, increased blood pressure, increased heart rate, and increased blood sugar. So what is it? Nicotine withdrawal syndrome develops in the first 4 to 12 hours after following smoking cessation. All of these manifestations are temporary, and they reach the intensity in the first 24 to 72 hours, decreasing in the following 3 to 4 weeks. Symptoms usually persist for more than 3 to 4 weeks in 40% of the patients. What are the withdrawal effects? These are the unwanted, distressing effects seen when a person quits smoking. Prolonged smoker exposure to tobacco makes the body adapt to the nicotine level, and the normal function of the body starts requiring nicotine. When nicotine is not available, the body cannot function properly, and withdrawal effects start in the form of anger, anxiety, depression, difficulty concentration, impatience, insomnia, restlessness, craving for smoking, increased hunger and eating, decreased heart rate, impaired performances. So what are the triggers? So physical triggers are the withdrawal symptom, as I told you in your previous slide. What are the behavior pattern? If patient is having habit of drinking alcohol, watching TV, driving, fishing a meal, drinking a coffee, taking a work break after having a sex before going to bed. These are the pattern when patient wants to smoke. So we have to reduce this. Emotional factors like stress, anxious, anxiety, bored, down, happy, lonely, satisfied. In these situations, sometimes when we are happy and we are doing some party, we are taking a 1 or 2 puff of smoking. So going to bar, socialization. We think that smoking is a good for socialization. So going to bar, going to a party, these are the triggers which are available in our society or in ourselves. So avoid these triggers to avoid the withdrawal symptoms or to help smoking cessation. What are the interventions available for smoking cessation? So intervention can be in an abrupt quitting or a reduction to quit. Second one, the behavior counseling interventions, and third one is a pharmacotherapy. So there are 2 kinds of therapy, non-pharmacological and pharmacotherapy. Pharmacotherapy in the form of nicotine replacement therapy and other drugs for pharmacotherapy. And e-cigarettes, vaccines also, multimodality approach. So before advising to the patient to quit smoking, we have to assess some criteria to know the dependence of nicotine of this patients. IQ scoring of Strong test of nicotine dependence. It has a 6 questions, but its overall marking is number 1 is how soon after you wake up do you smoke your first cigarette? Within 5 minutes, it is given a 3 point, 6 to 30 minutes is given 2 point, 31 to 60 minutes given a 1 point. After 1 hour, it is a 0 point. Second point is, do you find it is difficult to refrain from smoking in place where it is forbidden, like in a church, at library, or in a cinema? If yes, it is given a 1 point. Which cigarette would you hate most to give up? The first one in the morning one or all others? If any patient who hates much the first one in the morning, given a 1 point. How many cigarettes per day you smoke? 10 or less, it is a 0. When any person who is smoking more than 31 cigarettes, it is given a 3 point. Do you smoke more frequently during the first hour after waking? It is very important. After waking them during the rest of the day. If yes, it is given 1 point. Do you smoke if you are ill, that you are in the bed most of the day? Is yes, given. So overall point is given at 10. If point is more than 7, it is a highly dependence. Patient is highly dependent on nicotine. And if this point is less than 4, it is a mild dependence. So before advising to quit the smoking, always apply this criteria to your patient and know the dependence. The degree of such addiction can be quantified through the simple and validated screening tool. And this is a 5A and 5R model for quitting smoking. 5A for to quit tobacco and 5R for those patients who are unwilling to quit tobacco. If any patient comes, if you are seeing a lot of patients in Europe, give a 1 or 2 minutes to your patient and ask about the smoking. If patient is smoker and he wants to quit, you have to apply this 5A formula. Ask to quit at every visit, advise to quit tobacco at every visit, assess willingness to quit at every visit, assess quitting within a 2 week with pharmacotherapy or counseling, and arrange follow-up contact in first week after quitting. It is very important. If you advise something to some pharmacotherapy to your patient and you are not following it, it is also not okay. The second patient who is not willing to quit tobacco, what will you do? So apply this 5R relevance. Why quitting is important to them? You have to explain about the second-hand exposure, overall health, mortality data. You have to tell your patients risk, negative consequences. You can show the videos. You can show some movies. You can show some patient examples to your patient. What are the risks of this smoking? Rewards, benefit of tobacco cessation. If some patients are getting cured from some illnesses and initially he was a smoker and he had quit smoking, you can show these patients, you can show this kind of video or things to your patient, and this is known as rewards. Roadblocks. Identify impediments to quitting. With like, what are the hindrances to stop smoking to this patient? Some families issues and some surrounding issues you have to identify. Withdrawal symptom, fear, weight gain. Some patients think of after smoking I will get a weight gain. So these are the roadblocks. You have to identify these factors and correct it. Repetition. Repeat every time the patient comes to the clinic. Don't stop. So assess if patient is ready, then what will you do? Different stages of readiness. If patient is not ready, this stage is known as non-contemplation. If unsure, contemplation. If patient is ready, it is a preparation time. And 4, it is a time for action. And 5th is a maintenance. So people are not serious about quitting. They are highly positive about tobacco use. Provide them written information about long-term and short-term harmful effect of tobacco use to them. In this category, you have to work like this. So, I'm coming to therapy. There are 2 kinds of therapy, behavior therapy and pharmacological treatment. As I told you, nicotine replacement therapy, varenicline, bupropion, and there are miscellaneous therapy are not and chlorine. So, you have to find out the pickup date. First, a patient will find a pickup date, any date which we can choose, and tell your colleagues and friends, clean your house, remove all the smoking related products from your house, and then prepare for date quitting in this format. Then use these therapy. Nicotine replacement therapy in the 2 form, long acting and short acting. Long acting in the form of nicotine transdermal patches, short acting gum, lozenges, inhaler and spray. Yes, NRT help, non-nicotine replacement therapy. It releases the nicotine in the controlled manner and help people quit smoking. NRT increases the rate of quitting by 50 to 60% regarding the symptom. So these are the main. Nicotine replacement therapy can be given in the combination, like patch should be combined with the gums or tablets or inhalers also. So combination NRT therapy is always preferred in comparison to single therapy. So different dosage, duration and modes of delivery of nicotine replacement therapy. This is came from Cochrane library. Using a combination of nicotine patches together with other therapy is very important. So nicotine patches once in a day, easy to use, delivering a steady amount of nicotine to the body. How to start nicotine patch to your smoker? Identify the smoking. It is a patient is a heavy smoker or moderate smoker. If patient is a heavy smoker, start with a 21 milligram patch for 3 to 4 weeks, followed by 40 mg patch for 3 to 4 weeks, and then 3 to 7 mg patch for 3 to 4 weeks. If light smoker, then start with a 14 mg followed by the 7 mg for 3 to 4 weeks. Nicotine gum, if it comes in the 2 or 4 milligram, 8 to 15 pieces. So these are the, what are the contraindications? GI symptom, dizziness, headache, and yeah, this is a myth that what is the best therapy way to avoid putting on weight. Using NRT is the best way to weight gain after quitting. These are the varenicline. It is a partial agonist of alpha 4 beta 2 subtype, and it comes in a 0.5 to 1 mg BD dose. So start with 5.5 mg OD and followed by 1 mg BD. There is a no drug interaction with varenicline excreted by kidney, so avoid in renal CKD patient when 30 ml GFR is lower than 30 ml. Bupropion is another. It is a non-nicotinic drug but antidepressant, and more than 18 years of age it can be used. Dose is 150 mg per day for 3 days, followed by 150 mg for BD, 300 mg per day for 3 to 4 weeks. These are the second line drugs like chlorine and norepinephrine. It is a tricyclic antidepressant, 75 to 100 mg per day, length of treatment 8 to 12 weeks given. Chlorine is also a drug used for the lowering the blood pressure, and it is also second line drug to reduce smoking. Some vaccines are also available, but going on 400 microgram dose of nicotine vaccine showed a 6 week of continuous absence, but data is not much robust, but might be it will be future. So a few words about electronic nicotine delivery system. It is also known as vaping. It contains nicotine as well as ethylene glycol and some flavored reagents. E-cigarettes are banned in India. E-cigarettes are banned in India in 2019. And this is the concluding remarks. This is paper from our college. 62% of the patient is smokeless tobacco user and 80% were. Pharmacotherapy plus behavior therapy helps to overcome the withdrawal and craving. So this is the mind learning. No smoking. Thank you for your cooperation. Stop smoke.
Thank you for the. We will move on to the next one. So the next topic is unusual infection in diabetes, and followed by Dr. Ajit Dekra for the talk. At the outset, I would like to thank sir and Vimani sir and team ACP for inviting me here to discuss the important topic, and thanks to respected chairpersons. I will be dealing in the coming few minutes of journey to the unusual infections in diabetes, because we know that commonly few infections we are seeing in our day-to-day practice, but some patients come to us with, sir, ये वाला दाग हो गया है, यहाँ पे खुजली हो गई है, then we don't know what to do because we have been trained less in skin or any other infectious diseases. So diabetes is increasing by leaps, day by leaps and bounds, and we are facing the infections also in the diabetic population. So diabetes can affect any part of the body, and from top to bottom, we can see any infection from scalp to bottom. Most commonly, it is seen in bone and joint infections, sepsis, and cellulitis. The pathophysiology is very important to understand because there is decrease in the humoral and T cell immunity because of the high glucose levels when they are consistently high, above 200 or 250. So there is blunting of T cell response, lower secretion of inflammatory cytokines, decreased neutrophilic function, and the chemotaxis is impaired, the cytokine production is impaired, and what we have seen in COVID, that immune dysfunction, and ultimately the patients who are developing the n number of infections here and there. So these are the pathophysiological factors which we see due to the diabetes. The immune effects are usually neutrophil function is depressed, cell-mediated immunity is depressed, antioxidant system is suppressed, and the impairment are exacerbated by hyperglycemia and acidosis, which we see in the type 1 diabetes. So it also leads to more chances of infections. The predisposing factors, primary factors, or the secondary factors. The granulocyte adherence, chemotaxis, and phagocytic dysfunction, myeloperoxidase deficiency, complement pathway defects, and cytokine-mediated interleukin human necrosis factor. All these things are in a wrong direction. So secondary factors are very important to treat. In diabetic ketoacidosis, you have to improve the acidosis and use of intravascular access lines in the hospitalized patient, frequent hospitalization, neuropathy, gastroparesis, and dialysis in CKD patients. They may prone to patient for infections. So infections in diabetes, which we usually see, they are common and unusual. So commonly we see pneumonia, tuberculosis, myocarditis, UTI in our day-to-day practice with soft tissue infections. The uncommon are invasive malignant otitis externa, rhinoceros pneumomycosis, emphysematous infections of kidney or gallbladder. So the skin and soft tissue infections, they are very common if the sugars are high, above 250, and if there is any gut or any exposure to the foreign body, the patient comes to our clinic with very serious infections. This is common infection intratracheal, that is the fungal infection, which patient doesn't tell us. You have to dig up the history, and out of 10 patients, 3 to 4 patients have this complaint in your daily practice. So you can easily ask them, keep the area moist, avoid moisture, keep the area dry, and apply the solution or the ointment of micronazole, clotrimazole, or ketoconazole, and control the glucose levels. Dermatophyte infections is very common. from the scalp to abdominal part of the lower limbs, sole. You can see these infections in your clinical practice, and easily you can treat them with terbinafine. This is the synergistic necrotizing cellulitis. This is also seen in our clinical practice very rarely. So, necrotizing fasciitis with involvement of underlying muscle along with skin, muscle, fat, fascia are also infiltrated, usually seen in the lower limb and perineum, and they present with severely painful soft tissue infections and necrosis. And the organisms are usually found are gram-negative and anaerobes. So surgical debridement is an emergency feature in this. If you don't do or attend this patient immediately, it will spread through the fascia to upper levels. So good debridement along with the use of antibiotics, piperacillin, tazobactam, and clindamycin. Corneal gangrene. Few weeks ago, we have admitted this patient in our hospital, and he was lucky that we have operated him in time. And now, after the plastic surgery, he is very well after a few weeks of treatment. And necrotizing fasciitis of male genitalia as corneal gangrene, mortality is very high. So you have to be active in this treatment. You have to attend this patient early, call the surgical team, and go for the debridement, and you can save this patient. So it spreads to abdominal wall, buttocks, and thighs if not treated. Again, the multiple bacteria are there: gram-negative, Clostridium, anaerobic bacteria. Zygomycosis is high in diabetic population, and it is well-known feature. My dear friends, this was the picture which we have seen during the COVID. It was very common with the use of steroids or oxygen therapy. Anybody was not able to make it. Why it was increasing? So specific infection, that is rhinocerebral mucormycosis, it is caused by the Mucorrhizophus abscedia, and usually seen in patients with high glucose levels with diabetic ketoacidosis. And neurological deficits were also seen. Creatinine of palsy we have seen during the COVID, proptosis, and the ophthalmoplegia. So imaging is very important in this. What is the extent in the brain, and you can treat it with the antifungal agents like amphotericin. Watch for the creatinine levels while you are using the amphotericin. And the oral option was available, posaconazole. That's why we were having the good results during the COVID period. Mortality is 20%. This is invasive otitis externa or malignant otitis externa. 90% of patients with this, if coming to your clinic, will have high sugar levels. So if the patient is coming to you first time, he doesn't know that he is diabetic, please check his sugars if he is coming with malignant otitis externa. Caused by Pseudomonas aeruginosa, very severe pain. It may extend to the intracranial regions, so you have to go for imaging. And treatment is debridement and anti-pseudomonal therapy. Periodontitis, patient से कि मुंह से बांस आती है, and sometimes the dental people pick up that this patient is diabetic because they go to the dentist that they are having periodontitis, and they do the blood sugar levels, and then they send to you. So you should be vigilant for this also. Now the pulmonary infections, usually we have URI, LRI, and pneumonitis, and still I am very having the problem in seeing the government agendas that we are saying that we will be free by Amitabh Bachchan and by tuberculosis. But in my clinic, diabetes hospital, I see in 15 days one patient and we diagnose them of tuberculosis. So this is the pity in our country that still we are getting so commonly the tuberculosis patients, and there is increased frequency of infection due to the staphylococcal or mycobacterial tuberculosis in diabetic population. So pneumococcal vaccine is very important in the immunocompromised and diabetic population. TB and diabetes, we know it is more chances are there if the patient is having high glucose levels. UTI you see there daily in your clinical practice, but I have few patients who come to the clinic, sir, मेरे urine में तो daily कराओ, जब भी after 1 week of therapy of antibiotic or any, there is lot of pus cells. So asymptomatic bacteria, you have to diagnose it, and don't worry because in some patients you may see asymptomatic bacteria, but sterile urea, you have to go for mycobacterial culture. Sometimes they have tuberculosis infections in urine. Symptomatic bacteria, cystitis. 3 days back, I was called in my emergency room that patient आई है वो तो बैठ ही नहीं पा रही है, वहाँ तक ऐसे पूरे चला रही है पेट पे. So what I asked the patient what happened? She told me पूरे पेट में दर्द हो रहा. And when I took the history, she was having recurrent urinary tract infections, but she was having pain throughout the abdomen. Luckily, the radiologist was there. We have done the USG. She was having chronic cystitis. So in the bladder, she was having the infection. And see, the pain is not referred only to the lower area, but she was having abdominal pain throughout. So you have to be vigilant. The cystitis can be seen pyelonephritis. It is again a dreadful condition. You have to be vigilant. You have to treat it. Otherwise, the patient will end up into mortality is very high. So emphysematous pyelonephritis, it is extensively seen in diabetics. Mortality again is very high in this. Cholecystitis. One of my patients collapsed because of the rupture of this emphysematous cholecystitis. We can't do anything because she was admitted in emergency, and when she came back through the CT scan, and within 5 minutes she collapsed. And when the CT report came, it was shown that there was perforation of the gallbladder. Within 2 hours of admission, she collapsed. So this is so mortality is so high in these cases. Emphysematous cholecystitis. Diabetic foot infection, you all know it is very common, and we have to be vigilant in the early stage, because we are talking the unusual infections. So I will go through the melioidosis. It is spread by inhalation, percutaneous, inoculation, diabetes, alcohol are the risk factors. Acute is seen in 88% of patients, chronic presentation in 12%. It may present as pneumonia, skin infection, abscess, genital injury, arthritis, or osteomyelitis. So it can present as n number of presentations. You can see the pneumonia, and point-shaped lesions are seen, and you can treat them easily with cetrazidime followed by doxycycline. Prevention is again in this, it can spread through the soil. So foot care, wearing of shoes, blisters and cuts should be taken care. Apply the moisturizers, good urinary hygiene, and consumption of yogurt containing acidophilus. So worrying symptoms, if the patient coming to your clinic with foul smelling, vaginal discharge, dysuria, fever, painful swallowing, changing in their bowel habits, anywhere it can show you the symptoms. Now, the SGLT2 inhibitor use is very common in our clinical practice. So we get genital urinary tract infection due to the fungal infections are very common now, because SGLT2 inhibitors in Indian population, you have to teach them, counsel them about the hygiene. So the pragmatic usage of these agents is very important. Take the history, because out of 10 patients, 8 patients in your clinic will have this problem. Management of genital tract aquatic infection, we know, maintain it. The hygiene should be maintained. You have to apply the local clotrimazole, and fluconazole should be given. So to summarize, the unusual infections and the usual infections we were seeing. So diabetes increases the susceptibility to various types of infection. The most common sites of infection in diabetic patients are skin and urinary tract in our clinical practice. But we see the unusual cases of mucormycosis, melioidosis, or otitis externa. So all these have to be taken care. And the emphysematous pyelonephritis and cholecystitis, again, we have to be vigilant. Immunization, which we are missing. My dear friends, we are very much afraid कि patient बोलेगा कि तो महंगा दवाई लगवा है, but his hospitalization will be reduced. You have to teach them why you require pneumococcal hepatitis and the influenza vaccine. So cleaning and hygiene is vital, which is missing in the Indian population. Still, awareness among patients has been early detection. So the teamwork is very important. While writing the SGLT2, you have to counsel the patient. While giving the food education, you have to counsel the patient. So teamwork is very important. The teacher, educators, or any of the staff, make them the diabetes educator, and you can prevent n number of infections in your clinics or in your patients. Thank you. Thanks a lot for patience.
Thank you. Shall we allow 1 or 2 brief questions? We are already late. No question? The mic, please, madam.
No, he was not on SGLT2, but his sugars were consistently above 300. His HbA1c was 11.5. So he was having due to the diabetes. He developed a small oil, and he done the itching. After that, it became havoc within 5 days.
A very dear friend of mine, 65 years of age, a physician, showed me a photograph, his own photograph, and I could see that this is tinea problems. And he told me that his blood sugar levels have been normal, and he mistook it as the reason for this. He thought that it was probably SGLT2 inhibitors, and he stopped SGLT2. Do patients with diabetes develop tinea infections despite being in good control? He said that his HbA1c has been around 6.5%. And how do we treat them? Like, it is pretty nasty. It is very difficult to eradicate the anemia.
Because patients are really the kind that we have. In previous days, our Dadajis were using the long Bermudas like.
Talking about corporate, not the chorus.
Corporate is full body. You are talking about relative full body. Yeah, that is again due to the moisture and all those things you can develop in any patient if he is well controlled. In non-diabetics also, any number of patients are having this problem. This is very common in non-diabetics also, in corporates in India.
Regarding asymptomatic bacterial, you can treat, but what about asymptomatic bacterial in pregnancy? Secondly, for female diabetics who have got repeated UTI, they should be advised vital hygiene.
Usually having these symptoms of lethargy, body pain, or little fever. If they are developing first time, then you have to treat it because we have to prevent these.
Because causes symptomatic cystitis in 40%. Yeah. Myelitis vulnerability is dangerous in pregnancy, it's 25%.
If he is in the first trimester, then we have to treat it with the safe agents.
Even unexplained stillbirths occur.
Stillbirths.
Thank you. We come to the end of this very interesting session. And to all the speakers, they've done wonderfully well and enlightened us. Come to the end of the session. Thank you, organizers, for taking us to care of this session.
Well, friends, we have come to the last session in this hall today, and this is the much awaited session, a debate. This debate. The topic was personally from my side. Fat and fit, is it myth or reality? Now, it's going to be a wonderful debate because we have two excellent speakers, Dr. Arvinda Jagdishan and Dr. Rajeev Awasthi. Dr. Arvinda from Bangalore and Rajeev Awasthi from Lucknow. Am I right? Right. Yes, sir. Thank you. So, I would like to invite the chairpersons, Dr. Satish Pradhan, Dr. Tushar Kanti Behra. Tushar Behra is there? Yeah, please. And Dr. Ashok Mohanty and Dr. Gohar. Dr. Gohar Ahmed. Gohar Ahmed is there? Yeah. So now the rules of the debate, I'll tell you, I have been moderating the debate. Chairpersons will give the comment in the end. The rules of the debate are there. We will call first Dr. Rajeev Awasthi, who is going to say it's a myth. You cannot be fat and fit together. It's a myth. And time is 12 minutes. And then it will be Dr. Arvinda Jagdishan who will be saying, no, look, I'm fat. It's reality. Because he is one of the fittest persons sitting here. And then there's going to be 2 minutes of rebuttal from each side. So here we go. Can we have Dr. Rajeev Awasthi, please? Fat and fit is a myth.
Yes. Yes, I think this Arvinda is in the hand now. Yes, but I would like to choose my other point. He's too young to fight. Too young to fight. So, okay, good evening. I think debate should be spoken in a debate-like manner. So, the content, I think this is the diagram which tells you about the story behind the overweight people. I don't call them fat. It's not a good word. It gives you a body shaming type, little overweight. So this is the mechanism regarding the being the little oversized. So let's consider it. What is the obesity? First, when we speak about the problems with the associated obesity, it's not just the being on the higher side of the scale, but it is actually a pro-inflammatory state and it's a disease process. Anything which in the beginning is a disease process, it can never be called as fit. We will again later in the presentation we'll come to what is the fitness. But if you look here, There are many things like hedonic adipose tissue, we are gut, genetic, medication, environment, and so many things are involved, which actually leads to the high weight. Again, in the children, there's many other mechanisms which are involved to become overweight persons. We are not going to discuss anything in detail, but you can see here genetic, endocrine, psychological, and neurological, hypothalamic, and environmental issues. So, definition and classification of obesity, we know that it is BMI is the gold standard till date for describing the obesity. It's defined as a normal excessive fat accumulation that may impair health. And these are here you can see the different categories of the BMI and associated the degree of obesity. This is the burden of obesity, but you see here it is 28.6% generalized obesity and the 39.5% the abdominal obesity, and the generalized obesity prevalence is almost 1/3 of the Indian population. And the projected trends in the prevalence, you can see here the overweight impact. The 5.2% is annual increase in the adult obesity, and the annual increase in the child obesity is much higher, it's 9.1%. Can fat and fit be together? If you look at there in 1980s, there was a term which came into existence which says that the obese BMI metabolically healthy obese people. Is this the right term? Let's see. If you see as a normal BMI metabolic healthy person in this category, you can see here the obese BMI metabolic healthy, but still, despite everything, if you consider normal, they do have hyperinsulinemia and they do have hypertriglycerides. Healthy obesity, it's time to give up this ghost. It's a nation that is this notion possibly with obesity has no cardiometabolic complication. Like dyslipidemia, hyperinsulinemia is attractive for those who have body mass index that's crossed the threshold of 30 kg. Still, for how long are you going to remain in that state? That is the issue. So, the first report so-called metabolically healthy obesity in 1980s, and it's rare depending on the population and diagnostic criteria, depending on the and transition to being unhealthy for more frequent than in non-obese. So even if you are so-called fit today, probably you are not going to remain in that state, and that is why it's you are a disease. You will become unhealthy. So, what is less well understood or at least acknowledged is why studies might increase disease and mortality risk in healthy obese individuals. Again, it says that the health and fitness do not go hand in hand. Again, what is healthy? The notion of whether healthy obesity is a flawed term remains controversial, and says that according to the need, we move away from using BMI as a categorized as one of the obese or overweight or unhealthy. The real debate here is how do we define? Is the vegetarian who has a BMI of 30 avoiding all saturated fats from meat and consuming a diet heavy in simple carbohydrate, reducing his risk for cardiac disease, but increasing likelihood of elevated triglycerides? Can you call them healthy? So we need to redefine health and look at the overall process, considering fitness level, sleep pattern, joint pain, vitamin levels, breathing strength, happiness, and social connections. These are actually the hallmark and the qualities of the good fitness. So if you look at the data here, the healthy obese, so-called healthy obese, they turn into the unhealthy obese, which the number of people turning into unhealthy obese is far more than the people who are the unhealthy, they are normal weight and unhealthy from the beginning. This is a trial which was done from 2007 to 2010. It was a prospective cohort study involving 8,520 patients. And what it suggests that the metabolically unhealthy obese people, they have the highest incidence. And if you look here, the metabolically healthy obese and metabolically unhealthy normal weight people. They have almost the same kind of incidence of the type 2 diabetes. When we look at the ASCVD events or number of respiratory disease events or all-cause mortality, you can see here that the obese people who are metabolically healthy at the moment, they have higher incidences of the ASCVD events or all-cause mortality. It's almost same as the normal weight unhealthy people. So normal weight unhealthy people are almost equivalent to high weight metabolically healthy. Similar is the story association between the metabolically healthy obese and the cardiovascular and the respiratory outcome. You see almost the higher incidence is seen in the metabolically healthy obese as compared to normal people. So many prospective meta-analysis indicate that the people with MHO, that is the metabolically healthy obese, are at the increased risk of type 2 diabetes, CVD, higher risk of all-cause mortality, type 2 diabetes, ASCVD, heart failure, and respiratory disease that's seen in the obese people, and MHO represents the transient phenotype leading to an increased risk of incidence of ASCVD and all-cause mortality, and progress to metabolic deterioration. Hence, they should not be called healthy. Why to treat obesity? We know that the life expectancy reduced in the BMI category of 30 to 35 by 3 years, and the life expectancy reduced by 8 to 10 years in the BMI category of 40 years. So, thank you. Here I am in my. I think I completed
So good evening, everybody. At the outset, I thank the organizing team, especially Dr. Virmani, for giving me such a lovely talk. He always selects me for a tough talk. So always when you say, I'm fit, is it possible? They say, always say, no, it's not possible. If you take 50% of the people, doctors who are attending this conference, are fat. Say 90%. Sir, Dr. Banshi is saying 90% of it. I was a bit low so that some should not feel bad or some should not feel happy. So this is the thing. My opponent, Dr. Rajiv, initially in this statement only while we were beginning this talk, he said, no, I want to don't because I don't want to insult people fat and fit. So initially only lost the debate. What I am trying to do in my presentation, I am trying to show fat people, this person with higher body mass index can also be fit. There are few data which I am showing. Let's have the scientific part. So first of all, greetings to all of you from Bangalore. So fat but fit with the reality, I will be talking about reality. So if you see the introduction, they say laughter is the best medicine. But can it also make you fit? Today we embark on a whimsical journey to explore the age-old question: can you be fat? So there are few examples I want to show you. This is a lady, Jessamine Stanley, yoga teacher. See how fit she is. This is Martina Evans, 300-pound marathon runner. He was told, don't run marathon, you'll die, but still he is running till now. Other example, see this baseball player, see the golfer, see this football player. But still they are fit. So think, if someone spends hours a week running on a treadmill or pedaling on a bike, we probably consider them healthy and fit. Is it? But what if I say, if the same person also qualifies as having obesity, would your opinion change? Definitely should change. So is it possible be fit and fat at the same time? The history of fat and butt fit debate is not now, it's going on since 1999. In this article, I'm talking about 25 years back, with a large study that suggested you can be obese and still be healthy. Obese men could possibly reduce their risk of dying from heart disease more than threefold with regular exercise, even if they didn't lose a single pound. So this is an important study from 1999. The fat but fit debate argues whether people with overweight or obesity can be physically fit despite having excess body fat. Are we focusing on the wrong thing? See this research. Most of the research doesn't look at the obesity from all angles, and there are flaws in their study results. You can see in the most cases, the body mass index of chronic disease are observational, meaning they examine a snapshot in time and don't involve an intervention like dietary changes and physical activity. As such, they can't prove cause and effect relationship. So BMI is not a reliable indicator of health as it fails to consider individual differences such as sex, fat mass, lean mass, and body fat index composition. You can see in this picture the body fat composition. It's not only about the fat. You can see the muscle tissues, essential fat, non-essential fat, bone, and other things also. The fat percentage is not always about the obesity or the unhealthy fat. There are so many other things also involved. So this 2021 study, which analyzed 5 lakh patients, you can see in this study, what does it say? The physical activity does, in fact, provide health benefits across all body mass index category, a dose-response manner. A reduced risk of chronic disease across all body mass categories in those who are more physically active. So susceptibility to impaired metabolic health in relation to obesity is not necessarily mediated by overall fatness, but is largely dependent on the distribution of the body fat and the ability to sufficiently expand the adipose tissue depots. So although obesity is an important determinant of metabolic health, type 2 diabetes, hypertension, and cardiovascular disease, not all overweight individuals encounter these health problems. You should remember this. So if you see this classification of BMI, does it holds good? See the WHO classification, see the Asia Pacific body mass index. So how the difference is there? You can see the differences, how vague it is. So what is the BMI? If you see on the left hand side, you can see Arnold, and right hand side you can see Salman. Do you think they are fat? If they check their body mass index, they are definitely fat. Are they not fit? They are fit. So there is a base movement, that is health at any size movement, which is going on. This is a movement where they show even if the person is obese, there can be fit as well. This is an HAES movement, that health at any movement. You can see in this slide the regulation of metabolically healthy obese phenotype. The body fat distribution and weight gain are regulated by the complex genetic and epigenetic mechanisms that are probably governed by unique sets of development genes with tissue-specific expression operating even in utero. So this genetic regulation, together with cues for energy balance, dictates the adiposity of status of an individual throughout the life. You can see on the right-hand side how the genes plays an important. The normal weight metabolically unhealthy and metabolically healthy obesity. You can see this picture. You can see the metabolically healthy obese. On the left hand side, metabolically healthy obese. See the fat disposition there. On the right hand side, there is a lot of visceral adiposity. On the left hand side, not much of visceral adiposity is there. So it can be fit as well. So this is the metabolically healthy obesity. How the parameters are there. That means the inflammatory markers are less and they are not prone for any complication. Kindly note this. My opponent also are telling that any obesity, they are unhealthy. They can't be fit. And this slide shows that even if the person is obese, that he can be healthy and he can be fit as well. See these players. This is the NFL players. What is the NFL National Football League players? If you take their body mass index, all of them have got a body mass index of more than 30, but still they are fit. So we know Asian phenotype is different. We are having more visceral adipose tissue. This is we are discussing since morning. So this is the famous YY paradox. You can see on the left hand side, fat, he's fit. On the right hand side, thin, but not fit. You can't say, but he's an active person. So, he's a marathon runner, and another is a fit person, but lot of visceral adipose tissue is there. So, BMI alone can be misleading. So, BMI does not tell the whole story. Kindly remember, ladies and gentlemen. So, wait, let me check my BMI. This is what Dr. Rajiv Awasthi was telling. So, he wants to check his BMI. But the sumo players, are they fit? They're definitely fit. They can fight anybody. So, few scientific articles you can see what we knew about the topic till now. What this article says is physical fitness and all-cause mortality. You can see the higher levels of physical fitness appear to delay all-cause mortality primarily due to lower rates of cardiovascular disease and cancer. So it is generally what do you think is fat is unfit? So you can see here the fat can be fit as well. So, fat and fit, is it possible? How? See the articles now. The few scientific, this is the scientific data which I am presenting so that it will refresh your knowledge and think that fat can be fit as well. So, the new research from the University of Leeds on fit but fat paradox. It is centered on a road for IGF-1 signaling on obesity, showed some overweight people having seemingly healthy metabolism. It is explained by a good supply to fat cells that improving blood supply to fat would help prevent heart disease. Another study showed that you can be physically fit and have a overweight or obesity. These are all the articles, scientific research which has been done. So we can't blindly say fat and unfit. No, you can't say that. So the study which reveals surprises, you can see here, this meta-analysis concluded that compared with the normal weight, overweight and mild obesity was associated with a lower cardiovascular disease mortality. See this article. So we always think we talk about obesity, we talk about semaglutide, so our mind is oriented like that. It should not be like that. There is the opposite part also. So weight and health are not perfectly correlated. Fat but fit individuals have a 50% reduction in the risk of developing depression compared with their fat and unfit. So see these articles. So there are articles justifying that fat can be a normal person, fit person, active person, lovely person, jovial person. So weight and fitness are not perfectly related either. Fat but fit individuals had a similar mortality risk than the normal weight and fit individuals. So this is another article which shows the relationship between obesity and mortality in patients with heart failure as well. You can see here, the patients with advanced heart failure followed in a comprehensive heart failure center. What do they say? Elevated body mass index was an independent predictor of improved survival at 1 and 2 years. The promotion of weight loss in patients with heart failure may not lower the mortality risk and may even be potentially harmful. So be careful. Like in the sense, always don't be more aggressive. Don't tell that you have got a patient obese or anything like that. You just use the term, the person in front of me sitting with a higher body mass index, but he runs a marathon, he plays cricket, he plays football, he's fit. We know Arjun Ranatundra, how was he? You know Arvind De Silva, how was he? We know Dr. Anil Vilmani, how is he? But they are all fit persons. So they are all fit persons, they are active persons. So that is we have to appreciate them. So it is suggested in book sometimes heavier does mean healthier. We know, we used to learn about this. This is obesity paradox. When thinner means sicker and heavier means healthier. By showing this, do you think all thin persons are active? They don't have disease at all? Fat means unfit. Means thin is always fit. Do you agree with that? Never, isn't it? These people will also develop heart problems, kidney problem, osteoarthritis, cancer, everything. So that means it is also unfit. Then why only fat becomes unfit? That is my debate. So I am showing all the scientific data which says the fat can be fit as well. So thin and fat unraveling debate. On the left hand side, I am sure you know him. He is Puneet Rajkumar, he is a South Indian Kannada actor. He is a fit, active person. He died of a heart attack. Everybody, whole India is surprised why he did that. Manisha Kairala, is suffering from cancer. His mom died of cancer. All are thin and active persons. That means thin can be unfit also. So only not fat and unfit. Thin can also be unfit. So remember this point as. So this is on the left hand side. It is me giving an apple. On the right hand side, Dr. Avasthi giving the burger to his patients. So take home message that, ladies and gentlemen, regardless of your body weight, being physically active can reduce your risk of chronic disease. Instead of focusing on body weight, the emphasis should be placed on increasing physical activity and other healthy lifestyle practices to improve overall health. Focusing on cardiovascular fitness, muscular strength and endurance, flexibility and body composition can help promote physical fitness. Though exercise is important, many other factors affect body weight, including your diet, medication, medical condition, and other lifestyle factors. Dr. Anuj, so see these 3%. Dr. Jayant Panda, Dr. Anuj Maheshwari, Dr. Anik Vilmani. Well, thanks for inviting me, but are there white body mass index? Definitely they have white body mass index, including me, but they are all 2%. See their commitment. They organize so many conferences, they roam all over India, all over the world. So they have high body mass index, but still they are fit. Kindly note this before you give your conclusion. Do you think you can be fit as well as fat? Ladies and gentlemen, it's time for you to realize and give your vote. Thank you.
Yes, very nicely depicted, showing the pictures of stars, 2-3 people who died because they were still in the BMI range. Doesn't mean that you just overlook thousands and thousands of people, those who died because of the overweight. Those are unknown people. They do not have their pictures on the board. You can see the medical records, you can see the data across the globe, across the world. Why everybody is saying they reduce the weight? Because we know that there are problems. He said that the people don't die because of the heart failure. You see, search the data. You have very high incidences of the heart failure. You have high incidences of sleep apnea. You have all-cause mortality, which is much higher. It's not only that you are going to survive for a few minutes and just after this conference and you are looking fit, but again, you have to survive for a long time. If you look at the long-term data, everything supports that whatever it may be, but you certainly have much higher chances of developing higher disease incidence and mortality. And I must tell you, Arvinda, that the sumo wrestlers, they do 99% sumo wrestlers, they do not cross the age of 50. I am done.
Arvinda, 2 minutes rebuttal. Thin but fit. Is that all of you agree? Thin but fit. Do you agree? No. Fat but fit. Do you agree? So that is the dilemma of this debate. So the scientific data is always there for obesity and problems. But my challenge was to show the data, the research. Last year research also, it is not only 1999. It is 2022 data also I showed, which they are exploring that fat person can also be fit. It's not Salman Khan or anything like that. It is the scientific data. That is why we have the scientific debate and scientific fun, so which we had today. So my opinion is fat, still they can be fit. That is my thing.
Thank you. Thank you. I will not take a vote from the audience here, but both of the speakers have done a wonderful job. And I can only say one thing in the end, that I was surveying all the people sitting here, and I can say with conviction that barring 2 persons, Dr. Shashank Joshi and Dr. Vijay Patni, barring these 2 persons, I don't think there's anybody here whose BMI or waist circumference is within the normal. Does a new window say all are great?
So that's the take home message here.
Final comments from the chairman.
Sir, the bottom line, if you take the bottom line, the more conclusive research is available, the fact for big debate will likely continue for many years in many ACP conference, many RSSDA conference, it will go on. While both of us had a valid arguments, focusing on weight is not the answer to the good health, and it's not a strong motivating factor. Regular physical activity provides endless benefit such as improved mood, mental health, and a reduced risk of chronic disease, healthier bones and joints, and better quality of life for everyone. So if you are not exercising, ladies and gentlemen, start exercising. The for next ACP conference, we will bring your BMI at least below 25. Thank you.
Thank you.
If you can please stay here. Our one speaker is joining on the Zoom, so let him also be and let us encourage her also. So she is joining from US. So very soon she will be joining and she will speak on the other.
Hey, Gabriel. Thank you, sir.
Sir, आप ही आ जाइए डॉक्टर साहब। बेस्ट योगा आज
Yeah, can she see me? How can she see me? Right. Where is the camera? Is it working here or not? Dr. Vidya Sundaresan, Anup Maheshwari here. Welcome you in the India chapter annual conference. Dr. Vidya Sundaresan is the governor of American College of Physicians, Illinois chapter, and she has agreed for the speaker, being speaker in this our very prestigious ACP annual conference of 8th annual conference
which is being held at Bhubaneswar. We wanted her to join physically, but somehow she couldn't come, so she'll be speaking on Zoom. So over to Dr. Vidya Sundaresan for your deliberation.
Speak with any opportunities that I get for ACP India. Today, I've been asked to talk about adult immunization, with which I'll go through some of the salient features of what the Advisory Committee on Immunization Practices, ACIP, a CDC body, recommended for adult immunizations, and try to delve into a few of the why, when, and who questions. I do not have. Are you able to see my slides, Doctor? Okay. Yeah, I do not have any. I do not have any disclosures. Today I'll talk a little bit about some of the revisions in the content and a few case-based discussions on vaccinations, adult immunizations. We have an adult immunization schedule. This is free of cost, available on CDC's website. It has a few tables which can be extremely useful. Starts out with this introductory page, which gives or lists all the vaccines available for adults in an alphabetical order. It talks about what abbreviations, what their content can be, and also their trade names. So that is B. A lot of yellow. So those are universal recommendations. And if you look on the top, it gives you the age breakdown. So influenza and COVID are universally recommended 6 months and over. And then also with hepatitis B, that age cutoff there is 50 years. So based on the age and the universal recommendations and the color, this table is extremely useful. The purple there talks about recommendations which are based on some additional or special situations as well. And I'll talk a little bit more about detail in the subsequent slides on that. Where you see blue, that is shared decision making. And these are listed as such because of some insurance constraints or maybe certain risk factors that you really want to talk about with certain patients. So where you see the blue, there is shared decision making. One additional blue line, which has now been added over 60 years of age, is RSV with shared decision making. This is this RSV information has not yet been updated. After October, that will be after the October meeting for ACIP, there will be an update in this chart as well. The second table, which is also part of the adult immunization schedule, talks about the risk-based vaccination schedule. So pregnancy, which are the vaccines that definitely should be given? People who are immunocompromised, including HIV, what are the vaccines that they need to be given? And then asplenia, end-stage renal disease, chronic medical conditions, which vaccines are recommended in them. So this is also a very useful table. You'll see an additional gray box here. Gray is just that there's no recommendation one way or the other. There's not enough data. And then the orange is precautions. So be wary of precautions. And this table, this notes section is very, very useful, has lots of links and hyperlinks, which describes each of the vaccines which are recommended for adults and gives more information for the users. Lastly, there's an appendix section which addresses that orange part, precautions and contraindications, the red boxes. They really talk about each of those vaccines in detail. So in 2023, this was a historic adult immunization recommendation from ACIP because COVID became like a universal recommendation. And they did talk about what type of vaccine, and then, you know, the trade names there that is listed in the first sheet. In addition, the pharmacy, the American Pharmacy Association also supported or endorsed this recommendation from 2023. In that way, we recognized the pharmacists as important partners for vaccination and to reach our goals for adult immunization too. A lot of the adult vaccination, the vaccines are available in pharmacies. So people go there and get their vaccines. And this was in a way of recognizing them, and the endorsement came as a mutual recognition of these vaccine schedules, which are approved by ACIP from CDC. So table 1, you'll see COVID and influenza, they're universally yellow. The live attenuated influenza vaccine from age 2 to 49, it's recommended. Beyond that, it's kind of, you have to be aware, you shouldn't be giving a live attenuated beyond the age 49, it's not recommended. Then you will also see that Tdap is recommended again as a universal immunization schedule, and every 10 years it is recommended to boost that. And then measles, mumps, rubella, if born before 57, most people got natural infection. And if they are in healthcare, there's still some value of checking antibodies and giving them a booster dose. But most of the times after 1957, yes, this does become a universal recommendation. We did see outbreaks of measles. We did see outbreaks of mumps. These were in communities where the childhood vaccinations were not completed, or people did not get, even despite their complete vaccination, booster doses were not given. So in such groups, even in outbreak situations, they were even talking about an extra booster dose for MMR. You will see that college students, we had some mumps in college congregate settings. In those situations too, an extra dose or a booster was highly recommended. Varicella, if born in 1980 or later, yes, in 2 doses of varicella are recommended if they do not have a documented history of chickenpox. Zoster, now we have a recombinant vaccine. 50 is the age cutoff. It used to be higher with the older vaccine, but with the recombinant, the Shingrix, 2 doses are recommended after age 50, minimum of 4 weeks apart, but 2 to 6 months apart. That second dose should be administered. HPV, the age cutoff here is 26, but 27 through 45, there is a shared decision making, especially with risk factors like HIV, men having sex with men. There is a recommendation there, or a consideration for HPV vaccine to be given 27 through 45. But up to age 26, 2 to 3 doses, depending on the initial age of vaccination for HPV, it is highly, highly recommended. This is such a breakthrough that, you know, with the vaccine, you're able to, in fact, prevent cancer. How amazing is that? So there's a big push for giving it to children, and then following that up to age 26, there is leeway for HPV. Pneumococcal vaccine underwent a lot of changes with the increased valency that we have now. We also have a PCV, a conjugate vaccine with 20 serotypes there. So that's highly recommended instead of a PPSV. The short answer there is, can you give the PCV20, a conjugate vaccine, more durable vaccines, a more immunogenic vaccine? The answer is yes. Now, people who have already completed their series, is there a role for an additional PCV20? They've already completed, let's say, PCV13 or 15, followed by PPSV. Is there a role for giving them an additional PCV20 vaccine? So that is under the shared decision making, which was a change this time as well. After age 65, after having completed the primary series, then, you know, do you give the the additional vaccine, that's another shared clinical decision making. And hepatitis B, this was changed as well. Up to age 59, the cutoff was at 59 years. They should receive 2 doses depending on the type. So one of them, Heplisab, one of them, you'd need only 2 doses, and then Energic, so some of the other makes of hepatitis B, you need 3 doses. 4 doses depending on whether it's an accelerated schedule or if the patient's on dialysis. Another additional dose can be recommended as well. So 2, 3, or 4 based on the type of vaccine and their medical condition. And then meninge B, this was also meningococcal B. There was a shared decision making added 19 through 23. Again, college students are high risk for meningitis in congregate settings, so there is an additional recommendation for them. You'll see here that pregnancy, they in fact consolidated a lot of those live virus vaccines are contraindicated. They consolidated that recommendations. You cannot give that live attenuated influenza nasal vaccine in pregnancy either. Meningococcal B, Men B, they added as a precaution. Data is not very clear. So if the risk versus benefit, the benefit is much higher, that's the only situation you should regard giving meninge B. Otherwise, that was one pregnancy column was consolidated more. And then also complement deficiencies, asplenia, they added a lot of those vaccines in yellow. The only contraindication there was the live attenuated influenza vaccine. So a little bit more of the changes: COVID-19, pneumococcal vaccination, Hep B, polio vaccine actually was added to the notes section. It didn't make it to the main table, but we did see a resurgence of polio in some areas, East Coast and New York. So people who were really at risk, they're identified and given that extra polio vaccine, the booster, intramuscular, 1 booster was also recommended. If they've not completed their series, definitely that booster had more value. And then some minor edits for influenza, MMR, and meningococcal. So ACIP meets every year, more than once, depending on what vaccines need to be approved. But every October, they meet to update the vaccine adult immunization schedules and pediatric immunization schedules. So we expect another one coming for 2024 when they meet in October this year. But, every time when they come out with these changes, Annals publishes that and gives a very good review of all the changes that have been made. So here, like I said, COVID, I'll talk a little bit more about the latest change for COVID, but mainly they did recommend the primary series. And then they did also say they had this Johnson & Johnson, which was that viral vector vaccine, not recommended at all now. But if people have received it in the past, they included that in the notes section, what to do for subsequent vaccination for those people. And then there's the monoclonal antibody pre-exposure prophylaxis. They did include that. I'm going to watch closely to see what they say in 2024. It's not very useful, so we don't know if they'll remove this recommendation. Next, for hepatitis B, the Heplisab and Prehebrio, they're 2 different brands. The Heplisab now you just need 2 doses of that 4 weeks apart. And then they did say that not recommended in pregnancy due to lack of safety data. That was kind of consolidated for hepatitis B. And they did say 59 was that age cutoff. If over 60 somebody wants to take hepatitis B, yes, nobody's stopping them, but 59 is universal. Beyond that, yes, with shared clinical decision making, they're definitely, without risk factors over 60, talk to your physician and take it. Nobody will stop them. Here, with dialysis specifically, 1 extra dose for hepatitis B, that recommendation was also consolidated in 2023. Influenza, high dose influenza vaccine, that recommendation was reinforced, and the adjuvanted vaccine as well. These definitely help produce higher antibody response, and I'll show some slides about that later as well. Here, meningococcal, like I said, mening B is what they said with shared clinical decision making, and they reinforce the special situations. They just said that if you're taking one type of vaccine or one brand of vaccine, make sure that you take the same thing for the subsequent doses as well. That's what they said with the meningococcal. Polio vaccination, like I said, if there was no evidence of completed polio vaccination series in the past, then definitely these adults are the only ones that, you should definitely strive to complete those doses, and then addition of that one intramuscular booster dose is recommended for vaccination for people with increased risk of exposure to polio vaccines. Zoster vaccine, the addition this time was that serologic evidence of prior varicella is really not necessary. It's a good, safe vaccine, recombinant vaccine, so they are definitely recommending it for everybody over 50. That was the change. Again, appendix section, the last part of this gives you the contraindication and precautions for all those vaccines, very well listed. This time, the egg allergies was again reinforced. If it's just hives, you can still go ahead and take any age-appropriate and age-recommended vaccine for influenza. But if it's severe reaction, you do have the recombinant vaccines, which can be given without risk. They do not have that cell culture, so they kind of reinforce that as the precaution and contraindication. Guillain-Barré, history of Guillain-Barré by far is the only contraindication for flu vaccine. All right, so I'll move straight into a case-based discussion next. This is the first case, a 67-year-old male seen in clinic for a routine follow-up 2 years ago. He had received PCV13 followed by PPSV 1 year ago, and he asked you if he's up to date with his pneumonia vaccines. What will be your response? I'm going to go ahead and give the answers right away, but I'll give you a second to just look through these. The answer here is he is up to date with vaccinations, but this was the new addition for the PCV20. Now that it's available, after 5 years, he could receive that additional vaccine, and that's a shared clinical decision making along with the provider. And you'll see that here in that blue section, the shared clinical decision making for age above 65, that additional vaccine after having completed their series for pneumococcal vaccine. That was the addition this time. So pneumococcal vaccine, we have the 15, we have the PCV20 conjugate, 15 conjugate, 13 conjugate, and we have a polysaccharide vaccine, which is the PCV23. In general, when there is a higher valence, you have breadth of protection. And if you have the conjugate vaccine, that is more durable. Those vaccines are definitely more durable. You do have the mechanism of action, which is a T-cell dependence with the conjugate vaccine, and that also helps with memory B-cell production. So that's the reason why you have better immunogenicity and also higher durability with PCV or the conjugate vaccine. The polysaccharide vaccine is T-cell independent. That's a mechanism of action. And so you don't get memory B-cell production. And hence the immunity is not as good, not as durable. The 50 versus 65 years was the thought in terms of when to start recommending these vaccines. But with risk factors below 65, if they are given, actually 19 itself, these vaccines can be considered with risk factors. But 65 and above, you have that shared clinical decision-making ability. And vaccine order, what do you consider? You want to always give conjugate vaccine first. And the reason for that is that if you give the polysaccharide vaccine first, it can blunt the immunity that you get with the conjugate vaccine. I've listed here the valence and what is common, what is uncommon, what are special in the PCV20? Are those highlighted ones? And what are different in the polysaccharide vaccine? Those are highlighted as well. So between polysaccharide vaccine 23 and the PCV20, there's really not much of a difference. So if they haven't had any previous pneumococcal vaccine, there's a nice table that really talks about after age 65, give PCV20, or you can do a sequential combo option, 15 followed by TPSV in 1 year. 1 year is the interval where you have chronic medical conditions or you're just giving that in a healthy adult greater than 65. But with cochlear implants or in immunocompromised patients, when you're giving the sequential combo option, 8 weeks is the interval between PCV15 and PPSV, followed by PPSV. In short, you know, if people have received vaccination in the past and they're due for a PPSV, are you able to substitute that with a PCV 20? So yes, in short, the answer is yes. But this gets very complicated. You've already received this vaccine 5 years, 8 weeks, 1 year, etc., etc. So CDC actually has a very nice app where you can put in all the information and see which vaccine you want to give to your patients. So that's also free of cost. And this whole immunization table is also available as an app or online, which you can download and put on your cell phone. So very easy to look at that. It's hard to remember all this with the immunization tables. Even if I do it in and day out, even if we practice this, it sometimes is nice to have that handy reference on our phones or can print and put in our offices as well. So next case is that of a woman, 42-year-old lady who works as a nurse in pediatrics, comes to her internist's office for an annual checkup. She has a history of rheumatoid arthritis. So she's immunocompromised and currently on a biologic, started in 2020. She takes 5 days tapering course of prednisone orally when her symptoms flare up. That's about 2 to 3 times a year. And the patient's chart is flagged by her nurses as refusing vaccinations. What would be your response? Is what vaccinations appropriate for this patient? In the interest of time, I'll go with the answer. So she is eligible to receive pneumococcal conjugate vaccine. Although she's not 65, she's immunocompromised. Hepatitis A and B, universal recommendation there, and for B at least. And then hepatitis A, because she's a healthcare worker, she has a higher risk as well. And then influenza vaccine and COVID vaccines and Tdap, those are universally recommended. So definitely that needs to be given to her. And she doesn't want vaccines. Yes, I think this is an opportunity to talk to the patient and counsel her. All right. Next case is that of a male that's 49 years old and has a history of diabetes and chronic kidney disease, history of shingles when he was 47 years old. He's a caregiver of an 82-year-old father who lives with him. Father has shingles and 6 weeks ago actively. So the patient approaches you to see he's not quite 50. Can he take the shingles vaccine? What do you advise? Absolutely. Yes, receive the recombinant shingles vaccine now. Also because he's a close contact and a caregiver, so he does qualify for that. But he himself has had a history. So, with the immunocompromised, if they're definitely immunocompromised, 19 years and above, they are recommended, they are eligible for the recombinant vaccine. So that was added in 2022. But reinforced again in 2023. So quick questions. In the United States, for polio, is that available now? Yes, they are available. They're on the immunization schedule. In a note section, and adults may receive 1 IM dose if at risk. Meningococcal ACWY and then also Men B, both must be given to patient to complete series, true or false? Yes, it should be. But then with shared clinical decision making for Men B. A flu vaccine and COVID vaccines, can they be co-administered? Yes. RSV is a little different story. We don't have all the data, but the current recommendation says when you're there, you want to give all these vaccines together, go ahead and give it. And then any vaccine except for monkeypox can be given with COVID vaccine. Other than that, you can co-administer. And then what is the best time to get flu vaccination? We're in the Northern Hemisphere. September to October is the best time. So we had the bivalent vaccine last October, the last year, 2022, when those were available. People who had COVID prior infection, along with vaccination, their neutralizing antibody titers were much, much, much higher than anybody else. There was excellent data that the updated the bivalent COVID-19 vaccine was very effective in producing neutralizing antibodies. However, despite this, only 17% of the population really had this bivalent vaccine. The uptake was pretty poor. Despite that, we didn't have a bad summer with COVID. Numbers were really, really, really low. But that was also because natural infection immunity was still lingering. And then even with the previous vaccination and herd immunity. So there was all those factors. Now, it's beyond 6 months. We know that the natural immunity is waning. We know that even the previous vaccine from boosters, the bivalent boosters, is probably waning because the predominant strain now circulating is EG5. And there was XBB prior to that. There's still a lot of XBB, based off of which FDA recommended Moderna, Pfizer, Novavax to actually come up with a new updated COVID vaccine. The updated COVID vaccine is monovalent, based just off of the Omicron XBB sublineage, which has still cross protection against the currently circulating strain of EG5. So this is highly, highly recommended for anybody that is aged 6 months and older to protect against serious illness. In adults, older adults and people with risk factors, we know severe disease and hospitalization is definitely reduced. But in children, they also saw that with the bivalent boosters or a complete vaccination series, their visits to the ER also came down. So there is definite value in updating the vaccine and vaccine status in children as well, which is really what led to this universal recommendation, 6 months and older, to protect against serious illness and hospitalization, ER visits. So therefore, the updated vaccine is recommended universally. So we saw last year, based off of the different strains circulating, different seasons, the hospitalization rates, definitely were impacted by the COVID vaccines that were given. And again, like what I was saying, EG5 is the most prominent strain. CDC tracks this very, very carefully with what the circulating strains are. I actually get this information even for the local area in our county from our labs that will give us this information as to which is the main circulating strain. And that's like the state public health lab, which disseminates that information. And then reduction in the neutralization titers. With the XBB strain, you see that now we are also seeing a BA2.86, which is like one of the variants of the BA2, those breakthrough infections. You will see that the neutralizing antibody titers are adequate with the updated current XBB strain that is in the updated monovalent vaccine for COVID currently. CDC has a very nice table as to how many doses people should get, 1, 2, or 3. If children, basically, that's really where they're still recommending the primary series. But otherwise, even with the unvaccinated, whether they've had 1 dose or more doses, you'll see now the recommendation is just that updated. You don't need to go back and finish those primary series for adults. So really the summary, is anyone over age 6 months in children, those additional doses. I just want to quickly mention myocarditis, the multi-inflammatory syndrome in children and in adults, MIC, MIS-C and MIS-A. In those, if they have had it recently, within 90 days of getting the vaccine, and they still have symptoms, they're still on treatment for it, that is the only time you want to exercise precaution. It's not really a contraindication, but it's a precaution. And myocarditis too, if they have had vaccine-induced myocarditis, if they're completely recovered and over 90 days, they can still get the vaccine. A key takeaway still there with the myocarditis was that in males 12 to 15, which is really where they found a lot of this risk, the myocarditis secondary to COVID infection was 1.8 to 5.6 times higher as compared to vaccination alone. So there is still benefit of vaccination and universal recommendation for everybody. Because the risk is so much higher with the disease itself as compared to vaccination. But if there is post-vaccination myocarditis, then you want to just exercise precaution. If they're completely recovered, that's the only time you really want to go ahead and give the vaccine. A little bit about flu vaccines. With older adults, you do see that, there were cumulatively higher hospitalizations for the people that are higher. Risk is so much higher. So do we go ahead and give them a higher dose? Yes. So we do have quadrivalent. Everything is quadrivalent. 2 of the influenza A, H1N1 and H3N2, and 2 lineages of influenza B. So all the vaccines are quadrivalent. And for adults over 65, this is the high dose inactivated influenza vaccine, HDIIV, quadrivalent 4, that has 4 times the antigen as compared to the regular vaccine. The adjuvanted vaccine, it is adjuvanted along with a protein MF59, and that also gives very good neutralizing antibody titers. Their dose is the same as the standard, but it has an adjuvant. And then the recombinant vaccine, that has 3 times, not 4 times is the high dose, but all these 3 are recommended for people who are over age 65. A quick plug for ACP's, the adult immunization recommendations. The ACP's page has a lot of links. So if you have time, definitely look over that. And it's a quick reference, quick resource with really nice videos as well. Lastly, a word about RSV. This just got approved June of 2023. Adults 60 years or older. And here, this is shared clinical decision making. And this is because, of insurance reasons and also some risk factors that you may want to discuss with patients. The Guillain-Barré was a little bit higher than baseline other vaccines for safety data. But prospective studies and more data still are still needed to definitively say what the risk is. But they have, based on that, they have recommended a shared clinical decision making. Everybody over age 60, RSV, talk to your doctor and see. There is a huge list of people who are at risk for severe RSV. Landed a lot of adults in the hospital last year, particularly, especially after masking was, not as rampant. We saw a lot. But this year, everybody is curious to see what the effect of the circulating viruses is going to be. In addition to the vaccines, in a very timely fashion, these vaccines were released and approved. So let's see what the season's going to look like. So for the respiratory season, we also have, for adults and young children, they do have a monoclonal antibody for children younger than 8 months for RSV, and also pregnant women that was updated yesterday, in fact. I took some pictures of what IMA has approved in India, and these tables actually looked very much similar. They were last updated in 2018 is what I saw, but pardon me if there's a more updated version, which I did not find. But these recommendations are very much like what CDC has recommended, even the age groups. And they have, what I really liked is that they specifically broke down the risk factors for pregnancy, the people who are solid organ transplant recipients, who have stem cell transplants, and then HIV. And then I really like this table for healthcare workers as well, and travel. So this was a very nice document from IMA, and very similar to what the CDC has put together. So this will be my last slide. In summary, vaccinations in adults helps in more ways than one. especially, pneumococcal vaccine, influenza, COVID can be life-saving. Assess every adult at outpatient visits and inpatient visits to ensure patients are up to date with their adult immunization vaccines. We have updated recommendations for COVID vaccine in the United States now with the monovalent XBB strain, which is in that vaccine. And an influenza vaccine should be based on age, allergy profile, comorbidities, and it can be optimized for people over age 65. RSV is now available in adults over 60 in the USA. Pneumococcal vaccines. Look at that new app that's very useful for people who've had previous vaccination versus not. And the notes and appendix section of the documents are particularly useful. I will stop here and take any questions if there's time.
Vidya, this is Dr. Muruganathan. Can you hear me? Vidya? Vidya, can you hear me?
Right, I don't see anything in the chat.
Yeah, Dr. Muruganathan. Can you hear me now?
Yeah, barely.
Okay. It was a wonderful talk, a comprehensive talk on health. In fact, I learned a lot of new points from your presentation. What is different from the last year presentation, like RSV, updated vaccine, and so on. Really good. And your case study, like 49-year-old person whether gets singles and grandparent has got singles. All those points are very good. And definitely, we look forward to more such talks from you. We will organize one program. This maybe next after I meet you in October, then maybe October 8th will do really good. But with this monovalent vaccine, really very interesting. But myocarditis, pericarditis is also something. We have RSV, said for pregnant women also to be given. That's very nice. So thank you so much, Vidya, because we are now going for award function. So we are all. So once again, thanks for your wonderful lecture, and I would like to have your slide set as usual. We'll do it in October.
Thank you so much, Dr. Muruganathan. Appreciate it. Thank you.
Okay, thank you very much. Thank you. Good morning for you. Right? Good morning. We conclude.
Yes.